Welcome in our webinar.
Thank you so much. May I start the webinar, please, sir?
اتفضل دكتور محمد طبعا.
بسم الله الرحمن الرحيم وما توفيقي إلا بالله. It gives me a great pleasure to announce for the start of the International Trauma Webinar. After 3 months of continuous hard working, finally it comes live. The International Trauma Webinar with 48 eminent national and international speakers from Egypt, from India, from United Kingdom, and from Ireland, and more than 1,500 dear attendees. First of all, I would like to thank Eva Pharma Company for sponsoring this webinar. And this webinar is under the patronage of the Egyptian Orthopedic Association. And many thanks to OrthoTV channel for live streaming this webinar. Our dear Professor Adil Al-Adawi, the former Minister of Health and Population and the ex-president of the Egyptian Orthopedic Association and the president of the Egyptian Medical Association, will announce for the official opening of the day. Please, sir.
Thank you, Dr. Ashhab. Hello, everyone. Good morning, good afternoon, good evening, everywhere where you are. Here in Egypt today is the holiday, but the trip of science cannot stop anyhow. And our road in the scientific and academic journey should continue. We have always be grateful for those virtual platforms that allows us to share our knowledge, our experiences, and to meet a lot of friends from all countries and expertise, definitely. Even we are across continents. A lot of benefits we have gained from these virtual meetings. Thank you, Dr. Ashhab, our colleague, our active member of the Egyptian Orthopedic Association. He's the Dean of Benha Faculty of Medicine. Thank you for the Egyptian Orthopedic Association and expertise. All our guest speakers. Definitely, we will initiate a sort of friendship through science for the sake of our junior colleagues, our students, and our patients, definitely. I wish all of you a fruitful conference and productive discussions. Thanks to all of you, and looking to meet again in more and more active webinars. Thanks to all of you.
Thank you so much, sir. Thank you so much. And now we can start our webinar. Our first speaker will be Professor Gamal Hosni, the ex-president of the Egyptian Orthopedic Association and the ex-president of the Eminent International and the eminent star in Elizarov and deformity planning. Professor Gamal, please.
Thanks, Mohamed. First of all, I would like to thank Professor Mohamed Ashhab, Dean of the Benha University, for the invitation and the great efforts. But also, I would like to send the greetings of Professor Hani Mouafi, the president of the Egyptian Orthopedic Association. Unfortunately, he couldn't show up in the beginning. Perhaps he was going to join us later on. So I would like to thank Hani also, Professor Hani Mouafi. I'm going to speak about the close treatment of fractures in adults. This is very unusual. I'm talking about conservative treatment of long bone fractures. Fracture femur, fracture tibia, forearm fractures, fracture humerus. Do you think about close treatment of fractures in adults? It's a new treatment concept which we developed. When we classify the fractures, we classify them into bony injuries and soft tissue injury. This is 100% artificial. This is not true. It's one structure, bone and soft tissues. When the people talk about the bony injury, they always have hundreds of classifications. But when they talk about soft tissue injury, there's only one classification, which dated back to my birthday in 1957 or something like this. So if you want to classify this fracture, if you see an X-ray of this fracture, how would you classify it? Look to the soft tissue injury. It's very difficult to classify the soft tissue injury. Also, when we talk about neglected fracture of the lower limb, we talk about soft tissue interposition, muscle spasm, and bone loss. Remember that the conventional treatment is open reduction and internal fixation. This is double-edged sword. You have a bless, many advantages, but a curse, la'na, more soft tissue damage, because you add injury to the already injured bone and soft tissue. So open reduction is a new injury. You add soft tissue injury and bony injury. And people talk about internal fixation, but do they talk about failed internal fixation? Look to this double plating tibial plateau fracture. And we have this 2 centimeter gap in the sagittal plane. When we talk about closed reduction, we talk about closed reduction during the operation on the operating theater, post-operative, or operatively and post-operatively. And this is one of the publications about the closed reduction techniques, if you are intense. We are going to ask 3 questions. Is it possible to do closed reduction of fracture in adults? Can we reduce the fracture without anesthesia, without analgesia? Can we reduce the fractures post-operatively or during follow-up in the outpatient clinic? That means you are in your outpatient clinic, drinking coffee or tea, and you have a displaced fracture. Can you reduce it? What do we mean by closed reduction? We don't mean indirect reduction. This is not true. Closed reduction means without surgical exposure of the fragments, any surgical exposure, not a minimal invasive technique. This is not true. That means moving the neglected fracture from this point to that point without any incision, or from this point to that point without any surgical exposure. Is it reality or fantasy? Can we move this fracture, neglected fracture after 3 months without any incision to this stage? After 1 month, and this is the immediate postoperative. You see displacement, angulation. Can you move from this postoperative to gradual treatment to get this almost anatomic restoration? We always know that if you fail conservative treatment, you go to open reduction internal fixation. We are going to speak about the opposite. If you fail in open reduction, you can do closed reduction. Unlike this tibial plateau fracture, which had been treated by double plating with this lousy reduction, you see 1 or 2 centimeter gap, and the infection, debridement 3 times. Look, closed reduction techniques, using olive wires, using the arched wire techniques to close this gap without incisions. So failure of open reduction means closed reduction. How do you do closed reduction techniques during a follow-up in the outpatient clinic? I mean, you can do coronal translation, sagittal translation, rotational translation, axial distraction lengthening, and axial compression. I'm going to give you an example. This patient presented to us. This is 2 months post-operative. He didn't do a long film. After doing the long film 2 months post-operative, you notice that we have varus deformity. You see varus. When you do the mechanical axis from the center to the center, it lies medial to the center. So we treat the patient as a deformity. We have core, the apex of the deformity, and we put hinges or the ACA and distractor. And we do gradual correction 1 millimeter per day. You see the axis. This is osteotomy rule number 1, and we correct the mechanical axis 1 millimeter per day in the outpatient clinic. Again, soft tissue interposition and translation. This is immediate postoperative X-ray. Comminuted intra-articular, extra-articular after 1.5 months, and this is immediate postoperative. What we do? We do distraction first, then gradual translation from posterior to anterior. You see here, from that point to this point. Took about 1 month. See, this is immediate postoperative. This is gradual correction. You see, gradual correction and overcorrection after 2 months. Overcorrection to get rid of the soft tissue interposition. Then we treat the fracture as a deformity. We draw the axes and we correct the deformity till we get anatomic reduction. Again, if you have a long-standing film postoperatively in this comminuted fracture, and this is valgus deformity and shortening, we can do gradual correction of the deformity and lengthening from the site of the fracture. We consider the site of the fracture as a corticotomy. So you can do closed reduction operatively, postoperatively, or operatively and postoperatively. I'm going to give you an example or training. This is comminuted intra-articular, extra-articular supracondylar fracture in an old guy. This is 76 years old, diabetic with liver compromise and osteoporotic. We did 3D, and this is in the operating theaters. First of all, we do distraction or manual traction, and we move the fragments. Then we apply the frame to the proximal part, and we use the thumb to manipulate the fragments after drainage or after you aspirate the effusion. Use your thumbs. You see my thumb pushing the fragments. Then you put one wire parallel to the joint, and you build up the frame over this wire, 2 olive wires to compress the interarticular fragments, more wires. You see, this is good, and good reduction. But look to the sagittal plane, lateral, by the image intensifier. This is totally displaced fragments. You have flexion, you have 2 centimeter or 3 centimeter apart. This is totally displaced. And we try to compress, the guys try to compress, you have more displacement. So we do distraction, and after this we use olive wire techniques to close the gap. You see the anterior cortex and posterior cortex, and we ignore the fragments. Anterior cortex and posterior. Using the arched wire techniques. This is the arched wire. Again, with the coronal plane, we still have some sort of displacement. We corrected using olive wires. So this is the final lateral. I look to the long-standing film. After. We treat fractures like deformities. And during follow-up, we noticed that the patient had valgus deformity and 1.5 centimeter shortening. We corrected the valgus deformity 1 millimeter per day, and we did lengthening. And you see, immediate wood bearing with the man. 76 years old, diabetic, with liver compromise, osteoporotic. Actually, this is conservative treatment of fractures. Conservative treatment of fractures in adults. If you have a metaphyseal gap, I will show an example what we do. This is comminuted tibial plateau with metaphyseal gap. Look to the soft tissue. They always say you have to wait till healing of this soft tissue. You put external fixator, you put a cast, and within 2 weeks. Who told you that within 2 weeks this is going to heal? This is not true. We took the patient to the operating theater immediately, aspiration of the effusion, and manual distraction. You see my thumbs here. And manual manipulation. We get reduction. You see my thumbs over there. A correction, but we still have a gap. Did the first wire, olive wires opposite each other. You see the lateral, we still have a gap, 6 centimeter gap maybe. You see we still have this gap. What we do, we did acute compression immediately in the operating theater. Acute compression. and waited for 2 weeks. Then we do gradual distraction. You see, regaining the reduction and gradual distraction, you have new bone formation, and this is lengthening. Look to the bone formation in the gap, in the distraction gap. This is how we deal with the bone gaps. See the bone formation. This patient presented to us 4.5 months after the operation. This was the immediate photo after the accident, and this picture after 4 months with a stiff knees, ununited distal femur, and ununited comminuted tibia. We did closed reduction techniques. We used multiple olive wires with the screw traction devices to push this fragment medially from side to side, and we removed this part and put the frame on, and look to the end picture, complete union. Again, neglected open fracture, comminuted distal fracture, distal femur fracture with a bone gap. Look to the soft tissue injury, the bone is protuberant with infection. We did corticotomy first technique. We start the operation, we isolate this part, we do corticotomy. Then we go downwards and muscle flap done by the plastic surgeon, gastrocnemius flap. Then tear. But still, it's under tension. So the plastic surgeon asked us to shorten the gap. So we did angulation about 40 degrees to decrease the gap. Angulation. Then gradual correction, 1 millimeter per day after 3 weeks. We get anatomic reduction. And lengthening from the upper side. See gradual correction. Gradual correction and lengthening. See the distance, about 12 centimeter lengthening. So in conclusion, do you think that we can treat fracture in adults without operation, conservative treatment? Is it basics, myth, or legends? The real merit of closed treatment of fractures is to avoid additional soft tissue injuries. Gradual postoperative reduction during follow-up is possible without anesthesia or analgesia. Soft tissue interposition can be treated by gradual distraction, over-reduction followed by anatomical reduction and compression. Thank you.
Thank you so much, Professor Gamal, for this very interesting talk. We can allow just 1 or 2 questions after each speaker to just to stick to time. We have one question, Professor Gamal. What are the new serological lab markers for monitoring response to treatment of infected implants beside ESR and C-reactive protein?
But I didn't talk about the infected implants in this series. I didn't talk about them. So I'd rather to let somebody else to answer this question.
Okay. Thank you so much, sir. Now we will move to the next speaker. The next speaker, Professor Gamal, would you please stop your... Thank you so much, sir.
I already done.
Next speaker will be Professor Medhat Refat, Professor of Radiology and the ex-head of Radiology Department, Benha University, and one of the eminent stars in radio diagnosis and radiotherapy in Egypt. Professor Medhat will speak about the impact of MRI in trauma. Professor Medhat.
شكرا جدا معالي العميد.
شكرا جزيلا أستاذنا.
I am so lucky to join the Orthopedic Society in this international webinar. I think it's a great pleasure for me and to have our Prime Minister Dr. Adel Adawi and also the talking with Dr. Gamal Hosni is an eminent figure in orthopedic. I would like to share now my talk. This one it will take. Thank you. I am looking for my. If I can, this one. How can I? Once. Dr. Mina can...
Dr. Madhab, can you open first your presentation, please?
Where I
Open
can
first
put
your
it?
presentation, sir, and do sharing screen.
Where I can put it, my friend, for the setting?
Just open the presentation and share it.
Okay. Dr. Mina?
Dr. Madhab, can you open the mic? Just open the presentation in the laptop, and in the middle you will find
Okay.
the screen button. Choose the presentation.
I put it now in the desktop of my computer. Is it already seen?
No, sir, it's not seen, sir.
Not seen?
Not, sir.
Or
Not seen, sir.
not yet?
You open it, sir, and press on the share screen, on the button, green button, share screen.
Okay. One second. So ready now?
No, sir.
Professor, I have shared
It started?
the presentation.
Yes, sir. It's obvious now, sir. Yes. Next slide, show, please, sir.
It's ready now.
Yes, we can see it.
You can see it already?
Yes, sir.
Okay,
Yes, sir.
Yes.
May you start, please, sir? Just
Yes,
to take
start.
Thank you so much.
Yeah, we will talk about the MRI in trauma, which is more beneficial or not. The added value of the MRI in imaging of pathological fracture, we have some objectives. We are looking for that all the lecture about differentiation, about the traumatic fracture or from the pathological fracture, which is more in risk factors in also in the management. I already can move it. Okay. It's not responding. For that, how can I move? I'm sorry.
The slides are not moving, sir.
It's not moving, yes. Yes, the pathological fracture, which means that there is an abnormal osseous lesion. Fracture passed through this an abnormal osseous lesion. What about the impact of the imaging diagnostic clues? We have fracture line through focal lucent lesion, or fracture in unusual location, or a transverse fracture orientation of a long bone, or surrounding permeative change in the body, in the main bone, or industrial scalloping, or coronoid matrix, osteoid matrix, associated soft tissue mass, and also additional tumor deposits. Again, we can move on. Yes. The pathological fracture, there is typical location for that, including the metastasis of the multiple myeloma, which includes the spine, the axial ventricular vertebrae, the pelvis, the femur, and the humerus. What about the enchondroma, which is beneficial sites for the phalanges of the fingers, and the bone cyst in children? It will be for the long bones and the humerus. There is primary bone neoplasm, benign or malignant or multifocal process. Next. Yes. The clinical issue for the primary carcinoma, frequently metastasis to the bone, like breast, like prostate, like lung. The diagnostic checklist, it will be unusual location, as we tell before, the transverse orientation of the trauma, and any fracture pattern in absence of appropriate trauma history, like was called minor trauma. Next, please. We have some radiological findings which will be more clear in the conventional radiograph, like leucine lesion, coronoid matrix, ground glass matrix, surrounding permeative changes along the bone, industrial scalloping, and also associated soft tissue mass. Next. The CT finding have a great role for cortical destruction, for say something about the tumor matrix, the aggressive periostal reaction, and also the industrial scalloping, which we can say before. But the quantitative CT for detection of digital acknowledgement for the bone density can known, but we have a known lesion. What about if we have non-known lesion? Next. Yes. According to the MRI finding, there is factors suggesting pathological fracture. This means that we have multi-planar capabilities for the MRI imaging, like T1, T2, stair, gradient, and more another one sequences which can use for detecting the lesions, is it pathological or it's only benign fracture. Abnormal muscle signals can be added in the MRI. The soft tissue, it will be more beneficial. The industrial scalloping have more than 60% in pathological fractures. All of this, the fracture in related hematoma, which be confused for some radiological evidence like the conventional X-ray or the CT, but the MRI has great capability for detecting and degrading the hematoma. Is it acute, subacute, and chronic? The marrow edema, the signal dropped for the phase encoding in MRI, or the infiltrate process along the whole length of the long bones or for the axial vertebral structures. We add for the MRI, which is be more beneficial. This is the diffusion weighted image, which will looking for the water visibility. This is the tumor infiltration marrow, and it will be decreased diffusion. Next. There is Merrill's classification for the management of the fracture, put some points, about 1 point, 2 points, and 3 points for according to the site of the fracture. Is it in the upper limb or in the lower limb, or for the trochanteric fracture, which means that we are directly moving for more management, or what's called not waiting for conservative and let and see. Next. About the classification for that, minimum score is 4 and maximum of 12. More than 9% score or 9-point score. This is a prophylactic fixations. For score 8, treatment is based about the clinical judgment. The oversensitivity of this classification is more than 90%, but the specificity it's only for 35%, meaning that it will be unnecessary fixations for that patient. Next, please. For some example, about this old man have a fracture history of renal cell carcinoma, so it will be completely for pathological fracture, permeative bony or osseous lesion can be seen along the whole femoral shaft. The score this it will be 11, so fixed, reflected fixations dynamic. It will be before complete fracture can be happen for that patient. Next, please. Another type of pathological fracture for metastatic cell carcinoma or mild left-sided leg. Lytic lesion can be early seen in that one, the industrial scraping, and the pathological fracture it's already happened for that one, but it's not comminuted. So substantially transverse orientation for the fracture, which can leave or put a finger that this patient is not benign traumatic. This is only a pathological fracture following metastasis. Next, please. We get now the MRI. The MRI here, we have beneficial first time for the T1, which means we are looking more than the fatty marrow, but only we have here the fatty marrow, it's already interrupted. We have low signal line. We have more than one infiltrative lesion for that fatty marrow. The fatty marrow of the normal one in the femur is already changed. The T1 signal here is abnormally poorly defined, patchy area. It's already happening in the femoral neck. Now, cortical disruption, pathological fracture, which will means that one, and another photo for that one is already also the T1, which means we are looking for the fatty marrow infiltration. We have already a native lesion in another patient, or homogeneous and more definite, like one. This one is called the weighted not fatty marrow. I have more capabilities for seeing the fatty replacement by another patient, like a fracture line, hematoma, or edema. Next, please. This is a clear list for the role of the conventional radiography and the CT for pathological versus stress fractures, where what's more important for us is the MRI, which is we have to say that this is a stress fracture. If we have no infiltrative fracture line, it's already absent. It's only one line, low signal, linear diffusibility for that in a background of fatty marrow changes in T1. And the adjacent muscle edema for homogeneously low T1 and T2, it will be more beneficial for that edema or the fat replacement by edema or by water-like signal. It will be more seen and benefit for steer weighted image, which means that fat saturation. We already masking all the fat, only the water element it will be appear, or called in some centers it's water view. Next. Pathological fracture we have seen here in top of cortical tumor happening. Next, please. We'll show more. Yes. Patient have had adenointinoma, and we have already for that one is already transverse fracture, clearly seen. It's already clearly seen. What we are looking for, the MRI. The MRI, you can see the definite differentiation between the matrix or the fatty replacement in the tibial bone in relation to the fibula. Here is the fatty signal in T1, which completely like a fat, like the subcutaneous one in the leg. But here we have abnormal marrow changes in that one with already the presence of the transverse fracture. What's already happening that we have what is called you have to think about the pathological fracture, not only benign fracture. Could be a minor trauma happened or without trauma. Next, please. This is another pathological fracture on top of enchondroma, which is happening already in the fingers. We have already made matrix changes. It's already here for that one. And you can already the chondroid matrix in the center of the lesion. It's common here with that one. We oblique interarticular fractures with ring finger of the middle finger for that one, the middle phalanges. Next one. Yes, the switching or confirming the diagnosis. We have already here X-ray for the wrist, distal radius, bone, most likely giant cell tumor. If we do the MRI sequences, we have already a changing from giant cell tumor to another one. It's called like a cystic lesion. And we have already more edema-like signal about that one infiltrating. This is the marrow fatty area. Next, please, will show us more. Yes, the initial one is already, as we say, that this is giant cell tumor. But if we are applying for the multi-capabilities or multi-sequence or multi-parametric MRI finding, can conclude this is a bone cyst. It's proved to be that one. There is an hematoma, there is tissue reaction to the pathological fracture. It's already seen the extra osseous content. The only impression is non-aggressive lesion remains for that one. Next, please. Yes, for that one was called the osseous tumor does not cause acute pain, but rather than underlying lower level of discomfort. This is very common for the clinical orientation. The patient presenting with symptoms of a fracture, this is an important in helping to sort out the significance of extra soft tissue mass, which can be more seen in the cross-sectional imaging like the CT, but less sensitivity, but the MRI is more sensitive and more specific. Next. Another clue for that, the osteomyelitis, the infection, pathological avulsion fracture, the posterior calcaneus for one, and it's already going up with the tendon Achilles, it's already pushing it out way. You can see the diffuse bright signal in the T2 and T1, and the calcaneus presents for that, and soft tissue changes for the heel of the patient will manifested with osteomyelitis. Next, please. Another pathological fracture, varus angulation for that one, for that humerus. The clue is the underlying lesion are well bordered, the cortical destruction. You can see it very clear for that one. Next, please. Another one for pathological cortical fracture for left iliac bones. Diffuse bone involvement for that one, enlargement of the bone, which suggests the wideness of that bone, expansile Paget disease. Next, please. This is the lytic lesion for CT with medial femoral condyle, multiple cortical fractures. The attenuation of the lesion is similar to that of the muscles. You can see it. This is proven to be giant cell tumor. Looks like the muscles. It's already in comparison for the digital density for the inside the lesion and also the muscle bulk. Next. What are the general indications for spinal trauma? We have the CT and the radiograph. We can see the like ligamentous injury, perivertebral edema, spondylolisthesis, spondylolisthesis. But to look for the epidural hematoma, you should do MRI. To identify the spinal cord abnormalities, you should do MRI. To exclude clinically suspected ligamentous or occult bony injuries, you should do MRI. And also to see the stability, you can assess the stability of the cervical spine, you should do MRI. To differentiate between the hemorrhagic and the non-hemorrhagic spinal cord injuries, you should do MRI for prognostic neurological suppression. Next. We have here single vertebrae affection for one of the dorsal 4, partial collapse, but we have a retropulsive intermediate signal. This is not the normal for that trauma. This is already raising the possibility of pathological fracture. These patients have solitary plasmacytoma and it's already for compressed and already reduced the height, and we have anterior and posterior soft tissue. It changes with intraspinal component. Next, please.
Sir, time, please, sir.
Time, okay. Also, we were remaining the multi-levels for the affection for that before the bone marrow replacement, all the whole dorsal spine, the dorsal element, and because of the marrow replacement, acute fractures can be occurred. Next, please. Another pathological fracture for that abnormal bone. The MRI is looking for the abnormal signal, the cortical breakthrough, and additional marks. Next, please. I will be running. Is it hematoma or aneoplastic lesions for that hip region and the pelvic bones? Next, please. We already have here the coronal T1 MRI, that is patient for the X-ray. It's only rarified bone, but we already have here too much hematoma and also some enhancement of the lesion or already in the post-contrast enhancement fat set, which means but the hematoma it's not enhancing. Next, please. Yes, we have already here the lesion at the level of the lesser trochanter in the same patient. Next, please. To summarize, another for pathological fracture from patient from vaginal cancer. The diffusion disability is already here with old diffusion restriction. The lesion becomes more bright, which means that there is no diffusibility. This is packed cells, so it means that there is a neoplastic lesion. Next, please. There's another patient for multiple myeloma. You can see that clearly here it's called the apparent, the ADC, the apparent diffusion coefficient, which means the digitalized photo for the diffusion. We have here restricted diffusion. It's not appearing ADC, which means that completely approved. This is packed cells. Next, please. Yes, we are running. Combining the diffusion imaging for the conventional MRI, increasing the accuracy, increasing the specificity, increasing the sensitivity for differentiation between the normal or benign fracture from pathological fracture. The diffusion imaging protocol, it's very clear, challenging for that one. This recent article will be done. Next, please. There is some Altogether, some signs for benign origin of spinal fracture, not a single factor, more than one factor. Normal marrow signal, no involvement of posterior element, fluid or gas, low intensity, well-defined fracture line, limited perivertebral soft tissue, preservation of the posterior cortex, non-convex cortex, retropulsed bone fragment can be severely clean, it's not soft tissue, no epidural, no foraminal tissue mass, normal marrow in the whole adjacent vertebral bodies or ribs, anterior wedging, it's not complete to collapse, there is no osteoporotic patient with osteopenia or osteoporotic, and the lack of cervical or high thoracic lesion. This is all together. You can take home message: pathological fracture, unusual location, transverse fracture, absence of appropriate trauma, tips, metastatic workup, you have to do it, protocol advice for multiple views in the radiograph. The MRI should have T2, T1 for the fatty infiltration, and the diffusion weighted image, which more raising the sensitivity and the specificity of the imaging. Next. Thank you very much. And this is an old photo from 1891 when are building the bridge for Benha from the Italian engineer. Thank you very much. I am waiting for any question. I am so sorry that I make delay for that lecture.
Not at all, sir. Thank you so much, our dear Professor Medhat Refat, for this very interesting talk about a very interesting topic, which is the impact of MRI in pathological fractures in trauma. Thank you so much, sir. Now we will start the pediatric trauma session. Our first speaker will be our great professor, Professor أسامة حجازي. Professor أسامة حجازي هو مش محتاج تقديم. Professor أسامة حجازي هو من هو في قمة وقيمة وقامة في علم البيدياتريك orthopedic. It's a great honor to be with us, sir. Thank you so much, sir, for joining us. Professor Osama will speak about evidence of pediatric fractures and range of acceptability. Thank you so much, sir. Please, sir.
Good evening, everyone. At first, I would like to thank my dear colleague, Professor Mohamed Ashhab, the Dean of Benha Faculty of Medicine, for organizing this interesting webinar. My talk is about evidence of pediatric fracture treatment and range of acceptability. The objectives are planning a proper treatment strategy and estimating the prognosis in pediatric fractures, choice of the proper fixation method, and consider range of acceptability. Why children bones are different? It's a question, and we try to simplify it. There is a thick joint cartilage, so not imaged by X-ray. There is a thick periosteum, so the fractures heal rapidly, and the fracture of the failure of union is rare. More collagen and more cancellous bone, so fractures easily with a simple fracture pattern. Cross plate, this allows remodeling capacity. Ligaments are stronger, so bone fails first. Understanding the difference between pediatric and adult bone makes treatment of children fractures easy. Immature skeleton differs from that of adults in the following situations. Number one, at first, bone weaker but absorb more energy before breaking, capable of plastic deformation before they fail. Comminuted fractures are rare. The periosteum is thicker, so there is a significant osteogenic potentials. Bone is metabolically very active. Fractures heal very rapidly, and failure of union is rare. Active cross plate remodeling potential is very high. So consideration in pediatric fracture treatment are: children fracture heal faster, failure of union is rare, less immobilization time, stiffness of adjacent joints are less likely to occur, growing bone remodel. So the principles of treatment of pediatric fractures, there is controversy between non-operative versus operative treatment of pediatric fractures. Vast majority of pediatric fractures could be treated by closed methods, and this is a strong evidence. If you look at this picture, in infants, most of the pediatric fractures could be treated without operative fixation, except the articular fractures, means around the elbow or in the hip, around the hip. In children, sometimes we need fracture fixation, but most of the fractures could be treated without operative treatment. In adolescents, it follows the rules of adult fixation of treatment fractures. Principles of treatment of pediatric fracture: number one, majority of pediatric fractures can and should be managed non-operatively under the age of 8 years. Initial treatment permanent when possible. If you see a fracture at the first time, we must follow this rule. Initial treatment should be permanent when possible. Don't immobilize in a slab and send patient to X-ray and then come after 2 days for operation. No. Initial treatment permanent when possible. When possible, restore length, alignment, and rotation. Perfect anatomic reduction not essential for perfect functions. This is the rules in pediatric fracture management. Displaced intra-articular fractures will not remodel. So anatomic reduction in displaced intra-articular fractures is mandatory. Then come to fractures which are treated non-operative. We must repeat X-ray at weekly interval to check acceptable position. We must reassure parents. We do fraction and child observation. When operative treatment is indicated in open fractures, intra-articular fractures, multiple trauma, failure of non-operative treatment. Cross-plate injuries must be managed with care, gentle dissection. Simple treatment is the best. Most of serious complications resulting from over-treatment of pediatric fractures. For the treatment, the guidelines in pediatric fractures are: we must answer 3 questions. What is the treatment method is preferred in such a fracture? Conservative versus operative. What is the indication of operative fixation? What is the fixation method preferred? So, consideration for decision making to answer these questions are: age, fracture location, initial displacement, fracture stability, associated injuries versus open versus closed fractures. When non-operative treatment in non-displaced fracture, we immobilize and cast directly, such as this fracture. Displaced stable fracture, we apply close reduction and immobilization in casts. When operative fracture fixation, operative fixation in fractures. When conservative treatment has low or little value, such as in femoral neck fractures, biaxial fractures with intra-articular extension, Salter Harris 3 and 4, displaced supracondylar fracture of the humerus, displaced lateral condyle fracture of the humerus, displaced femur, tibia, and forearm shaft fractures in older children and adolescents, unstable pelvis, and acetabular fractures. Another indication for operative fixation when conservative treatment is not sufficient, such as in unstable fractures, and unacceptable results from non-operative treatment, high risk of non-union in such fractures, multiple injuries, vascular injury, and compartment syndrome. Conservative treatment, when and how? When and how we can consider these factors for decision making: age, fracture location, initial displacement, fracture stability, associated injuries, open versus closed injury. At age, most of the pediatric fractures can be treated by non-operative treatment under the age of 8 years. There are few indications for surgical treatment for children as compared to adults in younger age. Fracture location. Metaphyseal fractures are more amenable to close reduction and splinting than shaft fractures along the bone because there is high remodeling potentials in metaphyseal fractures. Epiphyseal injuries require reduction. The initial displacement, non-displaced stable fracture require well-molded cast and immobilization. Displaced stable fractures, what means by displaced stable fracture, if there is intact periosteal sleeve, require reduction and well-molded cast. Displaced unstable fractures, if there is a shortening, angulation, or rotation, require reduction and fracture fixation, such as those fractures. What's meant by fracture stability? Fracture stability is a stable fracture, is a fracture which likely to stay in a good functional position while immobilization requires immobilization in a well-molded cast. Unstable fracture is a fracture which is likely to shorten, angulate, or rotate before healing of the fracture, leading to poor function, and these fractures require reduction and fracture fixation. There is 4 main principles of closed method of treatment of fractures. The four principles are reduction, immobilization in a well-molded cast, and this is very essential in a well-molded cast, closed follow-up to check alignment, loss of reduction consideration. Reduction, closed, consider immobilization method on the day of the injury. Don't delay the reduction of any displaced fracture. When possible, restore length, alignment, and correct rotation. Restoration of alignment more important than fragment position. Maintain accepted position as possible. This is the first rule as regards reduction. Early reduction, early immobilization, restore length, alignment, and correct rotation, or maintain accepted position as possible. Immobilization in cast is very, very, very important in treatment of close treatment of fractures. We should apply well-molded cast using 3-point fixation principle as shown in this figure. We use the 3-point fixation principle. Consider post-reduction swelling in conditions which is we must prefer to cast splinting if they are considering post-reduction swelling. Don't limit splint or cast change in accepted position. If you achieve a good position and apply initial cast, and then with the follow-up X-ray, the position is accepted or maintained as it. Don't try to change the cast not to lose the accepted position. Close follow-up to check alignment is very important in close treatment of fractures. Repeat X-ray weekly to document maintenance of acceptable position until early bone healing. Consider accepted position and the remodeling potentials. Loss of reduction in cases of close treatment of fractures. Some conditions came with loss of reduction. So in this condition, we must consider what is the accepted position and the remodeling potential. Metaphyseal displaced fracture can be manipulated with appropriate anesthesia and analgesia up to 3 weeks after injury. Don't manipulate physeal injuries after 5 to 7 days. Methods of operative fixation is a classical method: close reduction and percutaneous fixation, either by K-wires or screws. Minimal invasive internal fixation using intramedullary fixation or submuscular plate. Open reduction and internal fixation and external fixation. The guide for choosing fixation method and fracture. We use K-wires for metaphyseal fractures like that. We use screws for articular and periarticular fractures like that. We use intramedullary wire or elastic nail for diaphyseal fractures. We use plates when intramedullary fixation is not preferable. When submuscular plating. Intramedullary nail used in diaphyseal fractures in adolescents. External fixation for open fractures or in infections. What's the range of acceptability in pediatric fracture treatment? Why there is a wide range of acceptability in pediatric fracture treatment. The vast majority of children fracture could be treated by closed methods, as we said before. This is strong evidence, and so why wide range of acceptability in pediatric fractures? Because there is active cross plate, so the remodeling capacity is very high. When to consider remodeling capacity or in fracture with loss of reduction or fracture present field. The initial treatment of fracture, we must apply conservative treatment, apply good reduction and good alignment. But if in some conditions fracture came with loss of reduction and fracture is presented late, so we can consider remodeling potential and apply what's called range of acceptability. What's the significance of using the range of acceptability, considering the remodeling in pediatric fractures to avoid more unnecessary invasive treatment, as we'll see after. The remodeling in pediatric fractures, because of the cross plate, pediatric fractures have a great potential to remodel. Amount of angulation and displacement would be accepted in children. The factors affecting remodelings are age. Younger is better. If this is the younger age, the better remodeling. Distance from the physis. The remodeling occur more at the most active physis. Degree or direction of deformity can have a role in remodeling potentials. Remodeling more likely occur if 2 years or more growth remaining, fracture near end of the bone, angulation in plane of movement of adjacent joints. So the growing bone has a capacity to remodel. The ability to correct deformity is remarkable. So statistically, pediatric orthopedic surgeons accept greater angulation deviation to indicate conservative treatment and apply less invasive treatment in pediatric fractures. So we come to see what's the range of acceptability and the remodeling in the pediatric upper limb fracture. The acceptability in upper limb fracture up to age of 10 years. There is active growth plate in the upper limb are proximal humerus and distal radius. So in our forearm bones, the angulation accept up to 30 degrees. Translation and shortening less than 1 centimeter. That not limit pronation and supination. For the humerus, we accept angulation up to 50 degrees, shortening of 1 to 1.5 centimeter. As there's overgrowth, there's a high growth rate in the proximal humeral physis. We see some examples. This is a 6-year-old child presented with this fracture. 3 months after injury, 1 year after injury, there is a good remodeling of the fracture. This is a 6-year-old child presented with this fracture, manipulated like that, and there is loss of reduction after 4 weeks and presented by this situation. If we apply the range of acceptability, we consider remodeling. If the position is accepted, we continue immobilization. If the position is not accepted, we re-manipulate. So this position is accepted as we consider the range of acceptability. So this is after 3 months after injury, 4 months after injury, and this is 7 months after injury, complete remodeling without any invasive procedures. This is example of 20 degrees fracture angulation with the distal radius. As we mentioned, the remodeling capacity is high near the cross plate, and this is 1 year later, complete remodeling of the fracture. This is a 7-year-old child with the physical fracture of the forearm with the angulation. This is 11 months after, we consider the range of acceptability, complete remodeling. A 5-year-old child presented with this condition, fractured distal radius and the distal forearm bones, 2 months after injury, presented by this condition. it's difficult to remanipulate and difficult to much better to consider the range of acceptability. This is 4 months after. This is 7 months after complete remodeling without any invasive procedure. This is a 5-year-old child presented with this fracture, manipulated, and came too late to us. 6 weeks after cast immobilization by this. It's very difficult to operate, very difficult to manipulate. So we consider the remodeling. If there is position is accepted, we continue. If not accepted, we will operate. So after considering the remodeling principles, this is 1 year after injury, complete remodeling of the fracture without any invasive surgery. This is another case of 8-year-old child, 2 months after injury, presented with displaced distal radius and ulnar fractures. We consider remodeling, and this is 2 years after complete remodeling of the fracture. This is another example of the displaced fracture, 1 week, 6 months after there is a good remodeling form. This is another 6-year-old child with displaced distal radius and ulnar fractures. 5 weeks after cuff immobilization, it's displaced. If you follow the rules of range of acceptability and this is 1 year after remodeled completely. How remodeling occurred? How remodeling occurs? There is a periosteum. There is a new bone formation here, and there is bone resorption there, and so the bone will remodel itself like that. Al-Faisal injuries, total height type 1 or 2. Most of these injuries are total height 1 or 2. 80% of longitudinal growth of radius occur in distal physis, so there is high remodeling capacity. If you see this case, this is a case of distal radial Faisal separation, displaced like that. After 1 month, there is displaced. It's difficult to manipulate. It's unwise to open. We consider the remodeling. This is remodeling after 1 month, complete remodeling after 1 year. For Faisal injuries of distal radius, don't try remanipulation after 7 to 10 days. This is increase the risk of Faisal damage. Proximal humeral fractures. This is an 8-year-old boy presented 3 months by this position. 3 months by this position after. So it's two ways: is it either to operate or to consider remodeling potentials. We follow the rules. This is 2 years after complete remodeling of the humeral fractures. This is fracture 1 day injury, 2 months neglected. Came like that, neglected proximal humeral fracture. We consider remodeling capacity. This is 8 months after, and this is 2 years after complete remodeling of the proximal humeral fracture. This is another example of neglected cases. This is 6-year-old boy after 1 month presented by this condition. It's difficult to treat closed, or it's unwise to open. Consider the remodeling potentials. This is the final results. This is another example. All of these fractures came late. The range of acceptability and the remodeling in the pediatric lower limb fractures, there is the maximum distal femur and proximal tibia are the most active physes. So we accept shortening in the tibia below 5 years up to 5 centimeters. After 5 years, don't accept shortening, because tibia has a very, very poor potentials of remodeling. More shortening. Accept the malalignment, except sagging less than 10 degrees, varus or vargas less than 5 degrees, because tibia have a very poor potentials for remodeling. Femur accept shortening up to 2 centimeters, so there is a good potentials for remodeling. Accept malalignment up 30 degrees of anterior angulation or lateral medial or lateral angulation. This tibia presented with malunited fracture. If you consider remodeling, this is complete remodeling after 1 year. This is another example. All those cases presented too late, either to operate or to consider remodeling. If you consider remodeling, especially in the patient under the age of 6 years, this is a good remodeling capacity. There is a complication of proximal tibial physis, delayed valgus position. So under the age of 5 years, partial spontaneous correction occurred. If there is non-displaced proximal tibial metaphyseal fracture, may be complicated by valgus angulation like that. If under the age of 5 years, there is spontaneous correction, so give the patient chance to follow up to 1 year. If there is no improvement, we'll proceed for surgery. This is an example of the case. After considering remodeling capacity, this is a good recorrection of the line. This is the accepted positions in the femoral fractures: 2 to 3 centimeters of shortening, 20 to 30 degrees of angulation. This is an example, fracture femur. There is a good remodeling capacity. A 5-year-old child presented by this fracture. If you consider range of acceptability and the remodeling capacity, this is a complete remodeling of the femoral shaft fracture after 11 months. This is an example of a 6-year-old child presented with malunited fracture. If you consider remodeling capacity and the range of acceptability, you accept, and remodeling will occur. This is another example. A 3-year-old child presented with this femoral fractures. If you consider remodeling capacity, this is a complete remodeling of the fracture. The message is there is a guide for pediatric fracture treatment. What's the preferred method? What's the preferred method? We can consider age, fracture location, fracture morphology, associated injuries, open or versus closed fractures. This is the criteria we should consider for decision making: age, fracture location, fracture morphology, associated injuries, open versus closed fractures. So the current concepts of pediatric fracture treatment are: accept alignment for each fracture, accepted alignment of each fracture should be outlined. We must know the accepted alignment of each fracture in different age groups in pediatric patients. Understanding a pediatric fracture remodeling and range of acceptability is a very, very essential point. Is understanding the pediatric fracture remodeling and range of acceptability in each fracture, considering the factors what we mentioned before: age, fracture location, fracture morphology. Most of common pediatric fractures require minimal care. Majority of pediatric fractures can and should be managed non-operatively. Parents' reassurance is very important in treatment of pediatric fractures, to explain to them why we are accepting some degrees of malpositions. Fracture and child observation should be considered. Cross-plate injuries must be managed with care. Thank you.
Thank you so much, our great Professor Osama Hijazi, for this very interesting presentation about a very interesting topic, which is the guidelines of pediatric fractures. Thank you so much, sir.
Sure. Thank you.
Our next speaker will be Professor Shyam Abdelghani. Professor Shyam Abdelghani, Professor of Orthopedic Surgery, Cairo, Pediatric Orthopedic Surgery, Cairo University. Professor Shyam will speak about missed traumatic radial head dislocations in children. Professor Shyam.
بسم الله الرحمن الرحيم. في الأول طبعا I would like to thank Dr. Mohamed Ashhab for the kind invitation and hope for him a great effort for this day. I will talk about missed traumatic radial head dislocation. Unfortunately, it is a commonly missed lesion. Normally, if we draw a line along the axis of the neck of the radius, it should bisect the capitulum. If we find the situation like this and this line is not centered into the capitulum, this means that the radial head is dislocated either in the anteroposterior view or in the lateral view. If this line along the axis of the neck of radius is anterior to the capitulum, it is anterior dislocation. If it is posterior, it's posterior dislocation of the radial head. It is very uncommon or very or extremely rare to find that this dislocation is isolated, but in the majority of cases, it is part of the Montague or Montague variant fracture dislocation of the elbow. And the most common type is the Bado type 1 with anterior angulation of the ulna with anterior dislocation of the radial head. Sometimes the fracture of the ulna is not clear fracture, but it is a plastic deformation of the ulna, or this may be the picture of the ulna after remodeling and the healing of its fracture. We have to differentiate this this traumatic dislocation from congenital one. The congenital one, in the majority of cases, is posterior. It is common to be bilateral. Usually, the shape of the elbow in general, the distal humerus, the proximal ulna, the proximal radius are abnormal. And so these are deformed bones, abnormal bones, and this is not a normal proximal end of the normal radius. So this is a congenital dislocation. This is an example of dislocation in a case of multiple epiphyseal dysplasia, multiple skeletal dysplasia. So we have to keep this in consideration. What is the meaning of late presentation? The fracture is late, more than 3 weeks or more than months. We see, unfortunately, we see cases up to years of missed anterior dislocation of the radial head. Normally, when we draw a line along the posterior border of the ulna, it should be tangent with the posterior border of the ulna along its whole length in the lateral view. But in the pathological side, the ulna, usually when we draw this line, the ulna is elevated at its center. So this is what's called ulnar cosine. This shouldn't be present. And this is indicative of the presence of anterior angulation of the ulna, and the head radius is anteriorly dislocated. But if the patients continue and with longer time of missed dislocation, the ulna will undergo remodeling, and in this case, the posterior border of the ulna restore its normal shape. And this may be called isolated anterior dislocation of the radial head, but actually it was a Montague variant that the ulna undergo complete remodeling. Sometimes flakes of calcifications appear in the capsule around the radial head, but this has nothing to do with the management and treatment and shouldn't be excised. The clinical presentation of these patients may complain of elbow discomfort, valgus instability of the elbow, prominent mass in the cubital fossa or palpable mass in the cubital fossa, limited elbow flexion because of impingement of the radial head against the distal end of the humerus, and sometimes with recurrent or repeated ulnar instability, they develop tardial ulnar nerve palsy and sometimes posterior interosseous nerve palsy. The treatment of this missed dislocation of the radial head is reduction. But we have two important prerequisites. Well, first, preserved radial head shape. The radial head has to preserve its concave surface. And there is no chondral defect either in the radial head or in the capitulum. So long these prerequisites are achieved, reduction should be attempted. This is an example of 10 years old child with missed dislocation, but the radial head lost its shape, lost its normal concave proximal end. So this patient is not amenable for reduction. The reduction technique or the technique to do reduction of the radial head depends mainly upon ulnar osteotomy. And this ulnar osteotomy is a flexion supination osteotomy because the malunion of the ulna is not just an anterior angulation, it's an anterior angulation and pronation of the distal end of the ulna. So the mainstay of treatment is ulnar osteotomy plus reduction of the radial head. It is very uncommon to require reconstruction of the annular ligament. This is an example of a 12-year-old boy with 3 years missed dislocation. The radial head is maintaining its shape, proved by CT 3D, and I operate upon them on the lateral decubitus position, and the incision starts between 2 points, the lateral epicondyle and the tip of the olecranon, and along the posterior border of the ulna. All the muscles are elevated subperiosteally from the ulna to preserve all the soft tissue and to avoid injury of the posterior interosseous nerve. Then we incise the capsule of the elbow and clean and remove all the fibrous tissue in the sigmoid notch, and then see the radial head and try to reduce it in place. Once we reduce it in place, the ulna will rotate in supination and the ulnohumeral joint will subluxate. This is what I mean. Once we reduce the radial head, the ulna will rotate and the ulnohumeral joint will subluxate. And the osteotomy here will decompress this relation between the ulna and the radius and allow reduction of the radius with reduction of the ulnohumeral articulation. We have to know that the radial head move with the distal fragment of the ulna, and this distal fragment of the ulna has to be manipulated in the position that keep the radial head stable in flexion, extension, and in rotation. And this position will be posterior angulation and some supination or external rotation. This supination will correct the pronation malunion that occurred in the ulna. This is the patient after surgery, reduced radial head, posterior angulation of the ulna. We don't need to put grafts, it's healed well. And the patient has full supination, full flexion, extension, supination, but mild limitation of pronation. Another example of 5-year-old boy, 3 months. This is a young boy. We cannot ensure the shape of the radial head from CT because most of the radial head is cartilaginous. But because it's only 3 months, then we consider the radial head has maintained its normal shape, the same approach, the same reduction. Look here, after reduction, the radial head, the ulnohumeral articulation is subluxed. And when we try to reduce the ulnohumeral articulation, the radial head will sublux and dislocate anteriorly again. So to reduce the ulnohumeral articulation and to keep the radial head in place, then we have to do supination osteotomy at the proximal ulna. So I like to reduce the ulnohumeral articulation, reduce the radial head, and fix the ulnar osteotomy at the position that keep the radial head stability. If we miss this rotation immediately after surgery, when the ulnohumeral joint reduce, it will dislocate the radial head anterior again. A sign of a good stable reduction, if we try to dislocate the radial head intraoperatively, we cannot do so. This is an indication that your osteotomy and your technique is in the proper way. This is after surgery. This is after healing, after removal of the plates with full supine, full flexion, full extension, mild limitation of pronation. This is the last case of 3 years old with very proximal fracture, very proximal malunion of the ulna. For it, I did very proximal osteotomy here, and we don't need grafts, and healed well and with maintained reduction of the radial head. So we have to keep an eye on the normal alignment of the radial head in relation to the capitulum. Reduction is mandatory so long the radial head is keeping its normal shape and there is no chondral defect either on the radial head or in the capitulum. Ulnar osteotomy is the mainstay for treatment, and it is not just an flexion osteotomy, it's flexion supination osteotomy, and annular ligament reconstruction is not essential. Thank you again, and hope you a fruitful day. Thank you.
Thank you so much, Professor Hisham Abdelghani, for this very interesting talk. شكرا جزيلا على تواجد حضرتك معنا دكتور هشام بيه.
شكرا لحضرتك. شكرا على الدعوة الكريمة.
شكرا يا أستاذ. Our next speaker will be Professor Osman Sharif. Professor Osman, Professor of Orthopedic Surgery at Azhar University. Professor Osman will speak about crushed limb in pediatric, how to deal. Professor Osman, thank you so much, sir.
First of all, I thank dear Sir Professor Mohamed Ashhab, Dean of Faculty of Benha. I see a great effort from Dr. Ashhab to regulate this meeting. Thanks for Dr. Ashhab. My talk is today is the crushed limb in pediatric and how to deal. My hospital in Damietta on the Mediterranean Sea, and there is a international coastal road near my hospital, about 7 minutes from main road. We facing a major accident every days and the high rate of this major accident. Sometimes this accident is unclassified. We see these cases. I having one of this case presentation, female patient, child, 4 years old, road traffic accident, had an open segmental fracture type 3C on the left post-pole leg. And this is the photo for the case. When I see this case, there is a two option, reconstruction or amputation. How to deal? There is a problem. Grade 3C, open fracture, crushed muscle, the crushing of the anterior tibial artery, plus still the posterior tibial and comprehensive injury and skin problem. There is a mangled extremity severity score. These findings suggest the mangled extremity severity score should be considered when managing the child with severe lower extremity trauma. This score including shock, ischemia, and skeletal and soft tissue injury and the age of the patient. My case is in the skeletal and soft tissue is a grade 4, very high energy, in shock, transient hypotension. In ischemia, there is the grade 1, which equal 0. There is the pulsatile posterior tibial artery, and the age group less than 30. Mangled extremity score is 7. 7 in the score means amputation of the limb, 7 to 12. This author concludes that in their hand, mangled extremity score 7 or greater predict amputation with 100% accuracy. But there is another scores like LSI, PCI, and Hanover fracture scale, but not like the mangled extremity score. But in my social and in my country, how to invite the parents about to amputate the limb of her girl. Please, no amputation for my limb of my girl. Please try to reconstruct as much as you can. But there is informed consent for amputation. I try. Reconstruct unclassically by the intramedullary, but in this case we do external fixation, but the plastic surgery asks for the intramedullary to deal with soft tissue. This is after 2 weeks. Surgical debridement several times done and resulting exposed bone and plastic surgery recommended for VAC application. 2 weeks after VAC application and 2 weeks after VAC therapy, there is a sequestrum and exposed bone. Here, drilling and shingling and try VAC again for the 4 week. 6 weeks after VAC therapy, this is good result and creeping of the granulation tissue. and then remove the sequestrum and do grafting and put external fixator instead of internal fixation. And this is the final result. But there is a deformity and malalignment of the foot and distal tibia. There is also a drop foot. Remove the dead segment and external fixator for pen track, severe pen track infection, and arrest of from external fixation. We do a laser off external fixator to do segment transfer and put also a foot piece for the correction of the valgus and foot deformity, and we'll do segment transfer. There is a small part below the epiphysis in the proximal tibia, but I try to gradual lengthening less than traditional 1 millimeter per day, and ask the patient to bear weight. There is a good, and also continue for segment transfer, and also continue for 6 months, for 1 year, and there is a good regenerate. But there is some displacement here, but not accept this displacement inside this catastrophe. And there's also a video on follow-up. There is the follow-up. Good alignment, and this is the accepted position after the follow-up. And this is the final follow-up, 7 years. Take-home message: one of the most difficult problems in the traumatology is open fracture of the leg, which have additional severe soft tissue damage because of its location and structure, anatomy, and the spares of the anterior coverage of the soft tissue is particularly prone to the severe injury. Our treatment protocol emphasizes on the debridement, irrigation, antibiotic therapy, and fracture stabilization and appropriate wound closure. Wound closure and soft tissue management took our priority in open fracture over the bone healing. Please don't amputate if you have a chance to reconstruct. Teamwork, including orthopedic plastic surgery, is very important in management of open leg fracture. Initial debridement is important in reducing the infection rate and the other complication associated with soft tissue coverage at the skeletal stabilization. Early soft tissue coverage in the acute phase should be priority whenever possible. In crush injuries with extensive soft tissue devitalization, soft tissue coverage should be delayed to allow for the second look and the serial debridement of the wound. Negative pressure offers orthopedic and plastic surgery important option for the advanced management of the open fracture wound when soft tissue coverage is delayed. Early physiotherapy in post-operative phase is important for good functional outcome. Thank you.
Thank you so much, our dear Professor Osman Bey, for this very interesting talk. أنا هستأذن بس من أساتذتنا الأفاضل المحاضرين. If our attendees has any questions, they can write in the question answer box, and our dear professors, please answer it كتابة, لأن we are out of time. على أساس إن في أجانب هيجوين من الهند ومن إنجلترا ومن أيرلندا، فإحنا مرتبطين بالتايم بتاعنا. فهستأذن من أساتذتنا إن هم يردوا على الأسئلة الخاصة بحضراتهم كتابة. مشكورين يا فندم. Our next speaker will be Professor, my dear brother, Professor Mohamed Hosni, Professor of Orthopedic Surgery and the Head of Orthopedic Department, Tanta University. Professor Mohamed will speak about physial injuries in children. Please, sir.
Good afternoon, everyone. It's a great pleasure to join. Dr. Ashhab, thank you so much for this great effort. I'm very proud and very honored to be here with you. And as usual, you are doing such a great effort to gather, well-esteemed persons from all over the world to give presentations about the up-to-date data and different fields of pediatrics and in different fields of orthopedics as well. It's a great honor, and I'm going to be presenting today some of the evidence-based approaches in physial injuries in children. So let's start. To start with, we have to understand some of the basics. We are back to basics. Now we have to understand the anatomy of the physis. The physis, as we all know, is the primary growth center of the immature bone. Apophyses, on the contrary, are subjected to tension forces rather than compression forces. Again, as we all know, the anatomy of the physis, it's subdivided into 4 zones: the resting zone, the proliferative zone, hypertrophic zone, and zone of calcification. The most important is the hypertrophic zone, which is further subdivided into the zone of maturation, the zone of degeneration, and the weakest of all is the provisional calcification zone. There are 2 other important structures. I'm sorry, is the picture clear? Are we following Dr. Ashhab? It's okay? Full screen?
No, please make full screen, sir.
It's not full screen. Okay, good. Just a minute.
Yes, sir. It's full screen
okay.
now.
Two other important structures are the groove of Rambier and the ring of La Croix. The groove of Rambier is located on the diaphyseal ends of the gross plates. It's formed by osteoblast, fibroblast, and chondroblast. As we all know, again, it's the gross plate that it causes the gross in diameter and the length of the affected bone or the normal bone. And it comes from this groove. And the ring of La Croix is between the ossification groove and the periost on the metaphyseal ends, connects metaphysis and epiphyseal periosteum. And it provides mechanical stability, as Dr. Mohamed Osama said in his presentation. Of course, his elegant presentation. Again, injuries, the worst type of injuries are most commonly known is the Salter-Harris calcification. It affects the germinal cell layer or the gross, and the worst of all is crushing of this germinal layer that would cause disturbance of the gross plate. This is the Salter-Harris calcification. Physial injuries are most commonly caused by number 1 in pediatrics, trauma. 30% of long fractures subjected to trauma. Also, it can be caused by infection, physical agents such as radiation or heat, tumors, and distorted gross metabolic bone diseases. And to a less extent, of course, neuromuscular disease. The worst case scenario would be physial arrest, would be growth arrest. This is complete cessation of growth at the physis, and depends on the magnitude of the force and the magnitude of injury and the age of the patient at the time of the injury, as Dr. Mohamed Osama also stated in his lecture. Significant depends on the age, site of injury, and the resulting and the sequence remodeling potential that is going to be ahead for growth, for remodeling, of course. If it occurs in long bones, bare bones, in the forearm and in the leg, you might be confronted with deformities in the coronal or the sagittal planes. How do we diagnose physial injuries? Actually, you have to anticipate physial injuries to start. You have to look for them, you have to wait for them, and you have to be cautious about having physial injuries in trivial traumas and in x-rays that don't have apparent fractures or maybe fracture lines. So you have to follow these children till skeletal maturity, because gross arrest or partial gross arrest might cause deformities and might end in sagittal or coronal plane deformities. Of course, we have the Harris gross arrest lines. These lines are transverse lines that appears after growth, and it would be a sign of remodeling in these fractures in the metaphyseal area, away from the physis, and this means that remodeling is going okay, and it does not show cessation of growth. So this is a sign for restoration of growth and going back to normal. If you have a sclerotic end, if you have a deviation from normal, if you have narrowing of the physis, if you have, especially compared to the normal non-affected site or maybe the rest of the physis, then you have cessation of growth, and then you have permanent damage, and it might be partial, it might be complete. MRI, of course, is very beneficial, especially in follow-ups and post-operative treatment. For example, in bowel resections, you might use an MRI to differentiate and to diagnose the type of physial injury. You might also have an MRI, but it comes second to CT in children, because CT is superior, because it appears to have a high, of course, separation between the bone and physial cartilage injuries, especially in cases of bar formation and growth of arrest, especially if it's central part. So MRI is also very, very useful in complex fractures and in follow-up after post-operative treatments. So to start with, we have to differentiate different types of Salter-Harris fractures, and the pattern of fracture and the location of fracture, and again the remodeling potential that is ahead of the child, that is his skeletal age at the time of trauma. How many years does this child have to remodel? Does he have a chance to remodel? Does this fracture or this physial arrest of growth has a chance to deform or maybe to arrest the growth, or does it have a chance to remodel? All this has to be put in mind. Reviewing the literature, they said that if you have 2 years of potential growth ahead, then you are actually having a problem, and you have to be very cautious, because any arrest of the growth or any deviation from normal might cause a deformity, and you have to watch this child until cessation of growth, until skeletal maturity. Of course, fracture patterns depend on the type of Salter-Harris type 1 and 2. Permanent growth arrest is rare. Treatment varies in specific site of the fracture. This is type 1 and 2. The specific fracture patterns 3 and 4. The articular cartilage is involved, and the physis as well. So the incidence of growth disturbance must be reduced. That means anatomic reduction is a must. And by anatomic reduction, we mean reduction less than 2 millimeter in diameter. That the reduction at the fracture site is less than 2 millimeter. It has to be reduced anatomic. That means 1 millimeter or below. And this is the ideal. Salter-Harris type 5, it's a very rare and compression growth plate, and it usually leads to growth arrest, complete growth arrest in those cases. Type 6 was not included in the original Salter-Harris classification. It's a compression injury of the precondylar ring, resulting in bony bridges at the edges of the fracture, at the edges of the physis, with subsequent angular deformities. And again, types 5 and 6 are not diagnosed acutely. They are diagnosed later on, and you can just monitor them and follow up them to diagnose that the child had a type 5 or type 6 injuries. This is how we classify fractures according to the site of the fracture. This is also very, very crucial, because growth arrest here occurs depending on the site you are dealing with. Now we are going to classify, or we are going to monitor, or we're going to speak about the most common injuries in specific fracture patterns in the tibia and the femur, for instance. You have to know the site of the fracture. This is also very important for the type of treatment and the type of fixation. At the end of the distal femur, 5% of the gross physial injuries occurs, 50% of them associated with growth disturbance. Expert opinions said that close reduction should be attempted for all mild to moderately displaced fractures. But Salter-Harris type 1 and 2, redisplacement is very, very common in the unfixed or unfixed types, and we suggest fixation of those fractures by 2 smooth heavy pins as shown in the x-rays, or to stabilize them in cast after also fixation with screws. Fixation methods have not been compared in the literature, so evidence-based, you have to fix Salter-Harris type 1 or 2 for fear of further displacement. Again, type 3 and 4, worst case scenarios, they have to be fixed either intra-epiphyseal screws, as you can see, or maybe even traversing the physis in some of the worst cases or severely displaced cases. to maintain or to attain an anatomic reduction. So anatomic reduction is a must in types 3 and 4. And this is the distal end of the femur. So it's not working. Okay. The proximal end of the tibia, we have studied also the literature, the case series that shown that incidence of the gross arrest and the proximal end of the femur with close follow-up has been considered, with close reduction, long leg casts have been proposed, and adequate treatment with minimally displaced acute fractures also has been proposed. But again, Salter-Hires type 3 and 4 has to be fixed after internal fixation, again, like the distal end of the femur, because if you do not do so, you might have also what was significant in the literature was the apophyseal gross arrest that had led to significant recurvatum in the sagittal plane. If you are not anticipating, you might end in also knee recurvatum. This is very important, the distal end of the tibia, and very complex as well. You might need a CT scan, and most of these fractures actually need CT scans, or even pre and post CT scans to make sure that everything is going in order and the reduction has been reduced anatomically. Type 1 and 2 are usually treated with close reduction, as we said before. In children that has at least 2 years of gross maintaining with less than 15 degrees of a blunter tilt, or maybe 10 degrees valgus, and no VARS, then you can also do a close reduction. In children that has less than 2 years gross remaining, acceptable angulation, 5 degrees, and in all planes, premature fascial closure is unusual. These are the guidelines in literature. Salter-Hires type 3 and 4 fractures require surgical intervention to avoid deformity. And this was also found very significant. Talus and triplane fractures should be reduced and fixed in the presence of 2 mm displacement, as you said before. Best judged on CT, also very, very strong significance in the literature. These are complex fractures and they have to be reduced anatomically, and they have to be monitored even post-operatively. You can do a CT to make sure that everything is in order and the fracture has been reduced to less than 2 mm displacements. Distal end radius, 75% of forearm gross occurs in the distal end of the physis. Thus, gross arrest affects one bone. It might lead to significant deformities at the end. So you have to monitor these fractures, and you have to keep monitoring these children until skeletal maturity. The goal of treating fascial fractures is to end with an acceptable reduction at the germinal, without subjecting the germinal layer of the physis to any further damage. The most important is determining the limit of acceptable reduction, as Dr. Osama Hijazi said in his, of course, presentation. So, degree of acceptance, the age of the patient, the bone affected, the part affected, especially the physis, because it is a growing part of the bone, has to be put in mind and has to be very, very well monitored. So the range of acceptance, Rang and his colleagues said that if you have past 7 to 10 days, this is the point of, actually that was a point of controversy. If you have type Salter-Hires type 1 or 2, or maybe they are also mentioned with other types, or we have exceeded 7 to 10 days, Salter believes that performing an osteotomy later would be much, much better than injuring the physis with a trial of close reduction and healing. So little clinical experience or experimental evidence even has proven this validity. Igol and his colleagues studied the effect of delay in reduction of Salter-Hires type 1 in rats. There was no evidence that a delay in reduction produced gross disturbance. This was also a very high significance. It's still recommended to avoid reduction in late presenting type 1 or 2 fascial injuries because of the interarticular component. But on the other hand, displaced type 3 and 4 injuries must be reduced by all costs, by all means, regardless of the time of injury. So if you have type 1 or 2, past 7 to 10 days, maybe let's say 2 weeks after the injury, you might prefer to deal with the deformity rather than dealing with further fascial injury. But in types 3 and 4, you are going to reduce whatever the time lapse between the trauma and the time of presentation of the fracture. How do we manage? Actually, you have to first differentiate, diagnose, then anticipate the problem, as we say, diagnose it promptly, and then quantify it accurately. So complete gross arrest would occur in especially types 5 and type 6 Salter-Hires classification. Partial gross arrests have been classified by Bright into central, peripheral, and combined types A, B, and C. with each of which have a different response and, of course, different management pattern. This is an example of central gross arrest, as you can see in the upper picture, in the upper X-rays, doing a plain X-ray and then an MRI, and again the peripheral gross arrest at the bottom, as you can see, with a plain X-ray and an MRI. So how and when do we resect the bars? And should we resect the bars or should not we resect the bars? Would this lead to a better prognosis, or would this be an ideal in solving such problems? Actually, it depends on the size of the bar. It depends on the site of the bar. So and the type, of course, types A, B, and C, as we said, central, peripheral, or mixed. This is very important. And how big is the bar? And you can, again, classify bars by an MRI or a CT scan. If it's a bony bar, if it's a cartilaginous bar, MRI would be superior than a CT scan. When to consider physial bar resection? If it's less than 30 to 50%, this is most of the literature. And if you have a potential growth that is for a minimum of 2 years ahead, that means the child has at least 2 years of growing potential, then you have to consider bar resection. What would you do after resection? You would put fat, you would put muscle, you would put silicone, and evidence-based series between those different types have not been proven any superiority of any of them over the others. They are all attempts of prevention of recurrence of barring. So basically, if it's less than 50% and you have more than 2 years of growth ahead, you would consider physial resection, bar resection. Corrective osteotomy, of course, if you leave the bar, and especially if it's a peripheral one or maybe combined types, you would end by an angular deformity in the coronal or in the sagittal plane, and then you would go for corrective osteotomy to correct these deformities as mechanical axis deviations and limb alignments. Hemichondrodiastasis actually has been tried before and has been performed and was doing well, but it has proven to be good, and especially if the bar has been less than 20 to 30% of fascia plate. I mean the circumference, the bar size regarding or compared to the circumference of the physis is less than 20 to 30% of the whole circumference. So, take-home message would be fascial injuries are very common in children. They require anticipation first. You have to watch out. They are there, and they might occur with trivial traumas, especially types 5 and type 6. They are not diagnosed actually acutely. They appear with follow-ups, and they appear, of course, with MRIs and CTs later on when you have barring. So you have to anticipate them and you have to follow up them. Gross plate injuries involving germinal cell layer is the worst. Then they produce irreversible damage, and that types would be types 3, 4, and 5. Management depends on if it's partial or complete gross arrest, and most evidence on management is based on case series, level 4. Fascial bar resection can be considered if the fascial barring of the size of the bar is less than 30 to 50%, and the child has more than 2 years of growth ahead. So fascial barring would be considered in these circumstances. I hope I have summarized the evidence-based about this interesting topic in pediatric orthopedics. Thank you very much for your time. Again, I would like to thank Dr. Mohamed Ashhab for this gathering and this excellent webinar. Looking forward to see you all, inshallah, soon. Thank you so much.
Thank you so much, our dear Professor Mohamed Hosni, for this very interesting talk, gathering all the guidelines for fascial injuries in children. Thank you so much, sir. Again, may I ask our dear professors to answer the questions of our dear attendees to write their answers in the question and answer box, because we are out of time and we have international speakers, so we have to stick to the time. Our next speaker will be my dear brother, Professor Ahmed Alam, a professor of orthopedic surgery and head of orthopedic department, Benha University. Professor Alam will speak about modified induced membrane technique in complicated pediatric forearm fractures. Professor Ahmed, thank you so much.
Assalamu alaikum.
Alaikum assalam wa barakatuh.
Hi, everyone. Thank you, dear old friend for many years, Professor Ashhab, for this nice invitation and this honor for this participation with you today. Thank you again. This modified induced membrane technique for the forearm infected segmental bone loss is a new technique evolved at our Benha University hospitals. I have nothing to disclose. This is Benha University Hospitals and Faculty of Medicine. As an introduction, the reconstruction of wide long bone diaphyseal defects is often a major challenge. Most common widely accepted procedures are autologous bone graft transfer and the Lazarus bone transport method. But the size of the non-vascularized bone graft is critical because defects larger than 6 centimeters cause graft resorption, even in a good vascularized muscular envelope. Clinical and experimental studies has shown that foreign body-induced membrane can promote the consolidation of a conventional cancellous bone graft for reconstruction of long bone defects. This technique was evolved in 1986 for defects larger than 15 centimeters and more. The idea is that the induced membrane appears to behave as a biological chamber that prevents the resorption of the graft and secretes a lot of growth factors. And the usual method of stabilization during this stage, the first stage induced membrane or first stage musculo, is external fixation, which has some accepted complications in the lower limb. However, in the upper limb, especially in the children, more complications can occur, including surgical difficulty in application, intract infection, soft tissue injury, early loosening, in addition to the complexity and the cost of the complex devices when applied to the upper limb. As an example, this young man have closed bending for a normal postbone forearm fracture, but unluckily, he was refractured later. Plating of the ulna was done, but severe postoperative swelling occurs and compartment syndrome, necessitating fasciotomy plate removal by the same surgeon on the same day. Postoperative infection was severe. Debridement was done 2 weeks later and 4 weeks later, still heavy infection. I received him, he is 9 years old, with 2 large open infected fasciotomy wounds, with infected nearly middle half of the ulna, with multiple large holes, radiologic signs of osteomyelitis, and 3 actively draining sinuses. In addition, the Volkmann ischemia present. The idea of the modified induced membrane technique is to do the classic aggressive debridement with lens adjustment and to make, instead of the external fixation, internal fixation construct, which is a simple K-wire construct like a long U-shaped stable, 2 staples or 2 long heavy K-wires in 2 different planes applied with different lenses over the cement, usually used in the first stage of the induced membrane technique. This is the patient immediately post-operative. This is at the time, this at the time of removal of the cement, showing how much the bed is very vascular, rich of blood, with capillary refilling and arteriolar refilling. The effect of the induced membrane, the effect of the cement, capillary refilling is evident. After that, we do the normal free fibrillar graft, which is fashioned by press fitting. It is important to press fit and fashion the graft to fit exactly to the size and the length of the defect to be hardly removed. In addition of the fixation that will be done later, this is a plate, hydroxyapatite. This is a patient 5 months later. This is a patient function after 1 year. This is a patient after 1 year X-ray. This is after 2 years at time of plate removal. The same patient after 5 years with good ulna growth and length and alignment and the good function for the forearm, the wrist, and the elbow. Another case for presentation showing how much the severity of infection and bone loss. This is during the first stage, the same idea, the 2 internal construct, the applied cement, and this is testing for the stability of the construct. It is very important to test how much your construct is stable. This is the fashioning of the graft to be exactly the shape and the press fit And this is 2 years X-ray for the patient. Another case for presentation also, showing the same heavy infection, how much soft tissue and bone affection is present, how much infection is present. This is the K-wires construct embedded in the cement. Again, testing the stability of the construct is very important. Very stable construct, no bone cement interface at all. Another case, just for demonstration, the same. This is second stage for another case, plating and so on. However, for pediatrics and adults, we did about 23 cases with this novel technique with average defect of 7 centimeters up to 11 centimeter bone defect, all united in an average of 4.4 months. Infection eradicated was in all. Follow-up average was 4.7 years up to 6.5 years. No refracture or infection recurrence occur in any cases. This is the same technique applied in an adult on a femur to show you how much the construct is stable, but of course with much heavier K-wires. This is a technique also in the tibia for much heavier patient with severe bone infection after blade infection and bone loss. But here I used the 3 K-wires, not 2, because the patient was really a giant. This is the X-ray after the first stage. This is a patient walking on the cement, on the internal construct, is about 130 kilograms, and his X-ray about 1 year with intake and incorporation of the fibula and the iliac graft. Take-home message, this simple internal construct is very convenient, effective in treating pediatric and adults. Forearm, possibly other bones, other long bones, infected long segment bone loss at low complication rate. Thank you for your time and attention. Thank you.
Thank you so much, my dear brother, Professor Ahmed Allam, for this very interesting case presentation. It's a very interesting case, Professor Allam. Thank you so much, sir.
Thank you, sir.
By the finish of the talk of Professor Ahmed Allam, we come to the end of the pediatric trauma session, and now we will move to the upper limb trauma session. And our first speaker will be Professor Yasser Safuri, Professor of Orthopedic Surgery and one of the eminent stars of upper limb surgery in Egypt, and also the head of Qasr Al Aini, Cairo Orthopedic Department. Professor Yasser will speak about management of acromioclavicular dislocation. Professor Yasser, please.
Thank you very much, Dr. Mohamed Al-Ashhab, for inviting me for this webinar. Is my screen, do you see my screen properly?
Yes, sir. Yes, sir. We see it, sir.
Oh, thank you very much. So I'll be talking about the acromioclavicular joint dislocation, its classification, and how we can manage this problem. As Dr. Ashhab said, I'm the chairman of the Orthopedic Department, Qasr Al Aini Hospital, Cairo University. I will be talking about our experience in treating these types of injuries. These injuries occur as a result of direct trauma, falling on the shoulder with this pressure on the acromion and then dislocation of the AC joint. So there is ligamentous injury. As long as there is trauma and high injury trauma, then there is ligament injuries. These ligament injuries are the AC joint with its ligaments, the CC joint, which stabilizes the clavicle to the coracoid. These are common injuries, 9% of the shoulder girdle injuries. It's more common in males than males and more common in athletes. As I said, it can happen as a result of falling on the shoulder or even direct trauma to the shoulder. Okay, so there are 2 main ligaments which are very important for stability. These are the AC ligaments and the CC ligaments, acromioclavicular ligament and the coracoclavicular ligaments. You should know there is some motion in the joint. This joint has some motion as gliding and rotation, and this is very important in doing your overhead elevation. There are certain factors for stability. which may be static or dynamic. Static, it's the capsule of the AC joint with its ligaments, mainly the superior and the posterior part of the capsule, which is thickened. And this type of ligaments are important for the horizontal stability. But there are other ligaments, which are the CC ligament, coracocavicular ligament, which is important for the vertical stability. The dynamic forces are two big muscles. These are the deltoid and the trapezius muscle. Okay. These ligaments have certain anatomy and have a footprint. You should be oriented by the anatomy and should know how to repair these ligaments. So as I said, the CC ligament is the conoid and the trapezoid, and they have a certain footprint. The AC joint and its capsule is thickened by ligaments, especially the superior and the posterior part, and is very important for the stability in the horizontal direction. We treat these fractures or dislocations by certain classification, well known, which is the Rockwell classification. Type 1 is only sprain of the AC ligament. Type 2, rupture of the AC ligament, but stable. Type 3, which is divided into two parts, is injury of the AC and the CC ligament, but A and B are two different types, which I will mention in the coming few slides. Type 4 is posterior displacement of the clavicle. Type 5 is complete rupture and instability of the AC joint. Type 6, which is rare, is the subcoracoid dislocation of the clavicle. Very simply, we use X-rays. One of these X-rays is well known as the Zanuka view, in which it's an EP view with the beam directed at about 15 to 20 degrees. This gives you a clear picture of the AC joint. Also, we can compare both sides, and we measure the distance between the coracoid and the clavicle. Some authors, I don't prefer this, can use weight to differentiate if there is instability of one side more than the other. Another view which is very important is the Alexander view. It's an outlet view with cross maneuver of the arm, and you compare both sides. As you see here, there is subluxation of the joint. We do not, in all cases, use CT scans, 3D CT scans, or MRI, especially only in special types of injuries, and if you want to have other idea about the ligaments, in some cases, especially in the late cases. As I said, type 3 is divided into two parts, A and B. A, it's a stable joint. B, there is posterior displacement of the clavicle, so there is horizontal instability. It's very important to diagnose these injuries, and we call it DPT, dynamic posterior translation. If it's missed and you treat these patients conservatively, they will have pain, especially in athletes. As you see here, it's very clear if you take a proper X-ray that the clavicle is displaced posterior, although in the AP view, you can find it not displaced and it's type 3. These injuries, if they are not treated well, then they will have dyskinesia and have pain in the shoulder. Therefore, the treatment is mainly conservative and surgical. Conservative by a single sling and then early rehabilitation. Surgical, we should go with the classification of Rockwood, as I mentioned before. So if you put an algorithm for treatment, we can say that type 1 and 2, we treat conservatively. Type 4 to 6, it's operative. But type 3, you should differentiate between A and B. But in hard workers, manual workers, and athletes, we treat type 3 surgically. If he is not an athlete, we should differentiate between A and B. If it's B, then it's surgical. In all these cases, we follow up the patient. Sometimes, after treatment, conservative treatment, they still have pain. These patients, we can reconstruct procedures. There's moderate evidence to support that early treatment is better than late treatment, but there are certain few articles which mention that we can interfere early for better results. In our school, in Kasaraini, we treat them early. So as I mentioned, type B, which is the posterior displacement. If it's left, it will lead to scapular dyskinesia, which means malposition or abnormal of the scapula while doing overhead elevation. Also known as the sick scapular syndrome. It's very, very troublesome for the sports and the athletes, and they have fatigue, and it's very difficult to treat. You should early diagnose these types of injuries. Surgical management is all about healing of the CC ligament and the EC ligament. And we can use different types of treatment, either using metal devices to keep the joint in its place or suspension devices. We prefer in our hospital to use metal devices. We use the hook plate, but there are other types like with different names, like using a screw between the clavicle and the coracoid. Suspension devices, you can do it also arthroscopically. It's minimally invasive procedure. It has its advantages and disadvantages. But you should know, as I mentioned before, that it's very important to reduce both joints. Reduce the distance between the coracoid and clavicle and reduce the AC joint in both planes. Historically, they only used to attack only the coracoacromic ligament, neglecting the AC joint. But this proved by time that it's not right, and it's very better to do it properly and reduce the AC joint with the coracoacromic ligament. Otherwise, you will have this type of pain, which is called the DPT, sick scapular syndrome. Okay, the hook plate. We use the hook plate in most of our cases. It has advantages: perfect reduction, early mobilization. After 1 week, you can go back to work. No residual foreign body remains in the patient because it is removed the plate after 4 months. The disadvantage, you need to remove the plate after 4 months, and also it does not address the core pathology intra-articular, which is present in 20% of patients above 45 years old. But you should know there are different types of hook plates with different heights. You should use the proper plate. Otherwise, you will have over-reduction and the patient will have pain and he will not be able to do early mobilization. Suspension device arthroscopically has a lot of advantages, like minimally invasive, and you can address the intra-articular pathology. As I mentioned before, it's present 20% of patients above 45 years old. The disadvantages restrict post-operative protocol, and you may lose some of the reduction during the follow-up. Sometimes they use buttons, so there is irritation of this foreign body, which is not removed. And there's also an incidence of 20% of iatrogenic fracture of the clavicle. I will show you my experience in 15 years of treating these patients with the hook plate. So this is a case, as you see here, with dislocation of the AC joint. The hook plate is used to reduce the clavicle in both planes, and then you repair the ligaments. This is an operative photo showing the stay sutures in the ligaments, coracoacromic ligament, showing the hook not inside the joint but outside the joint behind it, with proper reduction of the AC joint in both planes and repairing the ligament. Then you close the soft tissue above the hook plate. This is another case in which you use the hook plate. This is another type of hook plate with more length, and you are sure that there is no overcorrection of the clavicle. This is the early follow-up. 1 week, 10 days after removing the sutures, then he can move his forearm, his arm, and he do some jogging, especially if he's an athlete. Then after 4 months, you just remove the plate. Very simple procedure. Just remove it and slip it out, and it will not interfere with his return to sports, maybe after 3 or 4 days only because of the wound. Sometimes there's comminution interarticular fractures. The hook plate is very suitable for these types of injuries, in which you can reduce and fix the bone fragments with early rehabilitation and early movements of the shoulder. Sometimes, a case like this, you have dislocation or posterior displacement of the clavicle with complete rupture of the coracocervical ligament. This is a very difficult case to treat. As you see here, in these cases, you use also the hook plate with the repair of the ligaments, with early rehabilitation. To conclude, we can reach the best results by early management within 3 weeks, proper selection of the type of the hook plate, reducing in 2 planes, repair of the ECG ligament at the CC ligament, early rehabilitation, and removal of the hardware in 4 months. Thank you very much.
Thank you so much, Professor Yasser Safuri, Professor of Orthopedic Surgery and the head of the Department of Orthopedic Surgery, Cairo University, and one of the eminent stars of upper limb surgery in Egypt and all over the world. Thank you so much, sir, for being with us.
Thank you very much.
Thank you for sharing your very long experience with us, sir.
Thank you very much.
May I ask again our dear professors to answer the questions in the question and answer box down there, because we are out of time for the international speakers. If you can please write the answers to our dear attendees, I will be very grateful. Thank you so much. Now we will move to the next speaker. Our next speaker will be Professor Assam Al-Karif, Professor of Orthopedic Surgery, Alexandria University. Professor Assam أيقونة العلم والأخلاق في ألكسندريا وفي مصر كلها يا فندم. شكرا جزيلا يا فندم على انضمام سعادتك معانا. Professor Assam will speak about choice of implants for complex distal radius fractures, a very important topic. Thank you so much, sir. Professor Assam, you are with us, sir?
Yes.
هو في ريزونانس في الصوت عن سعادتك دكتور عصام بيه. Professor Assam, حضرتك معانا يا فندم؟
Yes, just 1 second.
Yes, sir. Yes, sir. I'm sorry, sir.
Full screen. Sitting. Okay.
Yes, sir. We can see your presentation, sir.
Okay, I'll just start.
Full screen, please, sir. Yes, sir. Thank you, sir.
Good afternoon, everybody. Thank you very much, dear Chairman, Professor Ashhab. This is a great honor to be with you in this marvelous seminar or webinar. I'll speak today about the choice of the implants in complex distal radial fractures. The distal end radius fractures is a matter of interest of all of the orthopedic surgeons, and it is an everyday practice of all of us. And the concepts and the principles of management for treatment of these cases has been totally changed in the last decade. Now each fracture should have its tailored and designed way of management. We have, for example, such complex fracture. We have to study the fracture displacement, the joint involved, whether it is the radiocarpal or the distal radioulnar joint also is involved. And we have to assume the mechanism of injury. We have to identify the size of the fragment and its location. We have to comment about the bone quality, if there is any associated soft tissue injury or ligamentous injury, either intrinsic or extrinsic ligaments. And also we have to consider the patient requirements and his age. So we need to know a detailed anatomy and the biomechanics for each fracture in order to choose the most appropriate way of management of these injuries. We also may need to use different modalities for treatment in the same time. And of course, none of us would like to reach this stage of complications with malunion, erosions, disruption of the articular cartilage, disruption of the DRUJ, ulnar impaction, TFCC tear, and persistently painful wrist and weak hand function. So all of these points we have to address while assessing the fracture of the distal end of the radius, the fracture displacement, mechanism of injury, what are the joints involved, location and size of the fragments, stability of the fracture, bone quality, if there is any associated soft tissue or not, and the age and requirements of the patient. Most of the treatment options for the fracture of the distal end of the radius, either distraction way or buttressing way, with the use of external fixator or internal fixator, with or without Kirschner wires, or buttressing plates or fragment-specific fixation. We have several types of plates present in the market, with low profile, thick plates, locked plates, variable angles, fixed angles, and so on. If we take this fracture, for example, we have comminuted fracture, maybe die punch, compression injury, shortening of the distal end of the radius, particularly on the right side, radial height may be disturbed, and fragment affecting the articular cartilage, and the fragment is embedded inside with dorsal displacement. And we have to reconstruct all of this and restore the normal anatomy and the normal heights and angulations of the distal end of the radius. Studying of the CT scan, comminution, particularly on the ulnar side. But we can note that the radial side or the radial cortex is intact. Only the ulnar side is affected, as we can see here. But in this sections, we can see that the volar cortex also is intact, and the comminution is present only on the dorsal side, while the volar side is intact. So we have to approach this fracture through the dorsal side, not the volar side. So we went from the dorsal approach and using a buttress plate and transosseous suturing. This is another example of complex distal radial end radius fractures with very comminuted, very small fragments, massive shortening, complete translocation of the hand and carpal bones. Now, how can we reduce these fragments? How can we fix? How can we restore the normal anatomy and the length of the distal end of the radius? Are we going to do some sort of distraction or compression or buttressing to reach a construct stable enough and to be maintained till the union? We prefer to use the internal fixation or internal distraction plates or distraction osteostensis. And this is after 6 weeks. Another example with fracture of the distal end of the radius, minimal shortening, massive volar displacement. So it is a compression pronation injury. Bone quality is rather good. And if we look at the CT scan, we can see that the comminution present both on the volar and the dorsal side. The DRUJ joint is affected, shortening and collapse. So we can go from the volar side, reaching the dorsal fragments, and augment the plate, buttressing plate fixation with Kirschner wires. This is another case with comminuted fractures of the distal.
موجود عليه. أنا دخلت وشايف.
Comminuted fracture of the distal end of the radius, again intra-articular involvement, but with minimal displacement. This patient was hepatic with high PT and ST with prothrombin activity only 70%. So we choose to go for percutaneous fixation using Kirschner wires and achieve good results and restoration of the normal anatomy. This is another case with fracture of the distal end of the radius, volar displacement, and volar subluxation of the whole carpus together with the volar rim fragment. And if we notice here, the fragment is rather small, short, and if we remember, this is the watershed line. We cannot put the end of the blade behind this line, so it will be very difficult to fix the volar rim fragment to reduce the volar subluxation of the carpal bones here. So we used to use Amy Moore technique of spring wire, fixing the volar fragments with Kirschner wires that is bent underneath the buttressing plates. And again, we can achieve a stable reduction with normal anatomy. There's another difficult case with 70 years old man with dog bite, with these severe soft tissue injuries. Sorry. And this is the X-ray. We can see the comminution, shortening, unstable. Maybe there was a bone loss. And of course, in these situations, we will not be allowed to use proper fixation. So we choose to put two Kirschner wires to maintain longitudinally to maintain the alignment, two transverse Kirschner wires to maintain the length, and the position is not bad. And after 3 weeks, the wounds are okay. There was no signs of infection. And the construct is rather good. But after a while, there was loosening of the transverse wires, collapse of the distal fragment, subluxation of the distal end of the ulna, loosening. Look at this hole. So we went for buttressing plate, bone grafting, and we found that this would not be enough, and therefore we augmented the fixation with a dorsal distraction plate. But after another 2 months, the bone graft was resorbed with osteoporotic distal fragment. As we can see, not fully united. So we went again, re-bone grafting, corrected the distal screws, and thanks for the distraction plate that helped us not to lose the construct. And thank you very much.
Thank you so much, my dear Professor Assam El-Karib, for this very interesting talk about the choice of implants in distal radius fractures. Thank you so much, sir. May I ask again, my dear professors, to answer the questions of our dear attendees in the question and answer box. Our next speaker will be Professor Benha Korana, Professor of Orthopedic Surgery at Azhar University and one of the board of the Egyptian Orthopedic Association. Professor Benha will speak about forearm instability, diagnosis, and management. Professor Benha.
Thank you. Is it okay now?
Yes, sir. Yes, sir.
Okay. Thank you for inviting me for this elegant conferences. And I think we have a lot of national and international speakers. My talk today about forearm instability. And thank you for this very nice trauma webinar about trauma. This is my learning objective about the definition, injury pattern, anatomy, some structures, involvement, diagnosis, and treatment option. What is the definition? The definition of the forearm instability is a complex problem resulting from trauma, disruption of the forearm stabilizer. So what are the stabilizers of the forearm? It's the radial head, the interosseous membrane, and triangle fibrocartilage complex. So looking for the anatomy and the biomechanical of the forearm stabilizer, we have structures in the proximal radioulnar joint with the articulation surface of the radial notch, annular ligament, and the head of the radius and the capitellum of the humerus. So the radial notch of the ulna, it is located in the lateral aspect of the proximal ulna. Annular ligament is a circular in shape as a ring, and the proximal radioulnar articulation composed of bone and soft tissues is the head of the radius with the radial notch. The distal radioulnar articulation is the bone, the head of the ulna, and the ulnar notch of the radius with soft tissue triangle fibrocartilage. So the ligament in the proximal part is the radioulnar joint, it's annular ligament, the quadrant ligament, and the oblique cord. In the distal one, the distal radioulnar joint, it's composed of the dorsal radioulnar ligament, palmar radioulnar ligament, the interosseous membrane. So the annular ligament is a strong band in the inner surface of the ligament covering the head of the radius. The quadrant ligament is attached, extending from the inferior edge of the radial notch, and its main function is helping maintaining the radial head in the position to the radial notch. The oblique cord is a flat fascial band in the ventral of the forearm, and the main function significant is not clear. So the distal radioulnar joint is articulated the ulnar notch of the radius with the articular disc and head of the ulna. The ulnar notch of the radius is located in the distal end of the radius along the interosseous membrane. Articulated disc, it is very important. It is called the triangle fibrocartilage because it is a triangular in shape. It is the main function to provide stability to the inferior radioulnar joint. So the ligament of the distal radioulnar joint, we have a palmar and dorsal radioulnar ligament and the interosseous membrane. The main function of the interosseous membrane is to maintain the space between the radius and the ulna during the forearm rotation. The very important structure is the interosseous membrane is composed of 5 ligaments. The main one is the central band, is the key portion to the reconstruction in the case of injury. Also, we have an accessory band, and also we have distal oblique band, proximal oblique cord, and dorsal oblique accessory cord. So muscle which are acting on the forearm, pronation by the pronator teres, pronator quadratus, and the supination by mainly by biceps and the supinator. And this is the muscle of the forearm. But what are the forearm units? The forearm unit is a single function unit composed of radial and ulnar, and their bone and soft tissue interacting, namely the proximal radioulnar joint, the DRUJ, and the interosseous membrane. And this is what we call the forearm unit. It's bone and soft tissues. The function of the forearm unit is to maintain the structural stability of the radius relative to the ulna and preventing divergence, transfer the load from the distal radius at the wrist joint to the proximal ulna as the elbow joint, provided attachment to the muscle traversing the hand, wrist, and elbow. This is the forearm unit, which is composed of bone and soft tissues. The radial head is the primary contributing to the longitudinal forearm stability. The second stabilizer are the triangle fibrocartilage, TFCC, and the interosseous membrane. The 3 mechanisms for this normal forearm function, the primary axial stabilizer is the radial head. The second stabilizer are the interosseous membrane and the ligament around the DRUJ and the PRUJ. The third principle is that the interosseous membrane is solely responsible for transfers a load between the wrist and the elbow. So the forearm instability, the forearm is a ring concept. You have to know this is a ring, and the key role for this is the head radius, the interosseous membrane, and distally the distal TFC. So it can be injured by double or multiple injury to these ring structures. This is the weight, if the transmission of the weight during compression and during distraction through the forearm to the elbow, or from the forearm to the wrist. So the rule of interosseous membrane, this is paper being published, is the low transverse and preventing radius and ulnar bone. And the forearm interosseous membrane contributes to 70% of the forearm stability. We know from the anatomy band, the main one is the central band, can be injured and associated with the elbow fracture. So this is what we call the hidden injury. The interosseous membrane injury is called hidden injury. So we have two types of longitudinal forearm stability, either acute or chronic. The mechanism of injury of the longitudinal forearm stability resulted from trauma, falling and outstretching hand, distributing and leading an impact on the axial force. This can be leading to several types of fracture, like ischial injury, Galeazzi fracture, and the Montego fracture dislocation. This is the mechanism of injury and how the force transmitting and injury to the head of the radius. This is how the injury, it can be by distraction force, attraction force about the collateral ligament by injury of the collateral ligament, or avulsion, then impaction of the head of the radius of the elbow with movement of the olecranon on the olecranon fossa. In ischial injury, as we know, there is disruption of the interosseous membrane. In the Galeazzi, there is a bone with inferior radio-ulnar joint injuries. And this is a distal radius fracture with distal radio-ulnar joint disruption. We have two types, volar Galeazzi fracture and dorsal Galeazzi fracture. And in the Montego fractures, the injury to the ulna with the radio-ulnar joint, with radial head disruption. And we have body classification into four types. So the pathomechanic of instability is traumatic axial load through the forearm. This is leading to radial head fracture, and this may be or may not be associated with disruption of TFC and interosseous membrane. This is the injury from the normal, the force transmitted when the interosseous ligament complex and the DRUJ are disrupted. There is no transferring of the load between the radius and the ulnar. And when the radiocapitellar relationship is lost, the radial head resection or fracture of the neck of the radial head, the ulnar transmitted the entire load to the elbow. And when the injury of the interosseous membrane and the TRUJ, the radius is longitudinally unstable and dissociation from the ulna, allowing the radial to migrating proximal. So you have, for diagnosis, you have to make a suspicious for that. So it is a high index of suspicious for this injury if you have a patient with the forearm injury. The diagnosis of acute, you have a high index of suspicious, history of axial load injury, examination of the whole upper limb is essential, concomitant bruising, swelling, tenderness in the elbow, the forearm, or the wrist may be present, although there is often mild wrist tenderness with the radial head fractures. This is an example for diagnosis of acute longitudinal forearm fractures. Also, we have a test, is clinical imaging of the C-finger compression test. This compression test elicits the pain with indicated disruption of interosseous membrane. And this is a test for compression of the inferior radio-ulnar joint. And this is insupination and pronation and abnormal movement with tenderness in the inferior radio-ulnar joint. And you have to examine for neurological test for the elbow dislocation, for the ulnar radius, median nerve, and median nerve lower anterior interosseous pain. So in the imaging, we have two types of imaging. We have a static X-ray. This is the X-ray, the radial head fracture commuted or with evidence of impaction. lateral elbow X-ray, loss of the empty space, assists the wrist radiography for evidence of positive ulnar variance. Comparative contralateral wrist X-ray should be obtained. This is an example of empty space sign and multifragmental radial head fracture. You have to suspect that there is a forearm instability. And this is a fracture of the head wrist impaction injuries. And we have a dynamic X-ray. This is two tests. Can you make an pronated grip view, pronator grip view? A difference in the positive ulnar variance may be observed. And we have an axial compression test, and we have normal longitudinal motion to be 5 millimeter or more, changing of the ulnar variance. This is the ulnar variance. And this is the axial compression test, distraction A and compression difference in this indicated positive interosseous membrane injuries. Ultrasonography can identify the central band injuries and the magnetic resonance and high signal and edema within the interosseous membrane. For the intraoperative, we have a pull test that is performed after removal of the head radius fragment, just to pull the bone. If there is an abnormal movement, indicated that there is instability. Or radial joystick test, that prevents the forearm using bone holding clamp, holding the proximal end, where is the lateral direction force, the spraying of the radius and the ulnar. And this is an example of the intraoperative test. Diagnosis also history of the elbow and the wrist injury, grip strength, history of previous axial injury, and then maybe remnant of the ulnar, and the positive grip test and the grinding test. This is an example of how to diagnose longitudinal, chronic longitudinal instability. Diagnosis is you have to put a high index of suspicious, and from the history, from sign of early failure, early loosening of the radial head, capitellar erosion or with the proximal migration of the radial head, give you a suspicious of chronic longitudinal instability. Radiography will be usually demonstrated positive ulnar variance and shows in the radio capitellar head, malunion, and previous surgically with the radial head. The aim of the treatment is to re-stabilization of this forearm instability. So address the specific component, either bony or ligament. For the bony, radial head, either repair or replace, and ligament, either repair or reconstruct. The most treatment strategy must be employed at the elbow, forearm, wrist, and whether there is an acute or chronic setting. In the elbow, the radial head, in acute injuries, the radial head fracture may be the only apparent component in the extrapyramidal, either you repair or replace. Repair more challenge. The range of the radial head arthroplasty implant, metallic and pyrocarbon, bearing surface options. And pyrocarbon better than silastic implant because the silastic leading to destructive synovitis. Radial head replacement, important consideration when you do this, you put the correct diameter of the radial head, the height of the implant length, because this will lead to a rapid capitellar erosion, medial offset, and also don't forget about cervicocephalic angulation. For the rest, treatment of TFC pathology by repair of the TFC should be considered, an alternative crossing the bend radius and ulnar. Ulnar shortening or straightening for the ulnar capitellar abandon. Interosseous ligament, there is a reconstruction and have many operation has been published. The interosseous ligament can be reconstructed either by Achilles tendon, flexor carpi radialis, palmaris longus, bone patellar tendon, or synthetic. Disadvantage, insufficient tensile strength. This is an example has been published about reconstruction of the interosseous ligament disruption. This is with using tightrope reconstruction, and this is a tightrope, and can be used also bone ligament bone graft for reconstruction of the interosseous membrane. And this is another example of reconstruction of the interosseous membrane. And this is the ligament augmentation and the reconstruction system. Your salvage procedure, when you have a patient with a chronic, you can do a salvage procedure. You're not responsible for the treatment. for the treatment of the pain and dysfunction. Use the Kabanji procedure and creation a one bone or creation a one bone forearm radioulnar synostosis. This advantage don't restore a good level of function and pain relief. This is a salvage procedure, a Kabanji procedure. You excise the distal part of the bone and the fusion between the distal end of the ulna and the radius with fusion. This is an example. Take home message to think about the stability of the forearm is gained by osseous and soft tissues. Rare lesion after high index of axial load needed to address soft tissue injury. Prognosis is generally poor. And this is my reference, and thank you for inviting me.
Thank you so much, Professor Karana, for this very interesting talk. شكرا جزيلا على حضرتك. احنا عارفين ان احنا يعني الوقت كان طايب بالنسبه لحضرتك عشان تجوين us. Thank you so much, Professor Benha.
Thank you.
شكرا جزيلا يا فندم. Our next speaker will be Professor Mohamed Mustafa Qutb, Professor of Orthopedic Surgery, Ashok University. Professor Mohamed is my dear brother and my dear friend, and we will speak about post-traumatic wrist arthritis, simple procedure, excellent results. Professor Mohamed, thank you for joining us, sir.
Thank you very much, Professor Ashhab, for inviting me among these eminent names, international and national speakers. Actually, they are my professors and colleagues. I would like to highlight a simple procedure that have been proven to serve our patients who have got complex wrist injuries, and there was only one option is to arthrodese or to fuse these joints, which is very cumbersome for a lot of patients, especially hard labral. I'm Ashok University Hospital, and my talk will be about proximal row carpectomy. Simply is this excision of the proximal carpal row, meaning scaphoid, lunate, and tracheatrium, and sometimes you remove the part of the scaphoid of the radial styloid to improve the range of motion and relieve the pain from the radial side of the wrist joint. So as we know that motion is life and life is motion, and we have taught a lot of our students these words. So the first prescription to keep this motion and to keep the mobility of the wrist joint was prescribed in 1944, and it was used to the ununited fracture of scaphoid and some types of Kienbock disease. And until very recently, there is a lot of publications about the same procedure and using it in another different indications like scapholunate dissociation. And this is a report in 2011. So what about the indications? It is the arthritic wrist, whatever it is, degenerative or traumatic, and the contraindication have been put like arthritic lunate fossa or capitate proximal pole, because they are the two articular surfaces which will be the main dominant for the mobility of the wrist after excision of the proximal pole. However, I think it is a reproducible form of the procedure, and we will see how we can increase our indications for using the procedure for these two contraindications. So the main stay about this procedure is to provide a painless, adequate motion grip strength of the wrist joint. And we insist on doing a preoperative evaluation to see the arthritis of the capitate and the lunate fossa, because, as we said, these are the contraindication to do these procedures as presumed previously. So this is the surgical approach for the open proximal row carpectomy. It is a dorsal approach, and either you use this tongue flap, distally based capsular flap, if you want to cover the arthritic part of the capitate or the lunate fossa in the radius, or you can use this limb ligament preserving approach, which is like a rectangular type of flap of the capsule, radially based, and you can do the proximal row carpectomy through this window, and then you close it back, so you have preserved the whole dorsal ligaments of the wrist joints. And this is a small video showing the how you can do the procedure, and this is the dorsal approach and identifying the extensor pulse longus and the floor of the fourth compartment, where is the posterior interosseous nerve, and we do wrist denervation through neurectomy of the posterior interosseous nerve, and also we open the interosseous membrane and do denervation of the anterior interosseous nerve also. And the next question is, do you prefer to do it as a one piece or a piecemeal? Most of authors prescribe the removal of the carpal row in a piecemeal manner. However, I find it in my hands it's difficult to remove all the fragments, and might keep some fragments or leave some fragments, especially volar. So I prefer to make it like a one piece. However, it takes some time, but with practice you will find it very easily, and you can excise the whole carpal row in a one piece like this, and you can identify the pathology. For example, this is an advanced Kienbock disease, and you can see the coronal fracture in the lunate, and these are the ligaments, examining the intercarpal ligaments, and you can take it like a one piece, like you can see from the video. The most important crucial point of view is to keep the volar radio-leonotracheatrial ligament. This is a very important ligament to keep in the volar part, because if you cut it or it is injured, you will find an ulnar translation of the wrist joint post-operatively. So it is a crucial point during your surgery to keep this ligament intact volarly. What about arthroscopic proximal row carpectomy? Actually, it is mentioned in the literature, and I've tried once, but you will lose a lot of shavers, and it will take some time more than the open part, and I did not find any advantage, except it is putting some hard time to the surgeon rather than making a benefit for the patient. What about the contraindication? As we have said, this is the most important slide, because it has been postulated that it is contraindicated, this procedure, in arthritic lunate fossa or arthritic capitate proximal pole. So we have seen that there are a plan to extend your indication into those two contraindications. Plan A is to cover this arthritic part, and it is prescribed by Green that you can make a tongue flap of the dorsal capsule like we have seen in the previous slide, and you can suture it back to the anterior capsule, so you cover this part of the capitate or the lunate if it is arthritic. So this is called interposition capsular flap, so you can use it if you have arthritic proximal pole or arthritic, the capitate fossa or the lunate fossa in the radial scaphoid. And this is a one example intraoperative photo showing how it is arthritic, the distal radius, but the capitated okay. So you can use, this is the capsular flap distally based, and it is sutured back to the volar aspect of the capsule. So it is like interposition between the two articular surfaces if it is arthritic. And this is the range of motion, and this is the post-operative X-ray. You will see a distraction between the distal carpal row and the radius because of the interposed capsule in between. The plan B, to extend your indication of this procedure, also you can use what is called mosaicoplasty, which have been postulated to be used in the knee joint and other joints in the body. Also, you can use the same procedure for the carpal row. This is an example of a huge ulcer and underlying cyst in the capitate. And because we did a proximal row carpectomy, you have a lot of bone, intact bone with articular cartilage. If the scaphoid did the original pathology, so you can take from the lunate. If the lunate, you can take from the scaphoid. So you have plenty of osteoarticular normal cartilage. You can excise and you can tailor it like as the defect exactly, and you can close your defect like this one, and this is extended your indication of the proximal carpal low carpectomy to arthritic joints. What about wrist innervation? I think it is a crucial part of our technique, and it has been postulated that you do posterior and anterior interosseous nerve neurectomy through the dorsal approach, where you do the open proximal row carpectomy. What about the postoperative protocol? It has been in the literatures have been stated that you take continuous palmar splint for 2 weeks, intermittent splint for another 4 weeks, and physiotherapy started after 4 weeks. But actually, personal experience in my hand, I allowed the patient immediate active daily living as tolerated, as pain tolerated, and I have seen some patients restored their complete function, for example, a butcher, before removing the suture. I mean, before 2 weeks post-operatively. And these are some case presentations to show the results of our procedure. This is one example of a male, 47 years old. He has got a scaphoid non-union advanced collapse with arthritic radial side of the scaphoid fossa. And this is the MRI and CT, and to see the magnitude of arthritis. And this is after excision. And as we have seen, this is assessed in the capitate, and we put the mosaicoplasty from the removed bone. Another case also, we fix this osteoarticular cartilage, and this is the range of motion. Of course, it is less than normal. However, it kept motion, and it gives much better results than wrist fusion. And this is the follow-up X-rays and hand. So in conclusion, it is a reproducible, simple procedure. As if you got arthritis, which was considered as a contraindication, now you can extend your procedure to this contraindication by these 2 plans, either interposition arthroplasty by the capsule or by the mosaicoplasty. It improves both pain and range of motion, and other options are still available if the usual contraindication have been found in such cases. And also you can use your wrist innervation to magnify your procedure in pain killing for your patient. Thank you very much, Professor Ashhab. Thank you for the attendees. I hope it was a small message for you. Thank you very much.
Thank you so much, Professor Mohamed Mustafa Qutb, for this very interesting presentation and very interesting talk. Thank you so much, sir. Again, may I ask my dear speakers and my dear professors to answer the questions, to write the answer of the questions in the question and answer box to our dear attendees, because we have to stick to the time. Our next speaker will be my dear Professor Amr Azzam, Professor of Orthopedic Surgery, Neuromotor National Institute. Professor Azzam will speak about a very interesting topic, articular distal radial fracture in adults. Professor Amr, thank you so much, sir.
Thank you, Professor Mohamed, for your kind invitation. Honored to be with you and my dear colleagues and professors. Our message today is to speak about a single case of the articular distal radial fractures in adults. And of course, Professor Assam Al-Karif and Professor Beha Korna have made my job easy. I am working in the National Institute of Neuromotor System here in Cairo. Here we have a case of 39 years old female with a fallen outstretched hand, with left non-dominant hand, with no other injuries regarding the elbow and the carpals. Our learning objectives, we are going to speak about the different, or describing the different types of distal radial fractures, with listing the indications for operative and non-operative treatment, which is a very important to be highlighted. Also, to outline the surgical approach for the fixation of the radial fractures and the choosing the appropriate implants according to the fracture type. Okay, this is a distal radial fractures to be epidemiologically the most common in all ages, might be a variant from a minimally displaced fracture with a low energy, with a poor bone stock and elderly populations, and another variant with a high energy trauma occurs most probably in the young populations with a shortening and a collapse, might be accompanied by carpal instability. To know our way in the lower radius, we have to know the anatomy properly regarding the dorsal cortex, which is thinner and weaker, with the volar cortex with the origin of the radiocarpal ligaments, which has to be preserved all through your intervention. Scaphoid fossa in the lower articular surface radius, and the lunate fossa, and the most important is a sigmoid notch, taking special consideration why it is fractured. What about the normal variants? Here, a volar tilt of the lower radius with 11 degrees, as we all know, with a radial height about 11 to 12 millimeters, and to know the radial inclination 22 to 23 degrees. This is the most important variance that we may build up our necessity for surgery for such a cases. Also, lastly, the ulnar, which was going to be a 0 degree. Here we have the classification starts, I think, long years ago, but the columnar series started by Regazzoni 1995 and also republished in 2019 by Blazer. How can we do a surgery, or what is the necessity for the operation? To know the necessity for the operation, we have to know when not to operate. When not to operate in the lower radius means non-displaced fractures and a very low demand patients and geriatric patients with unfit for surgery. And also, this is absolute indications for these lower radial fracture fixations and the open fractures and the articular fractures and the acute carpal tunnel syndrome. What about the relative indications? What will be the failure of close reduction and failure of adequately to reduce the fracture and difficult to treat a patient with a cast. The treatment options that Professor Assam mentioned, this might be a close reduction or a cast, or be aware about the compartment syndrome. Keep an eye on your patient, and a close reduction with a percutaneous spinning, or a close reduction with application of an external fixator, an open reduction application of a plating aided by wires, or a combination of all of these. What about the American Academy of Orthopedic Association 2017? It stated that there is no method of fixation to be recommended over the other, and there is no level 1 clinical evidence suggesting a superior modality for treatment of distal radius fracture. So it is a la carte. Back again to our case, to remember such a case. Can we classify such a case as a fracture? No, we have to use another modality. So we have to know the classification, the most popular nowadays, which was published 2018 in the OTA, the types classified into type A and B and C. To classify such a fracture regarding all the articular fractures, we have to do the CT with a multi-slice. Denoting that we are facing the articular multifragmentary fracture with a simple metaphyseal and a small extra-articular tip of the styloid process fracture of the ulna. What about our aim? The aim for the anatomical reduction, as we all know, is with no steps, no gaps, with a rigid fixation, and as we all know, the principles, the early mobilization. What about the planning has to be done? The planning starts from the preoperative period, the patient examination, if there is any wounds or edema, consultation with our colleagues to prepare the idea and the aim and the plan, and also the patient counseling and consent. Full instrument set preparation for this such a case will be a locking compression plate and K-wires and many Hoffman fixator. And to review the literature speaking about the internal fixation versus external fixation, 2015 and 2017 as well. Why are we going to use an LCP plate? LCP plate, as Professor Assam mentioned, we have different modalities of LCP plates, but highlighting an internal fixator principle, not jeopardizing the periosteum. It wouldn't be scrapping the periosteum, and this is a great advantage with a low offset plate, and the locking head screws is an angled plate all of them at the articular surface, when it's fixed to the plate, act each of them at an angle plate with a great stability advantage from versus the conventional screws. What about the steps? You have to prepare your plan from A to Z regarding the contralateral side testing and the external fixator as a temporary fixation intraoperative with a close reduction and traction under image with a percutaneous wire to fix the posterior fragment, as the LCP wouldn't reduce the fragment. You have to reduce the fragment before application or fixing the fracture by LCP. Applying the LCP plate with a final radiology check, as we are going to mention, and the removal of fixator with a DRUJ, as Professor Basha spoke about DRUJ assessment before you go away, and closure in layer and back slab. So the contralateral rest has to be examined for regarding the radiological parameters and the range of motion. To know your fixator, you have to know the fixator has a proper safe corridor regarding the second metacarpal shaft and the med shaft or diaphyseal part of the radius fixation corridor. Here we have the plate fixation using the volar approach, the Henry approach, and then applying the K-wires temporary fixation of the fragments, and then application of the LCP plate properly. The final radiological check after fixing by screws, LCP screws proximal and distal, you have to use two modalities or two views. The dorsal tangential view, here we have the arm of the patient tilted about 15 degrees from the vertical, and the rest is flexed. Polarly to have the highlight about the image, showing here the proper length of the screws, not piercing the dorsal cortex, not jeopardizing the extensor tendons, which is a very important complication you have to avoid. And another view is the lateral view, but we have to elevate the forearm in a 60 degrees to have the dead lateral view, abolishing the effect or the double effect of the radial styloid to know your screws are intra-articular or extra-articular. You had to use these two views. What about the DRUJ? It is a repetition of Professor Baha had mentioned. It is an ulnar compression against the radius, while the forearm is passively put in a flexion, so full supination and pronation. When you wouldn't hear the palpable click, it means that it's a stable DRUJ, which is mentioned in the AO surgery reference. What about our case? Here we have the post-operative X-ray, immediate post-operative X-ray, and another one 6 weeks post-operatively, showing the healing process is ongoing, and the physiotherapy starts for 12 weeks. Here we have our clever patient with a full range of motion regarding flexion, extension, ulnar deviation, radial deviation, which was regained. What about our take-home message? We have to think about the surgical indications, thinking about this when it's an intra-articular step of 2 millimeters or more, or radial shortening more than 3 millimeters, and the dorsal tilt will be a minus degree, which is a normal, is a volar tilt by 10 to 11 degrees, with a radial inclination less than 15 degrees, which is normally 22 degrees. If you select, please, the open reduction tendon fixation, be aware about the dorsal tendons and the anterior radicarpal ligaments as well. And please don't forget to check the DRUJ, otherwise you are going to fix the ulnar styloid. Lastly, it's important to understand the anatomy of the lower radius. Go to more information having a traction view intraoperatively or the CT scan. The CT scan is much better nowadays, and multiple treatment options considering the patient needs and your skills as well. And lastly, reminding you there is no level 1 evidence to support the treatment modalities. And lastly, please have a good soft tissue handling. Thank you very much.
Thank you so much, Professor Amr Azam, for this very interesting talk. Thank you so much, sir.
Thank you.
Now we will move to our next speaker. Our next speaker is my dear friend and my dear brother, Professor Faisal Zayed, Al-Azhar University. Professor Faisal will speak about posterior shoulder dislocation. Professor Faisal.
Assalamu alaikum.
Alaikum salam.
First of all, I'd like to express my deepest gratitude and thanks to Professor Mohamed Ashhab for inviting me and giving me the opportunity to share in this mega event, International Trauma webinar. My talk today is about shoulder trauma case discussion. I'll share with you some cases of posterior shoulder dislocation. Just a minute, please. Okay. First case is a male patient, 25 years old, exposed to trauma 6 weeks ago, and unfortunately managed conservatively by 3 different orthopedic surgeons. By examination of the, we can see the locked shoulder, and this is the X-ray of our patient. By reviewing the normal anteroposterior view, routine anteroposterior view of the shoulder, we can see clearly the normal Shenton or Mollins line and the glenohumeral overlap with preservation of the neck shaft angle of the proximal humerus. In our case, there's disruption of the Mollins line, which is equal to the Shenton line, with what's called the glenoid vacant sign with no overlap between the humeral head and the glenoid, with light bulb sign due to extreme internal rotation of the proximal humerus. By doing scapulolateral view, we can see clearly here is the humeral head is outside the glenoid, and the CT is of great value. It's very beneficial in the diagnosis of cases of posterior shoulder dislocation, especially in cases of locked posterior shoulder dislocation, as we see here. This is the 3D CT of the patient. As regarding options for the treatment, maybe non-operative, acute reduction and embolization external rotation for 6 weeks. I think this is not the option for this case. And we all agree the patient need an operative intervention. What about the operative options for this patient? Open or arthroscopic posterior labral repair after open or closed reduction. Open or arthroscopic posterior capsular shift and rotator interval closure. Humeral head derotation osteotomy. Allograft, osteochondral allograft. Open reduction with subscapularis transfer, which is called the McLaughlin or laser tuberous transfer to the defective modified McLaughlin. Hemiarthroplasty. And lastly, total arthroplasty. The decision depends on the duration of dislocation, age of the patient, activity level of the patient, and lastly, the defect size. There are a lot of algorithms suggested for locked posterior shoulder dislocation, as this one by Kukalis in 2017. Depending on either the patient is presented acutely or chronic after 3 weeks, and according to the size of the defect, if it is less than 25% of the humeral head or larger than 25 and less than 50% of the humeral head, and if the defect size is more than 50% of the articular surface. So this is a suggested algorithm for the treatment of cases of locked posterior shoulder dislocation. In elder patient with low debound, we can proceed for conservative treatment. If the defect is between 20 and 30% and the shoulder is stable after open or closed reduction, we can proceed for conservative treatment. And if the shoulder is unstable, we can proceed for McLaughlin or modified McLaughlin procedure. If the defect of the humeral head is between 30 and 40%, we can proceed for allograft, osteochondral allograft, with or without arthroscopic Bankert repair. And if the defect is more than 50%, we can proceed for arthroplasty. How can we measure the reversed Hill-Sachs defect? By drawing a circle over the humeral head and drawing a line from the center of this circle to the anterior and posterior ends of the defect. And there are a lot of papers published to treat the reverse Hill-Sachs lesion as this one in treating midterm outcome following fresh frozen humeral head osteochondral allograft reconstruction for reverse Hill-Sachs lesion, more than 30% with good results, by reshaping of the reversed Hill-Sachs into elliptical form and taking an osteochondral graft and fixing it with 2 headless screws. And this is a post-operative X-ray of this patient. By going back to our case, this is the locked posterior shoulder dislocation. By measuring the humeral defect of the humeral head, reverse Hill-Sachs lesion, we found it is 25% of the humeral head. So we choose to do an open reduction with subscapularis transfer, as mentioned by McLaughlin in 1952. And sometimes we need to do a transfer of the lesser tuberosity, which is modified McLaughlin by Hughes and Neer in 1975. This our patient under anesthesia. We can see obviously the locked shoulder with no abduction or external rotation. So we try just the trial of closed reduction, but it's failed. So we proceed for open reduction through deltopectoral approach and delivering the humeral head into the glenoid. And we can see clearly the reversed Hill-Sachs defect in the front of the humeral head. Then we insert 2 suture anchors into the defect with subscapularis tendon transferred into the defect and fixed with sutures. This is the post-operative X-ray of our patient. Immobilization of the shoulder with an external rotation brace for 6 weeks, followed by progressive passive active assisted and active range of motion and rotator cuff strengthening exercise for another 6 weeks. This technique results in free range of motion, stable shoulder with good joint congruency. Second case is this patient, 30 years old, exposed to a road traffic accident, and they come to us after 2 months and treated by the same way. The defect size was 30% of the humeral head, and this is the post-operative X-ray of the patient, and this is the range of motion of our patient with completely full range of shoulder motion, so we can't differentiate between the affected and non-affected shoulder. The last case was a male patient, 65 years old, presented after falling down after sudden convulsion attack. We can see the glenoid vacant sign and the light bulb sign in spite of preserved Shinton line. And this is a 3D CT of the patient, and this is the CT. The patient undergone a trial of reduction, which was failed, and come to me after 2 trials of closed reduction. Under general anesthesia, we do another trial of closed reduction. The most important thing is to apply a lateral traction force over the proximal humerus to disimpact the posteriorly displaced humeral head with the longitudinal traction in the internal rotation to avoid fracture of the proximal humerus. This is a CT post-reduction, and we choose to treat this patient as he is low-demanding patient, 65 years old, conservatively, and the patient do well. To conclude and take-home message, acute posterior shoulder dislocation are less common than anterior dislocation, but more commonly missed. 50 to 79% of traumatic posterior shoulder dislocation seen in the emergency department are undiagnosed. Abduction, flexion, internal rotation at time of injury. Look for light bulb sign and the vacant glenoid sign and disrupted Shinton lines sometimes. Reduce with traction and gentle anterior translation and avoid external rotation, which can lead to fracture. As regarding decision-making, you must keep in mind the duration of dislocation, age of the patient, activity level, and the defect size. open reduction with subscapularis transfer or lesser tuberous transfer to the defect are good options for defects between 20 and 30%. Thank you again.
Thank you so much, Professor Faisal Zaid, for this very interesting talk. Again, may I ask my dear speakers to answer the question of my dear attendees in the question and answer box. Now we will move to the last speaker in the upper limb session, my dear friend, Professor Ashraf Abdelaziz, Professor of Orthopedic Surgery at Al-Azhar University. Professor Ashraf will speak about post-traumatic radial club hand deformity. Professor Ashraf.
Thank you, Professor Mohamed Al-Ashhab, for this invitation. I think there are problems in sharing my presentation. So I will start with another device. Yeah, give me one minute.
Okay, sir.
Okay. Okay, sir. It's okay.
Yes, sir. Please. Yes, sir.
Okay, sir.
Can you maximize the photo bit? No. لا هي كده اختفت يا فندم. ايوه.
Okay, sir.
Yes, sir.
It's good.
هو حضرتك بس اعملها ماكسمايزيشن يا دكتور اشرف وشيل الصوره بتاعتي لان انا هقفل صورتي خالص.
Are you hearing me? Okay.
هو بس حضرتك ماكسمايز الكيس برزنتيشن. ماكسمايز الكيس برزنتيشن اللي هي مش باينه قوي فاهم. يس سر. بالظبط. حضرتك ممكن نريموف صورتي بقى خالص يا فندم بعد اذن حضرتك. تمام. اوكي. ثانك يو سر.
Now we'll talk about acquired radial club hand case report. Introduction. Treatment of acquired radial club hand is difficult. The option and the guidelines for treatment of the congenital variety may not be applicable for treatment of acquired type. The goals are cosmetic improvement, maintenance of any wrist motion, and stable pinless wrist and forearm motion. Surgical option, interposition bone grafting, centralization, radio-ulnar transposition. Recently, the circular external fixator can be used for bone transport. Our patient, she is a female, 5 years old, with history of chronic osteomyelitis of distal radius, managed by debridement several times, about 5 times. Signs of vision deformity, instability, limitation of left wrist, and the cosmetic affection. This is a picture of the patient, and this is a photo. There are complete instability of the wrist joint and the cosmetic affection. This is scars of previous multiple operation. This pre-operative X-ray, there are complete instability of the wrist joint, complete absorption of the radius. What to do? The goal: cosmetic improvement, maintenance of inner wrist mobility, stable pelvis, wrist, and forearm motion. Our surgical options: interposition bone grafting, centralization. In this case, not available for radio-ulnar transposition, or circular external fixator. But I choose centralization and manage this patient like congenital radial club hand. Our surgical technique: this is two flaps, flap on the ulnar side and the central flap, and we will move the ulnar flap to the central flap, and central flap we will move to the radial side. The scar on the radial side we will be managed by Z-plasty. The surgical technique we will be in this next video. Sorry, this is the flap.
Acquired أو traumatic radial club hand كان حصل لها fracture radius وبعد كده حصل فيها necrosis
This is the two flaps, and we will move this flap, ulnar side flap and central flap, we will move it to the radial side. There are markers on the extensor tendon.
احنا عملنا الفلاب اهي، ادي الفلاب بتاعتنا الفيونكا اهي كده،
two flaps،
وبعدين هنلفها كده لما نيجي نلف الايد، فده السكين الاول، ده الاكستنسور
تندون.
تمام. دي
there are loss of the extensor pollicis longus.
هنا الاكستنسور pollicis longus موجوده بس يعني في ادهيجن جامده جدا.
There are crushed extensor pollicis longus and the loss of attachment. This is the extensor carpi ulnaris. And this is exposed the distal ulna.
فتحنا الكبسول وادي الديستال ulna.
And we start shaving of the distal ulna, articular surface.
الناحية دي على الراديال سايد. عملنا هنا Z-plasty.
This Z-plasty and the exposure of the radial artery.
وبعد كده
and lengthening of the flexor carpi radialis valvaris longus.
اللي هي الحاجات اللي على الراديال سايد. هنا بس فاضل معانا
I will remove the leonate bone, then make centralization and the impaction of the distal ulna inside the proximal carpal bone.
أي حاجة هنحاول إن احنا نعمل لها ريليز في الممبرين كده، أو تكون في حاجة. ده البوست بعد ما ثبتنا الواير.
After fixation of the antegrade and retrograde
الواير ما بين السير والألنا
from the third metacarpal to central to the medulla of the ulna
عشان ما يبقاش فيه
and another wire from proximal to distal.
extensor digital communis.
This is extensor digital communis and this extensor carpi ulnaris will make augmentation.
تبقى تشد لأنها طبعا المفروض إن هي دلوقتي بقت
and make transfer of the extensor carpi radialis longus to the EBL.
الألنر ارتري قدام ما جيناش ناحيته. هناخد هنا طبعا الاكستنسور كارباي رادياليس لونجس او
This is the post-operative X-ray. This is after 6-week follow-up. The result at the last follow-up, the angle of radial deviation was 5 degree, and the volar flexion is 4 degree. The length of the ulna post-operative remain equal to the opposite limb. No finger stiffness. This is after 2 months follow-up after removal of K-wire. This is the last follow-up of the patient.
عندنا ايه الانسايد
The patient not start the physiotherapy. Discussion, radial club hand deformity acquired after osteomyelitis is very rare, and surgical correction remains a challenge for the orthopedic surgeon. In literature, various treatment modality for the acquired radial club hand, like cancellous bone graft, vascularized or non-vascularized, combined with ulnar shortening, interposition bone grafting, centralization, bone transport by laser off. This reference, thank you.
Thank you so much, Professor Ashraf Abdelaziz, for this very interesting case discussion. Now we come to the end of the upper limb trauma session. May I ask my dear speakers to answer any questions in the question and answer box down there from our dear attendees. Now we will move to the next session. The next session will be the spine trauma session. And the first speaker will be Professor Abdel Fattah Saoud, Professor of Orthopedic Surgery in Shamsia University, and the Vice President of Shamsia University for Student Affairs. Professor عبد الفتاح مسافر النهارده في عمره، ربنا يجيبه بالسلامه، فالمحاضره بتاعته ريكوردد. دكتور مينا ممكن نشغل محاضره بروفيسور عبد الفتاح سعود؟
بسم الله الرحمن الرحيم. Good afternoon. I would like to thank Professor Mohamed Ashhab, Head of Orthopedic Department, Benha University, for the kind invitation to talk about this displaced sacral fractures title, the minimally invasive treatment of those fractures. Sacral fractures are classified by Dennis classification. It's either zone 1. This is zone 1 when the longitudinal fracture line is lateral to the sacral foramine. Zone 2 when it is transforaminal, and zone 3 when it is medial to the sacral foramine. So it's passing through the neural canal. Zone 3 of fractures, which is medial to the sacral foramine and passing into the neural canal, is important because of its consequences, especially the neurological impact, and thus it's subclassified according to the displacement of the usually present transverse fracture line into type 1, which is minimally displaced, only kyphosis, and more kyphosis with more angulation, and completely off-ended, and it could be fragmented but in the same place without enough displacement. Usually there are other fracture lines than the longitudinal fractures, as I said. It could be one of these shapes. And this is another classification for the transforaminal longitudinal fractures of the sacral bone. It depends on the relation of the sacral fracture line to the articulation between L5 and S1, and the integrity of the relation between the pelvis and the spine, or the spinopelvic dissociation, as we talk about, is depending a lot on this classification, which is Isler classification, because the fracture line could be passing completely lateral, or partially medial, or totally medial to the articulation between L5 and S1, and thus affecting the stability between the spine and the pelvis. The problem with the sacral fractures in general, it's a high energy trauma with a lot of degloving of the skin and a lot of hematoma beneath the soft tissues of this area. So there's a lot of problems coming from management of the sacral fractures, coming from the dehiscence of the soft tissue. So we have to put this in consideration. The indications of surgical treatment of sacral fractures in general are expanding retroperitoneal hematoma, because fixation of the fractures then causes tamponade of this expanding retroperitoneal hematoma. And this is very important to save the patient's life, to stop the expansion of the hematoma. when the displacement is more than 1 centimeter, with the soft tissue compromise that I talked about, because the more stability, the more possibility of soft tissue to heal. And another indication of surgical management of sacral fractures when displacement takes place while you are doing conservative management. That means that it's not uniting. And in the case of neurological compromise, and usually it's in the form of bladder and bowel disturbance, usually incontinence, and it could be also showing L5 or S1 motor weakness. What are the goals of surgery? Stabilization and decompression. Let's talk first about decompression because it's easier to talk about. It seems that on the long term, direct decompression by decompressing the sacral foramine and the canal, and indirect decompression by just reducing and stabilizing the fracture. On the long term, there is no big difference. The real difference is on short term. So my personal bias is that I tend to do direct decompression in incomplete neurological affection to give more chance for complete recovery, and then type 1 and type 3, but I tend to not directly decompress the transforaminal fractures. It seems, at least in my hands, that the indirect decompression of the transforaminal sacral fractures is working much better without a lot of hazard to the patient. Stabilization, put two important biomechanical factors in mind before doing any attempt of stabilization of fractures around this area. The first one is the lumbosacral pivot point. It's described by McCord in 1992, and it's the axis of flexion and extension around this area. It's this point in the back of L5S1 disc. And for any construct that would stabilize the area around this articulation between L5 and S1, only those devices that pass at least partially ventral to this point would really add to the biomechanical advantage of fixation around this area. And I will talk a bit more about this during my talk. The second concept is the fixation zones. The yellow and the blue areas, zone 1 and zone 3, are the good areas for fixation, but beginning from S2 till the end of the coccyx, this is zone 2, which is not giving enough fixation. The method of fixation that are used are the iliosacral screws. The iliosacral screw is a sacral screw that starts in the part of the ilium which is buttressing the back of the sacrum, then passes in this anatomical void between the sacrum and the ilium. So it passes in two cortices of the ilium, then in this void, and then through the sacrum. To be able to put a screw like this, which is easily transfixing then any longitudinal fracture in this area, you need perfect reduction first. Otherwise, this is a very dangerous screw which can easily pass through the canal. So you need perfect reduction, and you need a lot of image intensification, which might not be very bad for the patient. It's very bad for the surgeon if he's doing this a couple of times every week. He's killing himself. So this is a problem with the iliosacral fixation. The other method is lumbopelvic fixation using iliac screws, and then doing a set like this, which is fixing the lumbar spine to the ilium. So it's buttressing the sacrum through this method of fixation. There are a lot of methods of fixation that is doing this same function of the lumbopelvic fixation, like this flying buttress method. And you can use both iliac screws and iliosacral screws. It's called MW technique. But the problem is that it restrains all this lumbopelvic fixation. It restrains the waist movement and might cause early spondylosis or adjacent segment degeneration, especially if the lordosis is not well kept, which is the case in most of these lumbopelvic fixation. So we will keep the lumbopelvic fixation to its indication, which is lumbopelvic dissociation. The other traditional method is plating. The problem with plating, it's not minimally invasive. It jeopardizes the skin, which is already jeopardized, as I just said. And if you take the concept of the pivot point, the only screws that work well and pass through the plate is the ones around this area, around the posterior superior iliac spine, and those screws that can pass from the ilium in the direction of iliosacral screws, which is only 1 or 2 screws on each side, which is usually biomechanically not enough. The traditional sacral bar didn't work because it's connecting both iliac wings from behind, and it's completely posterior to the pivot point, so it's not working and it's restraining the movement without real effect on the fracture unit. So I came to this idea in 2010. We started using this internal fixator in my department in Ain Shams University. First of all, we published the first 2 cases of this idea of the internal fixator. What's in the internal fixator? It's iliac screws on both sides connected with a bar or a rod from behind. So it's like the sacral bar, but the sacral bar, as I said, did not work because it's completely posterior to the pivot point. But if we connect the sacral bar to iliac screws, and the iliac screws are passing from here and through the iliac bone, so by these screws, the whole device is passing at least partially in front of the pivot point by using the iliac screws, and that's why this modification of the sacral bar worked very well. It's very minimally invasive. This is the first case, so we were exposing with a big wound, the posterior superior spine, but now it's just 1 centimeter that can take 2 screws. The idea is that with the exposure of the posterior superior spine and directing your screw towards the greater trochanter, you don't need any image intensification. And then, so the 1 or 2 screws on this side, 1 or 2 screws on this side, and then connecting them subcutaneously with a rod. This is one of the cases, and this was the first case. It was an open book fracture with the longitudinal fracture of the sacrum. We used a small plate by fan steel incision first, and then put the internal fixator behind. And then this was the second case when we came up to the idea of having 2 screws on each side, and it caused this very good reduction. This is another displaced case. Actually, this is a life-saving maneuver. It could be done under even local anesthesia. It causes very good fixation to the longitudinal fracture of the sacrum, and with a modification, even with the transverse fractures, as I'm going to talk about in a minute. And it's a definitive method of fixation around this area with very good results. We are using it also for sacroiliac dislocations. The good thing is that we've done a biomechanical study in USA, in the University of Toledo, myself, Lisa Ferrara, and Andrew Wakefield, and Joel from the United States, on 6 fresh frozen cadavers. And we have shown in this result, this experimental study, that it's after creating the longitudinal fracture through the foramine of the sacrum and using this internal fixator, it's even stronger than the intact specimen, and we showed this in the ISASS in San Diego in 2015. And then we had this publication 3 years ago on minimal access fixation of longitudinal sacral fractures using this novel posterior internal fixator with a minimum 3 years follow-up. It was published in World Neurosurgery, and we have very, very good results according to Pullman clinical score, 84% excellent clinical results, 12% good clinical results, and 4% fair clinical results. Socially, 68% returned back to their work and recreational activities, 20% the same work with less capability, and only 12% had to change their jobs. So in total, we had 66% excellent final results and 18% good final results. The only problem with these implants is the prominence of the screws on the posterior superior spine, but we can start this medially. And when we do this, we avoid this prominence. And also we can use S2 Ehler iliac screws, which starts a little bit downward and lateral to the first sacral foramen. It starts here in the sacrum, passing in this void in the sacroiliac joint, and then becomes an ordinary iliac screw. We are now using this rather than the ordinary iliac screws, and it solved the prominence problem. We can use it also as a joystick, this kind of screw, as a joystick for reduction of these difficult transverse fractures of the sacrum. Thank you very much.
Thank you so much, Professor Abdel Fattah Saud, for this very interesting talk and very interesting topic. Our next speaker will be my dear Professor Shyam Farhood, Professor of Orthopedic Surgery and the Dean of Al-Azhar Faculty of Medicine, and the role model, الأستاذ دكتور هشام فاروق role model للأدب والعلم والأخلاق في أساتذة جراحة العظام في مصر. Professor Hisham will speak about cervical and lumbar injuries. Professor Hisham, please, sir.
Rahim. I would like to thank you very much, Professor Mohamed Ashhab, the Dean of Faculty of Medicine of Benha University, for your actually commitment, consistency, and all of the good work that you are doing for education of orthopedic surgeons. I hope that you hear me, okay?
Yes, sir, we hear you, sir.
Okay. I would like also to welcome all of the attendees and from everywhere. What I'm going to talk about, it is two case presentation. One of them is cervical injury and one of them is lumbar injury. The first one, is cervical injury. And this is male patient, 32 years old. He had a road traffic accident. And he had a road traffic accident since 5 months. He came to me complaining of neck pain with no neurological deficit, and he had no comorbidities. This is the first X-ray that he did 5 months ago, that seen by our colleague, and they just suspected that he might have C1 and C2 injury. So they went for further investigations, which was CT. And as you can see in CT here, there is fracture odontoid. The 3D was not that helpful because of the cuts and the techniques, so we did not found any help from this 3D. And MRI also, we found some edema at the odontoid back. So this patient was diagnosed already as odontoid back fracture type 2, and he did already X-ray, CT, and MRI, and the surgeons that they saw the patient decided to treat him conservatively. So the patient went for conservative treatment, and they did a follow-up CT scan for him. However, in his CT scan, they found that it is not, there is no that much union at the fracture site. Also, there was something like splitting here, which was oblique fracture in the odontoid base, so it appeared in the axial cuts as well. This is also the more focused CT showing that the fracture is still non-united. And this is the final CT that he did before he coming to see me. He did a CT scan, and as you can see, is non-union here and there, and there. Also, in the sagittal cuts, there is non-union here, there, and there. Okay. So now the question is, this patient is 5 months on the road, and he had the cervical spine injury, he had odontoid fracture, was treated conservatively. The question, shall we continue on conservative treatment or shall we go for surgical treatment? I discussed the matter with the patient, and the patient asked me about what kind of surgery that you're going to do. I explained to him what kind of surgery, and that we have many kinds of surgery for this, either from the front or from the back. But if we go back again from the front, we found some difficulties because of the oblique fracture and so on. So the back that will do C1, C2, whatever the technique, but it will limit your rotation ability of your cervical spine by nearly 50%. So the patient decided to go for conservative treatment, to continue conservative treatment, even with the possibilities of healing is not that high. So this is a follow-up X-ray showing the odontoid fracture, but we cannot see if there is healing or not. So we did a CT scan after follow-up. Maybe this is 4 months after he came to see me. And after he started to have this treatment with teriparatide and vitamin D and calcium. So there is a good improvement and good healing going on. We continued for another 3 months to do to give him the same medical treatment with Minerva support, and this was his follow-up CT, which found that there is good union. And also we did an MRI, which I don't think that it is an important here, but the patient was anxious to know if there is any healing or not. So we did it for him, and the sound also that there is good healing is going on. Finally, we did a CT 3D, which was not helpful like the other one, but if you look to the bottom here, we found that the odontoid is crossing, the healing is crossing here. So this is united odontoid fracture after conservative treatment, and this is his final CT, and you can see clearly here that there is good, very good union in the odontoid fracture. This is the axial cuts showing also union, and the take-home message from this case that conservative treatment is a valid option for treatment of minimally displaced odontoid fracture type 2. However, we need to tell your patient that this will take long time. So give him an average at least 1 year to decide that it is united or not. So if the patient willing to continue with your treatment, with conservative treatment, he can take his chances. The second case which I am presenting is about lumbar injury, and this is another patient. He is 32 years old. He had no comorbidities, was given history of RTA since 1 year. So this X-ray on your right side after 1 year from the fracture L1 and the fixation from G11 to L2. This patient complained to me from his back pain. He had weakness of both lower limb. Also, he had incontinence of urine, and he had sexual dysfunction. On examination, he had local tenderness and prominence in the middle of the back, good flexion but painful limited extension, with grade 3 dorsiflexion of both feet and hyperreflexia of both knees, but no clonus. This is a CT scan. Showing the nearly united malunited compressed old burst fracture of L1, compromising the spinal canal with local kyphosis, maybe up to 40 degrees. This is a coronal and the 3D, and this is the axial cuts, which showing that the screws were put in a proper direction. MRI was done, and also there was like a smooth compression rather than sharp compression from the retropulsed fragment. And this is the another shot of the MRI. The axial cuts of MRI also showing the canal, and it's about 50% compromise of the canal. So now we came to the treatment. This patient is a patient for conservative treatment? I don't think so. This patient, this implant will come out of the skin soon, and if we did not interfere now, we will interfere compulsory later on. And in this case will be stage surgery according to the infection and so on. Also, he having a neurological deficit and progressing. So this is like red flag alarm. This patient need to have surgical intervention. So what's your strategy? Are you going to decompress it, direct or indirect? Are you going to do corpectomy? Are you going to do pedicle subtraction osteotomy? Are you going to correct it? How are you going to fix it? How many levels that you are going to use it for fixation? And also, do you go for front surgery, back surgery, or front and back surgery, or you will do it all from the back? Also, are you going to do decompression, or indirect decompression is enough for you? So all of these questions need to be addressed, and before you plan what you're going to do for your patient. So what I did for this patient is decompression from the back. I did not go from the front. I did only back surgery. We did decompression, especially at L1-2. We widened the decompression that was previously there, and we took the disc out, which was at the base of L1, between L1 and 2. We could not go for the disc above because it is nearly fused. And we put 3 screws on each side, above and below the fracture, and we corrected the situation, and this is what we get post-operative X-ray. This is 1 month follow-up after the correction of the of this deformity. This patient is doing well, and he is recovering regarding the power in his legs and the reflexes, but his incontinence of urine is still there, so we are still weaning him from his catheter. I did not ask him yet about his sexual function. So the patient is doing better than before, and he is happy. This was the X-ray before, and this is the X-ray afterward, and we are following the patient up, and I will keep you informed about the outcome and the results. I'm very happy to read any question and answer any question. Thank you very much again, Dr. Ashhab. And to take message of this case, the implant failure could be avoided by studying your fracture well before fixation, as not every fracture would be treated the same. So types of the fracture are different, and also the method of treatment and fixation are different. Thank you very much.
Thank you so much, my dear Professor Hisham Farhood, for this very interesting talk. And please, if anyone wants to send questions in the question and answer box, I think Professor Hisham will answer it in the question and answer box. Thank you so much, sir.
You're welcome.
Thank you, sir. Our next speaker now will be Professor Mohamed Fawzi Khattab, Professor of Orthopedic Surgery and Spinal Surgery and the head of the AO Spine chapter in Egypt. Professor Mohamed is one of the eminent stars of spinal surgery in Egypt. And Professor Mohamed will speak about complex odontoid fracture case. Professor Khattab, thank you, sir.
Thank you so much, Professor Ashhab, for your kind invitation. And I am happy to be among these eminent stars of orthopedic surgeons all over the world. dear friends and colleagues from all over the world, I'd like to share with you one complex odontoid fracture case. Before starting this case, I'd like to highlight that odontoid fracture refers to 5 to 15% of all cervical injuries, and it is more frequently anticipated in elderly patients, but in my country, it is usually seen in young populations due to motor vehicle accidents. Anderson and Dolenzo classify the odontoid fracture into 3 types. Type 1, which is avulsion of the tip, and it is usually managed conservatively, and it is only fixed if you have something like occipito-cervical dissociation. Type 2 and type 3. Type 2 is through the waist. Type 3 is through the body of the C2 vertebral body. It is usually unstable fractures, and type 2 is occur in watershed area, so the incidence of pseudoarthrosis is a little bit high. And type 2 usually amenable for odontoid screw fixation, halo in younger population. In older population, we don't recommend halo because it had a lot of devastating complication. C1 and C2 fusion in certain conditions. Type 3, shallow type 3 can be managed in Philadelphia or can be managed by C1, C2 fusion. The differential diagnosis of odontoid fracture is the os odontodium.
دكتور محمد بليز. هو السلايدز ما بتتغيرش يا فندم، السلايدز ثابته.
طب هي دلوقتي ما اتغيرتش؟
لا حضرتك اعمل فول سكرين يا فندم، هي كده مش فول سكرين يا فندم.
انا عامل فول سكرين.
لا مش معموله فول سكرين يا فندم. كده بدات تتغير يا فندم.
يبقى عندي لاج.
اوكي بدات كده يا فندم، بس هي مش فول سكرين، بس اوكي ذاتس جود.
انا عندي فول سكرين.
لا هنا مش سلايد شو. دكتور مينا حضرتك معانا في تكنيكال بروبلم ولا حاجه؟
طب
دكتور فوزي تحب اشير من عندي؟
لا عاوز تشير من عندك ما عنديش مشكله.
اوكي ذاتس جود.
اعمل فول سكرين وشير من عندك. ماشي.
حلو.
سوري فور ذيس انكونفينينس.
انا ما فيش مشاكل خالص يا فندم.
sometimes يعني ساعات كده النت بيبقى عنده
تكنيكال بروبلمز بتحصل كتير يا فندم. هو دكتور مينا هيشير من عنده يا فندم، وسعادتك مشكورا تمام. اوكي فول سكرين دكتور مينا. اتفضل يا فندم، اتفضل يا فندم.
Type odontoid fractures, as you said, can be anticipated in younger population. مينا next، ولا انتوا ما شفتوش دي اوريدي؟ ابدا من الاول ولا ايه؟ مينا انت سامعني؟
حضرتك وقفت يا فندم.
طيب بس هنا يا مينا ستوب، هنا هنبدا من هنا. The differential diagnosis of fracture odontoid is the presence of os odontodium, and it is usually a smooth, well-corticated piece of bone, and it is usually present above C1, C2 facet, as we can see here in the right lower slide. Next, Mina. Mina, next. And of course, if you have a favorable fracture trajectory, odontoid screw fixation is ideal for the patient because it will not affect C1, C2 motion, and we published simple and easy way to anchor the C2 promontory and apply the screw safely by the use of Yamshidi needle. Next, Mina. And this is our case. This is 23 years old male, presented with axial neck pain, normal motor power, positive Hoffman, positive Papneski, hyperreflexia. So there is signs of cord compression with history of fracture odontoid fixation 2 months ago, and he is medically free. To describe this X-rays, we can see that the patient has odontoid screw malpositioned. Its tip is usually at the promontory at the lower border of C3, not in the ideal place, and there is dislocation in C1, C2. If we can pick the posterior arch of C1 and the spinolaminar line of cervical spine is not coapted, so it is a complex spine surgery case. Of course, in such cases, we need to do CT and MRI. CT is to diagnose the bony pathology which is present. MRI is to identify the ligamentous and the neurological states. And of course, CT angiography is important to identify the state of the vertebral artery as well. Next, Mina. Here in the CT scan, we can see that, first of all, the odontoid fracture screw trajectory is not compatible and not friendly with the odontoid screw. So the choice of odontoid screw from the start is not ideal for this patient because it is, according to Grauer classification, it is type C, where the trajectory of the fracture starts from posterior superior to anterior inferior, and this fracture trajectory not amenable for odontoid screw. Number two, we can pick here that there is dislocation, rotatory dislocation in C1, C2, and there is pars fracture as well. So we can say it is not a simple odontoid fracture, it is an odontoid fracture with rotatory subluxation and pars fracture at C2 as well. Next, Mina. Here we can see in the axial cut that C1, C2, there is rotatory instability and the dents are not centrally located in its place. So there is disruption in the integrity of C1, C2 facets. Next. MRI, we can see the cause of hyperreflexia, the cause of Hoffman and Babinski, which is compression of the cord by the instability which is present because with this flexion attitude, there is compression by the posterior arch of C1 over the cord. Next. So what is the diagnosis? Next, Mina. We can say it is a fracture dents with C1, C2 rotatory subluxation. We can add there is pars defect, something like hangman fracture type 1, and the patient complains of devastating neck pain, signs of cord compression. He has previous history of anterior surgery, failed, of course, failed osteosynthesis. So we need to plan, and our plan will focus on how to reduce and how to fix. Of course, we need to intervene anteriorly to remove this screw with the complications that could be anticipated. Either the previous surgeon affects the recurrent laryngeal nerve or not. So examination by NT colleagues are mandatory. Then you will go to do removal of the screw, then to do traction, then to go posterior. Next. This is intraoperative photo after removal of the anterior screw, and we applied tongue traction as well, but we can see that the fracture is not reduced, although with reaching the maximum traction. So we decided to flip the patient to try to do okay, next, to do direct reduction. And we have two options, either to do transarticular Magarel screw or Harms and Goal technique. Next. The Magarel technique is the screw trajectory that fixes C1 and C2. It can be done percutaneously. It can have superior biomechanical configuration and diffusion service occur through the joints, but it is one screw trajectory. But it is difficult trajectory, unusual for most of the surgeons, unfavorable for this patient because he has dislocation and unable to reduce it with traction, and due to also the presence of high riding vertebral artery, as we can see here in the lower down cuts of the CT and the pars defect. So this patient next is more favorable to do Harms and the Goal technique by applying lateral mass screw in C1 and pars screw in C2. And of course, we'll go down to C3 to augment the construct because of the fracture in the pars at C2. And of course, it is well known straight trajectories with visual and ductile control. The dorsal fusion can be achieved and the manipulation of C1, C2 facets, and you can reduce the dislocation is possible. especially in expert hand, and direct repositional could be achieved. The drawback of Goland Harms approach is that you have sometimes venous plexus that can bleed around the C2 root. Some colleagues may sacrifice the root even. And of course, the two screws trajectory may have some vascular risk. The lateral mass screw at C1, if it is longer screw, can hit the internal carotid anteriorly. The lateral the C2 pars screw or pedicular screw can affect the vertebral artery as well. Next. So this is what we could achieve for our patient. After removal of the anterior odontoid screw who went posteriorly, we select to do C1, C2 harms and goal, and augmenting the construct by application of C3 lateral mass screw. And we can see here that we could be able to directly reduce the fracture and stabilize the fracture, and we applied bone for fusion. So C1 to 3 fixation and diffusion, and the patient postoperatively has normal motor power, and it was uneventful surgical procedure. Next, so my take-home message from this case scenario that odontoid screw is contraindicated if you have patient with short neck, significant cervical kyphosis, if you have concomitant thoracic kyphosis, because technically demanding and challenging scenario for applying the odontoid screw. It's contraindicated in osteoporotic patients. It is contraindicated when you have comminuted odontoid fracture. It is contraindicated in non-union as well, in C1, C2 rotatory instability like our case, or unusual fracture trajectory like our case as well. And the final decision on the approach will be depend on the patient-specific factors and the surgeon experience on different approaches. And I am ready for any questions. Thank you so much.
Thank you so much, my dear Professor Mohamed Fawzi Khattab, for this very interesting presentation. And we are happy to receive questions in the question and answer box. And our dear speakers and our dear professors will answer the question of our dear attendees. Now we come to Eva Pharma Company Talk, the sponsor of this webinar. Dr. Michael, Dr. Mina.
Yes, doctor. Can you hear me?
Yes, sir.
Okay. Is my screen visible?
Yes.
Okay. Thank you, Professor Mohamed. It's my great pleasure to stand before you today as we gather for this scientific marathon, the International Trauma Webinar. And let me first, before diving into my presentation, acknowledge your remarkable efforts in organizing this scientific webinar, along with our eminent professors from the Egyptian Orthopaedic Association, and also all the international speakers worldwide, OrthoTV. Really, it's a great effort, and thank you for this opportunity you give us. Always in Eva Pharma. Sorry, Mike. Okay, that's great. In Eva Pharma, we are always keen on sharing our heritage and our future and our remarkable milestones with our eminent professors. We have a great heritage starting from 1917, Drogerie, Riyad Armanius, and then Pharmacie Lausanne, Les Laboratories Delta, moving forward till 2023. And we are always focused along this journey in empowering the fight for local and international patient needs. And also we focus in producing high quality medications. That's why Eva Pharma have a lot of accreditations and certifications from a lot of associations, but here I will focus on the European Medicine Agency approval and certification, which allows Eva Pharma to export its product to European Union companies, and that's only for producing high quality medications. Eva Pharma is not only an Egyptian company, it is an international company. Our international presence is in more than 40 countries worldwide. And here is the evidence for that. We have a company in Germany which is called Elpa Life Science. It is responsible for licensing and marketing our products in Germany. We have products in Germany, which is Glanic Vital, known here in Egypt as Genofil, Sopalmeto, which is known as Prostanorm in Egypt, and also L-carnitine, which is known in Egypt as Carnivita Forte. We have the first Egyptian product in Canada, which is called the Diabetic alpha lipoic acid. You know it in Egypt with thiotacid. And also we focus on the research and development. We have the largest research center in the MENA region, which is called Mark Munir and Manius Research Center. We have more than 100 experienced scientists working along the hour to produce high quality products and to develop new dosage forms for patient compliance. And this was the opening of Mark Center in the presence of Professor Magdi Yaqub and our CEO, Professor Riyad Al-Manious. During the time of COVID, we managed to produce the Egyptian vaccine, EGVax, and we made and finalized the preclinical studies on EGVax, even though the COVID trend declines, but we managed to continue in producing EGVax so as to have the know-how and the technology to produce any vaccine to face any next pandemic which will face humanity anywhere in the world. Also during COVID, we managed to offer all the COVID portfolio for patients, not only in Egypt, but also in international markets. And I will focus here on the Remdesivir, which we were offered by Gilead Sciences to produce Remdesivir here in Egypt and export it to Africa and other countries in the MENA region. And that's due to our quality in the production of any medicine. Also, we have an innovation, our vial and ampoule line, and it is a totally sterile area, which is very unique in the Egyptian market and in Africa. And I invite you all to visit this area in Eva Pharma facility. There is no human interference in this line. Also in Eva Pharma, we have a division for animal health and for sure Limitless, as a new launch and a new sister company, which is Limitless for producing vitamins to Egyptian patients, and it's also present in the international markets. For sure, we have strategic partnerships with Eli Lilly and the Gilead Sciences, who choose Eva Pharma as the strategic partner in Egypt and in the MENA region to market their products and also to produce their product in their facilities. And that's due to our focus on producing high quality medicines. Let me move to our neuropathic pain patient, who you face a lot on your clinics as orthopedic surgeons. The patient of sciatica, patient of low back pain, patient of carpal tunnel, even the post-operative cases. We have a 360 solution for this patient, starting from the pathogenic treatment of thiotacid, as I mentioned before. It is not only a national brand, but it's also an international brand, which is present in more than 32 countries worldwide. It's our alpha lipoic acid thiotacid. It is recommended by a lot of international organizations as a pathogenic treatment for treating neuropathy. Moving to our neuropathic painkillers, we always believe that there is no one size fits all. We know that physicians tailor the medications according to the patient case. So we have a lot of options in neuropathic pain, starting from Sympatex, our serotonin norepinephrine reuptake inhibitor, duloxetine, which works by blocking the reuptake of serotonin and norepinephrine. And it not only reduces the neuropathic pain, but it also enhances the patient mood for neuropathic pain patient. Also, we have Conventine, which is the first-line treatment in treating the neuropathic pain. It's also recognized by international organizations, American Diabetic Association, International Association for Study of Pain, as a first line of treatment in treating diabetic peripheral neuropathy. It also had the most favorable balance between efficacy and safety among the neuropathic painkillers. It not only reduces the neuropathic pain, but it also improves the sleep interference and improves the quality of life for patients. It is safe for hepatic patients. Eva Pharma offers Conventine in 5 concentrations, starting from 100, 300, 400, and the new launches 600 and 800. So soon, conventin range will not be the same. It will extend its range, aiming to increase the patient compliance. For sure, it will be a surprise to you. I will not reveal it yet, but so soon we will talk to you in your clinics about it, not only in Egypt but also in the international market. Thank you, Professor Mohamed, for this opportunity. Thank you.
Thank you so much, Dr. Michael, for your talk and your presentation. And now I think we are ready for the Indian session. I don't know if our Indian speakers are with us now. I see some of our Indian speakers are joining.
Yeah. Hi.
How are you, sir?
Dr. John.
Professor John, how are you, sir?
Fine, thank you.
Thank you so much for joining our International Trauma webinar. It's an honor for us, sir.
Pleasure.
We have 10 of our Indian colleagues joining us in this very fruitful webinar. I think our first speaker will be Dr. Dilip Tana.
Yeah.
He is joining or not yet?
I hope so. We are still a little ahead of time because it was 9 o'clock by Indian time that it was supposed to start. So we are about
yes, I think
7 minutes to go.
5 minutes earlier, I think.
Yeah.
Yeah.
Which is good.
Can we start with you, sir, please?
Pardon?
Can we start with you, with your presentation?
Yeah, I don't mind
sir?
if that's... okay, so I just... yeah, so I can do that. Just let me just get my slide opened. Okay, so do you want me to start?
Yes, sir. May I introduce, sir?
Okay, so I'll just
thank you so much for our Indian colleagues and our Indian speakers for joining us. We have 10 eminent speakers and professors from India joining us with their very fruitful talks and very long experience. Our first speaker will be Professor John Mohamed from India. Will speak about an unusual tibial condyle fracture. Please, sir.
Can you see my presentation?
Yes, sir.
Okay, so just put it on hold. Okay, so this is going to be a presentation of an unusual presentation of a tibial condyle fracture. So this was a 26-year-old male patient who had a road traffic accident 11 days ago. So he was turned over in his motorcycle. He doesn't remember exactly how he injured his knee, but he was unable to walk. He was seen in a clinic elsewhere and had a slab put on, and then he was referred to us, but he came 11 days after his injury. And that was the x-ray that he had when he was injured at his first site of presentation, and we repeated the x-ray, and that was what we had when we got the x-rays. So do we have any interactive session, or do we just continue?
No, sir, we can continue, sir.
Okay, so this was the presentation. So the unusual thing about this was that if you look at the lateral side of the condyle, it actually appears to be elevated rather than depressed. So almost every fracture that we hear about or read about or learn about, there's an element of depression, while here the condyle actually seems to be elevated compared to the opposite condyle. So that makes you suspicious of something going on there. Obviously, you will get a CT scan, and I will just run through the CT scans, the various sections and the reconstruct. So if you look very carefully at this particular one, which is a giveaway, if you see this line here, this is the cartilage line. So the fragment has actually flipped upside down, the lateral condyle fragment, so that the fracture surface is facing up while the articular surface is facing down. Okay. So the other CT scans, you can see there's the 3D. Again, you can see the fragment here with the 3D reconstruct, the whole big fragment where this is turned down. This is the articular side and that is the fracture side. It also has a posteromedial fragment here and a further depression on the side posteriorly and a flip of the entire condyle on the lateral side. So we have to think about all this and then plan our surgery accordingly. So we looked at it and we studied the CTs, and then we decided that this was a situation where we had to start laterally to begin with, although he had a posteromedial fracture. So that was the approach. That is the condition of his skin. The swelling had settled down by then. He apparently had a lot of swelling when he initially presented to the earlier hospital, but this had settled down by then. This was the approach. And you can see that as we see the joint, you can see shining cartilage. So this is the tibial element. Here we've elevated the tensor, the sort of ITB band off the proximal tibia. And just as we are doing a submeniscal arthrotomy, you can see this fragment actually sticking out of here, turned upside down because the cartilage is on the inferior side. Okay, so that's the further sort of dissection, again showing the shiny side of the cartilage facing down. We actually had to gradually retrieve this fragment out of the joint because we had to flip it around to reduce it. So there's the fragment now outside the joint lying here. That's the gap here, the depression here. But this fragment would not fit in here until we had to further go down and actually move this fragment here. So there was a fracture here which had got depressed. And to get that in line with this, we had to actually elevate this fragment. So you can see that fracture here. We have to get the osteotome there and then gradually elevate that fragment up. And then we had the gap into which we could fit in this fractured fragment and then close the gap. So there's the fragment being put back in. And then finally, everything's closed down. We put the iliotibial band over it. And then once we had done that, we could go ahead and put our fixation on the lateral side. And then we went to the posteromedial aspect and put a small buttress plate on the posteromedial side. So that was the post-op AP X-ray, which was done immediately post-op. And you can see now how this fragment has fitted back in. We've got these screws into this fragment. And this is the small plate buttressing the posteromedial fragment. These are the AP and lateral X-rays post-operatively. So that was what we were able to achieve in this fracture. So now it was a question of getting him mobilized. So we started range of motion exercises just after the first dressing, which was on the second day, and the swelling had subsided. He was on the CPM machine, and we started him on just toe touch mobilization, no weight bearing, but toe touch mobilization. After about 4 weeks, he was partial weight bearing, and by about 3 months, he went on to full weight bearing, and he was making satisfactory progress. This was the situation here. This was him at 6 months post-op. You can see how the fracture is healed up all right. He's got a fairly good range of motion at this stage, not full range, but you can see he's almost able to squat, but not able to squat fully. So again, we continued with the exercises, and he had no pain. He was otherwise okay. And then when he came for his final follow-up recently at about 12 months post-op, you can see now he's able to squat fully. He's able to walk almost without a limp. And again, you can see the fractures healed. You may comment on a little bit of irregularity here, but on the whole, it's healed up quite well considering the type of fracture it was. He's got no deformity. His alignment is good, no flexion deformity, almost full range of flexion, and a pretty normal gait. So this was interesting. And so one of the reasons we were able to pick it up was because many years ago, I had seen a similar case. So this we are going back almost 18 years ago. This was in 2005. We had this patient present to us 3 months after the injury, okay? And he was treated in a cast, initially with 4 weeks, followed by physiotherapy and mobilization exercises. And there was absolutely no movement. His knee was stuck in extension and just had a jog of motion. And this was the X-ray that he came to us with at 3 months. So that again, when we looked at this X-ray, you could see again here that the lateral condyle is actually elevated rather than depressed. Again, you can see the articular surface here and the fractured surface on this side. So because we had seen this case, we were actually anticipating the problem when we saw this case this time. So we did not fall into this problem of what they had done earlier, which was put it in a cast, thinking it was a relatively undisplaced lateral condyle fracture. And this patient came to us 3 months after his injury with almost only a jog of motion. And that was the CT scan that we did at that time. And again, you can see how the articular cartilage is here. And this was actually almost the entire condyle, the lateral condyle, which is flipped upside down. Slightly different from the case we had this on this occasion, where there was not the complete lateral condyle, but almost about 2/3 of the lateral condyle. This one had the entire lateral condyle flipped, and he also had a stiff knee at this stage. And then we went in and we dissected it out step by step. You can see how the entire lateral condyle with the meniscus still attached to it actually was stuck there in a position. And we had to then turn this whole thing around. We put in some wires. And at that stage, this was many years ago, we just put in screws. Then we put him on skeletal traction and started mobilizing his knee at that stage. And he went on to do very well, but fairly well. He did not come back for a follow-up. Unfortunately, he's from down many miles away, and he did not come back for a follow-up. Although we had one telephonic follow-up with him, where he said he was able to ride a bike, and then he had a second fracture of his femoral condyle, which he sent me the X-rays for, where this fracture had healed, but the other fracture, the fresh fracture, needed surgery. So we asked him to come back, but he, I think, had surgery locally, but then we lost him to follow-up. But it was interesting because we had seen this case many years ago. That was the post-operative X-ray that we were able to achieve in that case with just 3 screws. We didn't put a plate at that stage. This was, as I said, in 2005. And then we had put him on skeletal traction and started his mobilization because he had a very stiff knee already there. So we wanted to mobilize him quickly. So considering that, he went on to heal well. And because we had seen this before, we were able to diagnose this particular case and treat it appropriately. And in this particular one, we have follow-up for a year now with a good result. So I think that is all that I have in my presentation. So I think basically you need to watch out for unusual presentations in any fracture that every time you think you've seen everything, you find something unusual which comes up with a different presentation. And some injuries just don't fit into the normal classification or patterns of fractures that we see. So you have to be aware of this. And if you find an apparent elevation of the condyle, think about a flipped fragment of the condyle, which may be responsible for this fragment being elevated rather than depressed, which would be the normal presentation that you see with a tibial condyle fracture. So I think with that, I will stop. And if there are any questions, would be happy to take them. I'll stop sharing with my screen. Thank you.
Thank you so much, Professor John, for this very interesting presentation. We are waiting for any discussion or any questions from our panelists, our speakers, our dear attendees.
Sure.
Any questions?
Has anyone actually seen something similar before? I think there's one Chinese report of a similar case which doesn't fit exactly the same pattern, but where they have reported that the fragment was flipped a little bit, but slightly different pattern again. But other than that, I've not actually seen any reports of this kind of presentation either. So if anyone has seen this, it would be interesting.
Any questions to Professor John? Okay, thank you so much, sir.
No, you're welcome. Thank you.
Thank you, sir. Thank you so much, sir.
There's a question, I think, in the question and answer box.
Yes. Yes, we have one question, sir.
Okay, so there were two questions, both about the meniscus.
The meniscus, yeah.
And there's one about whether I bone grafted
did you
it.
do
Okay,
bone
so
grafting, sir?
for the bone graft, no, because this was a fresh fracture and we were able to get the fragment back in place. And interestingly, this was the meniscus was still intact in the so the fragment had flipped over the meniscus, and once we got it out, we could actually put it back under the meniscus, and the meniscus was okay. So we just did a suture of the lateral part of the meniscus. We didn't really have to do anything else to the meniscus, and that was the interesting part again in this case. Yeah. And in the other case that we had done earlier, the whole meniscus was with the fragment, which is interesting. Okay. And we didn't do bone graft, and I think nowadays we very rarely bone graft in proximal tibial fractures primarily.
Yes. Yes, I think we have no more questions. I think there is a question, another question.
The chat, I'm not sure.
What about the neglected cases?
The mechanism of injury. Okay, so that is interesting because this is probably almost like a knee that probably half dislocated and came back with the fragment. I mean, it's interesting because the previous case had come 3 months later. It was difficult, but this guy had a motorcycle accident where he had quite a severe injury, but he doesn't quite remember exactly what happened. But it's a kind of a varus strain with probably hyperflexion at the same time. And this fragment broke and then just flipped over. So it's difficult to give a definite answer to that, but that's what I imagine what happened in that particular case.
And another question, sir, what about neglected cases more than 6 months?
On the medial side?
On the medial side,
yeah. I haven't seen this on the medial side, but we see a lot of late presenting tibial condyle fractures with malunions, etc. And today, in the younger patients, we are doing a lot of intra-articular osteotomies. If it's a posteromedial fragment, we will do a osteotomy from the back, or sometimes we even do a medial epicondylar osteotomy to get access to the medial side, and then do an osteotomy, elevate it, bone graft it, and then fix it. So we've done some of these osteotomies as late as 3 years after the original injury in the young patients, where they have got fairly good results. So I think the knee, a lot of these intra-articular fractures which malunite, we can still salvage, especially in the younger patient. Okay?
Yes, we have another question.
Exact pattern where it's flipped over on the medial side as well. So these are the only 2 cases we've seen in all these years.
Okay. Yes, sir. We have another question, sir. Look, flip rim fracture when you put a rim plate.
Yeah, so I think that was the best reduction we could achieve on the table. And that little bit of Stepho at the moment is totally asymptomatic. He's got a full range of motion. Interestingly, that a little elevation is in the middle and not directly on the weight-bearing part. So hopefully it will not cause a problem. But of course, we need to watch him over a period of time to be able to be sure. We've got a year follow-up. He's fine at the moment. He's got back his range of motion and he's got no symptoms, no pain at the moment. However, we would need a long-term follow-up to really say that he has no problems at all over a long term. Obviously, it would be a risk for early arthritis, but certainly he would have many years with this knee without a major problem. I would expect.
Another question, sir, that there was a little articular step off. Do you expect any consequences of this step?
Yes, so I think that's the question I just answered, was that, yes, you have to watch this. At the moment, he's asymptomatic, but you need to watch it for long term to really know if there's any early arthritis setting in the knee. Okay.
Yes, sir. Thank you so much, sir.
Thank you. It was a pleasure.
Thank you for joining us and for accepting our invitation, sir. Thank you so much.
It's my pleasure altogether.
Thank you, sir,
very
so much.
Okay.
Our next speaker will be Professor Dilip Tanna. Professor Dilip will speak about functional junctional fractures of the lower limb. Professor Tanna.
Thank you. Can you see my slides?
Yes, sir. We can see it, sir.
So I'm talking about the junctional fractures where the non-union rate is highest in the femur. I confine myself to the upper end of the femur and lower end of the femur, the junctional between the upper 1/3 and lower 2/3, and junction between the upper 2/3 and lower 1/3. Junctional fractures of the femur, upper 1/4 and lower 3/4 femoral junction. These are the fractures where non-union rate is fairly high, and if needed, I'm talking about, the augmentation is an excellent way in which you can probably tide over the crisis. Only nailing in an unstable such comminuted fracture is not good enough. So on day one, I feel you should do this augmentation if you feel that the construct is unstable. Now you can see this is 5 months unstable construct, and this is never going to heal up. And you can see here in the lateral view, there is hardly any hold of the upper fragment. If you see such a thing, there is no point in really going through the thing. This is the one which went through the non-union and ultimately it was treated with the augmentation plate, and this ultimately healed up very well. But you see this day one fracture, day one construct. In this sort of a day one construct, I'll augment this on day one because there is hardly any hold of the upper fragment there. The lower fragment is a reasonably good hold, but the upper fragment hold is not there. So such fractures, I feel, instead of waiting for the non-union and let 6 months pass by, when the patient suffers for 8 months, 9 months, or a year, it's much safer to do it on day one, augmentation things, and then it will be all right. Comminuted, I'm not talking about the transverse fracture, are unstable in only nail, more non-union chances. To overkill is not a sin in such fractures. As you can see here in such fractures on day one, if it is osteoporotic and all, you can do the augmentation and the fracture heals up and patient walks about on day one. Now this fracture, you can see if there is hardly any hold on to this fracture. On day one, if you do for such fractures, there is no point in just accepting this reduction. On day one, if you can do an augmentation, if you are stuck up, there is no harm. And I feel it is a very good way in which you can get away with such a bad situation. There is hardly any hold. You can see the upper end, hardly any hold in the upper end. Even the lower end also, the hold is poor. Even if you make the nail thicker, upper end will not be able to really get a good bite of that. That's the reason I feel an day one augmentation would be a better option in such fractures when in doubt. Now, this is an oblique fracture. Even if you nailed it, this is very unstable. Such an oblique fracture, even after nailing it, or even this is only one screw, but even 3-4 screws, if you put it, it's very unstable. And ultimately, it needed an augmentation plate. Or a fracture like this, you put in the fracture, there is already a fracture which has occurred here. You put in the nail, this already has a fracture here, and ultimately this is going to go away. And there is hardly any hold because there is a comminuted fracture. This piece is separate, there is the gap here. So the proximal hold is very poor. and this is the one which happens, and you can treat them with this augmentation plate and super stability. You can make the patient walk about. Even though this is a negative reduction, good valgus is maintained because of the hook plate which I have put in there. And this is the one which I feel on day one, you shouldn't hesitate to put in this sort of a construct. Now I talk about upper 2/3 and lower 1/3 fracture. This is the fracture which is notorious for a non-healing, and particularly antegrade 2-screw fixation is absolutely contraindicated, I feel. And this is the one which, if you put an antegrade nail, you should augment it on day one. And this is the only way, because as you can see here, there is a big medullary cavity lower down. And this is the reason why it will not heal up. You can see the CT scan. You see the CT scan there. This nail has hardly any hold in the lower fragment. And that's the reason why these junctional fractures are very notorious for non-healing. Now, that's the reason people talk about it today, that instead of 2 screws, put in 4, 5, 6 screws lower down, which is a good option, which I agree. It is a better option than only 2 screws. So even these 3 screws which have been put in, this has also gone in for that. So the 4 screws is being recommended, but it's still not certain. So even this thing ultimately went in for a non-union and it needed an augmentation. The better option for this sort of a fracture is a distal femur nail. I've done a distal femur nail and you can see it is very stable at the end of the construct, even though it is not a big hole there in the lower fragment, but the screws which have been put in, this is the subchondral bone here. It ends up in a subchondral bone, and that is a very good hold on the lower fragment because of this tip, which is subchondral. So in a distal femur nail, in a subchondral, which is the biggest and the best fixation, which is enhanced by 3 to 4 screws in the distal fragment, this is the one which is a good option for that. But if in doubt, please don't hesitate and do anything, whatever you desire. So 3, 4 screws is a good option for this in a distal femur nail, and that is the one which is an option. Antegrade 2-screw fixation lower down is not a good option at all. Thus, a subchondral distal femur nail will work in junctional fractures, but not sure. So why not adjuvant plate when in doubt? Overkill is not a sin. Now you can see this sort of an oblique fracture, which the idea, the antegrade nail and put in the plate there on the same side, patient start walking about and moving about on day one without any hesitation at all. Or a fracture like this, long oblique fracture with a comminution there on day one, antegrade nail and a plate. I didn't want to do a nail from below, retrograde, because there is an osteoarthritis there. That's the reason I didn't choose a retrograde nail. So I did this, and as you can see, patient walks about, moves about, and the fracture consolidates and is fully healed up. Here is the patient. The joint replacement surgeon did this knee joint replacement. Can you see my slide? My slides are seen?
Yes,
no,
sir.
earlier slide only is seen, sir.
Yes, what I felt. I thought my internet is giving me trouble here. Just a minute.
Yeah, we can see that the distal third femur with the plating, augmentation plating at present.
Yeah, plate and nail.
Nail only.
I think we have lost him because his internet is. You can see. No, that X-ray is not seen, sir. We still see that nail with a plate.
Yeah.
Okay, I think I'll have to come back.
Okay, we are waiting for you, sir.
Yeah. I feel is not seen. I'll just come back.
Professor Tana, you are still with us?
Tana, sir? I think we have lost him.
Can we go to the next speaker, sir?
Yes, I am the next speaker.
Okay, next speaker will be Dr. Shiva Shankar. Will speak about non-union of subtrochanteric fracture with broken PFN. Sir, please. Thank you so much.
Can you see my slides?
Yes, sir.
Okay. Thank you, Professor.
Thank you so much for accepting our invitation.
Thank you for the invitation. I am the immediate past president of the Indian Orthopedic Association, a trauma specialist working in a tier 3 city in the state of Maharashtra. This is the case which I wanted to discuss. A subtrochanteric fracture was treated with a dynamic hip screw or the sliding hip screw. As you can see, there is a interfragmentary screw or probably the screw through at the fracture site. But unfortunately, after a year, the fracture didn't heal and the implant broke. And that was the time the surgeon decided to treat this patient with a intramedial nail in the form of proximal femoral nail. And this patient was doing quite well for 3 years. This is the surgery. Second surgery was done in 2014. And in 2017, this is the after 2 months X-ray. And in 2017, the patient came with a broken implant in this fashion. So as the fracture was not united, the nail didn't sustain the loads of the patient walking for 3 years, and it broke in due course of time. This was the time I was involved. The patient didn't come to my center, but I was called by the original surgeon who had operated this patient earlier. And I did this surgery in his place. You can see there is a huge gap posteriorly. After the implants were removed, there was a huge gap posteriorly. What I did was I used 2 K-wires to prevent the nail going through the same track. So that to make the entry much more medial, I passed 2 antero-posterior K-wires. And I also passed 1 antiversion guide wire that will give, since I was operating on a lateral position in a simple table, this K-wire gives me direction of the neck, so that if I keep my jig parallel to this, doing the neck interlocking with the neck screw will be easier without much radiation. So with this, I pass this antiversion guide wire in the anterior part of the neck, and I pass 2 K-wires lateral to the entry site in the proximal fragment. And I could insert the nail, and I applied plate. And as you can see, there was a lot of gap here. I applied bone graft also in the same place. Here you can see there is a screw here. This screw prevents the nail going again laterally. This is the screw which is preventing, because the nail entry was taken earlier from the tip of the trochanter. I tried to medialize more by going more on the medial side of the neck. Again, due to the track which was there laterally, the nail could have gone more laterally. So to prevent that, I put a blocking screw lateral to the nail, which is seen here as an antero-posterior screw. And this is the immediate post-operative picture. This is the nailing. This is the augmentation plate. There is a lot of bone graft which has been applied in this patient. And he came only once for follow-up. And I tried to get his follow-up. I tried to contact him 2018, 19, 20, 21. So many times I tried to contact him. Finally, I could get his mobile number through one of his earlier records through the earlier hospital. And once I tried to contact him, he didn't come to me. Practically, it was a very near place, just about 20 kilometers from my place. So our hospital staff went and brought him to the hospital, and I took the X-ray. At that time, this is after 4.5 years, because you can see that we had not seen him earlier. This is directly after 2 months he came. After 4.5 months, 4.5 years, the fracture has beautifully consolidated. The earlier entry was from the tip of the trochanter. This I tried to medialize by putting a blocking screw, and the fracture consolidated beautifully. And this is the clinical picture. This is the picture of the earlier surgery, the next surgery, and the patient was able to do all the activity. Unfortunately, because of the 3 surgeries he had a shortening. You can see that he's lurching on the right side where I have operated because of almost 1 inch of shortening he has got. But he was able to do all the activity without any trouble. And you can see that there is a shortening of 1 inch on the side we have operated because of the multiple surgeries done. And the lurching could be due to either shortening. Also, lot of bone graft has been obtained in the earlier 2 surgeries from that side. So that also could have caused some problem with the muscles attached there. And anyway, all is good, which ends up well. And as Dr. Tanna was talking just now, at junctional area, especially non-union, it requires absolute stability. Absolute stability can be given only by plating. It cannot be given by nail or anything else. So if you are treating a subtrochanteric fracture or a lower third femur fracture, it's better to put if you are a nailer like me, it's better to augment the nailing with a local plate. The plate can be spring plate or a wave plate, or it can be a solid plate also. And you can see that the nail can give stability over a longer duration of longer length of time, length of the whole bone. So the nail gives long stability and plate gives near stability, because absolute stability can be given by only a plate. Nothing. If you are doing only nail, it doesn't give absolute stability, especially in non-union cases. It's better to do plating also as an augmentation plate. This is another case. Again, this patient was walking on the implant for 10 years and he sustained a fracture of the implant, and because of the non-union, as you can see. Since the entry has been from the tip of the trochanter, you can see that the inferior screw, though it is in the inferior part of the neck, it has gone into the center of the head. The varus was the one which is culprit here in this case. So what I did was, this is the earlier entry side. This is the tip of the trochanter. This is the neck you can see. And this was the earlier nail entry side. So I took an entry much more medially. How I took it? I applied a Steinmann pin. I prevented the my entry going again to the earlier entry by applying a anteroposterior Steinmann pin. Then I did the nailing. I did everything. I did the freshening of the bone ends because it's 10-year-old non-union. Then I did the shingling of the bone. I did the exchange nailing. I added bone graft. I added augmentation plate. So these are some of the pictures. I am removing the broken implant in this picture. Now you can see, but I am holding the fracture and I am trying to ream the bone. And also I am doing the shingling. You can see my sharp osteotome is shingling the osteoperiosteal flap around the bone. And this is the picture which shows that I am making a canal and there is an anteroposterior K-wire which is preventing the lateralization of the entry side. And there is also another K-wire here which is giving me the direction of the neck in the lateral view. So that when the jig comes after inserting the nail, so this gives me a fair idea about the direction of the neck. So at the end, you can see I have applied a proximal femoral nail. These are the 2 neck screws. This is the augmentation plate I have done. I have also done the bone grafting in this patient. And this patient, which had the fracture which had not united for 10 months, you can see here there is a lateral. I removed the K-wire and inserted a anteroposterior blocking screw so that the nail will not go to the earlier track. That is the reason why I have passed this. Here you can see the screw which is lateral to the nail. This earlier entry was from the tip of the trochanter. Now you can see that I have taken the entry almost from the piriformis fossa, and the fracture united within about 4 months time. The patient did all the activities beautifully without any trouble. This is the video just at 4 months time. He was walking comfortably, and I have subsequently removed the implant also. I thought I will be presenting one case, so I didn't include the final pictures. But here are some more pictures of similar cases which I'll rush through. This was a case subtrochanteric fracture which was treated with a regular femur nail. The fracture broke, the implant broke the surgeon decided to only remove the proximal portion of the nail. I ended up doing the next part of plate augmentation with nailing with PFN and the fracture consolidated, as you can see. Another proximal third femur fracture. I don't say that it is a subtrochanteric fracture, but it is a proximal third femur fracture. Again, you can see that the fracture has gone into non-union and the implant failure. This is immediate post-operative X-ray. You can see that beautifully the fracture has been reduced. Nail has been inserted again from the piriformis fossa medial to the tip of the trochanter. The alignment is good. The calcar screw, the cervical screw is inferior both in the neck as well as in the head, indicating that there is a good valgus. I have added good amount of bone grafting, and this is just at 8 months follow-up when the patient had come. This also case I had done outside, so I don't have the long-term follow-up, but you can see that the fracture had united without any problem at this stage. This child was operated at a young age when he had a fracture in the femur where the plating was done. He came with a subtrochanteric fracture. We removed the implant and applied a locking plate. Unfortunately, that locking plate broke in due course of time. As you can see, there was a gap. For a young patient, locking plate, I am not convinced. Unfortunately, because of the market-driven forces, somebody had used this locking plate at the time, and the fracture didn't allow collapse. The plate didn't allow collapse, and the fracture broke in due course of time. This was the time I was involved. I can see that again in this case, we have done nailing again from the piriformis fossa. I am reiterating again and again. All the problems in the proximal femur is due to entry which gets lateralized. If you take an entry from the tip of the trochanter and the bone is weaker on the lateral side, your entry gets lateralized. So always try to take an entry from the medial to the tip of the trochanter or even from the piriformis fossa. So then you can be in line with the middle canal, and you can see that the fracture consolidated in due course of time. This is 1 year later with a beautiful consolidation of the fracture, and this is the function of the same patient at this time. So these are some of the cases I wanted to show. This is one, probably the last case I'm showing. A subtrochanteric fracture. It's not an implant failure. It's a non-union. Again, you can see that I have used the same technique of nail with augmentation plate, and the fracture has consolidated. Friends, non-union requires absolute stability, which can be given only by plating with compression. So if you are a nailer like me, I am the past president of, there is a subspecialty in India, National Association of Interlocking Surgeons, the acronym NAILS, National Association of Interlocking Surgeons. So I am one of the past president and founder of this association. So I like to do nailing or a keyhole surgery. So if you are also nailer like me, you can augment the nailing with local augmentation plate. I normally tend to use spring plate or wave plate, especially if I'm using for a shaft, I use a spring plate. Spring plate is something like a bent like a C, so that I can do graft globally. The wave plate is also same. You can do graft globally, or sometime in a subtrochanteric region where I want to get stronger plate, I use radius ulna plate or a mini DCP plate. In that, it is difficult to bend it to a wave plate. So I use a straight plate in such cases. So nail gives long stability, that is over the whole length of the bone, and plate gives absolute stability by decreasing the working length of the bone. Thank you very much. Over to you, sir.
Thank you so much, sir, for this very interesting presentation. We are waiting for any questions.
There are not much question. If you have any question, you can ask me, or if any other panelist has a question, they can ask me.
If any one of our panelists has a question.
My question to you, do you do this such non-union with this technique? My question to you, Professor Mohamed.
Yes, sir, please. I'm sorry.
No, my question to you, and since nobody is asking any question to me, let me ask a question.
We have a question to you, sir.
Okay.
Do you rule out infection before revision?
I didn't get you.
Do you rule out infection before revision?
Definitely. The infection has to be ruled out, but all these cases were non-infected, one which I have shown. Yes, I do have cases where it was infection, where I have first controlled the infection by putting stimulant bead or antibiotic-coated nails. Then subsequently, I have treated them with a similar fashion. I have not included in my presentation in this presentation.
Yes, sir. When do you decide, sir, to go to external fixation?
Non-union requires absolute stability. I don't think external fixation is a good option. Yeah. If there is no infection, yes, I do put a nail and an external fixator in the form of like Elizero and compress. This is usually in the humerus, not in lower limb. Or I can do the same in tibia also, but I'm not comfortable in doing subtrochanteric area. So I preferably use external fixator only in upper limb. With a humerus nail, I do put a ring above and a ring below, especially in humeral fracture, which has gone into non-union. But subtrochanteric fracture, I think I'm totally against putting external fixator because it's really cumbersome for the patient.
Yes, in some literature, sir, when we found infection, we can put a custom-made nail from cement impregnated with antibiotics, such like the spacer, exactly. Do you prefer this technique, sir?
Yes, definitely I do prefer it. Even I do get, since I'm in private practice, I do get patients which come after 10 days or 15 days with infection pouring and the fracture not treated properly, or treated initially with external fixator, but infection has not been taken care. In such cases, I primarily use interlocking nail. I have designed a nail, interlocking can be done, and you can also add antibiotic coating on that. So yes. I use primary antibiotic coated interlocking nail in such cases.
Yes, sir. We have some questions from our attendees. First question, would you primarily put augmented plate if you anticipate non-union, sir?
No. Primarily, I don't put it because I don't want to open a fracture. See, basically you are losing the fracture hematoma, the advantage of the hematoma in fracture union. So I depend more on the initial stability. Very rarely, yes, comminuted fracture in young adults, I put a augmentation plate, especially in distal third femur, but not in the proximal third femur.
Yes, sir. We have a question from Dr. Ahmed Morsi. In the case revised by proximal femoral locked plate, when the patient can start weight bearing, sir?
I almost always allow all my patients weight bearing immediately with partial weight bearing with the help of walker. I give them walker and ask them to, I give them a bathroom weighing machine. I show them how much weight to put. Normally, I ask them to put about 25% of the weight in initial 2 to 3 weeks time. After 3 weeks time, I ask them to put about 50% of the body weight. Then by about 6 weeks time, all of them will be walking full weight bearing with the help of walker. By about 2 months time, they will be totally off the walker.
Yes, sir. Do you use grafting routinely, sir?
I didn't get you, sir. Please.
Do you use grafting, bone graft routinely?
Grafting, no. Grafting, I reserve it for only non-union cases. Primary, I don't do it. See, if you are operating 100 cases, only 1 or 2 patients will be requiring grafting. So other patients, if you are doing grafting, it's unnecessary. You are additionally morbidity you are giving to the patient. So I normally prefer doing grafting only as a secondary procedure, not as a primary procedure. Yes, in a non-union cases, I might little treat, over treat, even in a normal non-union or little hypertrophic non-union also, I don't mind putting a graft because I don't want to take a chance again. I should be the last purchase if I'm doing a revision surgery. With that intention, I might over treat with grafting. But primarily, no, I'm not from the school of primary bone grafting.
Yes, sir. There are a question from Dr. Mohamed asking if there are early post-operative signs of AVN. Any concerns in the entry point of intramedullary nail?
AVN is problematic with a piriformis fossa entry only in younger patients. The non-union usually doesn't happen in younger patients. Non-union happens in adults and elderly people. So entry over the piriformis fossa, I have never faced a problem. I routinely take any femur nail, whether it is proximal femur nail, any fracture of the femur, I routinely take a piriformis fossa entry. I have been promoting in India because the problem of going little more laterally from the tip of the trochanter is the proximal fragment goes into varus. Once it goes into varus, the non-union problem is very high. You can see that almost all the cases I showed, the entry was from the tip of the trochanter, as the implant manufacturer say that the entry has to be from the tip of the trochanter. If you take an entry from the tip of the trochanter, the screw, though it will be in the inferior part of the neck, it will go in the superior part of the head or middle part of the head. So the head goes into varus. Because of the varus vector force, these fractures go into non-union, implant failure and other things. So I have not faced any problem by taking an entry from the piriformis fossa.
And the same question from Dr. Sandeep, why would they get greater trochanter entry so often? And I think you have answered it, sir.
Yes.
Another question, retrograde nail for subtrochanteric, any difference in the results versus antegrade nail, especially in certain cases?
I think for retrograde nailing, we should reserve only for distal femoral fractures, not for proximal femoral fractures.
Yes. The last question, sir, if there is shortening, what's the solution?
I think we can either lengthen the tibia, because it's easier to lengthen tibia with a LA0. We have got good systems available. So I don't think, or even if it is less than half an inch, just a shoe raise is also sufficient. But if it is more than half an inch, I think better to lengthen the tibia. But unfortunately, our patients in the part where I practice in India, they don't accept. The surgery is the last resort, they accept it. Only when nothing can be done. So for cosmetic purpose, for lengthening purpose, they don't come to me for lengthening.
Yes. Thank you so much, sir, for this very interesting presentation.
Thank you very much, sir. Thank you.
Thank you, sir. I don't know if Dr. Dilip Tana is with us again, or he is has a technical problem.
I don't think he is not there. He is not there.
Tana has mailed and said he has a technical problem.
Okay,
because I just saw the mail. I think it is 21:45. I think. Thank you, sir. We're
Yes, sir.
Going into a little bit of spine now.
Yes, you are the next speaker, sir.
Yes, sir. I'm Dr. Surya Prakash Rao from Hyderabad. Let me share my screen.
Thank you so much, sir.
Just a minute, sir. Let me share my screen.
Hyderabad, there was the SICO, I think there about maybe 6 years ago or 8 years ago in Hyderabad.
Yeah, SICOT we had.
The SICOT was there, sir. It was in a big way in Hyderabad.
Yeah, it was a big event there.
Yeah. Sir, can I start?
Yes, please, sir.
Yeah, this is because I never thought that we are going to discuss a lot of case series, because one Dr. KBS Srinivas told me, he said, present one case. So, but then if retrospectively I feel had I known this, I would have made a big detailed presentation on this, because I have so many cases like this. But nevertheless, I'll just go through this interesting case of a post-traumatic vertebral non-union. Now, this is about a story of a woman who is 68 years old. She has a trivial trauma at home 8 weeks back. That is the day from the day she has presented to me. She was locally diagnosed as a T12 compression fracture, and routinely, as in orthopedic practice, a lot of people advise brace, rest, analgesics, and most of them, because it's a small wedge compression fracture, they say it will heal well conservatively, and they sort of in some scenarios they don't even allow her to get up and go to toilet. They say no, everything should be on the bed. Some sort of a severe restrictive regimens in some scenarios it is followed. But in this case, I think she was managed reasonably okay. She was given a brace and she was just about up and about after 3 to 4 weeks, but she had no relief even after 8 weeks. That's when she came to me. On presentation, she had severe pain, and the typical history she gave is unable to change the position from lying down position to getting up. And in bed, after sort of lying down for a while, she's not able to turn on either side. and severe pain, and this is impacting the activities of daily living. Fortunately, she is neurologically intact. Now, these are the radiographs which they came to us. And you can see this non-union here at a fracture at this level with lot of collapse of this. And she has an incidental degenerative spondylolisthesis at this level also. And then we immediately got an MRI scan to just check what is happening. And you can see in the sagittal view, you can see the sort of a Comel sign opening up nicely. It's collection of fluid into the vertebral body. And fortunately, there is not much of a sort of a canal or a cord compromise. And otherwise, she is neurologically preserved. Then when we get this flexion extension view, hello, am I with you? Yeah, when you see the flexion extension view, you see the thing opening up nicely, a sort of a Kumel sign, what we call it. Mostly this is a vertebral non-union, which is probably secondary to some sort of a phenomena, which most of us are not sure. It is mostly a sort of a necrosis of the bone, and then the bone stops healing. And these people are prone for further collapse, further kyphosis, and in severe cases, there can be retropulsion, and further trauma can lead to neurological deficit. Now, in this seminar, everybody was talking about osteosynthesis, but here we are looking at other options beyond osteosynthesis. We can consider doing a standalone vertebroplasty in her, or a standalone kyphoplasty, or we can augment the above procedures with the help of a posterior spinal instrumentation, or simple bone grafting, but many with posterior instrumentation. But many a times bone grafting through transpedicular doesn't really hold very good, especially in non-unions. In fact, if anybody wants to do a significant good sort of a stabilization, one has to go transthoracic and put a nice strut graft in the front, which becomes too much an aggressive surgery for a 68-year-old lady. So we chose to do a kyphoplasty in her. And here in kyphoplasty, we sort of place the patient in prone position. And then as soon as we put the patient in position, you see the opening of beautifully the thing is opened. Then we just go through the sequences of the procedure, how we do. We sort of use the, guide wires. After the guide wire, we put in the working portal, then the balloon inside, inflate the balloon. Once we had the inflation of the balloon, then we have the entire thing coming up nicely, and then we fill it up with bone cement. So this particular procedure gives a beautiful outcomes, and though it is done through one pedicle, it spreads on either side nicely, and then we can see a beautiful, filling up of the vertebra. And these patients have almost instant relief of pain. And we would be they'll be very grateful that within few hours after the procedure, they would get up and walk, and they would carry on with the daily activities. However, being an artificial bone cement in a normal spine, we just need to be worried about the adjacent segments. Sometimes this can be a stress raiser on the adjacent segments, and we have to do a bone marrow, bone density evaluation. And if we find significant osteoporosis, she needs to go for a teriparatide injection for a few months, and to ensure that all the deficiencies are taken care of. And I think this is a small case, and thank you very much for the time, sir.
Thank you so much, sir. We are waiting for any questions to Professor Sorai. I think we have one question, sir, asking about, is this the initial X-ray at the time of the fracture?
Initial X-ray, what I presented was when she came to me after 6 weeks, not the first X-ray after injury. It was the X-ray after she came to me. That was the X-ray taken in my clinic.
And what about the neurology in such a case, sir?
Usually, unless there is a canal compromise, there is no neurology. If there is a canal compromise, then they usually have a neurology. In fact, at this segment, even 10 to 20% of canal compromise patients usually do not present with neurology. And any situations where there is a gradual compression, the spinal cord is resistant to developing neurology. Most of the times, neurology happens in a sudden or a situation where there is a sudden sort of a jerk or an injury, and that is then sort of an insult to the dura.
Yes, sir. Dr. Walid is asking, sir, is kyphoplasty a sufficient option in this high stress zone?
Kyphoplasty is a very good option, especially when treating these non-unions. The safety of kyphoplasty is far better than in vertebroplasty, because vertebroplasty and kyphoplasty differ in two important methods. In a vertebroplasty, we just insert the needle and try to push the cement with force. Then it can take any pathway, whatever it wants, and it can sort of get into the breach and then cause or can extravasate into the spinal canal and cause neurological deficits or problems. But in a kyphoplasty, as I showed you in the short video, it's a situation where we create a nice controlled space with the help of a balloon, and the cement is delivered under no pressure whatsoever. So that way, the entire the cavity is compacted, and in the compact cavity, the cement sits. So kyphoplasty is very good because it restores the height, and also at the same time, it reduces the risk of cement leakage dramatically.
Yes. I think it's a very big problem, the cement leakage, sir.
Yes, cement leakage chances are much less with kyphoplasty than vertebroplasty.
Yes. Professor Hisham, you want to ask a question, sir? Professor Hisham Farhood? Okay, we have another question, sir. Would you consider a cage and a bone graft in addition to the posterior stabilization?
Those options would be for a younger patient. Suppose if the same thing happens in a 45 or a 50-year-old, then that would be my option. At a 68-year-old with a osteoporotic vertebral non-union, the faster, the less invasive and less morbid the procedure, the better are the outcome. The beauty of this procedure is that even if I do a kyphoplasty, suppose God forbid this fails, I have those options still available to me in the future. I am not burning any bridges.
Yes, sir. We have two of our attendees raising their hands. Can you please write your question in the question and answer box, please? Yes, we have a question, sir. Cause of pre-existing pathology, osteoporosis only?
Yes, sir. Most of the times, these Kummel signs and these non-unions are due to osteoporotic pathology only. The beauty of the kyphoplasty procedure is, as we do the initial steps of inserting the needle, we have an adequate provision of taking some bone from there and sending it for biopsy as well. So in these clear-cut cases, we generally do not send. But in case of any suspicion, we always take a biopsy before we do this.
Yes. I have a question from myself, sir, please. What's the precautions and the prerequisites you should have to avoid the cement leakage, because this can end in a disaster?
I did not get the question, sir. Can you please?
What's the precautions you do, sir, so you can avoid the cement leakage, because this may end in a disaster, the cement leakage?
Absolutely. Few things. One, the procedure of kyphoplasty is fairly safe when as we expand the balloon and create a nice cavity in which the cement can be deposited. That is one. Two is the cement is delivered at lowest pressure through a plunger which displaces the cement through the cannula. And three, we wait until the cement becomes into a toothpaste consistency. where as we push the cement out of the syringe, it sort of folds onto itself instead of dropping down. That would be the correct time where we have to insert the cement. With these precautions, we usually can reduce the risk of leakages to a maximum.
We have a question from Professor Hisham Farhoud. He is an Egyptian professor specialized in spinal surgery. Why you consider this fracture is non-union?
Whenever we consider it a non-union, because most of the osteoporotic wedge compression fractures heal within 6 to 8 weeks. If beyond 8 weeks, we see the cleft and we see the intervertebral instability, that is, there is an instability in flexion and extension view, where we see the mouth of the vertebra opening up and closing, then we see the Kummel sign, we obviously know the vertebra has not healed by this time, and it is unlikely to heal if you wait in the future. That's why we call it non-union.
Yes, sir. Thank you so much for this interesting presentation, Dr. Soraya. Thank you so much, sir.
Thank you, sir. Thank you so much. I will unshare my screen. Yeah, I've already unshared.
Thank you, sir. Thank you so much, sir. Our next speaker will be Dr. Venkaramana from India, speaking about intercondylar fracture of the humerus, fixation without olecranon osteotomy. Thank you so much.
Thank you, Professor. I'd like to share my slides. Please see. Are you seeing it? Are you seeing my slides, Professor?
Yes, sir.
Distal humerus fractures are a challenging but rewarding injuries to manage. Advances in plate design and surgical technique have improved the outcome of internal fixation, which is the current standard of treatment. However, the procedure can be challenging and has a high rate of complications. Sometimes use total elbow arthroplasty as a treatment option in elderly patients and in a difficult fracture where we cannot reconstruct the fracture. Thorough understanding of the complex anatomy of the elbow, the soft tissue stabilizing structures around the elbow, and the adjacent neurovascular structures is essential before doing surgery around the elbow. Distal humerus is a triangular lateral column and medial column. They are together tied by the articular fragment with a tie arch. The articular segment of the distal humerus is anteriorly angulated around 30 to 40 degrees and a valgus of 6 to 8 degrees, and the internal rotated about 3 to 8 degrees. Whenever you're going to go for before surgery of the elbow, you have to thoroughly evaluate whether the fracture is open or closed or the adjacent neurovascular structures are involved or not. Next. Our treatment goals are getting a articular congruity, are you with me, sir?
Yes, sir.
Our treatment goal should be restoring the articular congruity, re-establishing the anatomic and mechanical axis, achieving the stability so that you can allow the unrestricted elbow range of motion almost immediately. Non-operative treatment is only for non-displaced fractures, and whenever there is a comminution in a severely debilitated patients where they are not fit for surgery. There are several surgical approaches. One is lateral approach only for exclusively for lateral condyle fractures, and the posterior approach for all types of distal humerus fractures. Even in posterior approaches, I use mostly triceps sparing approach. I use in lateral decubitus with hand hanging over the support. Posterior, midline posterior approach, and the triceps is separated from the lateral and medial intermuscular septum. I excise the medial intermuscular septum after isolating the ulnar nerve and securing it. Through the intermuscular septum, I can feel the anterior condyle by finger, and most of the reductions I do under Shyam imaging sphere control. Sometimes we need olecranon osteotomy when the fracture combination is big and we cannot do a proper reduction by doing with a tricep sparing approach. But it is rare. Despite olecranon osteotomy, 40% of the anterior surface remain unvisualized, and osteotomy carries the risk of non-union, future need for removal of metalwork, and potentially limiting any future orthoplasty. Hence, I do osteotomy only when absolutely necessary. See, when I am doing this tricep sparing without olecranon osteotomy, my idea is first to reduce the columns in a three-dimensional way and check by Shyam imaging sphere and palpating with your finger both anteriorly and on all sides, and then stabilize them by doing a initial K-wire fixation. After reducing the columns, they automatically the intra-articular fractures will fall in alignment because the intact olecranon acts as a mold on which the fragments will be molded. So once we got the fracture reduction, the fracture fixation, we have to follow all the principles of the Driscoll. Whenever you have articular fragments, interfragment fixation, we can use one or two lag screws, but we have to avoid over-compression or fragment when there is a comminution. So first restore the columns, then reattach the articular spaces to diaphysis, and lag screws are neutration plate, compression plate, and bridge plate. Several plates will be used to do that job. Next. So plate position, I mostly use 1990 plating of Jupiter. Plate choice, medial side to contour that, we may many cases I can manage with reconstruction plate, but posterior lateral plate, I use a stronger plate, either a LC-DCP or anatomical plate. Indication for LCP is whenever the fragments are small and bone is osteoporotic and there is significant comminution of the columns. Bone grafting I use for columns when there is a comminution and gap, but we should not use graft in the olecranon fossa because it may cause some stiffness in later. Osteotomy repair should be done properly, otherwise it will go into problems of non-union. Ulnar nerve, mostly I don't do anterior transposition. I secure the nerve while doing surgery. We can get good results with wire rough and plating, but it has some problems of hardware pain, the plate and becoming prominent over the subcutaneous area of the elbow. Complication of non-union as itself are uncommon because it's a very metaphyseal bone and highly vascular bone. Unless there is gross comminution and a fixation problem with the fixation and problem with the bone quality, non-union is rare. But we can manage non-union very well by doing a revision plating and bone grafting like this. So we're going to the case example, 36 male with a right hand dominance. There is a distal humerus fracture extending into the intercondylar area associated with dislocation of the capitellum. Even such fracture can be very well reduced without doing olecranon osteotomy by tricep sparing approach. You see, this is a 3 months follow-up, getting full range of movements. And if you notice, there is a displaced fragment of bone anteriorly. Even that displaced fragment doesn't come in the way of movements if you do thorough physiotherapy. That fragment will absorb over the period of time. Another example, a badly comminuted fracture fixed by another surgeon by doing olecranon osteotomy. Fortunately, the reduction is good, but the plate he has used is a insufficiently strong, less strong plate. So because over the time that plate failed, And again, he applied a posterior plate, even that failed. So this case, I did a anatomical LCP plating and bone grafting, and he got a good fracture union and good movements. Another case, distal humerus fractures with intercannular fracture in a young female who is an endocrinologist by profession. This is also done by triceps sparing approach, and anatomical locking plating was done. Next. So another bad case done by triceps sparing approach, and here I have used additional K-wire support for the bone with just by reconstruction plate, both posterolateral and medial. After 4 years follow-up is very good. The plates are still holding good and with good union. Another case, very badly comminuted fracture. So very well fixed by reconstruction plates, and I have used K-wire for additional support. Another bad distal comminuted fracture, very well fixed. Even you can see the very good reduction of the intercannular fracture without olecranon osteotomy. So sometimes you face a difficult fractures, very badly comminuted with loss of bone. We can do total elbow replacement primarily. Here in this is an example of Bakshi's elbow replacement. Very good movements and a good follow-up of 18 years. Suppose when you see patients like this, a total loss of bone and even elbow is lost, you need a custom-made elbow to save the limb and movements of the boy. So thorough evaluation is essential for going for surgery. Understanding the anatomy and it should play an important role in giving good results. And most of the fractures can be fixed without olecranon osteotomy. Very rarely I use olecranon osteotomy. Articular reduction and stable fixation and early physiotherapy are essential for good results. Most of the intercannular fractures of distal humerus can be managed without olecranon osteotomy, avoiding the risks associated with it like non-union and implant prominence. Even without olecranon osteotomy, with triceps sparing approach, we can spare the anconeus. It is a secondary posterolateral stabilizer because we are not disturbing the triceps attachment to the olecranon. We can allow early movements so that patient can get post-operatively very good range of movements. Thank you, sir. Ready to take any questions?
Thank you so much, sir. I think we will have many questions in this very interesting case. First question, if you allow from me, sir, the last tip, sir, you have presented and you have done for her total elbow replacement. She was, as you said, 18 years old and with osteoporosis. What's the reason?
No osteoporosis. This is a badly comminuted fracture. And if there is a gross osteoporosis in elderly patients also, we can do elbow replacement. That's what I told.
Okay, she do not have osteoporosis, but she looks like to be in a younger age group.
There is the loss of bone. That's why I did a replacement.
Yeah.
Due to accident, trauma.
It was not amenable for fixation, sir.
Yes.
Because she's too young, I think, for total elbow replacement.
I understand, but there is a loss of bone. We cannot restore the condyles and diaphysis.
Yes, sir. We have some questions, sir. First question, sir, what are your options of management for low supracondylar fracture with intercondylar extension?
So that's what I have discussed. I can do without osteotomy with triceps sparing.
Yes, sir. Another question, sir. What's your physiotherapy protocol? Would you recommend immobilization early post-operative?
Very early, immediately when the pain is subsided. Even 1 or 2 days, I will allow physiotherapy.
Yes, sir. Will olecranon osteotomy changes the post-operative protocol of physiotherapy? I think, of course, yes.
Yes.
Another question, sir. When do you prefer to do primary arthroplasty rather than fixation? Is age would be the main factor after liver
age is the main factor. Age is the main factor which they cannot and the bone structure, that means very osteoporotic bone, very soft bone, very cannot hold the implants, then we'll go for arthroplasty.
Yes, sir. Another question from Dr. Najwa. What's the absolute indication of olecranon osteotomy, or when we should do the olecranon osteotomy, sir?
Especially what I follow is, first initially I do triceps sparing approach, and I try to do very good reduction with the help of CM image intensifier and different manipulations and finger palpation anteriorly. If I don't get a satisfied reduction, then I will go for olecranon osteotomy.
Yes, sir. We have another question from Dr. Ahmed. Professor Van, are you going to change the elbow replacement for the pediatric patient in the future with a larger size?
No, I don't do a replacement.
I think this is not a pediatric patient.
Yes.
Yes, sir. This is not a pediatric patient.
Yeah, I don't do a replacement for a pediatric patient.
Of course, sir, of course. Another question from Dr. Hani Mansi. Two plates have the same height, increase stress riser on the distal humerus.
Yeah, definitely. I don't keep on the same height. I will see the height is a little variation from lateral and medial plates.
Yes, sir. I think we have another question. Yes. Does the patient understand that the revision rate is high and will need this in the future? I think the revision rate and the total elbow.
Yeah.
Other option.
Definitely. There is no other option. Then only we are doing a replacement after explaining the patient.
Yes, sir. I think we have no other questions. What about the triceps tongue approach? You don't prefer it, sir?
What is that? Triceps tongue? I don't have experience in it.
Yes, sir. And if you are obliged to do olecranon osteotomy, you do a transverse osteotomy or chevron osteotomy?
Chevron. I prefer chevron.
Yes, sir. Thank you so much, sir. Thank you so much.
Thank you very much, Mohamed,
for accepting our invitation. I think we have the last question, sir. I'm so sorry.
Yeah, no problem.
Does the patient understand that the revision rate is high? We can do arthrodesis for the child in hopeless cases. She's asking about if we can substitute the arthroplasty with a prosthesis, with the arthrodesis.
No. For most of the pediatric patients where you cannot fix a fracture, they will very well tolerate the conservative management and ask them to do physiotherapy once the pain subsides. Just like a bag of bone technique, they will have good range of movements and reasonable stability. No need for joint replacement in children.
Yes, sir. Thank you so much, sir. Thank you so much.
Right, sir. Thank you.
Thank you, sir. Our next speaker is Professor Devendra Agraham. Will speak about small wounds should never be neglected. This is a very important topic, sir.
Good evening to all of you. Is my screen visible, sir?
Yes, sir.
Yeah. I'm going to talk about the open injuries with small wounds. We need to expect the unexpected complications when we see small wounds in open fractures. Commonly, we see these two kinds of open injuries: a small wound with a simple fracture, a large wound with a gross comminuted fracture. And most of the times, a grossly comminuted fracture with larger wounds, they take quick attention and then get treated in a different track. And smaller wounds, most of the times, they get neglected. So the small wounds with extensive comminution or bone loss or muscle damage is very important. It is very deceptive term to say that it is a small wound Small wound or large wound, both needs to be considered in the similar fashion, because there will be an extensive skin deglowing, crushing of underlying muscles, extensive bony comminution with loss, and there can be contamination and injury to the neurovascular structures. Let me share a case where an young individual who met with an accident and presented to us in the casualty at around 11 o'clock in the night. He had a ilium fracture on one side and forearm fracture along with open elbow. That is a 3 centimeters wound, horizontal wound in the posterior aspect of the elbow, just above the olecranon. And on arrival, the lactate was serum lactate estimation showed above 5, and blood sugar was quite high, which tells us that patient is having uncontrolled diabetes mellitus. And in these situations, when the patient arrives in shock and in the middle of the night, sometimes smaller wounds gets neglected. That is what has happened, and this wound was just superficially debrided, and then suturing was done. And 48 hours later, when we took him up for a second look debridement, by the time he got resuscitated and the sugars were a little bit less, ketones were negative, and lactate also is normalized. However, we can see that there is extensive crushing of the muscles, avulsion of triceps from the olecranon, and gross contamination both medially and laterally. So these kind of extensive soft tissue disruption through a small wound, we don't appreciate many times. So this gets missed. So here it took almost 1.5 hours for the debridement. And then once we are completely satisfied with the debridement, there was a dilemma whether to put an axonal fixator and wait and do, or straight away go ahead for plate fixation. Since it is a upper limb injury with open injury and adequately debrided, we went ahead to do a plate fixation, and at the time of second look debridement, these are the Shyam and X-ray images. And 5 days later, we can see that there is a infection, purulent collection coming from the suture line, and immediately the next day we have debrided the opened and debrided the wound. There was a lot of infection, and debridement was thoroughly done, and then started him on linezolid and amikacin for a week period, followed by oral lizolid for a 3 weeks time. Culture report shows gram-negative bacilli growth as well. And after 2 months also, still the infection is persisting. Even though it is not actively discharging, there is a sinus with minimal discharge, and we can see that the X-ray at the end of 2 months shows there is a dense sclerosis of the bone near the joint region, and intercondylar extension fracture alone looks healing. Apart from that, there is a periosteal reaction with osteolysis around the plate as well. So when we took him up for a debridement at the end of 2 months, this is how it has come out along with the plate. The whole sequestrum, around 6 centimeters of sequestrum came off from the operated site. And this is how we were left over at the end of debridement. There is around 8 centimeters approximately the bone defect. And at this stage, we were thinking to add external fixator. But however, if we add the pins, there is a possibility of pin tract infection again, and we might lose future fixation points if we apply the external fixator. So we have left him with above elbow slab, and we waited for some time, almost 6 weeks time. And this is the X-ray at the end of 6 weeks, where there is a bone defect with minimal periosteal reaction also we can see. And at this stage, once the infection is completely controlled, there is a bone loss in the upper limb. We had the options of taking either tricortical iliac crest, which can be used only for up to 6 centimeters, and vascularized fibula. There are advantages and disadvantages of vascularized fibula, because we need to have a good setup with a microsurgery team, experienced team, so that the success rate will be very high. So we have a very good plastic surgery team with us who does microsurgery procedures. So we chose vascularized fibula. It was harvested from the left leg with a skin island and vascular pedicle. And this is the fibula, which we break into two by taking a small half. Still, the vascularity is intact, both proximally and distally. And then we try to curve it and place in the defect, and dual plating was done. This is how it was planned in the defect. Medial column, completely it is stabilized, and lateral column, the small bone that is left over, it is fixed to the shaft, and then dual plating was done. And this is at the end of 1 month and 5 months X-ray, where the both proximally and distally the fibula is uniting with the host bone. And this is at the end of 1 year, where it has completely healed without any much problem. Initially, since there was a lot of crushing of soft tissues, we expected some stiffness, and he had stiffness. He required quite a long time physiotherapy, and he got reasonably good range of movements. And now he is able to eat on his own and drive the vehicles and routine work, even though there is a residual fixed flexion deformity, and not terminal range of movements are restricted. Coming to the one more case where a 41-year-old gentleman presents with a small open wound and around just above the patella, with the bone protruding through the wound, and there is a comminution at the distal femur fracture site with intraarticular extension. We can see that there is extensive gas shadow extending up to the mid shaft level, which tells us that the whole bone has come out through the open wound, and then soft tissue also is crushed, and periosteal stripping has happened, and the outside air is being sucked. So this is a very important sign that we need to understand. And during debridement, we need to extend higher up to the mid shaft level where the soft tissue stripping has happened. Otherwise, this can go on to have a serious complications with infections. So this happens, even though the wound is small, this negative suction effect, at the momentary negative suction effect that occurs at the time of injury, sucks out all the surrounding dirt, whatever is left over on the road. And then even gas, air also gets sucked into the bone intramedullary also. So it is very important not to reduce the bone if it is protruding through the open wound. We should not reduce the wound, bone in the casualty. Always take him up for early debridement, and then after adequate debridement, put the bone inside. So here, if we look at the pathophysiology, the small wound that happens when the moving object comes and hits the limb with the knee inflection, the wound is small and the bone protrudes out. And then when the violence continues, sometimes even the long segment of bone also gets ejected out. This is how is the mechanism of injury that happens, and bone loss occurs. So the principles of debridement remains the same irrespective of the size of the wound. So here we can see the left side picture where the wound has been, the open wound is included in the debridement, and then it is extended higher up, completely up to the mid shaft, and then surrounding contaminants, crushed muscles, everything was removed, intramedullary contaminants were removed, and loosely lying cortical segments are also removed. And we can see that there is some amount of bone loss. However, on day one, it is easy to do articular reduction, and articular fracture reduction was done, and external fixator was applied. And our Ganga Hospital open injury severity score was 10, which tells us that we have to stage the procedures for this kind of major injuries. And once the patient is fit for next procedure, once there is no infection at the end of 5 days, we have taken up for definitive fixation. And we can see that there is a bone graft also added at the fracture site since there is a bone loss. Primary bone grafting also can be done routinely in open injuries, provided we debride the wound adequately. And these are the limb alignment pictures. And we can see that the fracture alignment is good. And at the end of 15 months, we can see that the fracture has completely healed. And even though the small wound with extensive soft tissue stripping and crushing, we can see that patient is able to achieve a good range of movements, and he is able to do all his activities. So to conclude, small wounds should not be neglected. Small wounds with extensive comminution and muscle injury has to be taken care adequately as we give attention to the larger wounds. They are not just Gustloff-Anderson type 2 injuries. It is more than that. So we need to give equally good attention to the smaller wounds. since higher complication rate is possible, and we may need to do multiple secondary procedures if we neglect this kind of open wounds with small open wounds. Thank you.
Thank you so much, sir, for this very important presentation about a very important topic. We are waiting for any questions to Professor Devendra. My first question, sir, in the last case you have presented, do you use the less invasive stabilization system for putting such a longer plate?
Yeah. Yes, sir.
Yes, sir. We have a question to you, sir. How many liter of
yeah, I saw the question, sir. I mean, how much of, what is the amount of fluid that we use to clean the open wound?
Oh yeah, to wash it,
yeah. Initially, the 15 years ago, the evidence was like for type 1 open 3 liters, type 2 6 liters, and type 3 9 liters, like that. The saline we need to use to wash. But now it doesn't. It is not important for the amount of fluid that we use to wash. It is the adequacy of the debridement that we do by removing the contaminants. So adequate debridement is more important than the amount of fluid. Amount of fluid can be just, you can use even 1 liter also if you have thoroughly debrided the wound. So debridement is the key compared to the amount of fluid that we use to wash.
Yes, sir. Do you use, sir, topical antibiotic in the wound after washing out?
No, sir. Again, the answer is same. The adequacy of the debridement matters more than using local antibiotics or any other method. So debridement is the key. No local antibiotics we use routinely.
Yes.
It is not required, sir.
Yes, sir. And some surgeons in the last years used to do very good debridement and internal fixation if the wound is after debridement is clear, and they put a prophylactic septobal beads of antibiotics. You do not recommend this, sir?
No, evidence says that we don't need to routinely use topical antibiotics or local antibiotic beads. They have to be restricted to only the infections, because we are delivering the antibiotics directly to the open injury site. And debridement, even if you give tons and tons of antibiotics, if you don't debride the wound, again it is possible that it may go for infection.
Yes, sir.
So debridement makes the difference rather than looking at antibiotic delivery to the open injury site.
Yes, sir. I'm sorry, sir. We have many questions because it's a very important topic.
Yeah, no problem, sir. Please.
Sir, small wounds could be a large soft tissue stripping. That why we classify intraoperatively. Would you consider XFAX from the beginning in elbow case?
Sorry, sir. I didn't get you.
A small wound could be a large soft tissue stripping. That why we classify intraoperatively. Would you consider XFAX from the beginning in the elbow case?
Yeah, I think day one it should have been thoroughly debrided, and then if you find that there is a lot of contamination inside the wound, you can stabilize it with external fixator. Again, come back after 48 hours, do a second loop debridement, and then go for definitive fixation. Yes, external fixation also is a important this one, sir.
Yes, sir. Another question from Dr. Mohamed Zaki. What's the rule of cerclage in the case of lower femur?
Sorry, sir?
What's the rule of cerclage wiring in the case of lower femur fracture?
Yeah, they are all positional wires, sir. They're just to keep the fragments in position when they are scattered around the open injury site with soft tissue attachment. When you have soft tissue attachment, if you leave them lying scattered in the thigh, they may not participate in bone healing. Sometimes if you want to get a good alignment, positional wires also are helpful.
Yes, sir. Another question from Dr. Sandeep. Sir, how long could we wait for such small wound before definitive fixation? I mean, when are they expected to get infected if they are not seriously cleaned or deprived?
No, we need to be as early as possible to do debridement, but definitive fixation, you can wait even up to 2 weeks also. If there is no infection, then you can go ahead to do. We wait up to even 2 weeks if there is a lot of contamination on day 1.
Yes, sir. Another question from Dr. Ayman Abu Tawila. I think you have answered it, sir. How long period between debridement and permanent fixation?
Yeah, that depends. Like sometimes if the patient requires bone grafting and extensive procedures, we have to make sure that there is no infection. So we can give up to 2 weeks time also. We wait up to 2 weeks time and then do the procedure. Even sometimes in major open injuries, we wait up to even 3 weeks also.
Yes, another question from Dr. Abdullah. What's the best to do after infected tibial non-union, which fixed by intramedullary nail, please?
If there is infection with intramedullary nail, it is always better that we remove the nail and debride the intramedullary region outside everything, and then go for external fixator. Like you can choose OrthoFix uniplanar system or circular ring fixator also, Elizero.
Yes, sir. Which classification for the upper limb?
Yeah, open injuries, commonly everybody uses Gustilo-Anderson. Our Ganga Hospital open injury score, we use it for mainly the lower limb tibia fracture. And we do extend the same classification for upper limb also, so that we get a good idea of what is happening in this one. So MES score and Gustilo-Anderson score is fine.
Yes, sir. We have another 2 questions in the chat box. Do you use cement? Do you use cement after debridement? I think he is asking about musculoskeletal knee.
Yeah.
Maybe.
No, when there is a bone defect, if you want to do bone grafting, if you are planning to do bone grafting after some time, like not primary, maybe after 6 weeks or 2 months time, then you can fill the defect so that the defect doesn't get covered again with the fibrous tissue. The future dissection will be easy, and then easily we can bone graft it. So small defects you can put cement and then remove after 6 weeks time to bone graft it. And in infections, definitely yes, we do use cement, but not routinely like a cement beads. When there is only bone defect, we use cement.
I think we have no more questions, sir.
Yeah.
Thank you so much for this very interesting presentation about a very important topic, sir. Thank you so much, sir.
Thank you, sir.
Thank you, sir. Our next speaker will be Professor Vivek Trekav from India, 3-month-old fractured dislocation of the proximal humerus. Professor Vivek. Professor Vivek, you are with us, sir? Yes, we can see your presentation, sir.
And you can hear me? Right.
Yes, sir.
Thank you. Thank you so much.
Sir.
I'll be presenting a case on neglected proximal humerus fracture dislocation, a case. We know that in India and in other developing world, neglected injuries are quite common for us to deal with. And this literature is not evident in the worldwide evidences which are available. So what are the modalities by which we can manage these cases? That's what we are going to discuss over the next 10 to 15 minutes. I'll be presenting this case of a polytrauma who unfortunately was in some hospital for an ICU for his dorsal spine fracture, which was fixed somewhere. And he came to us after 3 months with this fracture. You can see what happened, that he was having pain, and whenever he was showing and telling that he was having pain, people said that it is because of the dorsal spine fracture which has been fixed. In spite of being in a medical hospital, he was, and this fracture got neglected. The chest x-rays were there, and the chest X-rays was showing the rib cages and not going right up to the proximal humerus. And hence, this fracture got missed. And 3 months later, he comes to us with a fracture which is like this, a fracture dislocation of proximal humerus. We got the CT scans done. And this is the CT scan, which you can see. If you see the scans, there is all the fractures, the humeral head is broken, the GT and the greater tuberosity is separate. The head has gone posteriorly. And if you see the third and the fourth films, 2D as well as the 3-dimensional ones, you can see that there is a lot of callus formation which has happened over a period of 90 days. You can see that the callus is there, especially under bone formation in the proximal part of the humerus has happened. So the question which comes now is where we are. It's a 90 days old fracture. The person who is there is a 40-year-old patient having a 4-part fracture dislocation of the humerus. He's a bus driver in an Indian capital city of a transport corporation and has to do heavy works which are there. And what are the possibilities which are available for us? Are we going for a replacement or we are going for a reconstruction? And this is a very common phenomena which happens in cases of fracture dislocation of proximal humerus. Whether we are going to go in for a proximal replacement or a reconstruction in a young man. Most of these are in young high-velocity injuries in young productive age group. And how do we achieve good results in a 40-year-old male? The questions which come are, if we are going to salvage this, what is going to be our approach? Whether we are going for a deltopectoral or a posterior separate approach or a mid-deltoid approach. How are we going to reduce? What are the tips and tricks which can we use for this reduction part? What will happen to the bone loss which has happened over a period of 90 days? And do we keep any backups as well while we are managing such cases? So these things need to be looked for and discussed. And I hope that we will have some questions regarding this once we have finished with this case. The choice of treatment, what we opted for in a 40-year-old patient was for head salvage and reconstruction because of his dominance, because of his work pattern which he was doing, and he wanted to continue in his work. Yeah. His profession was such. The fragment size, you could see. One thing which was helpful for me and to decide was the fragment size. If you see the proximal humeral head size, it was quite a big chunk of the two greater tuberosity as well as the proximal humerus head. And that made me think of a possibility of a salvage for him. And with the working in our trauma center at New Delhi, with our experience with open reduction and fixation of these fractures, we had a fairly good idea of managing such cases till 1 month, 45 days, but we had to extend it for 90 days here. This is the thing which we had published also in Journal of Shoulder Elbow Surgery, where we had a retrospective analysis of fracture dislocation cases, which we had managed with salvage and fixations. And what suggested that out of our 33 cases, majority of them had good results, provided the age was less than 50 to 55. The 3 failures which we had were mostly in the borderline areas of 55 years, where a possibility and the avascular necrosis happened. But in the young, most of the cases, we were able to manage these cases without any great morbidity to the patient. So the strategy which we used was a part of the diamond concept, which Peter Giannidis has so well espoused, regarding adequate stability, osteoconductive and osteogenetic potential needs to be brought about, along with man-made or natural growth factors which can be added. So you need some osteoconductive scaffold, you need some osteogenic potential and the growth factors, and also give mechanical stability and the environment so that the things can unite. So going back to our old case, original case, the deltopectoral approach is the standard approach which I use even for my posterior dislocation cases, as well as for my anterior fractures. A lot of callus and granulation tissue was observed, which was natural and which was obviously we had anticipated that. And since we were not able to identify the things, the first thing which we did was to osteotomize the lesser tuberosity here. Because the lesser tuberosity was malunited in a specific position to the humeral shaft or the rough area. And it was not possible to go into the glenoid posteriorly and visualize that humeral head and bring it back. So the first thing which we did was osteotomizing the lesser tuberosity, holding it with the ethibond as you can see on this picture, and then going about opening up the glenoid cavity and then trying to hinge out. The greater tuberosity was also tagged, which we had done, and then the humeral head, which was lying posteriorly, was slowly and slowly brought out, which was hinging on the posterior aspect of the glenoid with a periosteal hinge or the Homans, by hinging it and reducing it by leveraging at the level of the posterior glenoid. If it wouldn't have happened, we would have used a shank spin or some two Homans to elicit that fragment from posterior to anterior. So we were able to bring the humeral head from the posterior side to the anterior. And then the critical thing which I feel in proximal humeral fractures is to maintain the medial continuity or the calcar continuity, which is very important to get this back and to get the outcomes. For the bone loss and the gap which we had, we repositioned the greater tuberosity, and before that, we put in an intramedullary fibular strut. This was an autogenous fibula taken from the patient's body, but it was non-vascularized. It was purely used as a fibular intramedullary strut, which will be holding the humeral head with the amount of bone loss which has happened to give some support to the shaft and the humeral head. And then the callus which was there had been nibbled out, was put back onto the positions to be used as a bone graft. Then the K-wires which were used to maintain the arch as well as to maintain the neck shaft angle of the humeral head were done properly. And once we are able to get this with the continuity of the medial calcar, which is the most important thing, then subsequently a Phylos plate, standard Phylos plate was added to him, a 3-hole plate was added. In the end, since the lesser tuberosity which was there has been in the center picture, you can see it was lesser tuberosity which was osteotomized, was fixed back with a screw as well as the ethibond. And since the groove of the biceps tendon had become quite rough and was uneven, to avoid post-operative pain, the tenodesis of the long head of biceps was done here. As you can see in the final picture, the position of the Phylos plate is at right place. The calcar screws have been put, fibular strut is there, and a lesser tuberosity has been fixed back with a screw as well as ethibonds, maintaining the medial calcar continuity. This is the post-op image, and we were quite happy thinking that we have been able to bring back the position of the head as per the Hertel's criteria. Also, we were hopeful that this may work properly. This is his 3 months follow-up, where we started doing about his range of motion and muscle strengthening exercises after 3 months. And you can see that he was able to do quite good range of motion. You can even see the dorsal spine scar of his dorsal spine fixation, which was done and which had initially led to this missing of this fractured frater. This is his 6 months follow-up. And now you can very well see that the position of the head has remained at the place. The neck shaft has been maintained, and the screws, calcar screws, as well as the fibular strut out there is now getting incorporated, and the solidity to the fixation is being given. And this is his final follow-up at 2 years of follow-up, where you can see that the vascularity of the femoral head is maintained. And as you can see that he has got full range of motion, full abduction, full rotations, and he has gone back to his work of his factory, whichever the transport work which he was doing. So many things similarly of this dislocation. I'll just take one more case like this, showing you an anterior dislocation, another very small anatomical head, 4-part fracture dislocation anteriorly now, managed similarly in a young patient of 30-year-old, but here instead of putting in a fibular graft, we have used an iliac crest tricortical graft with a small anatomical head, maintaining the shaft and neck angle properly. And this is his follow-up at 3 years, 5 years, and at 6 years follow-up. Along with 8 years follow-up, you can see that there has happened mild sectoral avascular necrosis, but the patient is okay, his functional outcomes are excellent, and he's able to do all his activities. So I would say that in take-home for proximal humerus fracture dislocations are complex injuries. However, most young of the patients and the young patients who get these injuries can achieve good functional outcome after fixation, maintaining the head and the shaft angle, maintaining the medial cortical continuity, and fixing back the tuberosities well to the head will bring you back a good range of motion, meticulous surgical dissection, stable construction, and early physiotherapy, which is quite aggressive and improves over a period of 3 to 6 months, are cornerstones to achieve a satisfactory outcome. Thank you for your patient listening.
Thank you so much, Professor Vivek, for this very interesting presentation. I think we have many questions for you, sir.
Yeah.
Can I start with a question, sir? In such a case of neglected fracture dislocation, do you routinely use investigations such as MRI or isotopic scan to check if there is any early signs of AVN in the humeral head?
I might be using them in the borderline cases, as our study also showed, which we had done, which showed that most of these cases may have not the best of the results if the patient's age in Indian setting is above 55. Then you have to be slightly worried about them. And then you can decide whether you want to salvage along with consultation with the patient, whether you really want to salvage it or replace it. But with our experience in our literature, and there have been subsequent evidence also in the world literature, which suggests that in young patients who are less than 50, and with the present day implants which are available and the technology as well as the thought process which is there, we should be able to salvage this head. The avascularity, even if it happens in proximal humerus, may not be that debilitating and morbidity-wise as compared to a femoral head. Because the sectoral avascular necrosis, as I showed you in my last case, it was a small anatomical head. We fixed it around 2011, I fixed it. And now it's now 12 years. That it still is working. Patient's X-ray might show a mild sectoral avascular necrosis, but the patient's functional outcome ultimately is complete and is having good results. So MRI only in cases where the outcomes may be doubtful, which is in borderline cases or elderly patients. In young cases, until unless it's a comminuted fracture altogether with multiple parts, all efforts should be made for salvage.
Yes, sir. And if you suspect AVN, sir, do you prefer to use the fibular graft, vascularized fibular graft?
You can use it, but I don't have that technical expertise in my hospital where I'll be using that. And I feel to get that in a proximal humerus might be quite a challenging thing to do that. So, but since I haven't have any experience for that, we feel that providing good stability, good neck shaft angle, and maintaining the medial calcar continuity, that's the most important thing, which gives you the prevention of failure of the head, which goes into varus.
Yes, sir. We have another question from Dr. Fahd. Do you follow Hertel criteria to predict about the humeral head ischemia?
Yes. In my paper also, we had contentions regarding Hertel's criteria. And if you see the Hertel's paper as well subsequently, which he published in 2006 and subsequently in 2014 as well, the other authors who published, you can use the Hertel's criteria as a preliminary guideline. to get the prognosis. But it cannot be sacrosanct that if it is an anatomical head, you cannot go in for a reconstruction and you cannot salvage the head. And this was even admitted and agreed upon by the original authors as well, which we also had published in our paper like this.
Yes, Dr. Mohamed is asking about the post-operative regimen and when to start, sir.
Yeah, that's the most, exactly. That's very important because it's not the X-ray picture which is important for the patient. It's the functional outcome which he is going to get. And the functional outcome is purely based on the physiotherapy post-operative. I'm very aggressive regarding my physiotherapy in the sense that the next day onwards, the pendulum exercises will be started. The patient will be having active assisted exercises with the arm being assisted by the opposite side of limb up to 90 degrees of abduction and flexion. The second thing is after 6 weeks to 2 months, till that time, he's going to continue on this. Then once you see a check film which is showing you evidence of bone formation and the union process which is starting to happen, then you start them on active exercises, which is along with the walls, with the rotations and abductions, circumductions. And after 2 months, you start the rotations. And subsequently, you are going in once the fracture has united after 3 months for the active muscle strengthening exercises, which gives them the full range of motion. Remember that the motion continues to improve up to 6 months. Don't just get disheartened up to 3 months. Make sure that you are able to encourage your patients because the movements will increase if the patient is motivated enough to get movements up to 6 months.
Yes, sir. I'm sorry, Professor Vivek, we have many questions, if you allow us.
Sure, please. I'm very willing.
Dr. Ablatif is asking when to decide to do coracoid process osteotomy and based on which criteria do you decide the graft choice?
The graft choice. Okay. So the first thing is the various tips and tricks to reduce the anterior dislocation of which is fracture dislocation is one of them is coracoid osteotomy. However, for me, I haven't done a coracoid osteotomy till date in my more than 50 odd cases which we have done, even in late. Just last month, we had a case which was around 60 days old, but we still did not do because what we need to understand is if you are able to relax the muscles, you might be able to bring out the thing. So what I always do is make sure that my shoulder is flexed as well as my elbow is flexed, which gives and relaxes my biceps and the muscles which are originating from the coracoid, below which my head has gone. So once you are able to relax the muscles which are above that head, you will be able to tweeze out that head slowly and slowly from there. However, if you feel it has gone quite medially, coracoid osteotomy can be done, and it is a well-described procedure. As regards the choice of graft, if I find that the medial calcar is mildly comminuted, I might like to put in a tricortical graft there, making it as a wedge in the medullary shaft and fixing my humeral head onto it. However, if I find that my humeral head is also small and my graft positions may not be able to hold my humeral head to that, these are the places where I use a fibular strut, making it slightly pointed so that it can get indented into the proximal humerus part fragment and which gets it as a support.
Yes, sir. We have another question from Dr. Mudaffar Ahmed. Professor Vivek, any kind of soft tissue reconstruction have been done? And is there instability during the follow-up?
Yeah, that's a great question because we had a similar question as a letter to editor for our paper as well. And we found, and we have subsequently quite followed up, I feel that if you are able to reduce it with a soft tissue mobilization in a proper manner, we didn't have any instability because of the anterior glenoid erosion which can happen. We were quite expecting it in a 60-day-old fracture which we operated 4 weeks back as well. But it didn't happen once you were able to bring back your proper greater tuberosity and lesser tuberosity. However, as a precaution, after fixation, you should always check for instability. And if the anterior labrum or the anterior glenoid has got eroded, you can, and it's very well described, that you can go take out that coracoid and fix your, just like in a Latarjet procedure, can be done if you want to do it. However, in R50 or more than cases, and in neglected cases as well, we didn't have any opportunity or any requirement of doing such thing.
Yes, sir. Another question from Dr. Abdulatif. What's your best files plate placement criteria? Surgical set indications or fluoroscopy?
I didn't get, sir. Which is
what's your best files plate placement criteria? Surgical set indications or fluoroscopy?
It is a combination of everything where it has to go. You have to ensure that it is at least 1 centimeter lateral to your bicipital groove. That's the first thing. And based on that, you can even go slightly more laterally if you have a greater tuberosity. Regarding the top portion, you always look at the fluoroscopy to make sure that you are not going too high up. Again, it's around 8 millimeters down so that your anterior impingement or the impingement does not happen when it is getting abduction. But I feel after that, ensure in Indian population, sometimes the humeral bone morphology is small. So many a times your top screws and the calcar screws may not even go also. So they also give you, I put in some KYS in the proximal and the distal calcar to ensure that my plate placement is ideal. And it is going right into the screw fixation also is going into the humeral head. So I think it's more of a combination of everything.
Yes, sir. We have another question from Dr. Walid Goma. How can we avoid the axillary nerve?
Okay. So as a matter of fact, for any deltopectoral approach which you are doing, and once you are trying to mobilize the deltoid, which is from the lateral aspect with your finger with the blunt dissection, which you do, and see your greater tuberosity, at that time you need always to pass your hand and fingers over that sling into the inner part of the deltoid, where you will find a string-like structure along with the vessel, which is the axillary nerve. So you always check for axillary nerve on the lateral side whenever you are giving an abduction and mobilizing your greater tuberosity and below it. You cannot do much at that time if it is broken, but it's usually not torn anyway. Most of the 99%, you will never ever find that axillary nerve is going to be damaged. Yes, in callus formation, sometimes it can get difficult, but thankfully the callus is not formed so down. It is around 7 centimeters down. So the greater tuberosities and all, they are higher up and you are not going to have much problems, but you need to do blunt dissection sometimes to ensure that it is not entangled anywhere.
Another question, sir. Tips and tricks for reconstruction of the laser tuberosity and the subscapularis.
Okay, so if it is, make sure that you are having your ethibonds ready all the time. I would always say that proximal humerus reduction and fixation is more a soft tissue surgery than a bony surgery. You need to ensure that your tuberosities are fixed back to the plate or to the humeral head as good as possible. I always tie up my lesser and the greater tuberosities with ethibonds. Even if one of them is not broken, I manage and make sure that they are at the osteotendinous junctions so that you don't go through the bone or through the muscle. Osteotendinous junction will be the area where you should fiber hold of the sutures should be, and fix those sutures to themselves as well as to the plate, because that is what is going to give you good stability both from anterior and the posterior aspect and help you in post-operative mobilization.
Yes, sir. Another question from Dr. Mohamed. Sir, how would you explain the patient not having early AVN with such a fracture with less than 8 millimeter calcar?
Yes, and that's the reason why we contended Hertel's criteria in our paper. Because if you start following Hertel's criteria word by word, then no fracture dislocation, which is a 4-part, can be operated and salvaged. You will have to replace all of them. But you see in life and in nature, there are things which happens and there are a lot of vascularities which are coming from some areas which we are not so properly defining. which will give you back the vascularity. Moreover, the stability which you get by good fixation and putting in the grafts and the strut grafts, they help to give the creeping substitution and making sure that even if avascularity is happening, it can be circumvented and taken care by the newer vascularization which happens because of good stability which is there.
Professor Vivek, can we have more questions or that's enough?
It's up to you, not to me.
we have 4 questions more.
Sure.
Yes, sir.
Sir.
Thank you. Do you do biceps tenodesis routinely, sir?
No, I do not do them. I'm very particular. I try that biceps is not a vestigial organ or a tendon. It needs to maintain its position of the stabilizer unless your groove and the place in the rotator interval that has got a lot of irregularities and you are not been able to maintain it back in any fracture. I would not like to tenodese it, because if it is rough and the groove is not proper where it has to its excursion is not going to happen properly, then it might lead to pain. Those are the only cases where I will do a biceps tenodesis. Otherwise, I like to preserve the biceps.
Yes, sir. Sir, another question from Dr. Aziz Botros. Why you did osteotomy for the laser tuberosity?
Yes, because this fracture fragment was lying posteriorly. It was a posterior fracture dislocation. My lesser tuberosity was the first thing which I was seeing from my deltopectoral approach, which I normally take for this. And hence, to enhance my visualization of the glenoid, which, because it was a delayed case of 90, the lesser tuberosity had malunited to the soft tissues and the structures there. So I had to osteotomize it to remove it to get an exposure of the glenoid and subsequently go posterior to it to remove my femoral head. That's why.
Yes, sir. Another question from Dr. Amir Sheikh. What about intramedullary cage in such cases?
Yes, sir. You can use the cages as well if you are there, and you can use small amount and thinner cages. In India, we are much more conversant with autogenous fibular grafts, which we have been using. You can also use allografts if you have available of the fibula. They will also be done. I am much more conversant with autogenous fibula. That's why we have used them. But cages, small cages, thin diameter cages can also be used.
Yes, we have another question about the subscapular stenotomy. I think you have answered it, sir. Last question for me, please, from Dr. Abdulatif. When to decide that the fracture failure and when to pass to arthroplasty for young patients?
Young patients, as a trauma surgeon, I would like to fix it all the time if possible. But you should know your limitations, that if your head fragments are more than 3 or 4 or 3 fragments, then maybe you may have to go in for the replacement straight away. Sometimes it is crushed massively. As I said, my indication of managing this case by salvage was a big chunk of humeral fragment, head fragment, and a big chunk of greater tuberosity, which made me go back for a salvage procedure. However, if the humeral head is shattered, then that might be one of the more common reasons where I will go for replacement, or it's an eggshell in elderly patient.
Yes, sir. The last question, sir, from me. It will be from me. If this case did not unite, do you prefer to do hemiarthroplasty or reverse shoulder?
In 40 years, I'll still like to go with a platform type of hemiarthroplasty so that I can convert it later.
I prefer the same, sir. Yeah.
Thank you, sir.
Thank you so much, sir. Very interesting case. Thank you so much,
Thank
sir.
you.
Many thanks to Professor Vivek, and sorry for the very long question, sir.
No issues. Thank you, sir.
Thank you so much, sir. Now we go to the next speaker. Next speaker will be Professor Abhijit Wahingpur. Oh, Dr. Abhijit, how are you, sir? Second time to meet you.
Well, thank you. Yep.
Thank you so much for being with us, sir. Thank you so much for your support. Thank you for accepting our invitation, sir.
It's an honor. Thank you very much.
Abhijit will speak about distal radius fracture, a hand surgeon's perspective. Thank you so much, sir.
Thank you. Is my screen visible now?
Yes, sir.
So thank you very much for the opportunity, and it's an honor to be back here again with this August forum. And my task is to talk about distal radius fractures, approaches, tips, and tricks, a hand surgeon's perspective. So the hand surgeon's perspective basically refers to the soft tissue aspect and some nuances that we need to take into account when we talk about distal radius fractures. And I hope this will help our friends and colleagues who deal with these fractures. So this is the scope of the talk, wherein we will try to recognize fracture patterns that are unstable and those that require fixation. We will try and understand the classification systems and apply them, the approach and the anatomy, and understand implant design and indications along with a few caveats. We'll start with this case in point wherein a young individual had this fracture. He had a fall onto an outstretched hand, was treated with this splint. And I think a lot of us would perhaps think it's okay to treat it this way. But this kind of went on to having 5 weeks later a displacement of this sort. And one would often wonder what went wrong during the treatment of this particular fracture. Did we miss something? So with that introduction, here is another case wherein you can see that there is quite some combination and collapse of the fragments of the distal radius here. There is also an involvement of the ulnar styloid styloid process. The lateral view also shows that there is combination and angulation as well as shortening and displacement. And when we were discussing this case, some of us told that this is something which is still amenable to pins and casts. So just to kind of indulge and for resident teaching, we said, let's try distraction, and we got a reduction view on retraction. You can see the traction being applied. The reduction looks reasonably good even in the lateral view. And then we put it in a K-wire, and again now it looks quite good on the anterior-posterior view. But then the moment we released the traction, there was a collapse again with displacement of the fragments. So we decided to fix this fracture, and we went ahead, opened up, removed that incarcerated bone, put in a plate, and got a stable reduction. So why are we talking about this? Because I think the fundamental goal of treatment for any distal radius fracture or any intra-articular fracture is articular congruency, to restore the anatomical alignment in terms of the length, inclination, and the tilt, to achieve and maintain a stable reduction with adequate fixation that will allow for early mobilization, and which in turn will allow for optimum function while minimizing complications. And when we talk about restoring anatomical reduction relationships when possible, we have to then take into consideration the three criteria, that is the length, the tilt, and the inclination. And that can be achieved through different modalities, right from close reduction and fixation to pinning and screws and plates, cast, fixators, and so on and so forth. What is important is that whatever modality we are using, we have to maintain the reduction until the fracture unites and prevent any late collapse. And for that, we need to understand the different fragments, and for which we need to have a good understanding of the anatomical, of the classification systems that are described in literature. So there are several classification systems that we are all aware of, right from eponymous classifications to those that have been recently described, and that includes the column classification. In our practice, we prefer to use the column classification simply because it is more practical and perhaps has the least inter and intra-observer variability in terms of identifying the fragments. So here is a fracture in three different views, and these arrows perhaps will help you correlate the different fragments quite consistently in the different views. So the column concept was described and propagated by Rickley and Regazzoni, and it forms the basis of what is called as a fragment-specific fixation in distal radius fractures, and has been expounded by different authors. Simplistically, there are three columns: the radial, the intermediate, and the ulnar column. Where it gets interesting is the subdivision of the columns. So the intermediate column is perhaps the most interesting aspect of the distal radius, where you have the dorsal wall, you have the volar rim, and you have the ulnar corner, which is again subdivided into dorsal and volar. And then you have the free intra-articular or incarcerated fragments with metaphyseal defects. And then, of course, the ulnar column, which involves ulnar fractures, which may be of the styloid or the articular surface or the head of the ulna. The concept is quite simple, wherein we aim at achieving a stable reduction of all columns and components. And it is advisable to start with the simplest technique and then advance these techniques as needed to address all fragments. So again, the principles for surgical treatment remain quite universally standard. Articular reduction can be achieved with percutaneous, arthroscopic, or open techniques. We attempt to restore all the parameters of the distal radius, and this can be achieved by different devices that have been described. For example, in the left upper corner of your screen, you have what is called as a tetrahedron variant of the distal radius, wherein there is only a fracture of the volar ulnar corner, and then this can very well be fixed with a plate that is specifically restricted to the ulnar corner of the distal radius. In this particular schematic diagram, you would now appreciate that there is a radial column fracture as well, which has been addressed by a separate plate on the styloid process aspect. A dorsal plate can be applied as required, and so on and so forth. So it's like building up a mechano and trying to address different fragments with different devices. Here is a case in point with a PA and a lateral view. You can appreciate the severe combination of the fragments. If you look very carefully at the posterior anterior view, we can see the ulnar column is absolutely intact, whereas the fracture is involving the radial column and the intermediate column. And then we would now also appreciate that there is a combination of the dorsal rim, and these are fractures which are best studied with CT scans to gain further insight into what the anatomy of the fracture is like. And the CT scan would then also reveal the central depressed articular fragment. And these are reduced, and you can now see the intermediate column is being fixed with a plate, but this plate is not adequate to fix the radial column, in which case we use a separate implant to fix the radial column and achieve a good reduction which is stable and is adequate to hold this fixation till union while restoring all the parameters of the distal radius. Here is another case in point, and to the uninitiated eye, this may seem quite benign unless and until you pay attention to that little fragment in the ulnar corner, and that is the one that is going to play truant. So there is a fracture involving the dorsal as the volar cortices of the distal radius, along with this dorsal fragment, and then it's quite intuitive that it's very difficult to get a fixation or stability of this fragment through a volar plate screw alone, because you risk an intra-articular penetration in the radiocarpal as well as a distal radioulnar joint. So this fragment is especially important because it not only forms a part of the DRUJ, but also the radiocarpal joint. So again, a volar plate was used, and through a separate dorsal incision, that fragment was buttressed to achieve stability and good reduction of the distal radius. What about approaches and anatomy for these fractures? So we are all well versed with the volar approach. This is the Orbe approach, which is kind of a modification or an extension of the standard Henry approach, wherein we go through the flexor carpi radialis subsheath, and then you would identify the flexor pollicis longus as well as the median nerve, put it out of harm's way. And this stage, you would identify the pronator quadratus, which is coming into view right there. The distal aspect of the pronator quadratus is wherein what is called as the watershed line. And then you have the entire distal radius from radial to lateral right in front of you. We like to elevate the pronator quadratus by sharp dissection in a reverse L-shaped manner. And then using alternate sharp and blunt dissection, we elevate the pronator quadratus all the way from radial to ulnar so as to be able to suture it back to cover any hardware or implant that you may be using. One of the very important steps in good exposure and reduction of distal radius fractures is also the release of the brachioradialis that you need to do from time to time when you have these radial styloid fragments that are irreducible or maybe playing truant or difficult for reduction. So here is the approach wherein you have the entire distal radius in front of you for whatever surgery you would want to do. Here is a small trick that I would like to share with you all. Once you have reduced the once you have exposed the entire distal radius, there is a small cuff of tissue that you may want to elevate so that you can place your plate as far distal all the way up to the rim of the distal radius. And we'll just see that in a little bit in a video. Here is a video wherein you can see the importance of releasing the brachioradialis. This is a fracture wherein the radial styloid fragment was not being reduced. You can see the deforming forces of the brachioradialis onto the fragment there. And then as you dissect and as you elevate the tissue, this is the flap being elevated all the way from radial to ulnar. While we are preserving the distal insertion of the radiocarpal ligaments, it's very important not to destabilize the radiocarpal joint. And once you elevate that flap all the way from radial to ulnar, we'll see that in a subsequent slide how that helps in placing the plate. You would elevate that flap and protect it and keep it out of harm's way. Another approach is the volar ulnar approach, which is especially important for your tetrahedron variant or the volar ulnar corner. This is between the palmaris longus and the flexor carpi ulnaris. And then in this particular approach, you just go between the ulnar neurovascular bundle and the palmaris longus, which is put out of harm's way. And then you can put in your plate and your implant to fix the tetrahedron variant. I'm just going to skip through this video in the interest of time. We have to understand the design of the plate, which is very important because it is very pertinent to understand the different plate designs which are meant for different fractures. We always talk about the watershed line. And here are two very commonly used implant designs. Here is your variable angle rim plate, and this is a standard plate. Why is this important is because, as I showed you in the previous video, if you're using this particular plate, it's not going to address this fragment or the distal fragment for the fracture which is distal to the watershed line. And should you cross the fracture fragment or the fracture line with this plate, the plate is going to be proud and cause flexor tendon irritation besides loss of fixation. And in this particular case, it is important to get your plate all the way as far as distal as possible. The hypodermic needle is where your radiocarpal joint is. And now you can see this plate that hugs the volar rim and gives you adequate fixation with your brachioradialis release as well as release of the flap that we just saw some time ago. There are different types of plates. I won't belabor too much on this because I'm sure that every one of you must be very well versed. Every conference you go to, you would find different designs and newer designs coming up. What is extremely important to know is that it is not the plate, but it is a surgeon that is important in getting the reduction and fixing it and maintaining it. There are indications of volar plating, contraindications that have been described in literature. What is very important, perhaps, that I would like to share is also to understand the role of your distal oblique band of the introitious membrane in maintaining DRUJ stability. A lot of times you find that if the proximal fragment remains medialized, instead of lateralizing the distal, the proximal fragment, the oblique band remains lax, and that would still lead to DRUJ instability. So besides fixing the distal radius, it is important to also take into consideration the stability of the DRUJ in every distal radius fracture that we treat. And that raises the question of the case of the ulnar styloid fracture. Now, a lot of time, there is so much of debate about whether we need to fix the ulnar styloid fracture or not. To my mind, they do not always require fixation, especially if the DRUJ is stable in supination. However, if it is unstable in supination as well as in neutral and pronation, if you compare it to the other side, and if you have restored all the parameters of the distal radius, then it may very well be pertinent that the instability is because of the fracture and the THCC that is attached to the base of that particular fragment. Here's a case in point wherein we have fixed the distal radius fracture, and you can see with rotation the styloid fracture is falling off the distal ulna. Obviously, this is something that will require fixation. Here is a video to show how unstable the DRUJ is. We like to test it in all rotations. And then once we have established that the DRUJ is unstable, despite good fixation of the distal radius, we want to fix it. There are several ways to skin a cat. You can fix it with hook plates, with TBW, you can fix it with a suture anchor as was done here, or you can even fix it with headless compression screw and so on and so forth. However, distal radius fractures, although being so common, everyone does it in every step of their career, there are certain caveats that we need to remember and we need to identify. And one of the most important aspects is the problem related with intra-articular hardware, inadequate fixation, and this usually happens when we fail to recognize the type of fracture and the implant design. Tendon irritation and ruptures are again very common, both flexors and extensors, malunions and infections, which are usually rare. Here is a case in point where you can see the tendon rupture because of a proud plate and a proud screw. Implants that are within the joints are not very uncommon. One easy way to determine whether your screws are proud on the dorsal aspect is to take what is called as a Hoya or the Dernick view and make sure that despite these x-rays looking good, the Hoya view will show that these screws are proud and they need to be revised. Here is a case in point wherein the distal radius fracture was fixed in this particular manner, and then it gives adequate stability. There are radiological nuances such as the teardrop and the anterior-posterior diameter of the distal radius. And if that is increased, this is a disaster waiting to happen in terms of displacement at a later time. And this is exactly what happened with our case when we started off. If you look very carefully at these measurements, we now realize why this fracture displaced at a later date. Complications of volar plates cannot be overemphasized. They have been described in literature, left, right, center, but we tend to neglect them. And I think one of the most important aspects that we neglect is the proud hardware that may cause tendon irritation. So Soong's grade has been used to identify the risk that may be imminent for tendon ruptures. Please bear that in mind. Do not use plates that are meant for dorsal to be used on the dorsal aspect on the volar side, on the volar aspect for the dorsal side, so on. So these are very common things and common mistakes that we see in clinical practice. Proud screws as well. And then there are caveats that have been published to avoid extensive tendon complications, which have been described. And again, these are just images to kind of not to mock our colleagues, but to kind of just help us understand that these are things which can be avoided and save our patients from disastrous outcomes. Very quickly, dorsal fixation of the distal radius fractures is something that a lot of young orthopedic surgeons shy away from, thinking that these are fraught with complications. However, in a properly selected patient with proper indications, these are very rewarding techniques. And we use a middle longitudinal incision. We go through the third extensor compartment subsheath where we identify and evacuate the hematoma. We elevate the third and the fourth extensor compartments sharply off the capsule, incise the capsule if required, and then reduce and fix. And often bone grafting may be required. It's a very quick video for you to indulge me while we very quickly go through this. This is a dorsal radius fracture. You can see the combination that is present, and we use a middle. This is one surgery where soft tissue handling, soft tissue respect is extremely important. We elevate the flaps as full thickness skin flaps on either side of the incision, try and preserve the dorsal veins to the best of our ability, maximum possible preservation of the dorsal veins. And then as we go from superficial to deep, we identify the third extensor compartment, evacuate the hematoma, protect the tendon, keep it out of harm's way. Very sharply, we elevate the extensor compartments on either side of the third extensor compartment subperiosteally so as to expose the distal radius, release the brachioradialis if need be. And then a lot of times we find that there is a small window at the fracture site that can be used to elevate any incarcerated or impacted fragments using a freer elevator, just like so. Get in your bone graft whenever required to provide subchondral support, because a lot of times your implants are going to be used only in the buttress mode. So we have a very low threshold for using a bone graft, and then you bring in your implants. A lot of times you need different plates for the radial or the intermediate fragment, and then you can see that this is used in a buttress mode to reduce. Once your reduction has been achieved, you can then augment your fixation as required with a couple of plates more. The distal osteoarticular fragments that remain attached to the capsule can be sutured with non-absorbable braided suture, and these sutures can be passed through the plate and secured to provide additional fixation and stability to these particular fragments. We close the incision with covering the plates very carefully. And to date, to be very honest, we haven't had the necessity to remove any hardware for distal radius fractures treated from the dorsal approach. Very well covered plates and soft tissue handling that is appropriate will minimize the risk of tendon attrition and any complication that may be associated with the treatment of these fractures. So very quickly, in summary, we all know that distal radius fractures are very common. They will continue to challenge us in every walk of life and practice. We need to understand that our failures of fixation are what will help us improve our future successes. We need to very carefully assess the fractures to determine the optimal fixation, as well as understand and appreciate that each fracture is unique and should be treated as such, while remembering that it is a surgeon and his or her understanding of the fracture and how to fix it and not the hardware that will account for the outcome for our patients. So with that, I thank you for your attention. And if any questions, I'll be more than happy to answer them. Thank you very much.
Thank you so much, Professor Abhijit, for this very comprehensive presentation. And thank you for being for the second time with us. It's an honor for us, sir.
It's an honor. Thank you.
If we have any questions to Professor Abhijit. I think your presentation, sir, summarized all about the distal radial fractures. It was a very comprehensive presentation. Thank you so much, sir.
Thank you very much. Thank you.
Thank you, sir. Okay, sir. We can move to the next speaker, sir. The next speaker will be Professor Ashok Javashkar, will speak about a case of iatrogenic elbow instability. Thank you so much for being with us, sir.
Can you see my screen?
Not yet, sir.
Recording stopped. Recording in progress.
Can you see me?
Not yet, sir.
No, it says my screen sharing has been paused. I do not know why.
Dr. Meena?
Because I'm not able to resume share.
Any technical problem with the Professor Ashok?
Professor, we are seeing that you have started screen sharing, but it is not clear.
It's not sharing. Yes, sir. Yes, sir.
It's started
to appear now.
Yes.
Can you make full screen, sir, please? Any technical problem, sir? Dr. Ashok? Can you hear me? Dr. Ashok, can you hear me?
We can see your presentation, a case of iatrogenic elbow instability.
Yes, but I think he is not hearing me. Professor Ashok?
Yeah, I think he is right now.
Dr. Ashok?
Please go back to a full presentation, PowerPoint presentation. It has gone to slide view.
I think he's not hearing us. Dr. Ashok? I think he's not with us now. I think he has a technical problem, sir. Okay, we can move to the last speaker. Tell Professor Ashok join again. Dr. Terence Jose Giroma will speak about acute compartment syndrome with a special focus on a nerve recovery in children.
Thank you for this wonderful opportunity.
Thank you, sir. Thank you, sir. Yes, sir. We can see your presentation, sir.
I request all of you to call me Terence. I am Terence. That's it. being the last presenter, this is something a different concept which most of us are scared about, the nerve injuries. The moment we hear about nerve, we are a bit scared, as equal to the vascular injury. So these are my disclosures. Overall, we know that compartment syndromes or even Volkmann ischemic contractures, it's an orthopedic emergency. We know that it's an emergency. And we also been taught that these emergencies should be immediately should be addressed because it might affect the limb and subsequent damages. Most common in upper limb is supracondylar humerus and femoral fractures in lower limb. So today the focus is on the can you see this pictures and videos?
Yes, we can see it, sir.
The pictures, can you see the pictures?
Yeah, I can see the picture. No, I can see the slides, but the pictures are not obvious on the.
Okay, just give me
on the left side.
Just give me a second. Just give me a second.
Okay.
Second. Should I stop and start again?
Okay, sir, no problem.
Sorry for the inconvenience, sir.
No problem at all, sir. No problem at all.
Technical issues are happening around, so. Can you see the pictures now?
Yes, sir. We can see it.
Okay. Yeah. Perfect. So the picture, can you see the picture now?
Yes.
Thank you so much. Sorry for that.
Thank you, sir.
The problem is, we see in upper limb in children, this is what exactly we see in an emergency room or in any emergency settings. Patients might come with some fractures, with pain and swelling and no motor deficit. Say, for example, this is a patient who came to us 6 days after the injury because he was properly not addressed or inadequately treated by the referral physician. Then what happens is we need to go on, do the compartment release, even though it is 6 days old injury, especially in children. And at the same time, we did neuralize both the nerves, the median and the radial nerve. So we expected by 6 days of the injury, we know that the wound might dehisce, and exactly what has happened. The wounds also started dehiscing. But at the same time, the hand, which was completely paralyzed, started improving. So this was the range of movement we could get initially. But the wound also started healing. You could see a combined claw hand in this patient, which went into complete recovery of motor and sensory, approximately around 10 to 13 months for the sensory, and for the 7.5 months, the motor. So this was the final picture of the moment where the wound healed. And so you can see the movements there, the X-ray also united. So we always know that a 6 days old compartment syndrome, people and science article says that you should wait not to intervene. But interestingly, this is not the scenario which happens in children. That is the reason we also need to have the change or the paradigm change in understanding the compartment syndrome, especially in children following a fracture or following any other injury. Most common is the distal supracondylar fractures, which might cause a transient sort of compartment syndrome, and a pure brachial artery injury with fracture can also cause a compartment syndrome. So in a fracture alone with compartment syndrome, say this patient could not move her fingers because of an impending compartment syndrome. The family is also helping her. ultimately, what we could do is we fixed the fracture, the pulse came back, and the child also did well with good range of movement. So these are all certain fractures which you need to fix them to get a good range of motion. Even at the time of injury, there's a huge swelling and no movement, or a pulseless pink hand. We understand as an orthopedic surgeon that in 4 hours' time, the muscle go into necrosis. But 8 hours' time, the nerve goes into permanent damage. And we also know that if we could decompress early, this prevents paralysis and contracture. How early? So now, I told you in the previous slide, we could do a decompression in a 6 days old compartment syndrome in children. But literature says that if you do more than 8 hours delay, you might land up in septicemia or you might land up in contractures, and you don't have any proper idea whether you should go or not to go. And this was the reason we had a thought. Thought is something like 6 days of presentation is not exactly 6 days. Why? Because we may not know when the compartment syndrome started. Injury might have happened somewhere 6 days back. Slowly it have gone to the compartment, and compartment syndrome could have started little later. It need not be 6 days. So any number of days patients present to us, we do not know when exactly the compartment syndrome started, when the compartment started to rise, and when this patient developed paralysis or a partial weakness. That is the reason we also need not believe that a delayed fasciotomy will cause infection or sepsis, will have a poor outcome, as it was believed in the past. And moreover, we also have that there is a possibility of collateral circulation, which can also help us to get good circulation. The entire scenario of our case series was based on one article that is from Sundarraj from JBGS. They found almost in 196 patients, 55% had forearm fractures and 11 had supracondylar fractures. They retrospectively analyzed that all those patients who developed Oakman ischemic contractures did not have any surgery. So 196 patients did not have any surgery. Interestingly, they found the sensory recovery was possible in hand at 12 months, in forearm at 6 months. So no surgery, no intervention. They found that sensory recovery is possible even in this patient, meaning to say that nerve can regenerate and recover in the course of time. Also, we know that from literature, the muscle, even the smallest number of muscle, if it survives, it can regenerate even as late as 76 weeks of injury. So none of the authors or none of the compartment syndrome so-called specialists, they did not look into this aspect. That is the reason we found, and also you want to emphasize to the world that timing is not the indication for a compartment syndrome release. Why? Because we do not know when the compartment started, and without treatment, there is a possibility of sensory recovery. Why can't we go ahead and do to get motor recovery, even though the wound dehiscence may be a problem, as I've shown in one of the slides, initial slides there. So this is again another patient who had a injury who came to us 24 to 48 hours after the injury, good capillary refill, but the hand movement was not there. We know that there is a problem with the artery. We could do the primary anastomosis in this patient. The brachial artery was injured. We could do the primary anastomosis. The median nerve was bad. And we also know that because of 48 hours of injury, we know that the outcome is not good. The wound won't be so good because we repaired the artery there. And this was the flickering of movement which you see initially. Later, 1.5 months, what we could see is this patient slowly had a combined median and ulnar nerve claw hand. This was slowly recovering in this patient. You could see still he has a wound problem which healed ultimately, and there's a claw hand there and slowly improvement of FDS. But at 5 months' time, the recovery was complete. This patient could do a complete range of movement, though the wound also healed well. But the problem of wound, dehiscence or problem of wound will not be there, especially in children, if you have that fear in this patient. So meaning to say that we intervene even if it was delayed, this patient is going to do well. Another patient of a fracture displaced at 7-year-old girl had this fracture, and then we also had initially no movement there, have got complete movement after we fixed the fracture, and this patient did well. So one patient we had 2 weeks of presentation. So this is the patient where a boy who was completely crying without no movement. You can see the limb completely swollen, a sort of complete established called compartment syndrome. And what exactly was that? He was always crying, could have not any more motor movement, no sensory movement was also there. This was the fracture fixation. What we found was, once we do a complete debridement and we did decompress the compartments, we found the ulnar nerve was partially fixed with a Kirschner wire, On the contrary, the crushing wire was also passing through the supracondylar humerus and injuring the radial and the median nerve. So all these three nerves were injured, and the compartment got also infected. So we could do completely thorough debridement, could change the orientation of crushing wire, and we know that this wound is not going to be good. Though it looks good, it will not be good in post-operative time. So we expected the wound to be little superficial necrosis. Again, we put them on simulation. We healed well. The ulnar nerve started to improving. The median nerve also started to improving. We put them on therapy there. And then finally, this patient had this range of movement. Again, a 5-year-old boy who had a compartment syndrome. We fixed the fracture, and then he had a slowly recovering ulnar nerve, which also recovered in the course of time. Another interesting is the 7-year-old boy who had this brachial artery injury. There you can see the brachial artery injury is completely there, and the median nerve was also injured there. We could repair, fix, but immediately what happened is this patient did not have the median nerve recovery. And this is the video of the time 6 weeks you will see, and at 6 weeks, this is the range of movement of this child. And this patient also had some skin grafting done by other plastic surgeon in the elbow. Ultimately, what happens, this is the presentation at 12 weeks. Again, he had a high median nerve palsy. The median nerve did not recover. Do not worry about this, because we know that compartment syndrome will take some time for the motor to recover. And this was a 10 years follow-up. This patient had completely recovered the median nerve, and this patient had good FPL function and other function. You can see the scar there, just still lying there. Just came for a scar revision. I said we'll do somewhere in the school holidays. So such is the great potential of the nerve, especially if we see compartment syndrome, which has the potential for the nerve to regenerate the neuromuscular junction and get the muscle working. So don't think that muscle will not regenerate, especially in children of this kind. So what made us is that we have published this entire series as acute compartment syndrome, especially with a special focus on nerve surgery. This one published in one of the BMG journals. So what we found in our study was that the average time to surgery was approximately 44 hours. So many say that more than 8 hours don't operate. No, we don't follow that because we do not know when the compartment syndrome started. So in our series of 24 patients, we found that nothing contributed much to the outcome, especially the gender and all these things. But if they have supracondylar humerus fracture with artery injury or delay of 24 hours, they may have a bad outcome if they don't properly treat. And all those patients had radial, median, and ulnar nerve injury, and they recovered approximately from 6 to 8.5 months. Sensor recovery, as you know, that it was completely recovered in almost 10 to 13 months in our series. So to conclude, there is a possibility of motor and sensory recovery in patients with acute compartment syndrome, irrespective of time of delay in presentation. You go and intervene, give the nerves to allow to breathe, get the muscle to work, and definitely you're going to get a good function, especially in children. The motor and the nerve fibers can regenerate after the ischemic sequelae is being taken care of. Thank you so much for this wonderful opportunity. I thank our Indian contingent and also the Egyptian contingent for this wonderful opportunity of educational forum. Thank you so much. And I being the last speaker, I think so patient enough to be here, especially at this time. Thank you so much.
Thank you so much, Dr. Terence, for this very interesting case presentation. And thank you so much for being patient with us. So you are the last speaker, but as we said, the best is the last. Thank you so much, sir. Thank you so much, sir. If we have any questions to Dr. Terence? Okay, I think we have no questions, sir. Finally, I would like to thank all our Indian colleagues and our Indian professors and speakers for joining us in this very fruitful scientific webinar. Your participation makes us very honorable participation. Thank you so much for being all with us in this very fruitful webinar. Thank you so much, sir.
Thank you.
Now we will thank you. Thank you so much. Thank you, sir. Thank you so much, sir. And to all our colleagues, thank you so much, sir. Have a nice time. Thank you so much, sir. Now we will move. If you would like to stay with us, we still have 4 hours in the webinar.
It's almost 12 o'clock in the midnight, so I probably
we will finish at 2 a.m., sir. 2 a.m. Cairo local time. Thank you so much, sir. Now we will move to a very important session, which is the UK experience in trauma. And we have many eminent speakers from UK. Our first speaker will be my dear friend, Dr. Zuhair Nawaz from Brimley Park Hospital. Dr. Nawaz, how are you, sir?
Good, thank you. Thank you very much.
Very happy to see you again, sir.
Hi, how are you?
How are you? Thank you so much. Professor Nawaz will speak about fixation principles.
Okay. Bear with me. I'm hoping you can all see my screen.
Yes, sir.
Perfect. Okay. All right. Welcome, everyone. I'm going to speak to you about fracture fixation today. So it's the start of the session. I've given this talk in different varied forms before, but it's always seems to be well received. And the most important thing really is that failures are just as instructive as cases that we do really well. And that was a famous quote from one of the ex-president's wives. So this is a classic case that came in my clinic that needed managing. This is obviously a fracture that was managed elsewhere, and the fracture fixation has failed. So this is a regular case that I present because it has so many issues that people need to understand and explain in their mind how they go ahead with that fixation. So we're going to start with just simple, basic fixation principles. So there are always different modes of fixation. We've all done AO principles and we understand what those principles are. But the one that most people find difficult to understand is bridging fixation, which is classically the distal femur. So we always talk about the fracture and how we get it to heal. So we talk about the fracture personality, the soft tissues themselves. When we fix it, getting the alignment, we talk about the host and we talk about the metalwork. So the fracture personality is really important, looking at the type of fracture, whether it's comminuted, whether it's high energy, which part of the bone involves, whether it's diaphyseal, metaphyseal, is really important. The soft tissue envelope, we all know, is incredibly important. The alignment, when we fix it with the appropriate metalwork, is really important. And the host, unfortunately, in a trauma situation, is very rarely we can do anything about it, except for the fact that the patient is the way they are, whether they're diabetic, on steroids, etc. So the reason this lecture's first is to just start with some basic principles, and my colleagues will then go on to talk about other issues with trauma and their cases. But essentially, these are the three main laws that people talk about. So we talk about Wolff's Law and we talk about Perrin's strain theory. These are the two main laws, really. So Wolff's Law is physiological response to normal bone is dependent on the mechanical environment. And Perrin's strain theory also has a similar theory, which is the strain will lead to a physiological response to the broken bone. And that's, again, affected by the mechanical environment. So these two laws and the Frost concept all basically say, however you manage the bone, the mechanical environment you put the bone after you fixed it will determine how the bone heals. And that's the most important thing. So the bit from our point of view as orthopedic surgeons is, how do we fix the bone appropriately so it heals? So this concept has been thrown around, is now well established, and we call this the bone healing organ. So the hematoma that forms after the fracture is critical. And managing that hematoma, managing that area where the injury has happened, is paramount for the fracture to heal. So that's why we realize that non-open fractures are less likely to heal well and are more likely to go into non-union. That hematoma that forms at the fracture is sitting on the roadside or is sitting outside the body. It's no longer there. And then you debride and you open up the soft tissues, and therefore that bone healing organ is significantly damaged. And one of the things that we know is that the strain environment is one of the most important things in aiding the bone healing organ, i.e. getting the fracture to heal. It's really important. The strain is the most important thing here. So I'm just going to go through some basic concepts. So we're going to talk about load bearing versus load sharing. So load bearing essentially means that when you put a plate onto a bone, some of the weight is going through the bone and some of the weight is going through the plate. Now that is dependent on the fracture pattern. So the first two scenarios you can see that we've got a straight transverse fracture. We've used a compression mode, most likely, and the majority of the load is going through the bone and the plate is doing very little. In the second scenario, we've got an axially unstable fracture. So we've got an oblique line. And so therefore the bone is trying to shear off. And therefore the plate is having to work harder to hold the fracture together. And in this scenario, once again, we have bone load sharing. So some of the bone taking the load, but the plate taking more of the load. In a scenario where we have a defect or we have comminution and we've got a gap, essentially the bone is not in continuity or not in contact, at that point, the plate is taking all the load. And in that scenario, we talk about a load-bearing construct. So that first X-ray I showed you where we had a comminuted section of femur spanned across, that plate is completely load-bearing. So none of the load is going through the plate. Through the bone. So the question for us is, when we're trying to fix a bone, we want to decide how we're going to fix that bone and how much force we're going to put through the bone and how much we want to put through the plate. And depending on those forces will determine how we fix that fracture. So that determinant will then decide how the bone's going to heal. Is it going to be absolute or relative stability? Have we got perfect anatomical reduction? Have we lagged across the fracture? Have we done an indirect reduction? Have we restored the angular and rotational deformity? And what type of implant have we used? These will all determine how the bone essentially heals. And therefore, each device will require a different method. So if you're using an IM rod, or if you're using a bridging plate, or you're using an X-fix plate, then the stability and what you need to achieve to get the fracture heal are very different. So strain is the most important thing here. So strain is what we call change in length, is length over changing length. So therefore, from our point of view, what we're trying to do is make sure that the movement of the fracture site is sufficient enough for bone healing to occur, whereas not so much that we get a non-union or we get a fibrous union. So these are the points that we talk about A, B, and C. So A is where we have such a rigid fixation, there is no bone formation. So that's typically where we talk about putting too many screws into a plate. We make it so stiff and therefore the bone doesn't move and therefore there is no healing response at all. Whereas we get to the other end where we get to level C, where we have so much movement that we've essentially got a non-union or we've got fibrous union because the bone ends are so mobile, there's so much movement in the fracture site, no healing can occur, and you get that classical significant amount of callus but very little healing. So you want this ideal scenario, which is around the point of B, which is about 2% of strain, so that's 2% change in length, where essentially there's enough movement for the bone to heal, whereas so the bone will then start to regenerate and we'll get our classic callus formation and healing. So this is it zoomed in, so you can see, I don't know if you can see my arrow, but this is the point at 2%, where we have a point where essentially goes from too much stiffness to just about enough where Wolff's law starts to apply and the bone starts to heal. Okay, and in that process, we all talk about relative stability, absolute stability. But the key here is trying to get that stiffness just in the right position so that we get that healing process going. So how can we get that strain in the right position? So we talked about these before. So we talked about fracture personality. So it's understanding the fracture itself. Is it just a simple, straightforward fracture? Is it an open fracture? Is it comminuted? Is it segmental? These are really important. What's the soft tissue like? Obviously, if it's high energy, has significant periosteal stripping, then from our point of view, what we're looking at is trying to minimize further damage to the area, the metal device that we're going to use to fix the fracture, and then to try and get it aligned as best as we can. So in this scenario, again, we look at this and we look at this plate. So this is what we call a dynamic condylar screw plate. If you've not seen this, this is a non-locking device with a screw at the bottom that is spanning a segmental fracture. So this is a load sharing device. So some of the load is going through the plate and some of it's going through the bone, because these non-locking screws mean that the plate and the screws are moving and therefore you don't have a rigid construct. So some people would say this is a bridging concept, and what we're going to do is now discuss that. So this is what we call by bridging mode. So bridging mode is an internal X-fix. We all have heard that term. So it's like putting an external fixator on with pins. So each screw is a pin, and those pins are fixed to the plate with the locking threads. Now, from our perspective, each one of these scenarios, the plate has been put on in exactly the same way, but the strain environment for each of these fractures is significantly different. i.e. the amount of force going across the plate. So you can imagine the force or the movement in the first fracture compared to the fourth fracture are significantly different, because there is far more movement in the fracture number 4 because the bone is comminuted and segmented versus a straight transverse fracture. So in this scenario, as a surgeon, we have to accept that we can't just simply make the bone look straight. We've also got to realize that if we do the same construct for fracture 1 and fracture 4, there is a chance that fracture number 1 will go into non-union because there's so little movement within that construct. And with fracture number 4, we need to accept that there is a lot more movement in that plate and in that fracture, and therefore we may need to put some extra screws in to bring that strain environment down so we get healing. So the bridging concept is really important. So this is the idea that the load goes through the screw, through the bone, through the screw, across the plate, and then back through the screw and back out, exactly like an X-fix. This can only really be achieved with a non-locking plate. With a locking plate. If you have a non-locking plate, that is in effect the same as an external fixator, but loosening the nuts around the pins. In effect, you have a loose external fixator. At that point, the pins are moving, the bar is moving, and therefore the bone will load, and therefore you're more likely to get a higher strain environment and more likely to get a non-union or fibrous union. Whereas with the locking plate, the idea being because it locks in, we're trying to tighten these grub nuts around the external fixator bar, which gives us a stability. So when we walk or take load through the bone, it goes through the screws, along the plate, and then back down and bypasses the fracture, just like a bridge. So actually, there's a difference. So this plate is a non-locking plate across a wrist. So this is in spanning mode. And here on the left, we've got a diagrammatic picture of a locking plate in bridging mode. So we can see that the forces going through this plate go through the screws, through the plate, bypass the fracture, and then back up. So the movement generated at the fracture site is not of the fracture itself moving because we've created such a rigid structure, but the movement of the plate. The plate is what's generating the movement. As we load, the plate will bend or have a bit of micro motion. In a spanning plate, we've got the fracture moving, we've got the bone moving, and we've got a relatively non-rigid plate. And so there's forces going through the bone and the plate at the same time. So this is shared forces across the fracture. So this is where we talk about a non-locking plate being not length stable. So when you axially load a plate, the non-locking screws are likely to pull out sequentially, and there is movement between the screw head and the holes in the plate. Whereas in a locking plate, those screws are engaged into the plate, and therefore for the plate to fail or for the fracture to load, all screws have to fail, which is why a non-locking plate is not axially stable, i.e. if you load it, you will load the bone. The other part of it is the working length. So how much of the plate is doing the work? So I've again got two diagrams here. So you can put lots of screws very close to the fracture, or you can put the screws further apart, and we've got a part of the plate that's doing the work. Obviously, the more the forces across that plate, the more the movement there is and the more the strain there is. So if you've got a very comminuted fracture, ideally you want to put the screws closest to the fracture to reduce the strain environment, whilst making sure that your working length is appropriate. You do not want too stiff a construct. Whereas if you have a very straightforward transverse fracture, you actually want the screws to go further apart because you want a longer working length. You want that plate to do a bit more bending, because if you put those screws too close to that fracture, they'll be too stiff and you'll get a non-union. So again, it's that experience that comes with understanding what the strain environment is and where to put those screws to achieve that strain environment. This is the final thing. Again, it's a very similar concept. We talk about the X-fixes. So it is important always to try and span the whole bone. If we look at X-fix constructs, I've got two constructs here, one on the left and one in the middle. And you can see that if you space the pins out, high up in the tibia, wide apart, low down in the tibia, wide apart, that is a much more stable construct mechanically than having two pins very close together, like in the middle picture with a short bar. the longer the plate, the more stability it provides to the entire bone and the better the working length of the plate. Okay, so again, that's why when we start talking about periprosthetic fractures, the majority of us will always say that the best thing to do is to span the entire bone from top to bottom, and that provides this construct on the left. Locking screws into the locking plate, far apart, allows to share the strain, share the movement, share the load through a longer bit of metal, which will obviously help with your strain environment. So the last thing to mention is fatigue failure. So every plate will eventually fail. So that's cyclical loading. So in fractures, we have a race between healing and the plate failing. And therefore, there will come a point where the plate eventually fails. In this scenario, what we're trying to do is to reduce the amount of load going through the plate so that we get as many cycles as possible. So this is a classic example of what we call an SN curve. This is where we talk about the number of cycles and we talk about the load being put through it. So on your y-axis, we have stress, and on the x-axis, we have number of cycles. So if we look at that first picture that I showed you of the femur, where the plate was in spanning mode, non-locking mode, the amount of force going through that plate is significant. Therefore, we're at this point here, well above the first little star. We have a significant amount of load going through the plate, and therefore the number of cycles we can achieve is not many. Okay, whereas if we look at the big star and we can reduce the amount of force going across the plate, and we're in that zone where the big star is, then actually the number of cycles we've got for that plate to survive before it fails is more. So the idea of moving the amount of stress across the plate down to from the little star to the big star is to get more cycles and therefore giving our bone more time to heal. So we want a lower stress across the plate, so therefore we're as close to the endurance limits, we've got number of cycles as well. The last thing to mention, is off-axis fixation. So we all know, we'll use the DHS. So the DHS is a great simple device which works really well for an intratrochanteric fracture. But the idea is that it's got a lever arm, which is why we don't use DHSs normally in a subtrochanteric fracture, because in a subtrochanteric fracture, the fracture forces are not in line with the DHS screw, but they're a rotational force. So as you load, the proximal femur wants to go to varus, and therefore you've got a pivot point. So you've got a lever arm, and you want to try and reduce that lever arm, which is why we say you need to put a nail down a subtrochanteric fracture, ideally, because you shorten that lever arm. The nail is within the intramedullary bone rather than on the lateral aspect, and therefore it's better at resisting rotation. That's exactly the same with plating the femur. If we look at the mechanical axis of a femur, typically it's ignore the one on the right, on the left, but on the right, the typical mechanical axis goes through the center of the knee or slightly through the medial compartment. Therefore, actually, the best place biomechanically to put a plate on a femur is medially, but obviously we can't do that due to the neurovascular structures, and therefore the plate typically ends up on the lateral side, which means it's now an off-axis fixation. It's not on the weight-bearing axis of the bone. So that's why the plate starts to bend, because we're loading it off-axis. That's why the screws are so important, to allow us to position those forces and allow us that bone to heal. So in summary, when we're looking at bridging mode, it's really important to think about the strain environment, what mode of fixation you're using, consider your working length, always think about on-axis fixation if you can. So in the femur, that's obviously difficult on the medial side. However, if you have a very medial side, if you have a very comminuted fracture, always consider potentially putting on a double plate. So you'll see lots of papers now about plating the medial side. That adds further fixation. And then always think about your stress strain curve and cycles to failure. Thank you very much.
Thank you so much, Dr. Zohair Nawaz, for this very interesting talk about fixation principles. Thank you so much, and hoping to see you again in CCOT, sir.
Okay.
Thank you so much, sir. Thank you so much, sir.
Professor.
Thank you, sir. If we have any questions to Professor Nawaz? I think you have mentioned all the aspects regarding the fixation principles, sir. It was a very comprehensive presentation, sir. Thank you so much. Our next speaker will be Dr. Azal Jalungar. He will speak about dual plate nail fixation for distal femur fracture. Dr. Azal, thank you so much for being with us, sir.
Good evening, Prof. Can you hear me?
Yes, sir. I can hear you.
And you can see me, Prof?
Yes, sir.
Perfect. Congratulations. You're holding a fantastic talk. I mean,
thank you so
wide
much.
Variety of speakers, good talks. And I admire your endurance because you're going on for another 3-4 hours.
For 12 hours, sir.
Yes, absolutely. I'm just going to try to share my screen and see if that works. Share screen, share. Can you see my screen now?
It's yes, we can see it now. Yes, sir.
Perfect. So I'm gonna carry on after Mr. Nawaz. We worked together, we're great colleagues, and it was a very comprehensive talk about types of fixation, types of healing, stress strain theory, modes of fixation, and how our plate fixations fail and how to get it right. So I'm not going to go into details about how to do things and what is the theory behind it, but we're just going to probably look at some few cases, interesting cases, to see there are different ways of managing it. So I work in Frimley and a few more hospitals. Frimley is a big trauma center, and when we get something small to very complex injuries. So I'm going to talk basically about femoral and distal femoral complex fractures. We know these are difficult fractures to sort out because more, especially in the UK, they are seen in more elderly population who've got very weak osteoporotic bones, and treating these surgically is quite a big challenge, purely because of the high morbidity and mortality associated with these cases. And we all agree, I don't think there's any debate whether we need to fix this early, because this definitely reduces the morbidity and the mortality and gives us a chance to get the patients moving early, and in turn reduce complications and aid the fracture and healing. Now, what we need to do recognize is these are complex fracture patterns. So these are not for the faint-hearted to go and venture into. So these do require some advanced skills. And if you're just getting into a consultant post and we're all very enthusiastic to fix them, I would suggest obviously try to get these done as dual consultant case with your senior colleagues. And the more experience you get, the better you get at planning these and managing these. So all that done, let's look at a few cases. Now, straight away you can see from the x-ray, this patient's got a below knee amputation. 88-year-old, and this is not elderly here. An 88-year-old is male, poorly controlled type 1 diabetic, fell down and had this fracture of the distal femur. He uses a prosthetic walk, so he's a walker. So obviously we got the diabetes under control first before we decided to do anything. So now looking at the x-rays, you can clearly see it's a smashed up distal femur, a lot of combination, not enough tibia, just a small part of tibia left. Now, one could argue you could leave this and see if we can get it better and see if we can get healed, if it heals. But I think it doesn't, you don't need to be rocket scientist to say this is a difficult fracture and it's probably not going to heal. And if it does, it's probably going to take a very long time and not heal in the right position. So we need to do something about it. Now, one could argue that we could plate it, nail it, or do all sorts of things. But that's where planning comes into action. Definitely get a CT scan of these distal femoral fractures, proximal tibial fractures, because it helps you, one, to decide what type of treatment, where your approach is going to be, how your soft tissue envelope is, and what's the best construct that you can go through. You can clearly see the distal femur has now buttonholed through the quadriceps. The lateral condyle is split. So fixing this with a plate, 1 or 2, will be difficult. Secondly, he's a below knee amputee, so you want to get this going as soon as possible. Can I fix it with a nail? I doubt it, because it's so distal that the distal screws will not hold it. Now, what are the general considerations looking at this case? He's an amputee, he's diabetic, very distal fracture, to nail or plate in isolation. We've discussed this. The quads are torn. The fracture is buttonholed through it. Very poor bone quality. So ideally, yes, in an ideal world, we'll try to plate it both laterally and medially, as Mr. Neeraj suggested, best constructed from the medial side, but very poor control. I don't want to put him go through two wounds and 2 plates, or at least 2 big plates. So I want to reduce the risks of infection. One could say, yeah, you could link the plate with a conventional intermedullary rod, but this would be a struggle and the result would be unpredictable. These fractures, the problem with these fractures are they often go into varus. So we need to take that into consideration to plan it, whether we can put a medial plate or intermedullary construct. So as we always do, we do an MDT of these complex difficult fractures, and then come with a plan, and always have more than one plan in your book. I'm not here to teach all you accomplished surgeons, experienced surgeons, how to skin a cat. There are different ways of skinning a cat. This is just my experience. The one thing I would suggest is always have a plan ABC and have an MDT discussion with your other colleagues. So what we did, we put this gentleman on the table, obviously, tried to reduce the fracture, difficult and not unpredictable. It was very predictable, really difficult to get back to length. It was about 2 or 3 centimeters short. So what I used is a distal femoral distractor. So you can clearly see the shank spins going through the distal femur and the proximal tibia. And with the distractor, we got it nicely in place. We got the fracture reduced, back to length, varus valgus angle corrected. The next step for slide number 4, the image number 4, you can see, I wanted to temporarily stabilize it with something. So you can see the guide wire, a K-wire, and a posterolateral. It's a posterolateral anti-glide plate. It's a 1/3 tubular plate as an anti-glide to temporarily hold the fracture. You can see I've got 1 screw holding on there and probably another screw going distally. But I've planned it such that I'm going to probably have to move that screw or change that screw later. But at least I'm temporarily fixing it with the anti-glide plate. And then use a guide wire, an intermedullary guide wire, to do a fibular strut graft. So use a guide wire, just ream over it, depending on the size of your graft. And then you get a nice fibular strut graft into as an intermedullary device in there without having any metal as an intermedullary device. Okay, now I'll tell you why fibular graft over an IM nail. 1, I already want to reduce the amount of metalwork in the knee. 2, it's a good graft. So if I want to put some distal screws, I know my screws are going to go through some good cortical bone through the graft. Now, if you slide on top, you can see the top left, we've got some graft in. You can see my proximal screw is stropping the graft. So I've changed that to 2 small screws, got the graft right up all the way across, and then Bob's my uncle. It's easy. Get the plate size measured, the length measured. You got a ruler there, measure the side of plate, and doesn't matter what type of locking plate you use. This is a Dipusynthes locking plate, VA locking plate. Important, as Mr. Neeraj says, get locking screws in. So you can see the distal screws are all locking screws. You got a posterolateral buttress plate. You got a fibular strut graft in, and then you get some nice proximal locking screws across the fracture. These are intraoperative pictures, and we look at the postoperative pictures. So quickly going through it, it was a lateral subvastus approach. It was short and difficult due to the amputation, poor bone quality. Used a distractor. It reduced the fracture. Put a 1/3 tubular plate, and then use a midline patellar tendon approach to put the fibular graft in, and then lock it with a lateral femoral plate. Important, these are big wounds. If you think healing will be skin infection or ooze or whatever is going to be a problem, I always recommend use a negative pressure vacuum dressing, a PICO dressing, especially if it's my complex fractures and my revisions. I've put this as a norm, and it's definitely improved healing. And I've had less problems with oozing wounds. This is an intraoperative picture of the spanning the fixator. You can see the position below knee amputee. Forget about the other one. I'm talking about the left side. There's a distractor, small proximal incision for the other plates, other screws. These are the immediate post-op X-rays. looks all right. There's a bit of a gap on the medial side. Not to worry. As long as you've got it nicely reduced, stabilized with a good fixing principles, it'll heal. And there are 6 months post-op. Patient's very happy. Back, we had to change his prosthesis, of course, because of the size of the plate. It's a bit thick, but that's fine. We got a new prosthesis and he's happy mobilizing, a below knee amputee. And he's now 90 years, a happy 90-year-old man. That's my first case. Now, second case, very similar. Again, 90-year-old, very young, but a few comorbidities. She's got cardiac failure. She's got some heart problems going on. She's on blood thinners. But this is even more distal fracture. It's an intra-articular smashed up fracture with loads of comminution. Now, obviously, this is even trickier to fix. I don't think a nail plate combination would work in this because of the distal nature and the intra-articular nature. And look at the osteoporotic bone. I mean, the bone is like butter. You don't even have to use a drill to put a screw. So all this in mind, we could spend hours trying to fix it and make our x-rays look good. But I always say, keep the patient in mind, not just the fracture, the whole patient. You want an effective, reasonably quick surgery to give the best outcome. Not in a surgery which is going to take you 8 hours and your x-rays look good and the patient dies. So again, planning is important, which is why we get a scan and you can see both sides are off, both condyles are off, intra-articular split, and displays fracture. Now, the good thing for her was she was an independently mobile lady. So I wanted to get her mobile as soon as possible. Now, if I plated or nailed or plated and nailed, it would be, I'm sure we all agree that this would most likely fail. And we will end up having a second surgery or third surgery. So this is where we decided, let's give her a distal femoral replacement. Now, it's I wouldn't say much easier surgery, but it's a more predictable surgery if you plan it properly, where we decide what's the length of the fragment, length of the fracture, well, length of the distal fragment you need to remove, and then just do a revision type of a tibia and do a distal femoral replacement. Now, few considerations is, of course, pre-op templating, absolutely vital. That's when you get the height right, the rotation right. That's when you know that we're not going to make the knee too lax or too tight. Key is to reduce the fracture fragments first. So I know these are difficult fractures, but try to cobble them up together just to get the height of your osteotomy right. And obviously, once you get the height right, which is normally measured from the medial femoral condyle, we then mark at the top end where the osteotomy is. We just make a midline mark to guide our rotation. We need to get the rotation of the distal femoral replacement right. Put a prophylactic cable on before reaming, especially with these osteoporotic bones, because you will propagate the fracture if you don't put a cable at the top. Now, it's very easy. The posterior neurovascular bundle is very close. Now, imagine if you made an osteotomy of the distal femur with sharp edges, and we're nicely reaming it without considering that there are some pumping pipelines behind the fracture. There's a very high chance that your fracture itself will cut through the bundle. So I always say, use a bone hook or whatever you have and a strong assistant so that he or she can lift the femur off, and you interpose the distal sharp end of the femur with any protective thing you have, either a gauze or a swab, whatever, so that it doesn't puncture the neurovascular bundle. Then the tibia is prepared like any attuned revision tibia with stem and sleeves. Again, templating is important. You want to know what the size of the stem and your sleeve is going to be. And the femur, again, there are various sizes. We won't go into details, but what we use is the DePuy LPS system, which gives us good options, starting from extra small to whatever size we want. And it's got 3 components. It's got a stem, which can be either cemented or uncemented, that goes into the femoral shaft. The length, again, you can determine what you want. It's got a segmental component, which gives you the height you want. It starts at around, I think 25 millimeters and goes up to 250 millimeters. And then there's a distal femoral replacement component, which goes from extra small to any size you want. So always, whenever you're doing these replacements, these complex endoprosthetic replacements, you have to consider the soft tissue envelope to guide your size. Now, what you don't want to put is a big distal femoral replacement in a tiny lady and then struggle to close the wound and have a very tight soft tissue envelope. So that's the key. Always consider soft tissue, no matter what type of surgery you're doing. It could be a finger surgery or a brutal hip or knee surgery. These are the post-op x-rays. You can see that I admit the patellas looks tiny bit high, but not too bad. We've got the rotation right, we've got the height right, and the patient was happy walking in a few days. Case number 3, again, we're looking at a distal femur fracture in a 59-year-old female, but look at the size of that female. She is 150 kilogram with a BMI of 60. Now, this was a challenge because obviously of her size as well. You can see that the distal femoral spike is very close to the joint line. So one could argue, yeah, you put double plates and you could do it. So again, you could decide what suits you, what you're comfortable with. But what we thought is to do a nail plate construct. The important key in this is to reduce the fracture as best as you can before trying to stabilize it. So you can see the Hagrove's retractors reducing the fracture, and then we've got the fracture reduced with a locking plate, and then used an conventional retrograde intramedullary nail with some cables around to further stabilize the fracture, the construct rather than the fracture. And we've put the proximal locking screw through the nail to have even a better implant construct. You can see this post-op x-rays. You can see the proximal screw that is actually going through the nail, and some unicortical screws, some cable plating, and locking screws distally. The advantage of this is that look at the size of the patient. She's never ever going to tolerate non-weight bearing. So we wanted to get her going. We fixed it, and we let her partial to total weight bear, essentially weight bear as pain allows, and she's done well. Probably my last case. This is the different end of the knee. Is this the distal proximal tibia fracture? Again, 50 younger patient, but very poor, unpredictable patient. Compliance was an issue because we knew she was a chronic smoker, 60 cigarettes a day. She also had some short-term memory loss. So I wasn't sure whether she will be compliant with non-weight bearing if we just put some plates across it. So you can appreciate the fracture. There's a proximal fibular fracture. There's a lateral tibial plateau fracture, which extends into the shaft distally. So she's got a combination of a tibial plateau as well as shaft fracture. As always, plan it, have a plan A, B, C. So what we did is we firstly approached the lateral side of the tibia with the lateral approach, temporarily put a lateral proximal tibial plate with some screws across, then put a buttress plate on the medial side through a small incision. Now, what that allowed me is to absolutely reduce the fracture posterior medially, and temporarily held it with a couple of screws through the buttress plate and wire. And once that was in, we were happy the fracture wasn't going to move. I just went through a suprapatellar approach, put a suprapatellar nail in, and then fixed the lateral plate with some locking and non-locking screws, and then finished off the nail and the medial blade. These are the post-op x-rays. Now, I think these are about 6 months down the line, or probably nearly a year. Patient's happy, mobilizing from day one, and has done well. A quick word about periprosthetic fractures. These can obviously, we all know if the implants are stable, we try to fix them. Just like that, it doesn't matter what type of what company you use, any good locking plate screw system will help reduce the fracture with cables or wires temporarily, and then get a distal and then get a locking plate with good amount of screws. Obviously, you don't want to fill the whole bone with metal, otherwise you will not have any potential for healing, but good enough construct to make sure that you've got a balance between absolute versus relative stability. Now, some fractures can't be fixed. Periprosthetic fractures with loose components, these can be these need some special expertise for revisions. This fracture on the left side, you can see it looks like a straightforward oblique, but it wasn't. The fracture was extending right into the femoral neck. The split was going up. So obviously this was appreciated when we did the revision. And I want to make sure that the GT fragment was stable. Otherwise, we risk dislocation and non-union. So we fixed it with a GTR claw plate. And the patient's was for mobilizing straight away with no restrictions. One last case is again a distal proximal femoral fracture with a loose stem. Preoperative planning. That's what I would stress. This is the most important case because you get the length right, the components right, and you reproduce what you've templated. Obviously, the proximal wire has cheese wired through the bone, but not a problem because this is a diaphyseal fix, a press fit diaphyseal fix fixation implant, and again, no issues post-op. So in summary, we always consider the patient in total as a whole rather than only the fracture. It's extremely important that you discuss these in a multidisciplinary setting, bounce off ideas of each other, and have more than one plan during the surgery, and also make sure if there's a complete fracture that you've got right post-operative setting and maybe an HDU and ITU setting as well. You pre-template it. Always consider all these factors. What's the pattern? What are the comorbidities? Should I fix it or replace it? How much time I'm going to take it in order to make the fracture look better versus is there something else I can do which will achieve the same or even better in a shorter time? And always respect the soft tissues and preserve the bone biology. We need to know our limitations. I know we are all skilled surgeons and we think I think I can do a spinal fracture fixation. I can do a peel-on ankle. I can do a shoulder fracture dislocation. It's not a question that I can do it, whether I can do it well, and do I do it enough? Do I have the skills? If you don't have it, do not feel shy to give it to someone else who does more of these and probably will do a better job than the others. Thank you very much.
Thank you so much, Mr. Azal, for this very interesting presentation. Thank you so much. It was a very comprehensive presentation, sir. Thank you so much, sir.
Thank you.
Thank you, sir. Our next speaker will be Professor Arshad Khalil. Professor Arshad, you are with us?
Sir?
Sir, how are you, sir?
I'm very well, Prof.
It's very nice to meet you again, sir.
Thank you very much.
Thank you so much for being with us, sir. Thank you so much. Professor Ashhab will speak about ankle instability, use of internal brace outcome. Very interesting topic, sir.
If you allow me to share the screen, I cannot share screen yet.
Dr. Azal, would you please stop sharing screen, sir?
You're having a marathon session, sir. This is awesome.
for more than 12 hours, sir.
I can just imagine. Okay, sir. So
how's Professor Iman?
He's mashallah, he's doing very well. Thank you.
Thank you, sir. Thank you, sir.
Can you see my screen?
Prof, this is Azal here. I've logged off. Are you back in, Mr. Khalil?
I am, sir. I am. And can you now see my screen?
Nice seeing you, Prof. Again, take care.
Yes, sir. We can see it.
All right. So
thank you, Dr. Azal. Thank you so much.
Pleasure. Most welcome. Thank you. All the best.
Thank you, sir. Thank you, sir.
After those fantastic talks, I'm just going to try and keep it simple. Now, ankle joints are probably one of the most common injuries, but they are not as popular as the knee injuries or as high profile as knee injuries. Now, the ankle joint is injured through twisting. So the joint has 6 degrees of freedom. It has...
Sir, would you please make full screen, sir?
Okay. Is
yes,
that better? I'm so sorry.
Sir. Thank you, sir.
What I was saying was that the ankle joint is injured through a twisting force, i.e. torque force is applied. The ankle is a combination joint with 6 degrees of freedom. The primary stabilizers when the joint are loaded are the bones and the ligaments. These work well in the static forces. However, injuries occur in the dynamic phase, and here the peroneus longus and the peroneus brevis become very important in maintaining stability. The history tells us whether the injury is acute or chronic, and we get the classical history of instability on uneven grounds. Examination confirms in the acute stage, but in the subacute stage, we do the anterior draw to demonstrate instability. But the most important point of the examination is to look for secondary factors that could cause instability, such as hyperlaxity or typically the cavo-varus foot. The x-rays are sometimes this helpful, but the more important role for the x-rays is to find other injuries, such as an osteochondral injury, because this will have a significant impact on treatment. The MRI scan is the mainstay, where we can grade the injury, we can look for other associated injury patterns. Initial management is fairly traditional of rest and mobilization, and there is very good results of active functional rehabilitation, and the results of that are proven. So that with these active exercises, we can get about 8 out of 10 ankles to become stable. Hence, being such a common injury, majority will do well with therapy. Unfortunately, about 2 out of 10 will continue to be unstable. And historically, anatomical and non-anatomical surgical procedures have been described. And if you look at the outcome of these, it's interesting. So in this series, where they had athletes, at 10 years, only 50%, just over half of the athletes had actually gone back to their injury level using an anatomical repair. In my hands, the scope I use for intra-articular lesions. I don't use them routinely for ankle instability. And my protocol is exactly the same, where the diagnosis and examination is done. The patients must have physiotherapy, and surgery is only offered if the ankle has been unstable for at least 2 months after therapy. MRI is the mainstay. I only do EUA very rarely now. This is my series. We were able to review patients before COVID. So the surgical technique is a Brostrom anatomical repair of the ATFL and CFL using fiber wire, but I augment with the internal brace. And then I augment even more with the inferior retinaculum. I allow immediate weight bearing, and patients have physiotherapy, and they can return to sports around about the 3rd month. My series, we now have over 100, but these were, when we reviewed them, they were just under 100. Majority were boys. Thankfully, we're lucky enough not to have any infection. We used a validated scoring system, and as we would expect, 8 out of 10 patients had stable ankles. We identified the poor outcomes were those with other injuries to the ankle, so they were not straightforward ankle instability. So this is what I do. I always put a bump under the ankle so that the ankle is free. The main reason for this being that this stops the ankle subluxing anteriorly. I use an anterolateral approach. I look into the joint to make sure that there is no meniscoid lesion which are basically either CFL tears or bits of cartilage that have come off, or look for OCD. I first place the internal brace into the talus and the fibula, and then do the rostrum repair. So the brace is placed, and then it is overlapped over the rostrum. So it's an extra articular augmentation. And one arm of the brace can also be used to do the CFL, but remember that we have to go below the peroneal tendons for that. And then I do the Gould's repair. If like in this patient was a cavovarus foot, I always do the ankle stabilization procedure after all other procedures, such as the heel shift or the first ray surgery. The reason why I use the internal brace is that it is actually a pretty strong structure. It is stronger than the native ligament, and I have no control over the quality of tissue. So when you're treating hyperlax patients or patients with chronic instability, or those simply with no ligament, no ATFL at all because of the chronic instability, the internal brace is reassuring. Some of my patients' main exercise is getting to the fridge and back. So I really have no control over the patient-related factors. So yes, the internal brace works. It gives predictable outcome, and it is safe to use. I'll also touch upon something on the syndesmotic injuries. For us, the main problem with the syndesmotic injury is identifying them. Now, sometimes they're obvious, but often we discover them after the procedure in the check X-ray when we should have identified them. So Master Nawaz has gone off. When he was still troubling me, we came up with this idea, which was to stick some dye into the joint. And if there is a syndesmotic injury, what we notice is the dye traveling up straight away. And if there isn't, the dye remains in the ankle mortise. More importantly, once we have reconstructed the syndesmosis by any other method, we can still stick the dye in to see whether we've reduced the syndesmosis, and we find this very helpful. People have their own number of screws and whether they should be bicortical, but I think the tightrope has now become universal, and even a dinosaur like me has learned how to use it. Synostosis is probably the hallmark that we were unable to stabilize the syndesmosis. In my life, in my 30 years, I've repaired the deltoid ligament twice. Main reason for being that we need to understand that it hasn't got a single point of insertion, especially on the tibia. So the modern braces allow a multifold reconstruction of at least the deep part. And that's all I have to say about ankle instability, Prof.
Thank you so much, my dear Professor Arshad Khalil, for this very interesting talk. And thank you so much for supporting us all over 3 years ago, sir.
It's a pleasure. Thank you very much.
Sir. If we have any questions to Professor Arshad. Okay, I think we have to go to the next speaker.
Thank you very much. Thank
you, sir, because we are out of time.
I can imagine.
Thank you, sir. Thank you so much, sir. Our next speaker will be Mr. Nagwi Fayo from Frimley Park Hospital. Mr. Fayo will speak about calcaneal fractures. And before I introduce Mr. Fayo, I want to thank from the bottom of my heart my dear brother and my dear friend, Dr. Rami Sharif from Frimley Park Hospital, for sponsoring and arranging and moderating this UK session. Thank you so much, Dr. Rami, for your great effort for more than 4 years with me. Thank you so much. Now we will go directly to the talk of Mr. Fayo. Mr. Fayo will speak about calcaneal fractures. Sir? Mr. Fayo? Mr. Fayo, you are with us? Okay, I think we have to postpone the talk of Mr. Fayo. Now we will go to the next speaker. The next speaker will be Mr. Mohamed Hussein. Mr. Mohamed Hussein from Friendly Park Hospital. Mr. Hussein will speak about hemi transfer. Mr. Hussein, you are with us?
Hello, can you hear me?
Yes, sir.
Hi. Yeah. Okay, can you see my screen now?
Yes, I can see it, sir.
Okay. Just okay. I'd like to thank Rami, my colleague, and you, sir, Dr. Mohamed Ashhab, for letting me present my case that I did with my consultant, Mr. Alex Vaughan. First of all, I'm Mohamed Hussein, one of the trauma and orthopedics registrars in Friendly Park Hospital. I graduated from Alexandria University in Egypt in 2010, and I moved here to the NHS in 2018. I just want to present a very interesting case that we don't see very often in our practice. It's basically a hemi transfer on arthroplasty in a chronic PRPJ fracture dislocation. Just reminding everyone about the literature, intra-articular fracture dislocations of PRPJs have always been very difficult to treat, and a lot of these cases are either treated conservatively, even though they might need surgical intervention. And oftentimes, when there is an actual person who knows how to deal with these injuries, it's often very late, and patients are reluctant to do anything about it, because when they come to know about the major reconstructive surgeries that they need, a lot of people are scared, and obviously some surgeons would not want to do these kind of surgeries. Majority of these patients are young, fit and active individuals, usually males, 20 to 50 years, with injury being during sports, most of the time axial directed forces with a hyperextension, hyperflexion. Most common direction is the dorsal dislocation, but obviously it can be in any direction, volar, lateral, or rotatory. It can be either a simple dislocation or a fracture dislocation, which is the scope of my talk today. Mechanism of injury, as I said, is usually a direct blow, and the pathophysiology is either an avulsion injury or an impaction shear. If it's too comminuted, we give it the name pilon fracture, similar to the pilon fractures of the tibia. As I said, either an avulsion injury or a shear transfer. It's either if it's an avulsion, it's usually dorsal or volar, according to the direction of the force, with a hyperextension. If it's dorsal, the finger goes into hyperextension, followed by a failure of the volar plate, and then avulsion of the volar lip of the phalanx, and fracture. If it's a volar direct force, then it causes hyperflexion, and a failure of the central slip. This is if it's an avulsion injury. If it's a direct shear force, then it's an axial loading with a PRPJ in a flexion or extension, and obviously that can cause a fracture dislocation in either direction.
Dr. Mohamed, I think the slide is not moving. It's the first slide, DC.
Yeah, I'm going to move in a second. I'm still on this slide.
Sir. Thank you. I'm sorry. Thank you.
No problem. History clinical examination, obviously essential. Clinical examination is very important. Obviously, systemic examination to rule out any other injuries, but concentrate on the hands to identify any wounds, any other injuries, any other fractures. And in dislocations, deformity is usually easily identified clinically, but as always, you definitely need X-rays to clarify how much of the bone is involved, as well as if there is any other injuries. And the first time these fractures were actually classified with a proper classification was by Hastings in 1988, and he classified it according to the percentage of the joint surface that is involved. Less than 30%, 30 to 50, and more than 50% of the joint surface. Less than 30% usually stable and can be treated with closed reduction and closed splinting. 30 to 50% stability is tenuous. It might be stable, might not be stable, and that falls obviously differs from one patient to another. And that is a kind of a gray area. Some surgeons think this is stable, I'll treat it conservatively. Other surgeons think, no, I'll probably fix it. More than 50% joint surface involvement is usually an unstable injury and would need a surgical intervention. Management, as I said, conservative or surgical. Conservative can be either a closed reduction, splinting, extension block splint, or just an extension splint, or a body strap. Simple body strap is more than enough in simple dislocations or very small avulsions. However, if we come to the surgical intervention, it can be closed reduction and pinning, or open reduction and fixation. There can be many different procedures. If it's too comminuted, like a pillar fracture, then you do a dynamic distraction. Otherwise, you can do a volar plate arthroplasty if someone is an experienced surgeon, or arthrodesis. And the lastly, which came in recently, is my scope of my talk, is the hemihamate arthroplasty. So I'd like to thank Mr. Alex Vaughan, my consultant whom I did this case with. This is a 26 years old female athlete presented to us with a chronic fracture dislocation in her right middle finger, PIPJ. The injury happened in June 2022, and unfortunately, because she had COVID, a long COVID, we could not fix her in an appropriate timing. She presented to us in November after resolution of COVID with the injury. Her finger was in fixed extension. There's not 0 degrees of range of motion in her PIPJ. The IPJ was normal, 30 degrees of flexion, and she had a full range of motion in her MCP. These are the images when we first saw her in November. As you can see in the first image on the left, the lateral view shows an involvement about nearly 50% of the articular surface, and the AP views as well showed a bit of rotatory instability and a displacement of the fracture. So we decided to take her to theaters. She definitely needed surgical intervention. She could not do anything normal daily activities. And it's very important, before I proceed to talk about the surgery, it's very important selection of the patients. You have to pick up the right patient. You can't just say with any patient that presents to you with a similar injury, okay, I'll do that kind of surgery for him. This is a very complex surgery with a lot of you need a patient who's well educated and has expectations, and you know that this patient will not, I don't want to say like mess up your surgery, because the last thing you want to do is to do a very complex surgery in a patient who will not appreciate that and would not follow your instructions, and after a few weeks the surgery will fail because the patient did not simply follow your instructions. So you need to select the right kind of patient. Obviously you can't do it in an old frail patient, and you can't do it in a manual labor. You need to do it in probably an athlete, a young patient, well educated, knows what the surgery is like, and is aware of the complications and the duration of treatment. And obviously that will lead you to a big discussion with the patient and a consent before proceeding. So to cut it short, we've taken the patient to theaters, general anesthetic, tourniquet, supine position, made an approach. As you can see, it's a curved incision over the PIPJ with an ulnar base, a radial based flap, but the incision is towards the ulnar. We lifted up the flap, exposed the flexor tendons. As you can see, FDS and FDP tendons. We released the A2 pulley and A2 and A4 pulley completely to facilitate the release of the tendons. And then, as you can see here, mobilized the tendons, moved them to the side, protected the neurovascular structures, the two bundles on the sides. And then this approach is commonly known as the shotgun approach. I'm just going to post a picture here. It's commonly known as the shotgun approach. As you can see in the image, it's similar to a shotgun where you do a volar incision, open up the capsule and release everything, and then you flip the finger completely to expose the articular surface. This image is where we've taken just an X-ray with us to make sure that we are definitely in the right joint, although it's obviously easy to identify. But This is after some release of the fibrosis tissue that was around the joint itself. And then we did the shotgun approach, as I mentioned. This is the view from top, where you can see here the forceps actually pointing to the articular surface, the fractured articular surface. It's depressed, comminuted. I think the image is not very clear, but it's depressed, comminuted, and obviously rough. We cleaned it, taken out all the debris from it, cleaned out the non-united and non-healed bony fragments, and got to a clean, healthy bony surface. We got to this stage, and then we proceeded to make an dorsal incision over the hamate. This is an X-ray image to identify the hamate bone. As you can see, there's a dorsal incision, self-retaining tractor pointing out to the hamate here. And then we made using a saw, a small saw, as you use for similar to the hallux valgus procedures or any other hand procedure. We had measured the defect. It was about 1 centimeter by 0.8 centimeter in size. And we proceeded to put K-wires as a guide to where are we going to cut in the or saw in the hamate. Made the cut. We usually try to make it slightly bigger in case you need to trim it. But when you trim it, you don't want a smaller size than the actual defect, which will cause a problem. So you take a slightly bigger size of the hamate, and then you cut it with a saw. As you can see, this is after taking the fragment off. And as you can see, the rest of the hamate is left intact and clear without any other fractures. And then, so we proceeded to take that fragment, clean it, size it exactly to the shape of the defect. And then we placed it over the defect, trying to make the articular surface of the hamate itself articulate with the condyles of the proximal phalanx, and then we managed to initially fixation with a K-wire and testing it in flexion and extension, making sure that the fragment is well fixed and stable, and then fixed it with 2 screws about 1.3 centimeter in size, Synthi screws. Each one of them was about, as far as I remember, I think 10 millimeter length, which is actually a 1 centimeter length. Fix it with it, and again try to bury it. These screws, they are very good because you can actually bury them in the articular surface if you want to, or whatever direction you're going to fix the screws. In this case, we fixed it, as you can see in the X-rays here, from a volar aspect, because it seems more reasonable and was easier to do rather than through the articular surface. And then we tested it in flexion and extension to make sure that the screws are stable. And the bony fragment is stable. The finger is not dislocating. Surgery took us, I think, about 2 hours, if I remember correctly, and put the patient in a back slab for about 1 week. And I have to say here that the hand therapy is very important. So you have to have a good correlation with your hand therapy team. And again, the patient has to understand that this surgery is a very complex surgery, so they need to follow instructions of the hand therapy team. We brought her back after 1 week, made sure the wound is clean, and then after the second week, took out the stitches, and then started the hand therapy straight away. Gentle movements, in flexion and extension, but most likely blocking the extension not to lose the fixation until the fragments become sticky and they starts to unite. This is 6 weeks later. As you can see, I'm sorry, there's no lateral view here, but you can see that the bony fragment is well fixed in a good position, and that is in 12 weeks time. Bony fragment completely united. Patient had a full range of motion, flexion and extension in her PIPJ. No pain at all, was back to her normal daily activities. We were a bit conservative of her starting the sports, but we allowed her to start after 3 months, which is about that time. And by that time, she was actually discharged from physiotherapy. And that's really what I wanted to talk about. Thank you very much, Rami, my colleague, and thank you, Dr. Ashhab, for allowing me this chance to present my case. Thank you.
Thank you so much, Dr. Mohamed Hussein, for this very interesting case presentation. We can allow just 2 questions to you, sir, because we are out of time. We have 2 questions to you, sir. First question, did you repair the volar plate to the fragment after fixation, or do you leave it?
No, of course. So I did repair it with Mr. Alex phone. Yes, we did repair it. It's very important to actually repair it and then make sure that the flexor ligaments are sliding smoothly over the volar plate. Make sure that there is no any catching in the ligaments to allow for the early mobilization.
Yes, sir. Another question: how stiffness and tendon adhesions could be avoided while still graft stability to be preserved?
So again, this is what I mentioned by the patient selection. So you instruct the patient gentle movements, mostly in flexion, and start by passive gentle movements. You put a dorsal slab to avoid overextension, but gentle movements passively first 3 weeks, and then gently they start active flexion.
Yes. Thank you so much, Mr. Hussein, for this very interesting case presentation, and hoping to see you again, sir. Thank you so much. Thank you so much. Would you please stop sharing screen, please?
Yeah.
Yes, thank you. Our next speaker will be Mr. Nagwi Fayu from Friendly Park Hospital. Mr. Fayu will speak about calcaneal fractures. Mr. Fayu, thank you so much for joining us.
Thank you, Prof. Ashhab and Rami, for inviting me to this educational event and
thank you, sir,
and giving me an opportunity to talk. Let me share my screen. Can you see it?
Yes, sir.
My name is Nguyen Pyo. I'm foot and ankle consultant from Friendly Park Hospital in the UK, and this is our hospital. Just for those who don't know us, we are in southeast part of United Kingdom and not far from London. And I have nothing to disclose regarding this topic. I'm going to talk about the calcaneal fracture, which is common as tarsal bone fracture in adults, and it's most of the time it's a high energy injury falling from height. Most common male between 30 to 60. It's very devastating injury and with severe consequences and delay in return to recovery, affecting patients' ability to walk, wear shoes, and return to its function. The mechanism of injury is mainly that fall from height leading talus to wedge into the calcaneus, causing either intra-articular or extra-articular fracture. As you can see in here, the primary fracture line will be in the middle with the multiple split, dependent on the energy level pertained. So just to give idea of how the fracture can be visible on the images. And I will just go through quickly for the images to share the fracture pattern. Traditionally, we look at X-rays to assess the calcaneal fracture and the degree of collapse. We usually use 2 key radiological markers, as in measuring the angle. As you can see here, it's a Bolo angle and the critical angle of Gisane to work out the loss of calcaneal height and an articulating surface. I just want to share that this is the X-ray of a patient with the severe calcaneal fracture, where you can see the Bolo lines completely depressed and suggesting that this patient may require surgery. And people has created multiple classifications, and the most common ones that we use are SS low pressure classification and Sanders classification. There are others, but the 2 that I just mentioned are the commonest one to use. And I will go through this quickly for the sake of time. And in SS low pressure fracture, it's tongue type and the joint depression type, depending on the degree of energy involved. Whereas in Sander, the CT scan is used to assess fragments involved in the fracture pattern and ranging from type 1 to type 4. And for me, for practical purpose, when I look at the X-ray, I work out whether it is intra or extra-articular, or whether it is displaced or undisplaced before I make treatment plan. So a lot of controversy is around calcaneal fractures treatment, especially in the UK. It is because of this paper that was published in 2014 by Griffin Group in the BMJ, saying that calcaneal fracture does not get any real benefit from surgery. This paper has caused shockwave and unhappiness in our foot and ankle society, and because the hospital management people will come and say that what is the point of fixing this calcaneal fracture when there is a paper saying there is no benefit. But this paper has multiple weaknesses. They have over 2,000 people screened, and out of 502 eligible patients, they have only randomized 150, and over 350 patients were not randomized because these patients require surgery. And they reported that surgery has no real benefit in their short-term follow-up of their 2-year study, with 17% complication. So when one look back, this is a great study, randomized control study from Buckley Group from Canada in 2002. In the literature, this is the paper with highest number of patients randomized, of 200 patients in each arm, operative versus non-operative for calcaneal fracture treatment. Upon looking at, on a general looking at it, they found out that there is no significant difference. But when cases are stratified, Buckley reported that women, younger men, and high comminution fracture are better served with surgery, whereas men over 50, workers' compensation group, and heavy manual labor may not have significant outcome, and also 5 times higher likelihood of subtalar joint fusion as a consequence. So subsequently, this paper is in 2013 from Swedish group, and they looked at it, and of their patient, it's about 40 patients in each arm, operative versus non-operative surgery. They found that there is no real difference at initial 12 months, but longer outcome, they reported that some benefit in the patient who had surgical fixation, and also reduced the post-traumatic arthritis in this group. And this is subsequent paper from Griffin Group from earlier report on the BMJ. This is their 5-year outcome report, and they still report that there is no difference in outcome. So finally, and in recent systematic review, current best evidence suggests there is advantage for operative treatment. So, but one has to approach with caution when dealing with calcaneal fracture. You have to consider patient smoking status, diabetes, and whether it involves workers' compensation claim and mental health. What if not treated surgically? Obviously, a patient will suffer malunion, causing difficulty with walking. And also, talus will sit up, causing stress, and lateral wall impingement, irritating the peroneal tendon, and will have ill-fitting shoes. And this will be difficult in some patients, and who need to wear walk boot with a steel toe cap to get the job. So what are the indications for surgery? Obviously, if the injury is associated with ankle fracture or subtalar dislocation, ankle dislocation or subtalar dislocation, you have to do something about it. What about lateral wall blowness so significant that it's causing subfibular impingement? You have to do surgery to get it back to where it should be. And obviously, needless to say, if it is open fracture, you have to deal with it. So objective of the surgical treatment is that to reduce the lateral wall and to restore the calcaneal height and length, and also hindfoot varus and valgus alignment. And if possible, you want to recreate the posterior facet and to prevent occurrence of subtalar joint arthritis, and you want to aim for early mobilization. What options do we have? Traditionally, if these calcaneal fractures were treated with open approach, doing extended lateral, but it was associated with high risk of wound breakdown and infection. So people has slowly moved away from open surgery to less invasive surgery. And another option is that one can consider doing primary fusion of subtalar joint in a highly comminuted Sanders type 4 fractures. In approach, this is the traditional approach. I personally have used it many times, and I like that as well. If you handle it with care, you can do a great job with this. And it will involve full thickness flap raising, and you reduce the fracture under direct vision, and also put the plate and bone graft. But the problem is that one has to be very meticulous about wound handling, and they have risk of soft tissue complication and infection. This is a disaster. If that happens, it is difficult to manage and psychologically impacting to patient and also to you, and to lose confidence in handling this. And another approach, which I have using more and more these days, is a sinus tarsi approach. It's a small opening. You reduced it indirectly with the help of the fluoroscope and your wires and McDonald elevator, and then you put screws in a key position to maintain your reduction. And myself, I'm a big fan of putting bone graft, allograft bone graft, cancellous, in these patients because that I feel that you have to impact the bone graft too, and to prevent the collapse. So this is my route. It is my routine practice to use bone graft, and this is you can see that only 4 screws were used to fix the calcaneus with a bone graft in there. So, and there are more techniques. People use percutaneous approach on this. It is evolving. One just used K-wires and screws and shunt spin. However, I personally feel I never tried this approach. I'm just sharing this as a complete for completeness, because I would like to see where the fibular peroneal tendons are before I put the screws, so that there is no tethering. And this is again evolving. So I just would like to share a few cases with the audience about my experience as well. So this is the first case where you can see the obvious subtalar joint dislocation with the medial fracture, and here you can see the fibular edge has been pushed from the calcaneus. So for this, I went in through medial approach to fix the sinus tarsi, and then also put a small plate on the back of the fibula to get the realignment, and patient was quite happy, and rehabilitation went quite well. So second case, this is a bilateral case where on the right side you can see pilon fracture, talus fracture, and the calcaneus fracture. On the left is severe calcaneus fracture. So this is the outcome following the surgery. So I didn't do it on one sitting, but one can be done if you have time to do that on one sitting, but it's tough to do. So the third case that I would like to share is open fracture. So here I try to avoid using heavy metal in there. So I mainly use wire to hold the reduction. And here I used cerament white filler to take the space, and we maintain the wire. We leave the wire for at least 6 weeks, and then treat the wound with VAC dressing. So this is a final case which I did yesterday. Again, this is a bilateral calcaneal fracture, severely comminuted. This is 21-year-old female patient who jumped from height to commit suicide. In addition to her bilateral calcaneal fracture, she also have L4 bust fracture, which require operative stabilization. So this is now 2 weeks that I went in yesterday. So this is her 3D images. As you can see, blowout on both lateral and as well as medial wall. Sorry, it's so. This is to show her blisters, especially the left side one here. This one is significant blister because she has the medial wall blowout and led to severe soft tissue edema in there. So I started with the right side first, and to see how it goes. So this is again sinus tarsi approach, me elevating the fracture fragments. And I hold it with K-wire, 2 K-wire, and then I went on and using the plate. And of course, as I said earlier, I used the bone graft in there. So so I proceeded to the other side again, sinus tarsi approach, elevation, bone graft, plating. So now I will go on to tongue type fracture, which is a different beast to intracalcaneal fracture, intra-articular fracture that I mentioned earlier. For these tongue type fracture, these need to be treated urgently unless it is undisplaced, because they are associated with high risk of skin compromise, and usually they cannot wait for a foot and ankle surgeons to come and do the surgery. I think it's general orthopedic surgeons have to deal with it. And here you can see the skin necrosis starting up at the back. And this is how I would normally fix this. I use large 6.5 cannulator screw with a washer to hold it. And then I keep the patient in slight plantar flex position to detension the Achilles. So if this is left untreated, this is how it's going to happen. The skin necrosis will continue, and the breakdown, before you know it, it will become open fracture. So this is something that there's no controversy about fixing or not fixing. So in terms of post-operative, I keep the patient in the plaster cast for 6 weeks and non-weight bearing for 6 weeks. And then I will gradually mobilize them out of the cast with the crutches and then physio. So in conclusion, calcaneal fractures, they are challenging, but one has to treat patient individually depending on their characters, the presentation, the pattern, fracture pattern. And you have to choose your approach carefully. And, and needless to say, meticulous soft tissue handling is required. But most importantly, you have to enjoy it. Otherwise, it will be painful for a surgeon to go through that. I enjoy doing calcaneal fracture. It's a challenge, but I love to take it on. Thank you very much.
Thank you so much, Mr. Fayo, for sharing your experience in this very important topic, which is calcaneal fracture with us. Thank you so much, sir.
Thank you, Prof. Ashhab.
We have just one question from Dr. Gamal Qasim. Subtalar fusion versus operative intervention before the age of maturity.
Well, subtalar fusion for intracalcaneal fracture, I have only done 2. I am more towards fixing it. So, and it is difficult to get the position right, and so not for me.
Thank you so much, Mr. Fayo. Hoping to see you again with us, sir. Thank you so much.
Thank you, Prof. Ashhab.
Thank you so much, sir. Our next speaker will be Mr. Ahmed Al-Maghrabi from Friendly Park Hospital. Mr. Al-Maghrabi will speak about posterior malleolar fractures. Mr. Ahmed?
Hello, hi.
I'm
not sure if you guys can see me.
We can hear you, but we cannot see you. Yeah, we can.
Yes.
We can see you now. How are you?
I'm good, thank you. How are you, Professor Ash? I'm just about to share my screen.
Yes, please, sir.
First of all, I'd like to thank you all, Professor Ashhab and Rami, and all the people involved in actually arranging this huge event. And as I heard, it's probably the largest in context of the numbers and the hours and everything. So thank you very much for the effort. And I've been lucky enough to present last year, and again, I'm lucky enough to be among you today. So thanks for having me. I go by two surnames, and sometimes this is confusing. So some of you guys might know me as Ahmed Abdelaziz, and some of you might know me as Ahmed Maghrabi. So don't get confused. I'm the same person, and I'm not running away from any crimes, I promise you. I'm a foot and ankle consultant in University Hospital Southampton. I worked with Rami when he was in Southampton, but I don't work infirmly. And I'm a lecturer of trauma and orthopedics in Cairo University, which I'm very proud of, and the place where I learned. I won't say.
Sir, you are working with Professor Wagih Musa.
Yes, I am. Yes.
Yeah. Waiting for him, sir. Waiting for him.
I will pass that on, definitely. I try. I know it's a very dense day, and probably everyone's tired and exhausted, and will be by the end of the day. So I try to be sort of, instead of just going through ankle fractures in general, I try to be very specific to what I'm talking about today. And I think it's a matter which is slightly controversial. Some people might not have the full updates on it, so I hope the presentation will be beneficial to you guys. So posterior malleolus. Conflict of interest, I have nothing to declare related to this presentation. So I think by the end of the presentation, I'd like to answer 3 questions. Why do you fix posterior malleolus? When do you fix the posterior malleolus? And how do you fix the posterior malleolus? So I'll start with why. So we fix the posterior malleolus for 2 main reasons: stability and congruency. Stability, not only the syndesmotic instability, so we know the 2 main ligaments of the syndesmosis are the AITFL and the PITFL. And there have been different arguments as to which ligament is more important. Is the AITFL or the PITFL or the interosseous ligament? And some people think that the PITFL is the main stabilizer for the syndesmosis, and it's the main stabilizer against rotational instability. So one of the purposes we fix it is for syndesmotic instability, to prevent or to treat syndesmotic instability. And the other purpose is actually to prevent, especially with the large fragments, to prevent the tibio-talar instability as well. So the large fragment can make the actual ankle joint itself unstable and can subluxe anteriorly. The second, it's like any other articular fragment. Again, especially if it's a big fragment, it can affect your joint congruency. If you have an articular step, then it can lead to arthritis, stiffness, and pain. So in a sense, it's an intra-articular fracture. So when do you fix the posterior malleolus? Please completely forget the rule of thirds. No one follows the rule of third anymore. It's been hugely criticized, especially in the last 5 years or so. So the rule of thirds doesn't apply anymore. The rule now is, generally speaking, if it's big enough to be fixed, then you should fix it. Again, the classification has been updated. There are 2 brilliant foot and ankle surgeons in Liverpool, Mason and Malloy. And they've been working, well, not exclusively on posterior malleolus, but I think they're publishing almost exclusively on the posterior malleolus in the last, I don't know, maybe 7 or more than that. So they kind of updated the Haraguchi classification, which was sort of more familiar and more popular. And it's not very different, but I'll come why this classification is important in a minute. So type 1 is a sliver fracture, or it's a very small fragment, which most people will shy away from fixing, and I think it's really hard to fix. Type 2 goes into 2A and 2B, and the difference is 2A is only a posterolateral fragment, whereas 2B is a posterolateral and a posteromedial fragment. And type 3 is the almost peel-on fracture, where you get a really big chunk at the back of the tibia, And in my opinion, actually, this is the hardest. So when I started doing these fractures, I thought this is a big fragment. It's not comminuted. It should be relatively easy to fix. Quite the opposite, actually. This fragment is this type is the most actually difficult to reduce, especially if you're doing it 2 weeks down the line or something. So the beautiful thing about the Mason-Miller classification is actually it has implications on how, so it's sort of for the simple-minded people like myself. So if it's type 1, you don't worry about fixing the posterior malleolus. You just fix the syndesmosis to achieve the syndesmotic stabilization, and hopefully this small fragment will come up with the rest of the tibia, and the patient shouldn't have any problems. The reasons they split the posterolateral and the posteromedial fragment into 2A and 2B is 2A, you can go posterolateral approach, which I think the majority of us, even general orthopedic surgeons, are familiar with now, and people have been doing it in increasing numbers over the last few years. The 2B is, I think, slightly tricky, so you still can fix it through a posterolateral, but you'll have to combine that with a medial posteromedial approach, or you can go posteromedial altogether, so you can access both the posterolateral and the posteromedial fragment from the posteromedial. For type 3, and again, this is controversial, so they recommend going posteromedial, and I would agree, having tried posteromedial and posterolateral for that type fracture, but some people will still do it through posterolateral. Important thing to note, just to come back to this slide, sometimes the posterior malleolus, the posteromedial fragment, sometimes it's actually, because this is the constant fragment, like the posteromedial fragment of the calcaneus, we call it the constant fragment as well. So sometimes you cannot reduce, I'm not sure if you can see my cursor, but sometimes you cannot reduce this posterolateral fragment unless you reflect this posteromedial fragment out of the way. Then you can push that posterolateral fragment back in, and then you go and fix the posteromedial fragments. So I thought I would not waste your time about talking about posterolateral approaches. It's everywhere. If you haven't done it, probably you have seen it. So I think most of us familiar with the two windows, the one which is between the FHL and the peroneal tendons, and the one lateral to the peroneal tendons. I think the relatively new approach, which I am keen to talk to you about, guys, is the posteromedial approach, or approaches rather. It's 3 different intervals. So there's a posteromedial approach, there's a modified posteromedial approach, and there's a medial posteromedial approach. So start with positioning. So positioning is key in my opinion. I've almost moved completely away from prone position to posterolateral and posteromedial approach, and I'm doing everyone almost exclusively as what we call the recovery position, or the lazy lateral. The anesthetists love this position because they don't have to worry about all the technicalities and the difficulties of putting a patient in a prone position for an extended period of time. And yet you get an almost prone position on the lower parts of the body. So if you lie in this position and then after patient's asleep, you just twist the hip, internally rotate the hip, so you almost get a completely prone position on the ankle. Obviously, it's not for every patient. It has to be in patients who are sort of average or slightly slim. And again, remember that they have to have flexible hips. So if they have stiff hips, or if they have total hip replacement, you have to be very careful. So lots of these patients we treat in the UK have actually total hip replacements. The other position which sometimes you can use is actually keep them supine and just do your medial posteromedial approach through the figure of 4 position. You just have to have 2 assistants most of the time. Someone who will be bored and you just be pressing and keeping the knee in that position, and someone will be actually assisting with the surgery. So the 3 intervals described, as if you go, this is the tib post tendon, and your incision normally goes almost over the course of the tib post tendon. You identify the tib post tendon, and depending on your fracture and what you want to achieve, you can either go anterior to the tib post, and this is slightly uncommon because in the past people used to do it because they thought that this is the safest approach, because if you think about your bundle, the bundle is actually protected by your tib post, it's protected by your FTL, so it's protected by 2 strong tendons. But the difficult thing about this interval is you're actually fighting a very strong tendon, which is the tib post. and therefore it doesn't give you access to it only gives you access to this bit, and maybe after you push that tendon slightly laterally, you get access to maybe to this side of the tibia. But definitely, if you do, like I do sometimes, if you have a posterolateral fragment and a posteromedial fragment and you want to fix it all through posteromedial, then definitely don't go through this interval. So go through the interval between the tip post and the flexor digitorum longus. So still your bundle is protected because the bundle lies between the flexor digitorum longus and the FHL. So still your bundle is protected and gives you much better access to almost the whole posteromedial. And if you're careful with your dissection and you have blunt instruments which you can carefully put subperiosteally on the lateral border of the tibia, then you have access to the entire back of the tibia on a very easily fixed posterolateral and posteromedial fragments through a posteromedial approach. And you don't actually believe it. So whenever I tell someone who's not very familiar with the approach, believe me, you'll be able to fix a posterolateral fragment from a posteromedial approach. They don't believe it until they actually see it. But it's much more extensile approach than the posterolateral. You can never reach a posteromedial fragment, or it's very difficult to do it from a posterolateral approach, but you can easily do it from a posteromedial approach. This is fresh off the boat, like they say. So it's published in a very prestigious journal, Injury, in 2022. Whether the plates or screws, are they equal in terms of the outcome, in terms of the rigidity of the fixation, in terms of the backing out of the metalwork? And definitely the plates, whether it's in a buttress mode or an anti-glide mode, it has a slightly superior outcome compared to the screw fixation. So I almost always, unless it's a very small fragment, I almost always go for a plate. A few things to note. If you see a posterior malleolus on an X-ray, please get a CT scan. As much as the resources are limited and everything, but you're really compromising the patient's treatment and management if you don't get a CT scan. And I'll show you in this. I have only one case, so you guys are not too bored, but I'll show you how important CT scan is. And remember, fixing the posterior malleolus, yes, it helps with the syndesmotic instability, but it does not mean that if you fix the posterior malleolus, you don't have any syndesmotic instability. So whatever test you use for anterior instability, whether it will be the hook test or the push and pull test or the external rotation test or whichever, or the tap test, whichever test is your favorite test, each one of them has pros and cons. So whichever your go-to test you use for the anterior instability, remember to check this after you fixed your posterior malleolus. I'm not sure if these plates are available in Egypt now. So now people are starting to think about, like we do with the distal radius, we do fracture-specific or fragment-specific plates. So we have some companies now which do a posteromedial plate, which is perfectly contoured and low profile for the posteromedial fragment, and a posterolateral plate rather than the T or the distal radius plate, which sometimes used. And obviously the distal fibular anatomical plate now comes in two forms in almost all the companies, either a posterior, which you put on the posterior aspect of the tibia, or a lateral, the distal anatomical, the normal standard distal anatomical fibular plate. So if I get these x-rays, yes, I know the posterior fragment, yes, I know there is a fibular fracture, yes, I know there is a medial malleolus, a vertical tear, but unless I actually get CT, and unfortunately, and I do apologize, I tried to get the CT, but because it's the way we were allowed to take images from the hospital, I couldn't. So essentially what the CT showed is that there are posterolateral fragments, and there's a posteromedial fragment, and there's a separate anteromedial vertical medial malleolus fragment, as well as so some people refer to these ankle fractures now as quad malleolus, because the posterior malleolus is actually two fragments. So what I've done is, I'll just walk you through these steps. So I did the posteromedial approach. I almost always start with the posterior fragment, because I want to be able to see absolutely that I've reduced this fragment. I get a perfect joint congruency, because if you didn't do that, part of the operation is not complete. And if you start putting a plate on the fibula, then the fibula will obscure actually your reduction. You won't be able to assess whether you've reduced this posterior fragment or not. The only exception to this is sometimes I fixed, if it's a 2-week or a 3-week old fracture, which unfortunately sometimes we have to deal with, sometimes we fix the fibula first. And the reason is because when you restore the length of the fibula, and we know that the PITFL is intact, the posterior fragment is not intact, but the PITFL is intact. So by reducing the fibula, you're helping with the indirect reduction of that posterior malleolus because you're restoring the anatomy between the distal fibula and the distal tibia. So I've started with this plate, and I went for plate rather than screws and sort of very rigid fixation. I start with the screw at the axilla first to buttress the fragment in place. I hold it with a wire first and then put the plate on top of the wire. And because of the vertical medial malleolus, we can't leave it, so we have to treat it because it has a very strong shear forces across the fracture side. So with the vertical medial malleolus, so I used the posteromedial approach, and I used the interval between the tip post and the FHL and the FTL, to get to the back of the tibia, to fix the tibia and put it back in place. And then I went to the anterior to the tip post, like I'm doing a medial malleolus, and the standard medial malleolus, and I fixed the medial fragment, and again made sure that this is congruent, so the joint doesn't have any articular steps. With my posterior plate, I forgot to mention, when I did it, I specifically used this plate, and the reason is because I knew it's a posterolateral fragment and a posteromedial fragment, so I tried to have only one plate and to put the screws in this particular position so I can catch the posterolateral fragment and I can catch the posteromedial fragment. And then after I've done that, you can see that the fibula, you can hardly see the fraction. I promise you there was a fraction in the fibula, but because these ones are reduced well enough, now the fibular fracture is reduced into a perfect position that you can't almost see it. And then I put the fibular plate, I assessed the syndesmosis, and because you can't see it, but this patient had a very small fragment, which we call the Wagstaff fragment, which is essentially a fibular avulsion of the AITFL, and obviously it shows on the CT scan. So I knew that his AITFL as well is compromised. So I went on and fixed his fibula with the distal anatomical after putting an interfrag screw. And this, so imagine how, only judging by X-ray, how could I have known that this patient has a posteromedial fragment, a posterolateral fragment, a Wagstaff fragment. So the X-rays might have looked very benign, but the CT is a completely different story. And either you just ignore the posterior malleolus and you just say, I'm not fixing the posterior malleolus and I'm opposed to the idea, and that's fine. You're entitled to your beliefs. But if you want to fix the posterior malleolus, don't go at the back without knowing actually what you're about to expect, because you will not see it. You can fix it like 2 weeks or 3 weeks down the line. Everything will be, it will not be a fresh fractures. The fragment might have even sort of started to heal together. So unless you actually know what you're dealing with, it's just a bit of a gamble to go at the back. Thank you very much.
Thank you so much, Mr. Ahmed Al-Maghrabi, for this very interesting talk, and hoping to see you and Mr. Hussein, Dr. Ami, Mr. Ibrahim, and all our colleagues in States, Canada, Ireland, the UK, of course, and Germany in the upcoming Egyptian overseas online course. Hoping to see you, sir.
Thank you very much. Thank you, Professor.
Thank you so much. Thank you so much. Our last speaker in this session will be my dear friend and my brother, Mr. Ibrahim Said Qamar from Sligo University Hospital, Ireland. I'm very happy to see you.
Thank you, Professor Ashhab, for this generous invitation. I'll start sharing the... I know it's too late.
No. We have another 3 hours in the lower limb trauma session.
So... sorry for this. So today our talk will be about the subtalar dislocation. So The objectives of this presentation will be to discuss the mechanism of injury and the types of subtalar dislocations and the different management approach and the prognosis of this injury, and we'll give just a case example of this. So the subtalar dislocation is not a common dislocation we can see. It is a rare event. It is less than 1% of all dislocation, less than 1 per 100,000 per year. It is more common in the young or middle-aged males. It is usually, or most of cases, resulted from a high energy mechanism, and some literature saying 25% may be open, and some papers saying it up to 40%. Lateral dislocation is more likely to be open up to 60% of cases. So there is associated dislocation, like talonavicular joint dislocation, one of the common associated dislocation with the subtalar dislocation, and the associated fracture up to 44% of cases. With the medial dislocation, the dorsomedial talar head, the posterior process of the talus and the navicular bone. With the lateral dislocation, the cuboid and anterocalcaneus lateral process of talus and fibula is more common to be seen. The types, this is the anatomical classification. This is based on the dislocation of the midfoot in relation to forefoot, and this is based by Broca in 1853, about 170 years ago. So the most common is the medial dislocation. This is about 65 to 80% of the cases, resulted from the inversion force on plantar flexed foot. The susticulum tali act as like a fulcrum to rotate the neck of talus, will rotate and pivot around it and dislocate it. Usually, when we have medial dislocation, the reduction will be blocked by lateral structures like the peroneal tendons, extensor digitorum brevis muscle, talonavicular joint capsule buttonholing can happen and block the reduction. In the lateral dislocation, it is more likely to be open, as we mentioned. It is resulted from the eversion of plantar flexed foot. So the reduction, as we mentioned, will be blocked by the medial structure like the posterior tibial tendon, the FHL and the FDL. There is the posterior dislocation, which is rare. It's 2% of subtalar dislocations. It will happen with plantar hyperflexion. Will be tearing of the interosseous ligament, and the talar head will be sliding over the navicular. So when we see in the lateral X-ray, we can see the talar head is higher than the navicular bone. It is highly unstable, and most time it converts to medial dislocation. The anterior dislocation is very rare, it's less than 1%. It is excessive dorsiflexion with or traction force. The very high and stable converted mostly to lateral dislocation. Management approach, as we dealing with high energy trauma, so we are not treating only the fracture or the dislocation, so we need to treat the patient himself. So we need to follow the ATLS protocol first and be sure that we treating all the life-threatening condition before this. But to addressing the assessing the patient, on the physical exam, we need to assess the neurovascular status of the limb, the soft tissue, seeing if this open or closed injury, and we can see in the physical exam, in the medial dislocation to be locked like the foot will be locked in supination, which is known as acquired club foot. In the lateral dislocation, it looks like acquired flat foot and locked in pronation. So the imaging, the main thing can the X-rays, and as we mentioned, the medial dislocation talar head will be superior to navicular bone in the lateral view, but in the lateral dislocation, the talar head will be collinear with the navicular or inferior to it. CT scan is to assess any associated fractures or debris inside the joint, and usually we do the CT scan after performing the reduction, nothing to delay the reduction of the dislocation. So it can be done non-operative. About 60 to 70% of dislocation can be reduced in closed maneuver. Usually we need to flex the hip and the knee to ease the traction from the gastrocnemius, and then counterflex the foot, and then we can do eversion or inversion according to the direction of the dislocation. Most of this dislocation will be stable and can be bought in below knee cast for 4 to 6 weeks with non-weight bearing. If there is the reduction is blocked, then we need to go for open reduction, and this is indicated in the open dislocations, failure of closed reduction. About 32% of cases required to go for open reduction. As we said, medial dislocation blocked by lateral structure like peroneal tendons, the extensor digitorum brevis, and lateral dislocation like in this image, the posterior tibialis tendon, flexor hallucis longus, and flexor digitorum longus. When we go to reduce medial dislocation with the open technique, we need to go for sinus terci incision to clear the debris and to clear the blocking structure in the lateral aspect. You can go for medial incision for the lateral dislocation, but also sometimes we need to make another incision laterally to clear the joint. The complication of the subtalar dislocation, the most common complication is the stiffness and the post-traumatic arthritis. It is like most of patients, we can see radiographic evidence of arthritis in long term, about 89%, but only 63% will be symptomatic. A vascular necrosis of talus can be happen, especially if the dislocation associated with fracture of the talus. The prognosis would be very poor with the high energy mechanism, and as the lateral dislocation, which is mostly higher energy needed, and also for the open dislocation because the wound complication and the infection. This case came to our hospital. She is 83 years old female. She was a driver and she hit a wall. So she attended to the ED, which the guys in ED followed the ATLS protocol, the take image. They tried to reduce it first, but they couldn't. And they called us to come to give them hand there. They give sedation in the ED, and we already reduced the dislocation in the ED. And we followed the British Orthopaedic Association standard number 4 regarding the open fractures, like starting antibiotic, applying saline-soaked gauze, and the tetanus vaccine and the other guidelines. Then we took the patient to theaters, and we did X-fix, and we did the debridement for the wound, and we applied a vac dressing. This is the image from theater after applying the X-fix. And then we send patient for CT scan, which showing the posterior process of the talus was broken, and there's some debris also in the joint. So we took the patient again for another session of washout, debridement, and we go with a minimal incision, like small incision posteromedially. We go between the Achilles tendon and the flexor hallucis longus, and we used a 4mm cannulated screw to fix this fragment. We kept the X-fix for 6 weeks for the care of the wound and to keep the stability of the joint. After that, we removed the X-fix, wound is healed. The patient started with bearing accelerated a range of movement exercise with physiotherapy, and the patient doing well after that. There is some papers like to be good evidence. And thank you, Belbolben Mountain from Sligo. Thank you.
Thank you so much, my dear brother, Dr. Ibrahim Said Kamar, for this very interesting presentation about a very interesting topic. Thank you so much.
Thank you. Thank you. Have a nice day. Thank you.
I think it's too late for you.
Like for me, because I just had not 9:30. I'm waiting for Isha prayer and then sleep.
Hoping to see you soon.
Inshallah.
Thank you so much, my brother.
Thank you.
شكرا جزيلا أخي الحبيب. We have finished now the session UK Experience in Trauma, and then we come to the last session in our webinar, which is a unique session, unique gathering of eminent stars in one session, the lower limb trauma session. Our first speaker will be the hallmark of trauma in Egypt, Professor Osama Farouk. دكتور أسامة فاروق طبعا هو من هو، يعني مش محتاج تعريف، يعني Professor of Orthopedic Surgery, Ashok University, one of the eminent stars in EO, and the hallmark of trauma in Egypt. Professor Osama, please, sir.
Thank you very much, Professor Mohamed Al-Ashhab, for introducing me. I attended most of the talks today and enjoyed them very much. Now we will move to talk about the fragility fractures of the pelvis. First of all, I would like to thank my dear friend, Professor Mohamed Al-Ashhab, for organizing and moderating this very interesting international trauma webinar, including more than 50 speakers from 4 countries. Thank you, Professor Al-Ashhab. My deep thanks and appreciation. This female patient, a diabetic patient, 73 years old, presented with painful right hip region. We did plain X-ray and CT scan that showed this in place fracture of the pubic rami and right sacral fracture. I think most of us will take a decision to apply a conservative treatment in this lady and give her medical treatment for pain and for osteoporosis. 6 weeks later, the patient presented with pain, deterioration of mobility. We did again plain X-ray, CT scan that showed progression of the fracture. So we are going to define the specific characteristics of fragility fractures of the pelvis, and we will ask ourselves, do we need to have a classification of pelvic fragility fractures, and how can we apply this classification? We are going to outline the different treatment options and describe the outcomes expected after pelvic fragility fractures. Pelvic fragility fractures is going to increase worldwide. 7% of all osteoporosis-related fractures are now pelvic fragility fractures in people over 50 years. The average age of patients with low energy pelvic fractures is around 70. It is 69 years. It is expected to increase by 60 to 100% by 2030. So we are facing more and more cases with pelvic fragility fractures. What are our concerns when we face a case with pelvic fragility fractures? The cavernous bone corridors, this will make the fracture reduction as a difficult task. We have as well the limited fixation opportunities in such quality of bone. Moreover, we have the vulnerable soft tissues in older patients, medical comorbidities, limited surgical reserve when we decide to go with surgery to fix the pelvic ring. We have also difficulties with compliance with post-operative weight-bearing protocols. And if we decide to conserve we have the complications of prolonged weight-bearing restrictions. We would like to differentiate between the fragility fractures and the insufficiency fractures. Fragility fracture, the bone fails after low energy trauma. So low energy trauma to the weakened bone will lead to a fracture. It is caused by a mechanical force that would not fracture the normal bone. While insufficiency fractures, the bone fails during normal daily activity without history of trauma. So it is caused by the physiological load, the physiological stress applied to the bone with deficient elastic resistance. These insufficiency fractures are usually diagnosed by clinical suspicion and often delayed in diagnosis. We have a patient presenting with insidious onset of low back pain or pelvic pain, symptoms exacerbated by weight bearing and relieved by rest, with progressive loss of mobility and independence. Then we will suspect this patient to have an insufficiency fracture. And we will do our radiological workup, AP inlet and outlet views. Most of the cases will need CT scan to settle the diagnosis. And we should differentiate the radiological pictures of insufficiency fractures from osteoblastic deposits. When we see these lesions, they are usually sclerotic with trials of healing and callus formation, but still with preserved facial planes, no bony destructions, and there is lack of soft tissue mass. MRI examination is more sensitive to detect occult pelvic insufficiency fractures, whether anterior or posterior, and a bone bruise in the sacral area may be the first MRI sign of insufficiency fracture. This means disruption of the cancellous structure of the sacrum, like we can see here in these MRI pictures, even before we detect these fracture lines in the CT scan. When we talk about the pelvic fragility fractures, we have three important questions to answer. Does injury pattern differ in fragility fractures of the pelvis from that pattern in young age groups? Do we need to have a specific classification? And how can we treat such fractures? And the answer for the injury pattern is yes. We have a different injury pattern in pelvic fragility fractures. We have usually osseous disruption. Osteoligamentous is rare. It is seen only in high energy trauma, but in low energy trauma, in fragility fractures, the disruption is osseous through the pubic rami anterior or the sacrum, and sometimes the iliac bone posteriorly. So it is bony disruption, both anterior and posterior pelvic ring. Usually the disruption is undisplaced or minimally displaced at the beginning. Do we need a classification for fragility fractures of the pelvic ring? And the answer is yes. As we have different injury pattern, we need also a comprehensive classification of fragility fractures. Thanks to Professor Romans and his group, they described this classification for fragility fractures of the pelvis. They reviewed 245 patients over 65 years of age, and they analyzed the morphological appearance of these fractures, and they could identify 4 fracture patterns. Type 1, isolated anterior pelvic ring lesion. This is the first stage of pelvic fragility fractures, to have isolated anterior pelvic ring lesion. Type 2, we have non-displaced posterior lesion combined with an anterior one, and we don't have displacement. These are usually showing minimal instability. Type 3, we have a posterior unstable lesion. This is the difference between type 2 and type 3. Instability of the posterior lesion, this means we have displacement. Type 4, we have bilateral posterior instability of the posterior ring. So the difference between type 3 and 4, type 3 is unilateral posterior instability. Type 4, we have bilateral posterior instability of the pelvic ring. What about fracture progression? Fracture progression is a real phenomena in fragility fractures of the pelvis. Again, thanks to Professor Romans and his group, after reviewing 148 patients, they could identify progression of fracture in nearly 15% of patients after non-operative treatment. Female patients have high risk of fracture progression than males. What is fracture progression? The fragile bone may fail to heal due to metabolic and or mechanical factors, like the case we presented at the beginning of our lecture. And in this, we will have persistent pelvic pain, progressive deterioration of ambulation, progression of fracture, and deformity of the pelvic ring. This deformity is usually internal rotation and sagittal malrotation of the pelvis. This is fracture progression that will proceed to non-union. What about the treatment of fragility fractures of the pelvis? This depends on the classification type. For type 1, we have only anterior bony disruption. Non-operative treatment is applied, and we address and correct the metabolic error in the patient. Type 2, we fix the posterior fracture percutaneously, percutaneous iliosacral screw fixation, or sacroplasty. What about type 3? Again, if we can achieve closed reduction, we will proceed with percutaneous iliosacral screw fixation, or we may need to do open reduction. In type 4, we may apply again percutaneous transiliac transsacral fixation, and in complex cases, we may need lumbopelvic fixation. So the percutaneous iliosacral screw fixation is a working horse in fixation of the sacral fracture in pelvic fragility types. It is a safe, minimally invasive procedure in such fragile patients. However, if we look to the sacrum in this CT cut, in this CT transverse cut, we can see how empty are the ala of the sacrum. So we expect to have increased failure rate of iliosacral screw. For this reason, we need to improve our internal fixation technique to have longer screws, more screws, combination of fixation techniques, augmentation of screws by bone cement, to apply posterior bridge plate, to use these bridge plates as locked plates, to have lumbo-pelvic fixation, which is invasive in such fragile patients. And lastly, to have sacroplasty as a useful technique in some patients. This is an example of the use of percutaneous transiliac transsacral screw fixation, and the outcome is encouraging. This technique lessens pain and improves ambulation, and still it is a minimal invasive technique. And if we use 2 screws, this will augment the fixation and the stability of the construct. Again, cement augmentation of iliosacral screws may be a solution. It increases the purchase of iliosacral screw 3 to 4 folds. And in biomechanical studies, this technique has greater pull-out forces. So we inject bone cement around the inside the channel around the iliosacral screw. The posterior bridge plating is another method of fixation. Screws are inserted into the sciatic buttress, so we can have long screws into the dense iliac bone. We can augment the fixation by iliosacral screws as well. An alternative is posterior iliac external fixator. Lumbopelvic fixation and triangular fixation is the method of choice in complex cases with U-shaped fracture and spinopelvic dissociation, but it is an invasive tool in such fragile patients and should be applied only in selected cases. What about sacroplasty? It is the same like vertebroplasty, same philosophy. Image-guided technique, effective choice for rapid pain relief and early mobilization of the patient. What do we expect after fragility fractures of the pelvis? What is the long-term clinical outcome? 20 to 30% of cases showed decreased physical functioning and the quality of life. To summarize the differences in pelvic fragility fractures and fractures in young adults, we have the mechanism of trauma as high energy trauma, in fragility fractures, low energy trauma, pattern of injury in young osteoligamentous, we have disruption of the symphysis pubis disruption, sacroiliac joint disruption, but in fragility fractures, we have osseous disruption, pubic rami fracture anterior, iliac or sacral fracture posterior. Fracture progression is not known in young adults. Fracture progression is a real phenomena in fragility fractures. Sacral fractures in young adults, transforaminal in many cases. In fragility fractures, we have usually alar fractures. The bone quality is good in young adults, poor in fragility fractures. Insufficiency fractures can be seen in young adults after corticosteroid intake or irradiation, but can be seen continuously in older patients. Fixation failure is rare in young adults, can be seen more in fragility fractures. Our take-home message: pelvic fragility fractures are challenging. They have different injury pattern. They need diagnostic workup, especially in insufficiency fractures. The options for operative treatment are iliosacral screw or transiliac transsacral screws in order to have better fixation in such poor bone quality, augmentation of screws by cement or sacroplasty. Failure rates and complications are expected. Fracture progression is a phenomenon. However, we still have opportunities for improved surgical options. Thank you very much for your attention.
Thank you so much, my dear Professor Osama Farouk, for this very interesting presentation. Thank you, sir. Thank you so much, sir.
Thank you.
If we have any questions to Professor Osama? Okay, thank you so much, sir. It has been a great honor for us, sir. Thank you so much.
شكرا جزيلا لحضرتك.
شكرا جزيلا يا أستاذنا الغالي.
اتشرفت الحقيقه بوجودي في الجلسه دي اللي فيها عمالقه.
ده شرف لي انا يا فندم، شرف لنا كلنا.
شكرا دكتور اسامه. يعني هيتكلم دلوقتي
شكرا.
كل العمالقه، الدكتور محمد الشافعي والدكتور محمود الرصاصي وكل الاخوه الزملاء الافاضل اللي في الجلسه. عشان
انا بعتذر على التاخير اللي حاصل يا فندم، معلش العدد كبير قوي فانا اسف يعني.
شكرا جزيلا.
حضرتك عملاق يا دكتور اسامه من غير اي حاجه والله. أنا شاكرين جدا. Good evening to everybody and thanks Prof Ashhab. Thanks for the audience who staying that late. This topic is actually the dry science is a bit difficult, but we try to make it as easy as possible. I'm going to talk about management of fracture neck-of-femur, which everybody in audience and speakers are expert in this topic. But we're going to add the evidence-based approach so that we may learn something new. So the objectives of this talk is, first is the management of fracture neck-of-femur, which you already know the basics, some controversial issues and questions that really does not have a clear answer until now. So we're going to tackle this. We see the variation in practice between surgeons. Every surgeon do it differently between different hospitals, different universities, different countries, different background of experience. Okay, and then we're going to look at the definition. We're going to look at just having problem here. I want this part to, sorry for that. Look at the definition of evidence-based medicine, and then look at the application of evidence-based on fracture neck-of-femur. Okay. I couldn't advance the slide. Okay, when we have a fracture neck-of-femur, if it is intracapsular or extracapsular, with intracapsular, you may have option. With extracapsular, we have one option, and these are the basics that everybody will apply. But when we come to questions that doesn't have answer, like for example, if it's intracapsular, would you fix by screws or plate? Would you do a DHS or would you do for a hip replacement? And when you do a hip replacement, whether you do a hemi or a total, when we operate, should be today, tomorrow, or next week? Should we use traction? What are the rules of using antibiotics? Also DVD drugs, drains, blood transfusion. How about the post-operative bed rest? When the patient can walk with a full weight bearing or not? And then when we're going to talk about implants, which is currently a problem in Egypt, about availability. If you don't have, for example, joint replacement, then you may have to use a fixation in a patient where joint replacement is indicated. So availability is a big issue. Economical constraints in different places, hospital and national policies, and then surgeon preferences or his knowledges. And then we're going to talk about new technology, a patient also seeking fancy options from internet, commercial companies and their influence, especially that everything is commercially driven now, drugs, trauma implants, elective implants, and others. So how are we going to answer this question? It all depends on the way you practice medicine. So do you practice medicine based only on your training? Or do you practice it? It has always been said that we are slaves to our training. So, for example, if somebody was trained in UK in a certain era, he is going to use his training in spite of this training being even changed. So we are still slaves to all the training that we have. Some using only their own personal experience or advices from colleagues. Some using only preferences of patients. And some using their knowledge and new textbooks, or based on recent literature like case reports and retrospective studies, or maybe guidelines from American and British Society. All these are okay, but in fact, we should combine all of them in addition to the high level of evidence studies like randomized control trial and meta-analysis. So when we talk about evidence-based, is actually by looking at high level of evidence studies like randomized trial and like meta-analysis. A definition of evidence-based, a simple one, is the integration of the best research evidence with our clinical practice. So there's a combination of these two. And they are components, as you can see here. We have the patient, we have the doctor, and we have the information. And then we got questions or problems that need to be answered. So the 5 main steps for evidence-based medicine is that first is that you have a clinical question, you have a patient-focused or a problem-oriented, okay? And then you're trying to find the best evidence for that through your literature search. Then you get a lot of information. You need to do a critical appraisal for that, and you evaluate the evidence for quality and for usefulness, and apply this evidence by implementing useful findings in clinical practice. So you implement, and then you see the results. So you evaluate, and then you see the intervention that you did and the effect of that evidence-based process. This is a very serious statement. When somebody say that in 21st century, clinicians who cannot critically read a paper or a study is as unprepared one who cannot take blood pressure or examine the cardiovascular system if he is like a junior doctor. As we know, the level of evidence for the studies that's published are 5 levels. So when we ask an expert in the field, so, for example, if you ask the top surgeon in fracture neck of femur in the whole world, this is level 5, which is the lowest. And after that is a case study or case report or series, and then retrospective, which is a level 3, and then a prospective cohort study, which is a level 2, and then level 1, which is randomized control trial and systematic review or meta-analysis. So this slide is very, very important because this slide, what we're going to apply to every step of the management of fracture neck of femur in the next slides. This is the same pyramids that we showed before, which is a level of evidence, but it's just done in a more complex fashion. Okay, so here we have 17 questions that need to be answered. This collection of literature and the level of evidence is not done by me. This is something that has already been published. However, this is not up to date, which means that some of these 17 questions could have an update maybe at the time of giving the talk. There could be a paper that could be published just like yesterday that I didn't look at, or maybe something that's going to be published today. So this evidence should be updated every now and then. So when we look at this, I'm just having a bar here at the top. I can't get rid. Sorry. Give me a second. So the first question is the time of surgery. Here is the answer to the time of surgery. But this level of evidence is level 3. So when you have a level 1, just go and apply it straight away. When you have level 5, you will just put a question mark on it, and you need to verify it by other means. When you have something in the middle, like level 2 or 3, then you may take it, and also you have to consider other factors that could make you change that. So the timing of surgery here, no randomized trial evidence available up to now. So we don't have like a level of 1. However, it has been known that early surgery is good. If you do the early surgery within the first 12 hours, the results are not good because your patient need to be optimized. So the best results are between 24, 36, maximum 72 hours. And any delayed surgery after that usually has got complications that could be pressure sores, pneumonia, confusion, and others. Question 2, preoperative traction. This is a level 2 evidence to show that there is no evidence to support it is routine use. When I went to UK in 1993, traction was not used at that time, but it was nearly routinely used in Egypt. So I think that has been for a very long time. Nobody's using traction for fracture and neck of femur because you're going to do the surgery within 12 hours, within 24 hours, then there is no point using traction. Prevention of pressure sore, and this is a level 1, that all patients, they have to have, mattress, specific mattress, and this is available and cheap, and it's not something sophisticated. Oxygen therapy. This is a level 2 evidence to support the use of oxygen, not only preoperatively, but also after surgery. Definitely during a surgery, patient is supported with oxygen, but after surgery, for 48 hours or 72 hours, they should be administering oxygen. Thromboprophylaxis, this is a level 1. They should have thromboprophylaxis. There is an update every day about this. I mean, currently, aspirin is taking a lead, especially in US, and, other forms of anticoagulation is still in use in different places. And this is a level 1 that we should have to use this. How about pressure gradient stockings? Yes, there is a level 1 to support wearing these stockings or الشرابات اللي هي بتاعة الدوالي. تمام. Type of anesthesia, that's again level 1 to support the use of spinal or epidural or regional anesthesia rather than general anesthesia. How about type of analgesia? This is a level 2 evidence to say that adequate analgesia before, immediately, and after surgery should be done, and nerve blocks could be considered, and it is useful in some cases. Prophylactic antibiotics, again, this is a level 1, and this should be done during induction, so it would be like a 1 hour before surgery to give the highest therapeutic dose, and this is level 1. However, the routine use of antibiotics for a prolonged period, here there is a level 1 of evidence to say no need for this. Okay, this is something that probably could be questioned in Egypt, and many men might not agree, but this is a level of evidence to say that the dose should be only the first day of surgery. When I practice in UK, they always ask me on the first day of arrival, what antibiotics are you going to use, and are you going to use 1 dose or 1 day? So either 1 dose before induction, some surgeons use this, and many other surgeons may just use only for 1 day, but none will use beyond 1 day of antibiotic therapy. How about the type of surgery? For trochanteric fracture, or a DHS or a nail, whatever it is, it's a fixation. This is a level 1. And using joint replacement for this, yes, occasionally I use this, but the level 1 of evidence support fixation for trochanteric fracture rather than replacement. For undisplaced fracture, intracapsular fracture of the neck, here there is a level of 1 to say that you can either use screws or DHS for undisplaced fracture. And for displaced fracture, this is the one where here you have difficult decision whether to use a replacement or to use a fixation. Here it depends on so many factors. However, the fixation has got a higher risk of failure. But if you have a young patient and you have to do the fixation, then in this case, it has to be done. And you can see the level of evidence is marked in front of every answer, that here you have level 1 evidence. Surgical wound drains, this is a level 2 to say that this is not required. I mean, especially for arthroplasty, I personally stopped using drain now for more than, for just about 20 years. Until 2004, when I was in UK, I was using drains for joint replacement in HS. When I went to the US, there was no drains used for either in US or in Canada when I practiced there. And that's since that time, which is almost now getting into 20 years. Now in UK, no drains are used, especially for joint replacement, whether knees or hips, at all. In Egypt, I know that the practice, many of the surgeons use drains, but here is the level of evidence, as you can see. Post-operative blood transfusion, this is a level 2 evidence to say it is not required in asymptomatic patients, especially with the hemoglobin, if it is above 8, and if the patient is not symptomatic, no need to use blood transfusion. Even this level is starting to get lower, some using it up to 7, and even in some centers using it up to 6. I know that many of the anesthetists will transfuse patients post-operatively if their hemoglobin is less than 9 or 10, but there is no evidence for this. Surgical swabs, this is a level 2 evidence to suggest the calcium hydrogenate swabs to be used. For urinary catheterization, again, this is a level 2, avoiding indwelling catheters and try as much as you can to use intermittent catheterization to reduce the risk of infection. Nutritional status, this is something very important and is usually ignored. I actually do this especially for not only for trauma patients, but also for elective patients coming for joint replacement. And this is very, very useful to fight infection and also to improve the rehab. These patients should have nutritional assessment. Some evidence support using oral protein supplement for 6 months after surgery. Nasogastric tube feeding for some patients is needed. And this is level of 2. Mobilization, this is a level 3 evidence to say early assisted ambulation within 48 hours. And rehabilitation, level 2 evidence to suggest coordinated rehab program early in the post-operative period. And this should be assessed, and patient will not be discharged unless they have really been assessed and their home situation to make sure that they are safe. We answered all these 17 questions, and I'm happy to take any questions after this talk, and thank you for listening.
Thank you so much, Professor Mahmoud Hafiz, for this very interesting talk and this evidence-based talk about the fracture of the femoral neck. If we have any questions to Professor Mahmoud. I think we have no questions, sir. And if we got any questions, yes, we. Yeah, someone is asking about hemiarthroplasty or total hip arthroplasty. Someone, his name is not. Yes, Dr. Fahd. Yes.
Just quickly, it depends on many factors. It depends on many factors. I mean, if you have a patient who's coming with a fractured neck of femur, and activity level is the most important rather than chronological age. So we're looking at the physiological and a functional age rather than the chronological. And if the patient is active, try to do a total joint replacement rather than a bipolar or a hemi. One point I just want to mention that I noticed that some of the trainees, they always think about having a bipolar for the young patient because their acetabulum is normal, so that they don't want to replace the acetabulum. In fact, this is completely wrong, because if you have a young patient, you have to have total hip replacement, because the worst articulation is when you have a metal against either cartilage or bone. this will be eroded, and then this patient will suffer when they have total joint replacement later on because of the lack of bone stock. So this is my message, is that young patients, total hip replacement, not bipolar.
Thank you, sir. I think we have no more questions. Thank you, sir. Thank you so much, Professor Mahmoud Hafiz.
Thank you so much. Thank you.
Stay with us, sir. Thank you so much, sir. Our next speaker will be Professor Hatem Jalal Zaki, Asyut University. Professor حاتم هو من هو طبعا، ويعني وريبريزنتيف بتاع سيكو، يعني دكتور حاتم بيه يعني قمه وعلم يعني. Professor Hatem will speak about multi-ligamentous knee injuries decision making. Professor Hatem, please.
Thank you very much, Professor Mohamed, for the kind invitation and for arranging this great international webinar and the great effort. So I appreciate your invitation with all our professors and colleagues. So the talk today is about the decision-making in multi-ligament knee injuries. And I'll try to give you an idea about how we define it and how we make up our decisions. So these are my disclosures. So the intended learning is we define multi-ligament knee injuries. We tell you about the types and actually the principles of management, how we approach them and when to do what needs to be done. In general, when we say multi-ligament knee injuries, we mean 2 to 4 ligament knee injuries. So less than 2 is not a multi-ligament. We need at least 2 ligaments to define multi-ligament. When we have an actual knee dislocation, that's actually quite rare, fortunately. Less than 0.2% of injuries in general. And we do consider them as a very serious injury with potential life-threatening injury due to the neurovascular injuries that may happen with them. So they are a very serious injury. They should be assessed well and decision taken properly. Amputations does have an instance in these injuries. So if you don't pick up the vascular injury, that can have serious consequences. So the classification, the Schenck classification, he defined KD, which is knee dislocation 1, when you have one of the major injuries, which is ACL or PCL injury. KD2, if you have both the ACL and PCL injured. 3M, which is the 2 central plus the medial ligament injury. 3L, which is the 2 central plus the lateral injury. 4, when you have all the 4 major ligament injuries, and type 5, which is a fracture. Some people differ. I mean, when they say knee dislocation or multi-ligament, it's the same, but it's not actually the same. For the knee to actually dislocate, usually you need your ACL, PCL plus one of the collaterals to be torn. So you cannot rarely have a knee dislocation just with ACL and MCL, for example. So that's why really the knee dislocation can happen with a KD3, 4 or 5, not less. So KD1 and 2 will not be actual knee dislocations, but it will start from KD3 and 4. So the clinical presentation, there's obviously a high energy trauma, but sometimes it's a very subtle injury in obese patients. So don't underestimate that low fall on the ground in obese patients. Deformity will be easily looked at, swelling and ecchymosis from the rupture of the capsule. Dimple sign may happen, which is when you have buttonholing of the medial femoral condyle through the medial capsule. You must check the stability, and the most important is neurovascular examination for any emergencies. We published a long time ago with one of my consultants, the chronic irreducible posterolateral dislocation. So when you look at an X-ray like this, and even if you try to reduce it on the X-ray, you see there's a widened medial joint space that sometimes may signify buttonholing of the medial condyle, and it's an irreducible dislocation. And if you look at the MRI, you can see that the medial collateral ligament is actually inside the knee, and that's why the medial condyle is buttonholed, and you cannot reduce the medial compartment, and this has to be done surgically. There are certain red flags that we must look at. Hyperextension of the knee, usually that means both cruciates are gone and the posterior capsule. Popliteal ecchymosis, that might happen if there's a vascular injury. Of course, we're going to examine the vascular status, examine the peroneal nerve. Sometimes if you have rupture, there's lack of hemarthrosis. So it's not actually swollen. You might think it's not swollen, it's not a problem. But if you actually rupture the capsule, there's no actual knee collection. And don't forget, you might have a very trivial trauma with obese patients that causes a multi-ligament knee injury. It's important to do clinical assessment for the ACL, of course, anterior broad Lachman test, PCL for the SAG sign, We test for medial and lateral in about 30 degrees of flexion, and we test for the posterolateral corner also with the dial test. It's very important to do the proper investigations, X-rays, MRI for all patients. Duplex ultrasound is the minimum to be done. And if the ankle brachial index is less than 0.9, you must do a CT angiography. So these are standard procedure. You must do the first three in all cases of multi-ligament knee injuries to make sure you don't miss a vascular injury. Popliteal injury is up to 30%, sometimes go up to 40 and 50% in some studies. If that's the case, you need a vascular surgeon to come in and repair. At that time, the orthopedic operation will be delayed. You need to do an external fixator, and the vascular surgeons will be working. Common peroneal nerve injury, again, is almost 1/3 of the cases will have that, so you must examine for that. The ankle brachial index is very important. Normally, it's above 0.9. If it's between 1 and 1.4, which you test the blood pressure, systolic blood pressure in the ankle and in the brachial artery. It should be higher. However, if it's less, that means you might have a vascular injury. So if the ankle brachial index is less than 0.5, 0.9, CT angiography must be done. It has high sensitivity and specificity when you're related to that. So don't be afraid to do that. It's very important to check for vascular problems. For common peroneal nerve injuries, sometimes they're incomplete or complete. It has been shown that when you have an incomplete injury, so some muscle weakness, then most of the time these will recover and have a good outcome. In complete cases, only about 40% recover. If that's the case, up to 3 to 6 months, no recovery, then you could go for a tibialis posterior tendon transfer to restore the foot drop. So when do you do an external fixator? Major trauma, open fractures, vascular injury, if you have compartment syndrome, very unstable knees, if you have multiple forward ligament injury, dislocatable, sometimes you need to do an X-fix, polytrauma if you need to do a DCO before you manage the knee, and in very obese knees, when they're very big thighs, the brace doesn't do a good job, then you need to do an external fixator to keep the knee in place till you do your definitive surgery. So the important decision is time of surgery. Are you going to repair or reconstruct? Which grafts are you going to use? Are you going to do it staged or not? And the mobilization and the rehab post-op. Now, surgery is the way to go. Most of the literature supports surgery. No one does non-operative and multi-ligament knee injuries. So the old teaching of doing it in a cast or a splint, and then we don't do that. If you suspect it, you must do your MRI. If it's confirmed, then you must plan for the surgery. Now, when do we do that? It can be done acutely within 3 weeks, staged, in which you do the outer ligaments in the first 3 weeks, and then after another 6 weeks, you do your ACL, PCL, or in chronic cases if they present late, but then you have to reconstruct all and you're looking for more graft. So the advantage of the acute is that you're able to repair some of the ligaments, such as the MCL. So you're reducing the graft needing. For the reconstruct, if you do for the chronic one, then you need to reconstruct everything and you need grafts for everything. So what do we do? For ACL, we do reconstruction. Either you're going to do the surgery open or arthroscopic, depends on the skill available. You can do the PCL, again, open arthroscopic. The posterolateral corner, we're going to do a reconstruction. Of course, that's open. It's the MCL that also has good outcomes if you do a repair in the acute phase within less than 3 weeks. So this is the advantage of doing it acutely. You can repair the MCL and the outcomes are equal to reconstructing. But in the top three, the ACL, PCL, and posterolateral corner, they should be reconstructed, especially posterolateral corner. It has been shown reconstruction gives better outcomes than repair. So where do you get all these grafts? So you can have the hamstring of both knees. You have the quad tendon on the same side. You have peroneus longus on both sides. And this is a very good addition to our scope of grafts. And it's easy access. I encourage everyone doing knee ligaments to learn peroneus longus grafts for their normal ACL. So they have these available for the multi-ligament and, of course, the bone tendon bone. For the MCL, if we're going to do reconstruction, then we use ipsilateral hamstring. We leave the distal hamstring attached, and then we do the pyramid reconstruction with the posterior oblique ligament. For the ACL, we use the peroneus longus or quad. For the PCL, we use the hamstrings. And for the posterolateral corner, again, we're using either the peroneus longus or the hamstrings for the other side. I prefer to do the Laprade technique, but I use one graft, which is through the Y technique modification. So this is an example actually of a patient he came with a trial stage procedure. So someone operated on him, did an MCL and a lateral collateral ligament repair. This failed in this patient. He's actually quite a large patient, and he still came. The ACL, PCL were gone, and the MCL, LCL were very lax. So the examination showed grade 3 everything, ACL, PCL, MCL, and the lateral side completely open. Since this was a late procedure, we decided to do reconstruction for all 4 ligaments. So this is after 3 hours of surgery. We did 10 screws, 2 for the PCL and a staple for the graft. We did the MCL POL reconstruction, and we do the pyramid system, also described by Laprade, anatomic-based reconstruction with an extra staple or anchor for the deep MCL. We do the Laprade for the posterolateral corner with 4 screws with a Y graft and 2 screws for the ACL. It's quite a big surgery, so you must plan really the full team for the operation. Now, the literature has shown with different systematic reviews, reconstruction does better than repair. It's better to operate early within 3 weeks, and you get less arthropibrosis if you do a delayed ACL. But really depends on your system. Are you going to do staged or not? So again, more literature showing this is 60 cases multi-ligament knee injury. Surgical management gives the best results, whether you do them late or chronic, but surgery is the way to go. This study found that doing everything as a single stage procedure is better than doing it on 2 operations. And this is my personal preference. And really the outcome depends on the surgery, the preoperative level, and the rehabilitation after the surgery. Laprade again described over almost 300 cases, anatomic-based reconstructions, early post-op rehab, significantly improved the outcome. And it doesn't matter whether it's ACL, BCL, PCL-based, both of them did very good in the results. Then lastly, we come to the rehabilitation. We give them because it includes PCL and posterolateral corner. We do non-weight bearing for 6 weeks, but with a hinge brace, because we need to start range of motion of the knee as early as possible. So we start partial weight bearing at 6 to 12 weeks, again in the hinge brace, and we start early range of motion up to 60 degrees in the first 1 month, 4 weeks, and then we want to reach 90 degrees in 6 weeks, and MUA roughly to 6 to 8 weeks. And I actually added this as part of the rehabilitation. It's not uncommon that when you do all these ligaments, the knee will become stiff, even if you start early range of motion in the hinge brace and you do a manipulation under anesthesia at 6 weeks. Some surgeons consider that as part of the rehabilitation. You may describe that to your patient. If they're slow in the rehab, do the MUA, they continue their function and they get a much better range of motion. So finally, it is quite a serious injury. It's very important to look at the neurovascular injury, do your ankle brachial index, common peroneal nerve examination. Depends on the time of surgery. My preference is I do them acute, less than 3 weeks, and I do them as 1 stage, not at 2 stages. I want to save time for the rehabilitation of the patient. It's very important to the grafting. I add and I stress out the peroneus longus graft now, very good source of grafting. Reconstruction for everything except the MCL. You may do a repair in the early stages, and early post-op range of motion is a key to minimize knee stiffness. Thank you very much.
Thank you so much, sir, for this excellent presentation. Thank you so much, Professor Hatem. We have 3 questions for you, sir, if you allow me.
Of course.
First question from Dr. Yaqub. In knee dislocation, any evidence to do MRI before XFAX?
So I would do an MRI as soon as, of course, it's an emergency procedure. I would not leave the knee dislocated. You have to reduce it. You put it in a brace. You do your MRI so you know what you're dealing with. I don't want to make the patient enter surgery before knowing what I'm dealing with, because sometimes you may need to do things acutely. You have to check the vascular status before. Maybe he has a vascular injury. That means XFIX might need to be done anyway. So I would reduce it, X-rays, MRI, and then properly evaluate vascular, and then I decide what to do.
Yes, sir. Another question from Dr. Gamal Qasim. Can ultrasonography be used as a tool for net diagnosis of knee ligamentous injuries if MRI is not available?
I don't know how clever they will be in the MRI. Of course, you can do for the MCL. It depends on the skill for the posterolateral corner. ACL and PCL, you cannot really diagnose them with ultrasound that much. I would highly recommend you do an MRI. If you're going to be operating in these very complex knee injuries, my advice is send the patient somewhere to get the MRI, because otherwise you and the patient will be in trouble if you don't have the proper evidence and you know exactly what needs to be done before you go in.
Yes, sir. I'm sorry, sir. We have about 3 or 4 questions also, if you allow me.
Of course.
Another question from Dr. Walid Goma. Sequence of reconstruction if one in staged surgery.
In one stage, so what we do is we go in, we do the tunnels, and then we pass the graft. So we do the central compartment first. We do the tunnels. We pass the graft for the PCL and fix that. And then, so we pass the graft for PCL and ACL, but we fix the PCL as number 1. Then we fix the ACL. Then the knee is stable. Then I usually do the posterolateral corner, and I finish with the MCL, which is the easiest. So I don't want to keep the posterolateral corner till the end because it's actually also a complex procedure. So central compartment, posterolateral corner, then MCL.
Yes, sir. Another question from Dr. Ahmed Majid. Does peroneus longus graft strong as hamstring?
Yes, definitely. There is lots of evidence now in the literature. If you look at all the results, it's as strong as the hamstring tendon. And again, if I have one message for you, the knee surgeons, please go and learn peroneus longus graft. Lots of videos. See it with 1 or 2 surgeons. It is not a difficult graft. Some people are doing it routinely now for primary ACL. So you may do that. Sometimes you're doing your hamstring and it cuts early. You need to have the peroneus longus available right there and then with you.
Yes, sir. Another question from Dr. Ziad Mahmoud. Not sure if this is common with multi-ligamentous injuries, but do you address patellofemoral joint instability with these as well?
It's not in my experience that there is patellar instability. In some cases I've had, the patellar tendon was actually ruptured in addition to the multi-ligament. That makes it easy, actually, decision, because then you're doing it open. The patellar tendon is already open. You just open the knee, you do your ACL, PCL, then you fix back the patellar tendon, and then you do your collaterals. But I've not seen actual instability, and I don't think in that setting of a large trauma, you're thinking about the MPFL and how it would get injured in something like this.
Yes, sir. Another question, sir, from Dr. Saad Abu Zaid. If patient with knee dislocation with vascular injury, should I apply X-Fix? And if so, who will interfere first, orthopedic surgeon or vascular surgeon? How to apply X-Fix in order not to hinder vascular repair?
So it will be a cross knee X-Fix. So both of you will enter the operating room. The orthopedic surgeon starts, you reduce the knee, you put 2 Shan's pins in the femur, 2 Shan's pins distally in the tibia in slight flexion position to help the vascular repair. You're not going to put it in full extension, slight flexion position, and then you're going to finish your X-Fix and leave the surgery. Then the vascular surgeon probably will put the patient, will twist the patient, and then we'll be working on the knee. It will be difficult for you to operate after the vascular surgeon. You may disrupt his repair. He needs stability before you operate, before he operates.
Another question, sir, from Dr. Ahmed Hussam. What's the protocol of management of multi-ligamentous injuries with tibial plateau fracture?
It's well, you need to do everything together. Obviously, what I've seen, what I've had is having an ACL, for example, and a tibial plateau fracture. So I do everything at the same time. So I fix the plateau, I do the internal fixation, and at the same time, I would repair the ligaments so that the patient will have early rehabilitation. So I've had cases which have done MCL or posterolateral corner with the tibial plateau.
Yes, sir. Another question from Dr. Mohamed Riyad. If staged procedure selected, when to start second operation, sir?
Second operation, usually after 6 weeks. So you'd have to stabilize the collaterals in the hinge brace for them to heal. Once those heals, you're doing early range of motion. Once they heal, you could do at 6 weeks the central tendons, central ACL, PCL.
I'm sorry, sir. We have 2 or 3 questions in the chat box.
Of course.
Okay. Another question from Dr. Fahd Kada. In irreducible dislocation, for example, post-total knee arthroplasty hinge type, you still go for advanced imaging or straightforward to the operating theater and open reduction?
Sorry, he said dislocation after arthroplasty?
After arthroplasty, sir.
I will refer it to Dr. Mahmoud.
Yes.
I don't have.
I will take it. I will definitely take it.
I think we have just one more question to Professor Hatem. Can we use the peroneus longus alone for adding?
I don't understand. Maybe he means for ACL. Is that correct?
Yeah, for ACL. I'm sorry.
For ACL, yes, definitely. Lots of papers are coming up now comparing hamstring and peroneus longus grafts, and they're showing equal results and no affection of on the ankle. So this is a nice graft. I used to take all the time quad tendon in addition to the hamstrings. I strongly advise you try the peroneus. You'll be very happy. It's a very nice addition. We're using it in shoulder now as a free graft. We're using it in the knee. So yes, you can use it for primary ACL for sure, and there's evidence to support that.
Yes. Thank you so much, Professor Hatem, for this excellent presentation. Thank you so much, sir.
Thank you, sir.
Our next speaker will be Professor Mohamed Shafai, my big brother, Professor Mohamed Shafai, Professor of Orthopedic Surgery, Minya University. Professor Mohamed Shafai will speak about how to fix medial tibial plateau fractures. Professor Shafai, please.
Bismillah ar-Rahman ar-Rahim. Welcome to all. First, greetings and congrats to Professor Ashhab for such an enormous effort and international webinar. Thanks to the speakers, international speakers, and thanks to EVA company for sharing. I would like to talk about a medial tibial plateau or medial tibial condyle fracture, which is used to confuse me in the past. Why it is different, why it is not very clear, it is not behaving constantly. Is it a pure fracture or a fracture dislocation? There is a wide range of soft tissue injuries associated with it. But I figured out that it is either a coronal or sagittal fracture. Either should be regarded as subluxation or dislocation until proved otherwise. The coronal fracture, as we see, it is caused by compression of the medial femoral condyle in hyperflexion, and the fragment is always large and not comminuted fragments. This coronal fracture occurs only in the medial plateau, probably because of the buttressing of the superior tibial joint to the lateral one. It may involve up to half or more of the medial tibial articular surface, and it displays distally with the medial femoral condyle, subluxing with it infromedially. And the rest of the plateau subluxes anterolateral with the ACL injury is common. And we see that there may be a translation of the lateral tibial plateau. This is a lateral translation. We can see the ACL avulsion imminence. We can see the capsular sign or sign of ACL injury. In this X-ray, we can only or hardly see the fracture, but we can see the double contour of the posteriorly depressed posterior half of the medial condyle. Because it occurs in hyperflexion, it greatly affects the mechanics of the knee as rolling and occurs in flexion. So it must be stabilized. Also, because it occurs in hyperflexion, the neurovascular injury is rare. And when we extend the knee, it is usually stable in mediolateral stressing. This case of a 45-year-old lady presented with a varus, unable to weight bearing 3 months after fixation of medial tibial condyle fracture. The X-ray shows the varus. The articular surface is probably reduced in this X-ray, but the plate is anteromedial. The oblique view shows the posterior condyle, posterior part of the medial condyle is distally displaced. And the coronal cut of CT shows that the coronal fragment is completely missed. So it's a fixed plate and screws to one part of the bone, missing the other fragments. And this is the CT. And intraoperatively, after removal of the plate, the fragment is displaced inframedially, and just elevating this and putting an anti-glide plate did the job, maintained the reduction, and the fracture healed. Coming to the sagittal fracture, which is the other side of the lateral tibial plateau described by Schatzker and colleagues. Schatzker could describe this as a type 4 fracture, a fracture of the medial tibial condyle, but in a rather confusing way. They subdivided this into A or B, whether it is comminuted or not, whether it is porotic or not, and it may be a part of dislocation, and it may fracture the eminence. However, the key is the fracture exit in relation to the eminence. This is the type 2 fracture in the Moore and Hall classification of the knee fracture dislocation. This is type 2, which is they called entire condyle fracture. This is distinguished from Schatzker type 4 fracture by the fracture is passing under the eminence and go to the other condyle. And it may involve the medial or lateral plateau. On the medial condyle, the both cruciates and the deep MCL remain intact. So the medial condyle stay, and rather the lateral one with the tibia is the one who subluxes laterally. The lateral collateral ligament is involved in half of dislocations, or fracture of the proximal fibula may occur. And with such a displacement, both peroneal nerve and vascular injury rates are significant. This paper looked at the a new classification with a prediction of associated soft tissues, and they classified the medial condyle fracture into type A, where the fracture is medial to the intercondylar eminence, B is within the eminence, and C is rather passing the lateral to the eminence, which is the entire condyle type described by Moore. Type C, which is the lateral to the eminence. And the neurological and vascular injuries seen were only in type C fractures. The more lateral the fracture, the more the compartmental and vascular injury, and the less ACL and meniscal injuries. So the sagittal medial tibial plateau fracture is a high energy mechanism injury. It is unstable, represent a variant of knee dislocation. It is caused by shearing or transverse force, displacing the remaining plateau with the tibia laterally. So this presentation, schematic presentation, is probably wrong. The medial condyle does not move, rather than what shows in the CT real, that the medial condyle is stay in relation to the femur, and the lateral one with the tibia is the one who moves laterally. And this is an X-ray one case. The medial tibial condyle is in normal relation to the medial femoral condyle with an intact cruciates and coronary MCL. The lateral tibial plateau moves or translates laterally. And this well shown on the CT, that the fracture passes under the eminence to the middle of the lateral tibial plateau. I go from the lateral side, taking care of any incarcerated fragment or meniscal injury on the lateral side, doing the reduction and fixing by a locked plate. It is actually surprisingly good result with this injury, Probably because there is the cruciates are intact, minimal ligaments injury, and if there is no vascular injury, this result is at 10 weeks full range of motion of the knee. Another case with much more grave displacement, the lateral tibial plateau with the tibia displaces and locked lateral to the lateral femoral condyle. And this is well shown in the MRI. Again, fixation on the lateral side by a locked plate with excellent result at 10 weeks. Full range of motion and good power. Another case with an even more dislocation. The medial condyle remains its relation to the medial femoral condyle. Even in the vascular compromise, after reduction with the Hoffa fracture fixed, it is a good range. So the medial tibial condyle fracture either is coronal or sagittal, and it must be regarded as dislocation or subluxation until proved otherwise. Expect meniscal cruciate neurovascular injury as the fracture exits more laterally. The MCL is usually intact. The lateral collateral ligament may be injured with severe displacement. The coronal fracture fragment displays distally, so it must be fixed by an anti-glide plate with compression. However, the sagittal fracture of the medial tibial condyle displays transversely with widening or translation, and it must be compressed by a buttress plate. Thank you very much.
Thank you so much, Professor Mohamed Shafii, for this very interesting presentation. I think we have a question for you, sir. If we fix the plateau, does the ACL will be lax or it will be fixed tight and not affected? As we said, if the exit of the fracture is lateral to the eminence, then we expect that the both cruciates are intact. But if it goes through the eminence, the ACL may be avulsed. And it is avulsed usually with the coronal fracture of the posterior medial condyle. Yes, sir. If any other questions to Professor Mohamed? I think we will have a lot of questions because it's a very important subject, Dr. Mohamed.
Thank you very much. Greetings, Professor Ashhab.
Thank you so much, sir. I think we have no more questions. Yes, we have one question. Do you fix at the same time with the plateau? No. Do you fix? No, I'm sorry. Do you fix ACL at the same go with the plateau?
Yes. If it is a bony injury, I fix at the same time. If it is a soft tissue injury, is interstitial injury, then I reconstruct left.
Yes, sir. Okay, I think we have no more questions. Dr. Mohamed, thank you so much, sir.
Thank you.
Thank you so much, sir. Thank you so much, sir. Our next speaker will be Professor Mohamed Mahmoud, Professor of Orthopedic Surgery, Cairo University. Professor Mohamed will speak about combined pelvic and acetabular fracture in adolescents. Professor Mohamed, please, sir.
Good evening, dear professors and colleagues. Thank you, Professor Mohamed, for this kind invitation and for your great effort. You hear me?
Yes, sir. We can hear you, sir. We can hear you, okay, sir.
And the screen is shared?
Yes, sir.
Fracture in combined fracture pelvis and acetabular in adolescents. This is 16-year female patient hit by a heavy truck. From the emergency plain X-ray film, we can find she had fracture pelvis, right superior pubic ramus, inferior pubic ramus, left fracture acetabulum. She had associated injuries, left Montague fracture dislocation, rim collection, retroperitoneal hematoma. She was admitted to ICU. And now the question, what is the ideal orthopedic management for her fractured pelvis? Either conservative or operative. The conservative supporter will say she is a female, 16-year, young female, and the fracture pattern is none or minimally displaced, so we should treat this fracture conservatively. On the operative side, we should answer this question. Is this indicated for operative intervention? What is the method of fixation? What is the sequence of intervention? The objective of our lecture, young age effect on decision-making of management of pelvic trauma, patterns of combination, importance of searching about the hidden pathology, and the ideal management. Age effect. Young children pelvic fractures and injuries are peculiar. In this talk, we are not talking about children injury of pelvis, but adolescents. Adolescence means age between 13 and 19. Any patient above 13 years of old, their pelvic fractures characteristic and indication of operative treatment are equivalent to those in adult. And this is the most important statement in my talk. The aim of operative intervention, emergency measures for damage control associated pelvic organ injuries, stabilization of fractures and restoration of the anatomy, and avoid later complications as limb length discrepancy, osteoarthritis, and so on. The spectrum of injury, the combined pelvic and acetabular fracture, range from the left picture, which we hardly can see the fracture, to the right one, which measure displacement and fracture and dislocation. So it is not one type. The mechanism of injury in this combined injury is not clear as single. Usually there is a lateral injury vector, an external rotation force, and usually combined mechanism of injury. On the pelvic side, usually the injury type are anteroposterior compression and lateral compression. And on the acetabular side, usually transverse, T-shaped, and associated both columns. But any type can occur. This is the statistically type according to statistic. The associated injuries, there is a high injury severity score, need for blood transfusion, many other system and organ injuries. So we should follow the general rules of management of polytrauma patients. First, we should define the fracture and the injury through precise, systematic, and detailed imaging. Easy to focus on the acetabular fracture. Please don't overlook the subtle injuries. The scenario is that usually the acetabular fracture is very clear. So every patient has acetabular fracture. You should search in detail the rest of the pelvic ring to not miss any combination injury. Because these combination injuries is common and more common than we think. The potential combinations are acetabular fracture plus anterior pelvic ring injuries, posterior pelvic ring injuries, and combination of both anterior and posterior pelvic ring injuries. Return back to our case. This is the anteroposterior film we have seen. Now, after making an oblique obturator view, we found this. So this is fracture acetabulum transverse type with a posterior wall large fragment, and maybe have been dislocated and reduced hip. Doing outlet view, looking at the sacroiliac joint in a more detailed, precise way, you can find that there is a sacroiliac injury. The sacroiliac is widened and there is a fracture at the ala. More precise, looking at the elite view, you can find that the sacroiliac joint is not in its place and compare it to the sound side on the right side. So definitely there is a sacroiliac injury. Going more detailed by studying the TT cuts, the axial cuts at the acetabular level, you can find the posterior wall and the fracture acetabular pattern. With reconstruction, 2-dimension, you can see more detail of the fracture pattern. At the sacroiliac joint, now we can notice that the sacroiliac joint is completely disrupted. It is not a mild injury. With reconstruction, 2D view, you can find this is a fracture dislocation at the sacroiliac joint. So after studying in detail this imaging, it is not a simple non-displaced fracture, but this case is a combined fracture acetabulum, transverse posterior wall, plus fracture pelvis, type C completely unstable, posterior ring fracture dislocation at sacroiliac joint, and anterior pelvic injury. So what is the treatment strategy? Consider each injury separately. You should study each injury separately and then plan operative approach. Is it ideal for a single approach? If a possible, or it is a possible for stage and sequential approach. In your plan, please start by making a stable platform. You should build a platform or a base on which you build the rest of your fixation. And this platform should be connected to the axial skeleton. So we are talking about the sacroiliac joint. Concern anatomical reduction, stable every injured point. No mobile point is allowed. In the present case, on the pelvic side, we performed posterior ring percutaneous iliosacral screw fixation, anterior ring percutaneous retrograde anterior column or superior pubic ramus screw, and on the acetabular side, we performed open reduction internal fixation with double plating for the posterior wall and the transverse element. This is the post-operative X-ray, inlet and outlet view showing that fracture pelvis is anatomically reduced posteriorly and anteriorly, and oblique views for the acetabular reconstruction showing anatomical reduction of the transverse fracture acetabulum and the posterior wall. To conclude, adolescent pelvic injury is equivalent to adult pelvic injury. There is a wide range of the spectrum of this combination. Please achieve precise detailed image studying, individualized treatment plan. Consider starting rigid axial posterior platform. Strive for anatomic reduction and rigid fixation. Thank you.
Thank you so much, Professor Molhem, for this very interesting case presentation. حالة رائعة يا فندم والله.
العفو. شكرا دكتور محمد.
Thank you so much, sir. If we have any questions to Professor Molhem. I think we have no questions, sir. Thank you so much, sir. Oh, yes, we have one question. Dr. Yaqub is asking about sequential fixation.
Yes. As I recommend, you should start by fixing the pelvic ring to the axial skeleton. The problem in combined injuries to the acetabular and pelvic, that the acetabular site in the space or location will be changed. So you have to make an stable platform posteriorly to the axial skeleton. Upon this platform, you can build your other fractured part. So we started by fixation the pelvic ring by iliosacral screw and the anterior ring by retrograde screw. Then the patient put on prone position for posterior fixation of the acetabular wall and transverse fracture.
Thank you so much, sir. I think we have no more questions. Thank you so much, Professor Mohamed.
Thank you. You're welcome, Dr. Mohamed.
Thank you so much, sir. Our next speaker will be Professor Mohamed Fadel, our dear professor, Professor Mohamed Fadel. Professor Fadel will speak about crushed lower leg bone and soft tissue, a case for discussion. Dr. Fadel, you are with us, sir? Dr. Mohamed, you are muted, sir. Dr. Fadel, you are muted, sir.
Is it right now?
Yes, sir. Yes, sir. Okay.
Thank you. I'm sorry.
Thank you so much.
Good morning for this early marathon day, a new day. We bypassed the other day. Thank you, Professor Mohamed Ashhab, for this.
Thank you so much, and sorry for being late, sir. Thank you so much, sir.
No, for these fruitful days, it's very nice and fruitful hours, and you give us a chance to meet experience from the different friends from all over the world. I would like to appreciate your trials and also your invitation. Thank you so much. And also for our participants from all over the world and our friends who share us now from either from Egypt or from different countries all over the world. I am live with you, but I couldn't see that I am in the photo, but I didn't like to play with the camera. May I disturb something? But I am live with you. It is not recorded. I am Mohamed Fadel from Eminent University, 240 kilometers south to Cairo, lying on the River Nile, and belongs to many associations all over the world, but stay that the Egyptian Orthopedic Association is the most beloved one for me. And I'd like to kindly remind you to see you in November with the Egyptian Orthopedic Association and CICOT, which will be also another international live in-person conference. Nothing to be disclosed from this case presentation. When we talk about crush injury of the lower leg, we find that two topics erupted actually in front of us, the bone defect and the soft tissue defect. 2 points will be appear. Many conventional methods are used for bone defect or soft tissue defects and also for combined bone and soft tissue defect. The need for microvascular consultation is a major obstacle, either to reconstruct the bone defect alone or concomitant bone and soft tissue defect. Another 2 points is that the specific method of skeletal reconstruction of those are a topic of controversy, and the problem increases so much if there is massive bone loss, soft tissue scar, vascular compromise, and short tibial ligaments. Returning to our case, it is a case of multiple trauma patients, open fracture, grade 3B, crush injury, actually not open, simple. It is there is a skin loss, crushed muscles, exposed tendons. Moreover, there is a bone shatter, the combination with deficient parts and open disturbed joint and the tendons exposed as we see here. At least just the medial and lateral malleus is in place and the other is disturbed, the lower stern at all. So assessment as usual, ATLS, polytrauma patient should be managed as it is, serious one, mangle extremity score to check if it is amenable for salvage or not, and damage control surgery would be assessed. The assessment to not include only the patient, should be include the surgeons, the hospital, the capability of the hospital to deal with such cases, and the post-operative follow-up. The outcome of this is that we have a bone defect and soft tissue reconstruction. Muscular technique, bone transport, vascularized fiber graft is used and conventionally famous that it is a very good solution for bone defect reconstruction. On the other hand, also primary versus secondary, skin grafting, flaps, and female-facial flaps successful in many instances to soft tissue reconstruction. So we dealt with it as we think with each other that need aggressive debridement, no wound closure to give the chance for our friends to ask them. So we apply unilateral frame and gives a chance for the plastic surgery. We suggested that he would do the best. We couldn't do this if we have even to stay 1 or 2 days to wait him. So the consultation of plastic opinion is nothing to be added if no working as a team, and it is the case in many instances. So it is a time lag for soft tissue reconstruction, and it is a more problem if we find that we will do the bone first, or the soft tissue defect, or the soft tissue defect, and then the bone, or the combined bone soft tissue in one session, which is so difficult, and all agree that all these capabilities should be followed or associated with stability by whatever, external fixator, ring fixator, or hybrid, or internal fixation. What the plastic surgery chooses to do, simple posterior skin release and skin grafting. A long story that resulted in soft tissue failure, and we still have open wound as it is for the crushing, and the tendon is exposed, and the return again for our circuit, we call it return option requirement. In these cases, we look for the result of assisted technique as the only solution in our hands, and we are obliged to work as an orthopedic surgeon and a plastic surgeon in the same time. So the operative procedures as used, debridement, sequestrum, if there antibiotic, and application of Elizarov, and looking for using Elizarov assisted technique, and using the versatility of the external fixator in these instances, and planning first for the soft tissue reconstruction. We apply a diagram and found that it is 4 centimeter for cubic centimeter and another 2 centimeter on the other hands. So we plan for doing this. Here we can explain that the technique is to do underneath this a wire, then 3 hooked wire attached each one to a slotted threaded rod. This threaded rod and attached to a plate. This plate mounted to the foot and tibia plate. It is looks here well more. How it works, the skin follow this traction hit to cover this area, which is here in the diagram is clear. Another one kit is applied to the other direction to track this to cover these tendons and the bone in this area. Looking for the X-ray to find that the bone is it's distracted anteriorly and displaced anteriorly, and also in the EP view it is distracted more laterally, and the skin kit is working well. So we will find that later on that also the bone is not working well yet. So we do distraction between the distal part, the distal construct, to have a room for moving by these olive wires, to have the bone to be in between these both ends, between the foot and ankle and between the distal part of the tibia. This is the kit of the skin, how it is works. And then after removal of the kit and improving the skin, and then after removal of this huge skin traction kit, we have now the patient walking well, and follow-up proved that there is a very nice and aligned until this, it was this beforehand, and now it although fused, but it works well in alignment and no deformity, and we have a very good skin coverage and everything is well. So either we are working well with our friends in the plastic surgery, but in some instances we are obliged to do both SAM. These techniques have been adopted since 20 years ago. This is a paper had been published by me and Professor Jamal Hosni, and this is presented in Kurgan Elizarov Institute in 2007, around also 20 years. So discussion, we can say why we use this complicated thing. Use it because it is so difficult to use microvascular, so difficult, and you need time to use bone transport, and muscular technique need more bone, which is in many instances, this is the microvascular, how it needs skill, which is not usually found in our cases. And this is how much bone needed in both iliac wings, which had been taken to reconstruct for this infected manual for a long time. We need more bone, and also bone transport need more time. So the problem more is for skin coverage to climb this step ladder of the skin climb, or to do this problem of microvascular skills that have been needed. So we can say that looking for as a message or a conclusion, in the case of return option requirements for these cases of plastic surgery and bone and soft tissue defect concomitantly, we prefer to use the Elizarov assisted technique to solve the problem of both bone and soft tissue defect in one session and by the hands of the orthopedic surgeon on. Thank you.
Thank you so much, my dear Professor, Professor Mohamed Fadel, for this excellent case presentation. It's a disastrous case, sir.
Thank you so much, and I hope that I stick to the time, because I know that it is too late for all of you.
No, thank you so much, sir. We have a question to you, sir, from Dr. Fahd. How you decide the length of distraction, and any difference between Elizarov and TSF in such cases?
Yes. Although actually it is a very good and complicated question, didn't evolve except from a colleague who is working in the field. I think that the problem of measuring the distance, as you see, it is crumpled from up and down. So you do distraction and follow it either by pressure by your thumb to feel the steps, because the tibia is a unique because it is subcutaneously. This is one, but it is not the only to be used. You should do distraction between the foot piece and the distal part of the tibia. Distraction more, because you will do after distraction, you will do dragging or pushing the olive wires to rearrange and reposition this scattered and shattered bone from the anterior displacement of the foot. All this construct should be distracted posteriorly, not only posteriorly, but also distracted medially. It is a very complicated one. Actually, though Taylor special frame is unique for doing difficult and so severe complicated cases, but actually in my hands, as I worked early in Taylor special frame since 20 years ago, but actually by using Elizarov and the manual work of Elizarov, if it is done carefully, the marvelous effect of it in such cases is much better than that of the Taylor special frame, which needs more many times to go through the system and to go through the hardware or the program of the telespecial frame to rearrange and put numbers and put some angles and to get out and to have output. This output to be followed, or it is a long story in my opinion. I think that maybe those friends who are acquainted and working all daily with the telespecial frame may say against this, but my feeling is that it works well in this condition much better than that of telespecial.
Thank you so much, sir. I think we have no more questions. Dr. Fadel, thank you so much, sir, for being with us in this time. Thank you so much, sir.
Oh, you are welcome, and go ahead. It's very nice and fruitful for us all.
I think we have just one more question. Can that applied by external fixator?
Yes, it is a very good question. This is to support our idea that it is not possible to be applied by external fixator, except if a system, a specialized system, had been devised by the orthopedic surgeon to do it. It is not away from our artistic and our, you can say, designing for something to help this. If I would like to do it, I can do it, but it is so problematic. The idea of Elizarov is to apply this to correct angulation, to correct rotation, to correct the displacement, and in all these instances, to correct the soft tissue defect. And moreover, is to give the chance for the patient to walk from the first day of his operation, which is the most unique effect of Elizarov. So it is, in my opinion, it is so difficult and they need a special device. And I didn't know that there is a special device that helps for soft tissue expansion by using monolateral fixation. Otherwise, you can use monolateral fixation assisted with soft tissue expansion, that is the conventional one that had been used by our friends in plastic surgery, or using some assisted things of negative wound pressure or VAC as a famous name, to do some wound closure or reconstruction. But the problem of it is that it needs a bed, a good bed to work on. And in this case, I think it is no bed to work on.
Thank you so much, sir. Thank you so much. Our next speaker will be, thank you, sir, will be Professor, my dear brother, Professor Mahmoud Rosasi, Professor of Orthopedic Surgery, Tanta University, and one of the administrative board of the Egyptian Orthopedic Association. Professor Rosasi will speak about post-traumatic complex ankle deformity with infection. Professor Mahmoud, please. Dr. Fadel, would you please stop sharing your screen, please, sir? Thank you, sir. Professor Mahmoud.
السلام عليكم ورحمة الله وبركاته.
عليكم السلام ورحمة الله وبركاته. عذرا على التأخير يا فندم، معلش ظهرت حضرتك معانا يا دكتور محمود.
لا أبدا، تحت أمرك دكتور.
ربنا يخليك يا فندم.
Thank you to Ashhab for this kind invitation and enormous work and tremendous symposium today. Good morning, everybody.
Morning, sir.
I will present an interesting case of severe post-traumatic ankle deformity in a 14-year-old child. This child presented to us at the age of 14 years. He had a history of run-over injury on his left ankle joint at the age when he was 7 years old, with extensive bone and soft tissue loss on the lateral aspect of the ankle, managed at that time by initial management, serial debridement and split thickness skin graft. Due to lack of or loss of the lateral support by the lateral malleolus, there was lateral talar subluxation and the drift of the foot into varus deformity. His treating surgeon, to avoid the infection and bad soft tissue condition at the ankle joint, he did a supramalleolar valgus osteotomy. So he created an opposite deformity to correct the varus deformity of the foot. And as we know, two opposite angulations will equal one translation. And the end result is that he presented at the age of 14 years with this severe deformity, where the joint orientation line of the ankle joint was always perpendicular to the joint orientation line of the knee joint, and the foot was placed on the lateral aspect of the leg. And this is the way he was walking. The foot was non-showable. He cannot wear shoes, and markedly translated and angulated with a severe deformity at the distal tip. And to make things worse, we can see here the bad soft tissue condition and the unhealthy skin graft on the lateral aspect of the ankle, with a sinus penetrating into the ankle joint, draining with active infection, extending into the ankle joint. In such cases, we usually put a problem list to be able to put a treatment plan. So if we summarize the problem list for this case, there is severe deformity, ankle joint subluxation, and the ankle is almost disorganized due to long-standing subluxation and the active infection, the presence of deep infection, and the bad soft tissue condition due to unhealthy skin graft on the lateral aspect of the ankle. Deformity analysis and operative planning. We usually do these lines intraoperatively under imaging our surgery. We can see here the joint orientation line of the knee and the joint orientation line of the ankle perpendicular to it, distal. And there is a cora at the distal tibia with the angulation anterior medially about 90 degrees. Traditionally, in such cases, we do osteotomy at the distal, at the cora, apply alizaroferine for gradual deformity correction for such a large magnitude of the deformity. However, this direction in such a case, due to unhealthy soft tissue on the lateral aspect, such unhealthy tissue can never withstand this direction for a large magnitude of the deformity correction and the presence of active infection. We usually say that soft tissue loves bone shortening. Whenever you have a bad or unhealthy soft tissue, it's better to go for bone resection to allow safer correction of the deformity without any tension on the soft tissue. So we did resection of the distal tibia, aiming at tibio-talar fusion. As we mentioned before, the ankle joint was disorganized and non-salvageable, so the aim was tibio-talar fusion. So we resected at the level of the cora. We did acute correction of the deformity and the modest shortening, leaving a gap. This transcalcanean wire will maintain the alignment of the foot under the tibia and will guide the transport of the tibial segment to achieve tibio-talar fusion. We did a proximal tibial osteotomy for re-lengthening. For first, bone transport, what's called internal lengthening, and then the lengthening of the whole leg, which is the external lengthening. This is during a treatment. Very important that the incision was placed on the healthy convex side, and we do the no skin elevation or subcutaneous dissection. The incision will go through the skin subcutaneous tissue and the periosteum as one flap to maintain vascularity. And despite all these precautions, we can see here superficial skin necrosis of the unhealthy skin on the lateral aspect. However, during the distraction proximally of the osteotomy and at the time of achievement of the tibio-talar docking here distally, we can see here epithelialization and the healing of the necrotic skin and the eradication of the infection. This clarifies or explains the effect of distraction histogenesis on the distal, improving the distal perfusion of the leg and the healing of the soft tissue.
In cases of ankle fusion, you have no reference distally to measure the tibial length, so we rely on the clinical measurement of leg length in this way. The patient is sitting on a wheel in a chair with the knees flexed at 90 degrees, and we apply a water scale or ruler on the knees, both knees, to make sure that both knees at the same level, so automatically both legs are of the same length. Usually in doing ankle fusion for adults, we intentionally leave the fused side shorter, about 1.5 to 2 centimeters, to allow for rocker bottom shoes wearing. But for this child, he's only 14 years old and is expected to grow more until the age of 16 or skeletal maturity. So we intentionally equalized both leg length, so when he is skeletally mature, he will have a residual leg length discrepancy of 1.5 to 2 centimeters, allowing them to use rocker bottom shoes. This is at the end of treatment. Before frame removal, we can see here the regenerate more than about 11 centimeter regenerate of internal and external lengthening. This is more than 40% of the total length of the initial length of the tibia. And the tibiatellar, very nice tibiatellar fusion. No skin graft or bone graft was used in such a case. After removal of the fixture, automatically we have to apply cast, full cast, to avoid regenerate fracture or deformity, and allow the patient weight bearing for 1.5 months. We can see here very nice consolidation of the regenerate and the fusion side, the healing of the skin, unhealthy skin, and the complete eradication of infection, and marked improvement of the soft tissue condition on the lateral aspect of the ankle joint. And this is the gait of the patient before treatment and the shape of his foot. And after treatment, we can see here the foot is well aligned under the tibia, the gait with equalization of leg length. However, due to the fused ankle joint, he cannot, he is walking heel to heel gait. This is improved by wearing a rocker bottom shoes, as we see here. To compensate for the fused ankle, we can see here the rocker bottom shoes improved his gait too much. Okay. And thank you.
Thank you so much, Professor Mahmoud Rosasi, for this very nice case presentation. Thank you so much, sir.
Thank you, Dr. Ashhab.
If we have any questions to Professor Mahmoud. It's a very interesting case, sir.
Thank you. Thank you.
Yes, we have one question. How did you deal with deep space?
Yes, we did some acute shortening, the modest acute shortening, and the left space, we did the bone transport and doing the compression destruction. The compression by itself will gradually obliterate the dead space. And as we mentioned before, when we do bone resection for deep infection, you actually do your debridement through a transition zone, not completely healthy tissue. So there is residually infected transudate. Doing gradual compression will squeeze out this infected transudate and gradually obliterate the space. And this is the beauty of the destruction compression technique.
Yes, sir. Another question. For how long is applied?
This case took about, due to his young age, the bone formation was very beautiful, and it took us about less than 6 months to complete his treatment.
Yes. Another question. Did you do graft at the docking side?
No, at all. No skin or bone graft, healed spontaneously.
Another question from Dr. Mohamed Osman. Can we use fibular transport by Elizarov in this case?
Fibular transport should be reserved for extensive bone loss, tibial bone loss, usually in excess of 10 centimeters at least. But for such cases,
it's better to do tibial bone transport.
Okay. Thank you so much, sir. We have no more questions. Thank you so much, Professor Mahmoud. Now we will move to the next speaker. The next speaker will be my dear brother, Dr. Mohamed Laklouk, Professor of Orthopedic Surgery, Minya University. Professor Mohamed will speak about role of external fixator in tibial plafond fracture. Professor Laklouk, please.
Bismillah ar-Rahman ar-Rahim. Our talk today about role of external fixation in balloon fracture. First, I would thank my great brother, Dr. Mohamed Ashhab, for this great international trauma webinar, and many thanks for our lovely association, Egyptian Orthopedic Association, and here Eva Pharmacy for this sponsoring of this nice meeting. Balloon is a French word for a pestle. We can see the tailors like this piston. Also, plafond meaning a decorated ceiling. A tibial plafond fracture, also known as a balloon fracture, is a fracture of the distal end of the tibia. Some state that it is about 5 centimeters from the ankle joint. 3 important anatomical structures related to the balloon fractures are the articular facet of the tibiotalar joint, metaphysis of the tibial shaft, and the fibula. Most commonly associated with intra-articular extension, like these X-rays, comminutions, and significant soft tissue injury. So the 3 main structures for a balloon or plafond fracture: significant soft tissue injury, comminution, and intra-articular extension. History of balloon fracture. It is first stated in 1911 by Etienne Distot, and Gerson in 1959 he told that there is imposition. Leach and Sick states that fibular fixation alone is enough for stability of tibial plafond. But Rudy and Algauer in 1969 talk about details of injury of the balloon fracture, and in 1979 talk about the result of open reduction internal fixation of the tibial plafond fractures. The statistics of the balloon fracture, about 1% of all fracture, 10% of the tibial fracture. It represents about 30% of open fractures, and 10% of these balloon fracture eventually go in for arthrodesis of the ankle joint. First, we must differentiate between the fracture of the ankle and balloon fracture. Ankle fracture is typically associated with lower energy mechanism, such as twisting injury or descending from stairs or sport injuries, and occur by either pronation or supination injury, which lead to push-off injury or ball-off injury for medial or lateral malleolus, sometimes with rotation and ligamentous injury or posterior malleolar injury. But balloon fracture are intra-articular fracture of the distal end of the tibia that involve a significant portion of the weight-bearing articular surface. Occur with high energy to the ankle may be caused by either motor vehicle accident, fall from height, or severe sport injuries. True bending, the mechanism of injury for balloon fracture either occur with true bending, which is a rare injury and usually occur in porotic bone. Torsion force leads to mainly ligamentous injury, but axial compression, which is the most common cause of injury, lead to more comminution, more soft tissue injury, and more articular damage. Pure compression is rare. It's usually associated with either inversion or eversion. Balloon fracture results from an axial load with disruption of the weight-bearing articular surface. The articular component will involve either weight-bearing surface, medial malleolus, lateral malleolus, or posterior malleolus. The degree of comminution of the articular surface and the damage to the articular cartilage and the joint surface incongruity lead to worse outcome of these injuries. Foot position decide fracture pattern. If the force is applied with the foot in either plantar flexion, like this injury, lead to fractures result in posterior malleolar injury. Like this mechanism of injury lead to fracture of the posterior malleolar injury. With continuation of this injury, and this is the X-ray of the posterior malleolar injury. If another mechanism of trauma, like sliding in the wet floor, also lead to posterior malleolar injury because there's a vertical compression force with plantar flexion. If the force is applied with the foot is dorsiflexed, like fall from height with dorsiflexed foot, this leads to vertical compression force and fracture of anterior malleolar injury. Classification of the pelvic fracture. The purpose of the classification is to aid the surgeon in selecting a treatment methods, provide prognostic value. AO classification is the most famous classification. Number 4 means fracture of the tibia or fibula. Number 3 means fracture at the distal end of the tibia, and subdivided into A for C, complete articular, which is more subdivided into 3 subgroup, either simple or wedge or multifragment, split or split depressed or depressed, or simple articular multifragmental metaphyseal, or multifragmentary epiphyseal and metaphyseal. Rudy and Delgado classification, there is 3 subtypes, either non-displaced interarticular fracture, displaced without comminution, and displaced with comminution. 3-column classification was based in the CT radiology. There is divided the distal end of the tibia into anterior and posterior column by the intermalleolar line, lateral column by the fibula, and the medial column for medial malleolus. Because we deal with external fixation, we must know a lot for soft tissue injury so we must know the AO soft tissue classification is either closed skin lesion or open skin lesion. Closed skin lesion, type 1, no evident skin lesion. Type 2, no skin laceration but only contusion. Type 3, circumscribed degloving. Type 4, extensive closed degloving. Degloving means there is a separation of the subcutaneous tissue from the fascia, and this is gap filled with hematoma and liquefied fat. This photo shows it's open degloving injury with this wound in the skin, and this photo shows closed degloving injury. There is no wound in the skin, but there is bloody vesicles. Type 5, necrosis from contusion of the skin. Open skin lesion, either skin breakage from inside down. Type 2, skin breakage from outside in, but the lesion is less than 5 centimeters. Type 3, lesion more than 5 centimeters with increased contusion and revitalized edges. Type 4, full thickness contusion. And type 5, extensive degloving injury. For muscle and tendon lesion, type 1, no muscle injury. Type 1, only in 1 compartment. Type 3, into 2 compartments. Type 4, in 3 compartments. Type 4, there is a compartment syndrome or crush syndrome. Also, the muscle and tendon lesion, type 1, no neurovascular injury. Type 2, only nerve injury. Type 3, localized vascular injury. Extensive segmental vascular injury, combined neurovascular injury with subtotal or even total amputation. Journey classification. We now talk about the treatment of pelvic fractures. Several options having various advantages and disadvantages have been introduced for the treatment of pelvic fracture, either closed reduction and casting, combined intermodular nailing, complete fixation, open reduction and internal fixation, minimally invasive plate, external fixation, or 2-stage treatment. Despite recent advantage in medical science and technology, the treatment of pelvic fracture has remained challenging. None of the available treatment methods could be considered as the gold standard for treatment of pelvic fracture. This is due to severe injury, soft tissue, high energy pattern of the fracture, and severe edema. Soft tissue injury is an important reference when determining the optimal timing of internal fixation and the surgery and choosing the type of fixation. So we can see this a lot of injury of skin in this condition. The goals of treatment for biological exposure, articular surface restoration, bone graft metaphyseal defect, pattern split fixation, atraumatic closure, early active range of motion, protected with bearing. The reduction is very important, single most important factor for better function outcome. Fracture reduction quality is more important than implant choice for stability. The reduction can be done by direct reduction, through open reduction, or percutaneous reduction, indirect reduction either by calcaneal traction, mobile traction, external fixation, elizaro fixation, or distraction. Like this case, in my case, there is only reduction through ligamento-taxis. There is not a single method fixation ideal for all pelvic fracture and suitable for all patients. There is a lot of type of external and internal fixation methods. There is a lot of questions that come to our mind in treating pelvic fracture. If consider the trauma, we must know the type of injury, either high energy or low energy. According to soft tissue classification, we can choose this algorithm. If the fracture is open, we can do debridement and application of negative pressure dressing, and then external fixation, or closed, we can restoration to the type of fracture we can manage. According to that type of fracture, we have a type A and B, and the type C1, we can treat it through open reduction internal fixation with locking plate using minimally invasive technique. Type 2, C2, and C3, according to, we can use external fixation. According to the type of implant, we have either open reduction internal fixation, or external fixation augmented with minimally invasive technique. The external fixation either by elizaro or monolateral fixation or hybrid external fixation. According to the technique, we can talk about reduction sequence, approaches, and the fibula fix or not, and the outcome. Timing of injury, either timing of treatment, either acute treatment or delayed intervention or staged procedure. Indication for operative treatment: articular step more than 2 mm, valgus angulation more than 5 degrees, any varus, open fractures, compartment syndrome, vascular injury, or polytrauma. A non-operative indication: undisplaced stable type A1 or significant comorbidities, excessive risk with surgery. Surgical timing: we can do either acute intervention or late after 6 days, and avoid from the first and 6 days because this is a bad general condition of the soft tissue. So in this case, we cannot do immediate intervention, so don't touch the patient, or just do traction and do delayed intervention. Acute definitive open reduction internal fixation indication in simple and close minimal soft tissue injury within 1 day of a trauma and with experienced surgeon. But the drawbacks: there is a severe skin problem, especially when you use large plates, may further compromise the availability of the bone and the damage of soft tissue. Staged management is if there is any skin complication. Indication of first aid state management for stabilized injury, like this X-ray. Reduce soft tissue tension and management open wound till improved, and then do definite treatment. Decrease severe pain. Why we need the first stage? For allowing soft tissue to settle and further imaging and plan joint reconstruction by either open reduction internal fixation or continue with external fixation. But the drawbacks of the delayed intervention: it's long-term hospital stay, increased risk of infection, lack of anatomical reduction due to delayed operations. The first stage done by either temporary fixation or plus or minus overreduction internal fixation of the fibula as soon as possible, and do ligamento-taxis to reduce the fractures and stabilize the fracture with soft tissue soft tissue recovery. We can use price in principle, LP like protection, R for rest, I for ice backing, then compression and elevation. Plus or minus fibular fixation for controlled talus position, we use this posterior subluxation of the talus. After reduction of the fibula, we can see that the talus reduced for normal position. The use of the drawbacks of fibular fixation is complication of the skin, like these wounds. We can use intramedullary fixation of the fibula to avoid this skin complication. Other step for the first aid, early fixation of simple articular component to convert type C to type A, like this X-ray for the restoration of articular surface. Also, early fixation of the simple metaphyseal component for conversion of type C fracture to type B fracture. Why we do early fixation of this metaphyseal fixation? Because later in the second stage, there is a difficulty in reduction of this fragment after removal of the fixator, and it is for interfragmentary fixation of metaphyseal fragment. When we use traction by external fixation as a first step, we must fix the first ray or the medial cuneiform or cuboid bone to prevent procurvatum deformity of the distal tibia, like this photo. So we must need fixation of the first ray. We can use external fixation as a definitive treatment, either in isolation or with limited articular fixation, or interfragmentary screw for the metaphyseal extension, or can use olive wire within the frame of Elizarov, plus or minus fibular plating, and supplemented overreduction internal fixation by minimal or many adhesive plates. The advantage of Elizarov external fixation, it is a circular frame, provide better stabilization, especially in comminuted lesion and with soft tissue injuries. It controls the fracture in all three planes of the reduction. We can use through it olive wire for syndesmotic separation and reduction of articular cartilage, for fixation of the tibial malleolar fragment. Also can even provide a horizontal compression for spiral fracture of the metaphysis or diaphysis. Inclusion of the foot in the external fixation and using as a joint spanning are also possible with the using of Elizarov external fixation. If we compare the result of the two-stage internal fixation with methods with a definitive external fixation, the period of fracture union was longer for two-stage group, but the rate of non-union, malunion, and the infection were higher in external fixation group. We can use first aid or the first stage either by external traction fixation, or use a resuscitation distraction frame or traveling traction frame. All these a different method of traction for our ligament taxis for this pilon fracture. The disadvantage, the distal fragment can be displaced posteriorly as we mentioned before. It is entry point for using the Chan's half pin. When we use Elizarov method for fixation for the management of pilon and the distal tibial fracture, a technique guide, we do the proximal construct of the frame, and this is for foot pieces for the foot, and we have a floating ring in front of these fractures. Then apply the Elizarov. After ligamentotaxis, we can fix the fracture by wires and fix the calcaneus through the foot piece. And we can use distraction for a reduction of the fracture. Then adjust the floating piece in front of the fracture fragments. And we can use olive wire for compression of the fragments and reduction of and maintain stability of this fracture after reduction. Then reduce the lateral fragment by this wire. Then decrease the ankle joint distraction after fixation of this fragment by the olive wires. And the final frame reconstruct. Thank you.
Thank you so much, Professor Mohamed Laklouk, for this very interesting talk. We have just one question. Can we do primary arthrodesis from the start?
I'll try first to try to reduction. But if there is extensive injury, we cannot do reconstruction for this fragment. We can do, in some cases, primary arthrodesis.
Yes, thank you so much, sir. Thank you for joining us, Professor Laklouk. Thank you so much, sir.
Okay.
Can we stop, please, the sharing screen, sir?
Okay.
Thank you so much, sir. Our next speaker will be Professor Ahmed Rami from Helwan University. Professor Ahmed Rami is my little brother. Thank you so much, Professor Rami, for joining us tonight. And sorry for being late. Professor Rami will speak about posterior malleolus fracture from another point of view. Now we see the Egyptian point of view, not the UK point of view. Thank you so much, sir.
Thank you, Dr. Mohamed, for your kind invitation and for your continuous support for the process of continuous medical education. As you said, we now try to present the Egyptian point of view for the posterior malleolus fractures. Now I'm sharing my screen. Can you see it? Is it clear, Dr. Mohamed?
Yes, sir.
Okay, thank you. Actually, posterior malleolus fractures are still controversial till now. When we review the literature, we will not find a clear consensus on the treatment, but on the treatment for the fracture, especially that there are many patterns for the posterior malleolus fracture. This is one example of these patterns where we can see here a very small fragment in the posterolateral corner of the distal tibia. And this is another pattern where we can see a larger posterolateral fragment. And this is a third pattern where we can see a large posterolateral and posteromedial fragment, and it's more clear here in the 3D view. Our ILO is to describe the indications for surgical treatment for the posterior malleolus fractures. Actually, when we go through the literature, we will find that there was a clear consensus on that a size about 20% or more of the tibial of the distal tibia is an indication for surgical intervention. And it's clear that it's 20% in the lateral UX. However, later it was proven that the lateral X-ray overestimates the articular involvement of the distal tibia if it's compared to the CT, and this study has proven this. These are two examples of two patients. Here we can see the posterior malleolus fracture. It represents about 15.5% of the distal tibial articular fracture, but when we go to the axial cuts of the CT of the same patients, it's only 10.6%. Another patient at 5.5%. When we go to the CT cuts, it represents only 11%. This has led up to the question, is the lateral X-ray is enough? And the answer was no. And this was proven again in this study where they have studied 160 ankle fractures involving posterior malleolus. And here, in this group, it was representing 57.5% of the group where they have managed according only to the plain X-rays, while in 42.5% of this group, they have treated the patient according to the CT scan. In this group, only 26.3% of these patients were treated surgically for the posterior malleus. But in this group, when they have used the CT informations, this group, which was treated surgically for the posterior malleus, it was around 50%. So in the posterior malleus fractures, the preoperative CT is mandatory. We cannot plan our treatment only on the lateral X-ray. In this study, we have asked another question. Are there any other factors that determine the treatment plan for the posterior malleus fractures? And the answer was yes. The posterior malleus fracture is an articular fracture. So the articular surface congruity will affect the final outcome of the treatment and the quality of reduction. And they have emphasized the fact that the size is not an accurate indicator for the treatment plan of the posterior malleus fractures. And they have raised the principle of fracture configuration. We have found that the fracture configuration will directly affect the treatment plan and the final prognosis. In this study, they have studied the fracture configuration of the mapping of the distal tibia, and we have found that this area, the red area, represents about 70% that could be fractured in the posterior malleus. And again, for the Mason classification, they have made this clear and simple classifications for the posterior malleus fractures. In type 1, as we can see, there is a small fragment in the axial CT cuts. This fracture line does not cross through the incisura, while type 2 and type 3, the fracture line crosses the incisura here and here. But in type 2, the fracture fragment is only posterolateral in 2A, while in 2B, there are two fragments, one posterolateral and one posteromedial. In type 3, there is a larger fragment that includes the posterior malleolus, and some authors consider it a billion fragment. In this study, well, they have planned the treatment according to the Mason classification. They have concluded or advised that in type 1, we don't need to do any direct surgical intervention to the posterior malleus, and we can fix it indirectly by syndesmotic fixation, because we all know that the posterior malleolus is the tibial attachment of the posterior syndesmotic ligament. In type 2 and type 3, they have advised of open reduction internal fixation or surgical treatment generally for the posterior malleolus. Back again to our cases. In the first case, as we can see here, there is a small posterolateral fragment, as we can see, and it does not cross through the incisura. And according to Mason classification, this is type 1, and this is what was done according to their treatment guidelines. There was only syndesmotic fixation. The second case, as we can see, there is a larger posterolateral fragment that the fracture line crosses through the incisura itself, and according to the classification, this is type 2A, and this is what was done. There was a fixation, direct open reduction internal fixation of the posterior malleus using two screws. The third case, as we can see here, there is a large fragment posterolateral and posteromedial. That's clear here in the 3D reconstruction, and according to Mason classification, this is type 2B, and this was treated surgically. I'm sorry for the bad quality of the X-ray, but this is the only one that I got for this patient. The patient was treated by plate for the posteromedial fragment and the additional screw for the posterolateral fragment. So our home message, in Mason type 1, we don't need to treat the posterior malleolus itself surgically, but we can use syndesmotic fixation only. It will sufficiently reduce the small posterior malleolar fragment, while in Mason type 2 and type 3, we need direct surgical treatment for the posterior malleolar fracture itself. Thank you.
Thank you so much, Professor Ahmed Rami, for this very interesting presentation. If we have any questions to Professor Ahmed.
Thank you, Dr. Mohamed.
Thank you, sir.
It's my pleasure.
يعني أنا بقالي زمان ما شفتكش يا دكتور أحمد، وأنت وحشني والله.
باشا انا ببقى مبسوط وانا موجود مع حضرتك والله ان شاء الله
ربنا
على خير.
ربنا يبارك فيك.
ربنا يخليك.
Okay, we have just one question. Professor Ahmed, what approach do you prefer for open reduction internal fixation?
Actually, it depends on the fracture configuration, but in most of the cases, the posterolateral will be sufficient.
Yes, sir. Okay,
but
thank you so much, sir.
We can see, as we can see in some cases, there are posterolateral fragment and
Another question, why buttress plate? From Professor Amr Azam, why buttress plate? Dr. Ami?
Because, Dr. Mohamed, it's intra-articular fracture and it's a large fragment, and I thought that the screw will not be only, the only screw will not be sufficient for the fixation of such a fracture.
Yes, we have two more questions, Dr. Ahmed. Sequence of fixation in trimalleolar fracture from Dr. Saad.
Look, there is a controversy on this issue, and it's usually according to the preference of the surgeon. But generally, from my point of view, I would like to restore the length of the posterior of the lateral malleolus first, then to attack the posterior malleolus, then the medial malleolus.
Yes, sir. And from Mohamed, what about the lateral approach?
The lateral approach will not be sufficient to attack the posterior malleolar. Remember that you have a small skin bridge between the posterior approach and the lateral approach. So it's better to attack it either posterolateral and posteromedial, or otherwise you will sacrifice the skin.
Yes, sir. The last question is mentioning through lateral approach, through fibular approach, I'm sorry, through fibular approach.
I didn't get it, Dr. Mohamed, please.
Yeah, I think he's asking if you fix the posterior malleolus through the fibular approach.
No, it's posterolateral approach. Posterolateral, through the posterolateral approach, you can reach the posterior malleolus, posterolateral fragment, and the lateral malleolus also.
Yes, sir. Much, Professor Ahmed Rami. And now we will move to the next speaker. Thank you, sir. The next speaker is my dear brother and my dear friend, Professor Mahmoud Abu Zaid, Professor of Orthopedic Surgery, Benha University. Professor Mahmoud will speak about metatarsal fractures. Professor Mahmoud, please.
Thanks, Dr. Ashhab, for your great efforts. And thanks to Egyptian Orthopaedic Association, and thanks to Eva Farms. I will try to be sticky to the time schedule. We will talk about metatarsal fractures. We will show two items: the Lisfranc injuries and the metatarsal shaft fractures. The Lisfranc injury, the dilemma regarding to the diagnosis of Lisfranc injury. So diagnosis, you should put it in mind as any foot trauma, you should suspect Lisfranc injury and you should exclude Lisfranc injury. We will deal with the diagnosis and treatment of Lisfranc injury. Regarding the imaging, we should have AP oblique lateral views to the foot. We have 5 critical radiographic signs that indicate the presence of midfoot instability. The first is disruption line drawn from the medial base of the second metatarsal to the medial side of the medial cuneiform, as shown in this X-ray. This is an AB view. Secondly, there is maybe widening in the interval between the first and second ray, as is shown in this X-ray. The third cardinal signs, disruption of line drawn from the medial side of the base of the fourth metatarsal to the medial side of the cuboid on oblique view. And maybe we have a dorsal based subluxation on the lateral view, and maybe disruption of the medial column, which is line longitudinal from the medial suspect of the navicular and medial cuneiform. If we suspect Lisfranc injury and these 5 cardinal signs are not seen in these AP, oblique, and lateral views, you should have stress and weight-bearing radiographs, and you should have a CT scan to exclude Lisfranc injury. The treatment of Lisfranc may be non-operative in form of cast immobilization for 8 weeks if no displacement on weight bearing and stress radiographs and no evidence of bony injury on CT. You have no bony injury in CT, and the loaded foot views are normal. The operative intervention in the form of open reduction and rigid internal fixation. The indication of open reduction internal fixation is any evidence of instability more than 2 millimeter shift. And this open reduction internal fixation is favored in bony fracture dislocation as opposed to pure ligamentous injuries. As pure ligamentous injuries, the evidence-based medicine now is regarded to the fusion. Primary arthrodesis of the first, second, third tarsometatarsal joint, the indication of pure ligamentous arch injuries excluded by CT. This is the primary arthrodesis of the first, second, third tarsometatarsal joints with screws. There is a controversy between the screw usage for internal fixation or for fusion or bridging plate in open reduction internal fixation, not for the fusion. Midfoot arthrodesis, we should extend your arthrodesis to the navicular and midfoot in chronic Lisfranc injuries with neglected injuries more than 6 months with advanced midfoot arthrosis and have failed conservative therapy. The metatarsal fractures, the 5th metatarsal fracture most commonly fractures. 3rd metatarsal fracture rarely occur in isolation as 68% associated with fracture 2nd or 4th metatarsal. Multiple metatarsal fracture lose the stability of intermetatarsal ligaments, leading to increased displacement. So in these cases, multiple metatarsal fractures, even undisplaced, should be fixed. Stress fractures, consider metabolic evaluation for fragility fracture, seen mostly at the 2nd metatarsal in ballet dancers and cross-country runners. The treatment of metatarsal fractures, non-operative treatment in the form of pilon knee cast indicated in 1st metatarsal non-displaced fractures, central metatarsals isolated non-displaced or minimally displaced, stress fractures. So this indication for isolated central metatarsal, which is non-displaced or minimally displaced. And we will show the next spine what is the level of this displacement. Operative intervention, either percutaneous versus open reduction internal fixation, indicated for open fractures, 1st metatarsal any displacement. Why the 1st metatarsal any displacement should be operative intervention, as no intermetatarsal ligament support and 30 to 50% of weight bearing with gait. The central metatarsal multiple fractures, multiple central metatarsal should be have operative intervention, even non-displaced. And if there is displacement in sagittal plane deformity more than 10 degrees, this sagittal plane deformity, if dorsal displacement, this will be lead to transfer metatarsalgia to the surrounding central metatarsals. And if it's a plantar flexion, this will be to lead to pressure ulcer and compression sore. If more than 4 millimeter translation should be have operative intervention for the central metatarsal. The base of 5th metatarsal, we can show this slide to show the anatomical parts of the fifth metatarsal with the tuberosity fractures, which is avulsion fractures in zone 1 from peroneus brevis or the plantar rhabdomyolysis. The true Jones fracture is zone 2. It is opposite to the fourth intermetatarsal articular surface. And the third zone 3, is stress fracture and shaft fracture and head fracture for the fifth metatarsal. This is the classifications for the base fifth metatarsal fractures. The treatment of the base fifth metatarsal fracture, zone 1, it is a proximal tubercle, non-unions and is uncommon and treated by protected weight bearing cast. Zone 2 is a metaphyseal diaphyseal junction involved the fifth metatarsal articulation. This is a vascular water area. This is increased risk of non-union, so treated by non-weight bearing short leg cast for 6 to 8 weeks. Intramedullary screw fixation for elite or competitive athlete. In zone 3 fractures, this is a proximal diaphyseal fracture, distal to the fourth to fifth metatarsal articulation, increased risk of non-union and treated by non-weight bearing as short leg cast for 6 to 8 weeks with intramedullary screw fixation in sclerosis, non-union in athletic individual. Thank you.
Thank you so much, my dear brother, Professor Mahmoud Abu Zaid, for this very interesting topic about the metatarsal fractures. If we have any questions to Professor Mahmoud. I think we have no more questions. Professor Mahmoud, would you please stop your sharing screen, please?
Okay, sir.
Okay. Thank you so much, Professor Mahmoud. Our next speaker will be Professor Ahmed Abeid from Monofea University. Professor Ahmed will speak about a very important topic, which is complex acetabular fractures associated both columns. Professor Ahmed, you are very welcome, sir.
Thank you, Professor Ashhab, for your kind invitation.
Thank you so much, sir, for being with us.
I'm sure your tremendous effort all over the day is matchless.
Thank you so much, sir.
I'll go through a complex case of acetabular fracture. My screen is well shown for all of you.
Yes, sir. Yes, sir.
Okay. Most of us face these complex fractures every now and then, and the management of these cases should be in experienced hands because the complications is very disastrous and needs very difficult operations to correct these malunion or non-union in the form of arthroplasty.